Okay, so cardiovascular, first we have embryology. Okay, so heart morphogenesis. Heart is the first functional organ in vertebrate embryos, beats spontaneously by week 4 of development. I know this is important. So week 4, that's when they do the scans and, they detect a heartbeat. So first functional organ in vertebrate embryos beats spontaneously by week 4 of development. So under this, they've given us cardiac looping, septation of the chambers. Okay. So what is cardiac looping? They're talking about primary heart tube loops to establish left-right polarity. And again, this begins in the week 4 of development. Defect in left-right dynein involved in left-right asymmetry can lead to dextrocardia as seen in cardiogenic syndrome. So yeah, we saw this earlier with the dynein. So defect in dynein involved in left-right asymmetry can lead to dextrocardia as seen in cartigenous. Okay. 1 sec. Look my timer. Okay. Okay, so next we have septation of the chambers. What's happening in the atria? So first we have the septum primum grows towards the endocardial cushions, which is over here, narrowing the ostium primum, which is meaning the first opening, ostium primum. So the second thing that happens, the ostium secundum forms in the septum primum. The second opening forms in the septum primum due to cell death. Ostium primum regresses. Anyone remembers what mechanism of cell death this was for embryogenesis? Apoptosis by intrinsic pathway. So that was the quick recall. So yeah, ostium secundum forms in septum primum due to cell death. Ostium primum regresses. So yeah, ostium primum regresses, becoming smaller. So third, we have septum secundum. Septum secundum develops on the right side of the septum primum as ostium secundum maintains the right-left shunt. So then number 4, septum secundum expands. So the blue one expands and covers most of the ostium secundum, which is the opening. The residual foramen is called the foramen ovale. Yep. So as we're seeing here, septum secundum is expanding and foramen ovale is what's left over of the opening. Okay. Then we have septum. Yeah, at the end over here, only foramen ovale remains. Second, foramen ovale. And then the degenerating septum primum. So next step, septum primum closes, which is the green one, closes against the blue, closes against septum secundum, sealing the foramen ovale soon after birth because of increased left atrial pressure and decreased right atrial pressure, which makes sense. Then next step is septum secundum and septum primum fuse during infancy and early childhood, forming the atrial septum. So during infancy and early childhood, forming the atrial septum. So yeah, as soon as the placenta is removed, we have increased the SVR, increased left atrial pressure, and that leads to reversal of flow, and that would increase pressure on this side, pushing this flap against the blue one. And then after, during infancy, it gets fused. Okay, so that's the septation of the chambers. And then what happens in the atria? So patent foramen ovale. So what is this condition? This is caused by failure of the septum primum and secundum to fuse after birth. Most are left untreated. So yeah, they don't fuse. Most are left untreated. It can lead to paradoxical emboli, venous thromboemboli entering the systemic arterial circulation through the right to left shunt, as can occur in ASD. Yeah, so this is a triple whammy situation. So yeah, PFO caused by failure of septum primum and septum secundum to fuse after birth. Most are left untreated, can lead to paradoxical emboli. So first, this patient has an underlying PFO. Second, they have a paradoxical emboli. And third, that, yeah, so the emboli had entered the other side and caused a stroke. So yeah, it's a triple whammy situation. So can lead to paradoxical emboli, the venous thromboemboli entering the systemic arterial circulation through the right to left shunt, as can occur in an ASD. Okay, so that's septation of chambers. So next we have ventricles. So the muscular interventricular septum forms, which is this part. Opening is called the interventricular foramen. Then the AP septum rotates and fuses with the muscular ventricular septum to form the membranous interventricular septum, closing the IV foramen. So the AP septum rotates and fuses with the muscular interventricular septum to form the membranous part, the membranous interventricular septum, closing the interventricular foramen. Then third, we have growth of the endocardial cushions, separates the atria from the ventricles and contributes to both atrial septation and the membranous portion of the interventricular septum. So one more time, the growth of the endocardial cushions separates the atria from the ventricles and contributes to both atrial septation as well as the membranous portion. So muscular portion and then the membranous portion of the interventricular septum. So VSD is the most common congenital cardiac anomaly and usually occurs in the membranous septum, which is this portion. Okay, so yeah, we're seeing atrioventricular canals, the muscular interventricular septum forming, and that's the foramen. AP septum forms, what did they say, loops around, rotates and fuses with the septum, and then the membranous interventricular septum is formed. Okay, so that's ventricles. Next, we have outflow tract formation. Neural crest cell migrations leading to truncal and bulbar ridges that spiral and fuse to form AP septum. That forms the ascending aorta and the pulmonary trunk. Yeah. So outflow tract formation, the neural crest cell migrations leads to truncal and bulbar ridges that spiral and fuse to form the AP septum, and then the ascending the aorta and the pulmonary trunk. So conotruncal abnormality is associated with failure of neural crest cells to migrate. We have transposition of great arteries, we have retrology of fallow, and then we have persistent truncus arteriosus. Okay, now coming to valve development. So we have AP valves are derived from the endocardial cushions of the outflow tract. And then we have mitral and tricuspid derived from the fused endocardial cushions of the AV canal. So these are cushions of the outflow tract. And this is cushions of the AV canal. So AV, outflow tract, mitral and tricuspid from the cushions of the AV canal, which makes sense. That's where they are. So then valvular anomalies may be stenotic, regurgitant, or atretic. Example, tricuspid atresia, or displaced. Example, Epstein's anomaly. Okay, next we have aortic arch derivatives. So they develop into the arterial system. So we have first arch, second, third, fourth, sixth. So yeah, first is maximal, one for maximal. So part of maxillary artery, which is a branch of the external carotid. So this comes up in questions. Part of the maxillary artery, which is a branch of the external carotid. Then second, we have the stapedial artery and hyoid artery. This is, second for stapedial. Third, common carotid artery and proximal part of the internal carotid artery. C is the third letter, so C, common carotid and internal carotid proximal. Fourth, on left, the aortic arch. On right, the proximal part of the right subclavian artery. So fourth arch is 4 limbs, which is systemic. Then sixth, proximal part of pulmonary arteries. So yeah, 6 is the green, the proximal part of the pulmonary arteries, and on the left, only the ductus arteriosus. The sixth arch is the pulmonary and the pulmonary to systemic shunt. Okay, yeah, makes sense. So that's a way to remember. So sixth arch, pulmonary, and the pulmonary to systemic shunt, which is the ductus arteriosus. So yeah, third arch we're seeing. Okay, let me start from the top. So first, part of the maxillary branch of external carotid. First is maximal. So first is maxillary artery. Second S, second for stapedial, so stapedial and hyoid, not pictured here. Third, C is the third alphabet. So CC stuff, common carotid artery, and the proximal part of the internal carotid artery. Okay. On both sides. Then fourth arch on the left. Fourth was a pink. Okay. So on the left, the aortic arch. On the right, the proximal part of the right subclavian artery. And then they've also said right recurrent laryngeal nerve loops around the product of the fourth arch. So this is important. Right recurrent laryngeal nerve around the fourth arch. Left recurrent laryngeal nerve around the sixth arch. So this is for the ductus, around the ductus. Product of the sixth, which is ductus, right subclavian. I think there was some mnemonic, but I made a note later, so it'll come up. Yeah, then sixth, proximal part of the pulmonary arteries, and on the left only, the ductus arteriosus. So sixth arch, pulmonary, and the pulmonary to systemic shunt. Right, so that's aortic arch derivatives. Yeah, this is high yield, and fine, it's a struggle that it doesn't stick. So first maximal, second stapedial, third the CCC, so common carotid, internal carotid, proximal, fourth arch, four limbs. Okay, so systemic stuff, the aorta and the proximal part of right subclavian. Sixth is the pulmonary and the pulmonary systemic shunt. Okay, cool. Next, we have heart embryology. So embryonic structure gives rise to what? So we have the truncus arteriosus, giving rise to the ascending aorta and pulmonary trunk. We have the bulbus cordis, smooth parts, outflow tract of the left and right ventricles. I think the smooth part came up in UL question, bulbus cordis. Then we have the primitive ventricle from the trabeculated part of the left and right ventricles, primitive atrium, trabeculated part of the left and right atria, left horn of sinus venosus, coronary sinus. This is a question. So they would talk something about the coronary sinus and ask where it's derived from. That's the left horn of the sinus venosus. And then the right horn of sinus venosus is the smooth part of the right atrium, sinus venerum, endocardial cushion. So atrial septum, as we saw on the previous page, membranous interventricular septum, the AV, and the semilunar valves. So yeah, AV we said was the outflow, derived from the endocardial cushions of the outflow tract, and mitral tricuspid valve from the endocardial cushions of the AV canal. Okay. So the AV as well as the semilunar valves. The right common cardinal vein and the right anterior cardinal vein is SVC. Posterior cardinal, subcardinal, and supracardinal veins from the IVC. So right and right for the superior, right side is superior, posterior, sub, and supra, inferior. Then we have the primitive pulmonary vein, which is a smooth part of the left atrium. So that makes sense. Then we have sixth embryonic arch, ductus arteriosus. Yes, okay. So at 22 days, we're seeing at 22 days, we're seeing the first aortic arch in red, the bulbus cordis, the sinus horn, and the cardinal veins. So by the time it's 24 days, first aortic arch is giving off the aortic roots. Truncus arteriosus is formed, bulbus cordis is still here. This is from the ventricle. Atrium and the sinus venosus, so 24 days. And the pericardium is also formed by 24 days. Then at 35 days, we have the primitive left atrium, left ventricle, truncus. So primitive left atrium is formed at 35 days. By 50 days, this looks like a normal structure of the heart. We have the aortic arch coming from the first arch. So red and red, this is the ascending aorta and pulmonary trunk. Right atrium, left atrium, ventricles. I'm just trying to correlate in my head. SVC is also coming from here. So, yep. Any mnemonics, feel free to share. So yeah, I think I remember a question on this. The smooth parts or outflow tract of the left and right ventricles, bulbus cordis. Other than that, then coronary sinus is important. Yep, so that's the heart embryology. This was a UL image. Okay. Okay.
We have a question, Saira, also on right and superior posterior cardinal veins also, I think.
Right superior.
Right common cardinal, right anterior cardinal, SVC.
For SVC.
Posterior cardinal, posterior cardinal, subcardinal, and supracardinal.
For IVC, okay, yeah. Yeah, so these are the ones. I would say like right superior, just to remember. I know this is a religious thing, but yeah, right is superior, inferior is the others. So yeah, this is also a question. Coronary sinus, yeah, we eat with our right hand, even in India, so we know right is superior and inferior is the other one. So coronary sinus, left horn, and smooth pars pulvis chorus. Yeah, I'm struggling with this page because it just doesn't stick, although like visually it makes sense.
Yeah, it doesn't stick. Huh?
Yeah.
That's really.
Yep. Anyway, thank you, Amna. Okay, so next we have the fetal circulation. This is tested heavily, I think. Let's see. So blood in the umbilical vein has a PO2 of 30 millimeters of mercury, and is approximately 80% saturated with oxygen. So blood in the umbilical vein, which is the red one. Okay, yeah, PO2 30. Umbilical arteries have a low oxygen saturation. So yeah, this is one of the, one of the few exceptions to the rule. So it's vein is carrying oxygenated blood, artery is carrying deoxygenated. So then 3 important shunts. Number 1, we have blood entering the fetus through the umbilical vein, is conducted via the ductus venosus into the IVC, bypassing the hepatic circulation. So we're saying it's coming from the umbilical vein. Some of it is going inside the liver, but then it's bypassing most of it bypasses the liver. Yeah, and it's entering the IVC. Okay, next, number 2, most of the highly oxygenated blood reaching the heart via the IVC is directed through the foramen ovale into the left atrium. So most of the highly oxygenated blood reaching here via the IVC is directed through the foramen ovale into the left atrium. So then next, deoxygenated blood from the SVC. So we're having superior vena cava, deoxygenated blood from the SVC passes from the RA to the RV to the main pulmonary trunk, main pulmonary artery, then the ductus arteriosus, and then the descending aorta. Yep, so descending aorta reaching the lower body. So shunt is most of the body. Shunt is due to high fetal pulmonary artery resistance. So yes, shunt is due to high fetal pulmonary artery resistance, which makes sense because it is not taking a breath. Then at birth, when the infant takes a breath, there is decreased resistance in the pulmonary vasculature, increased left atrial pressure versus right atrial pressure, as we saw. So foramen ovale closes, now called the fossa ovalis, increase in oxygen from respiration, and decrease in prostaglandins from, and the drop. Yeah, this is important. Increase in oxygen from respiration, as well as the decrease or the drop in prostaglandins from placental separation leads to closure of the ductus arteriosus as well. Okay, nice. So then this we've seen NSAIDs, which are prostaglandin inhibitors like indomethacin and ibuprofen or acetaminophen, help close the PDA. Then it becomes the ligamentum arteriosum, which is a remnant of the ductus. Yeah, we have questions on that too. So endomethacin ends the PDA versus PGE1 and E2 keep the PDA open. So this we're all familiar with. Okay, so that was the fetal circulation. So yeah, we're seeing from the placenta, going to the umbilical vein, bypassing via ductus venosus, coming into the right atrium. So yeah, IVC, going into the right atrium. And then from the right atrium is going in through the foramen ovale, going to the left ventricle, going to the aorta, then through the ductus. No, one more thing. So this SVC is going from the right ventricle to the pulmonary trunk, from the pulmonary trunk to the ductus arteriosus, and then going there to the descending aorta, and then return is where the umbilical arteries, again, going back to the placenta. So high oxygen concentration in the umbilical vein, moderate by the time some of it is mixed from the liver, low oxygen via the ductus, and very low in the SVC and the distal half of the IVC. Okay, yeah, so PO2 is still only 30 millimeters of mercury and 80% saturated with oxygen by the time it reaches. All right, so next we have fetal postnatal derivatives. Ductus arteriosus, derivative is the ligamentum arteriosum near the left recurrent laryngeal nerve. Ductus venosus, postnatal derivative is the ligamentum venosum. Foramen ovale, fossa ovalis, allantois, fetal structure, urachus, and then the postnatal derivative is median umbilical ligament. We have a few questions on this thing. Urachus is the part of the allantois between the bladder and the umbilicus. Umbilical arteries, medial umbilical ligaments, umbilical vein, ligamentum teres hepatis, round ligament. Yeah. So contained in the falciform ligament. So yeah, ductus arteriosus, ligamentum arteriosum near the left recurrent laryngeal nerve. Ductus venosus, ligamentum venosum, foramen ovale, fossa ovalis. Allantois, urachus, median umbilical ligament. So AN. Urachus is part of allantois between bladder and umbilicus. Umbilical arteries, medial umbilical ligaments, umbilical vein, ligamentum teres hepatis, round ligament, contained in the falciform ligament. This comes up in a question, I believe. Okay. This also near the left recurrent laryngeal nerve, ligamentum arteriosum.
Yeah, left recurrent laryngeal nerve loops around where?
The left side.
Six pharyngeal, right?
Say again, sorry.
6 aortic arc.
Yeah, 6th arch. Yep. What was the mnemonic we had said? I think left was 6.
Yeah. There was some mnemonic for that.
Yeah.
Sixth, actually 6 is a little bit lower if you see in this picture. So 6th is pulmonary arteries and
6th.
ductus arteriosus. But
Okay.
4th is a little bit above, like aortic arch and part of the subclavian artery, proximal part of the subclavian artery.
So just visually looking at this level is 4 and this level is 6 in order. Okay, so 4. Yeah, so 6th was left recurrent, and then again right is on top. Right is better, so right is on top, and then it's left recurrent laryngeal nerve. Okay, nice. Thank you.
So 4th and 6th have a mnemonic, San Antonio Police Department.
Nice. Okay.
So right side would be subclavian artery, left side aortic arch, and then for the 6th, right side pulmonary artery, left side ductus arteriosus. So that's SAPD. I was typing it in the chat too, so I'll put it in here.
Thank you. San Antonio
Police Department.
Police Department. So SATPD. Okay.
SAPD.
Oh, SAPD. Okay.
Subclavian artery, aortic arch, pulmonary artery, ductus arteriosus.
Nice. San Antonio Police Department to tell us aortic arch is 4th and 6th. So right is subclavian, left aortic arch, SAPD. So subclavian, aortic arch, pulmonary artery, pulmonary artery, ductus. So right, left. Okay, nice. Thank you so much for sharing like that. All right. San Antonio Police Department. Yes.
And third, we have also one. Third is also a question: common carotid and proximal internal carotid artery.
Common
also can be any questions here.
Yeah, I probably ignored it in my head because I don't like this. But yeah, third common carotid artery and proximal part of internal carotid from the third arch. So third alphabet. So CCC, I should remember. Okay, we should remember. All right, thank you. So that's the aortic arch derivative. So we...
Anyone has mnemonics for the previous one, truncus arteriosus thing? This one, yeah.
Right?
This page.
Yeah. This is a struggle. I think I should create one if no one has any. Anyone has any mnemonics? Okay. We'll make one later.
I'm sure you can make some rated R ones, but
Okay, yep. Yeah, we're adults. Please share, guys. I know I've shared some rated mnemonics, but just for the sake of memorization, because I really struggle with it. Okay. All right, for now, moving on. So your fetal postnatal, we finished it. So just a quick jog. Ductus arteriosus, ligament arteriosum. So near the left recurrent laryngeal nerve. Ductus venosus, ligamentum venosum. So yeah, ductus arteriosus, ligamentum arteriosum, left recurrent laryngeal nerve. So this is all to do with the sixth arch. Okay. And ductus venosus, ligamentum venosum, foramen ovale, fossa ovalis, allantois urachus, median umbilical ligament, and then umbilical arteries, medial umbilical ligaments, umbilical vein, ligamentum teres hepatis. So round ligament, this contained in falciform ligament. Okay. Okay, next, coming to cardiovascular anatomy. So heart anatomy, the left atrium is the most posterior part of the heart. This comes up a lot. Enlargement of the LA, example, mitral stenosis can lead to compression of the esophagus, leading to dysphagia, and or the left recurrent laryngeal nerve, a branch of the vagus nerve causing hoarseness, so Ortner syndrome. And then RV, right ventricle, is the most anterior part of the heart and is most commonly injured in trauma. LV is about 2/3. So one more time, sorry. RV, yeah, this is a question actually. RV is the most anterior part of the heart and most commonly injured in traumas. LV, left ventricle, is about 2/3 and right ventricle is about 1/3 of the inferior diaphragmatic cardiac surface. Yes. So RV is the most anterior part of the heart and most commonly injured in trauma. So what are we seeing here? Aortic knob, pulmonary artery. I don't see the azygous vein that we're supposed to see, but okay. SVC is somewhere in this area, and then azygous vein. Okay, left LA, RA, RV. So RV is injured. It's the most anterior part of the heart and is most commonly injured in trauma. And LV is about 2/3. Okay, right ventricle is about 2/3 and left ventricle is about 2/3 and right ventricle is about 1/3 of the inferior diaphragmatic surface. And yeah, descending aorta is there. So yeah, aortic knob, pulmonary artery, SVC, azygous is just for me imaginary. I think, I don't know what exactly, but moving on. Next, we have the pericardium, consists of 3 layers from the outer to inner. We have the fibrous pericardium. Then we have the parietal pericardium, the epicardium, which is the visceral pericardium. The pericardial space lies between the parietal pericardium and the epicardium. Yep, pericardial space lies between the parietal pericardium and epicardium, which is the visceral. So yeah, any space is usually between the parietal and the visceral. So here the visceral is the epicardium. So pericardium is innervated by the phrenic nerve. Pericarditis can cause referred pain. This comes up in questions. Pericarditis can cause referred pain to the neck, arms, or one or both shoulders, often left. Yeah, pericarditis radiating to the shoulder. Referred pain to the neck, arms, or one or both of the shoulders, which is usually the left. All right, next we have coronary blood supply. Yep, heavily tested. And something that I don't like, but let's do it. So the LAD and its branches supply the anterior. So we're on the anterior side. So anterior 2/3 of the interventricular septum. So this blue area, the anterolateral papillary muscle, and the anterior surface of the LV. So the LAD and its branches supply the anterior 2/3 of the interventricular septum, the anterolateral papillary muscle, and the anterior surface of the LV. Most commonly occluded is the LV, yeah, LAD, the lady. Yeah, what was the old mnemonic? Lady is the most commonly, something like that, med school used to say. Lady is the most commonly occluded. Then PDA supplies the posterior 1/3 of the interventricular septum, posterior 2/3 of the walls of ventricles, and posterior medial papillary muscle. So PDA supplies the posterior 1/3 of the interventricular septum, the posterior 2/3 walls of the ventricles, and the posterior medial papillary muscle. So the RCA supplies the AV node. Where's the RCA? Yeah, okay. So RCA supplies the AV node, makes sense because it's in that area, AV node and the SA node. This comes up in questions too. RCA supplies the AV node and SA node. Infarct may cause nodal dysfunction or bradycardia or heart block. So the right acute marginal artery supplies the right ventricle. AMA, right acute, anterior, right acute. Yeah, right acute marginal artery, AMA supplies the right ventricle. So LAD, PDA, RCA, main things. LAD, PDA, and right coronary artery. But then we come to dominance. Right dominant circulation, which is the most common, PDA arises from the RCA. So again, right is dominant. So most commonly from the RCA. Right dominant, right, we say we eat from our right hand, it's superior. So right dominant circulation, most common. So this PDA arises from the RCA. Then we have left Ds. So left dominant circulation, where does it come from? Left circumflex. Co-dominant circulation, PDA arises from both the LCX and the RCA. Coronary blood flow to the LV, the left ventricle and the interventricular septum peaks in early diastole. This is super high yield. So coronary blood flow to the left ventricle and the interventricular septum peaks in early diastole. Coronary sinus runs in the left AV groove and drains into the RA. This is also comes up in questions, interpretation of this. The coronary sinus runs in the left atrioventricular groove and drains into the right atrium. Okay, yeah, inferior wall of LV forms most part of the diaphragmatic surface of heart supplied by PDA. Yes, we saw that. Okay, so this was the UL image. So right dominant in 85% of patients, left dominant circulation in 10% of the patients. So the anterior wall is substantially larger than the inferior wall in 3 dimensions, such that the left anterior descending artery supplies 50%. So the lady again supplies 50% of the total left ventricular myocardium. So here again, we have the LAD supplying the anterior and what was AS? Anteroseptal. Then the left circumflex supplying the anterolateral, and all of this being supplied by the right coronary artery. So IL, inferior, IS, and RV. On the left side, if we are left dominant circulation, so here we are seeing this is the same, anterior and AS are still supplied by the LAD. Right ventricle is still supplied by the right coronary. The difference is most of these areas, so the blue, which was just the anterolateral septum, septal area, AL is now being supplied by the left circumflex, the AL plus the IL plus the inferior plus the IS. Okay. Any mnemonics to drill this in?
Can you repeat the last 2 options and last 2 lines for that, please?
This one?
Yes.
So coronary blood flow to the left ventricle and the interventricular septum peaks in early diastole. So that's why they say that the heart receives its blood supply during diastole. Specifically, they're mentioning early diastole. Yeah, peak is in the early diastole. Coronary blood flow to the left ventricle and the interventricular septum peaks in early diastole. The coronary sinus runs in the left AV groove and drains into the right atrium.
Yeah, so where is the coronary sinus here?
In the image?
Picture, yeah, in this image, any idea?
I think it'll be internal, a deeper structure in the cavity, right?
Okay.
So it won't be seen on this one, but
okay, thank you.
Left AV groove. I think we should maybe be able to make it here. Left AV groove and drains into the right atrium. Yeah, actually, no, this is ventricular, so we won't be able to see it here either. Yeah, it's not pictured actually. Anyone?
Yeah,
Please correct me if I'm wrong. Yeah, I think it's an inner sub. I think in UWorld, when we have the cross section and the cut section shows up in a few images. We'll see if it comes up. Okay. If anyone has any idea or any images, please share so we can pull it up. Okay, so next we have cardiovascular physio. I know we did this on the bigger group. So cardiac output variables. Okay, Vinay shared something on the WhatsApp group. Okay, so coronary sinus. Okay, nice. Thank you. So maybe I can look it up online also just to see. Give me a sec. Large venous structure located on the posterior aspect of the left heart, coursing within the left AV groove. So yeah, okay. So it is visualized. Thank you, Vinay.
And there is an importance for the coronary sinus. In whole body, it has the most deoxygenated blood. I think it is from your question, I think.
Yeah, correct. I remember
Most
now.
deoxygenated blood will be present in the coronary sinus.
Yeah, that's right. Most deoxygenated blood in all of the body is in the coronary sinus. Yes.
Yes,
Thank you.
heart uses the oxygen more than any other organ.
Yeah, that heart places the maximum oxygen, but the coronary sinus is again the most deoxygenated because it's extracting all of it, right? So it makes sense. Yeah. Thank you for that point. Yeah, that was a question on UWorld. And yeah, coronary sinus. So they said left AV groove. What was it? Sorry, second. Left AV groove and drains into the RA. So left AV groove and draining into the RA. No, this is the LV. So where's the RA? Okay, so it makes sense. So in this image, if we had to extrapolate any other better images. Okay. So it'll be here, right? No, this is the right side. Left AV groove, atrioventricular groove here, this part. Am I right? Left AV groove is probably here. Okay. All right, we're good. Good marginal artery, LAD.
Yeah, thank you.
Thank you, Hamna. That was a question. Yes, that's important. Okay, so next we have cardiovascular physio. We have cardiac output variables. Stroke volume, contractility, preload, afterload, cardiac oxygen demand. Okay, so stroke volume affected by three things: contractility, afterload, and preload. SV into cap, the mnemonic. Increase stroke volume with increased contractility, increasing preload, and decreasing afterload. So let's see. Increased contractility, like anxiety and exercise. So it makes sense. If there's increased contractility, stroke volume is going to go up. Increase in preload. Example, early pregnancy, there's a volume overload state or a little bit, hyperdynamic circulation. So increase preload. And if decrease afterload, it has to, So again, preload is the passive stretch before contraction. Afterload is the ventricular push of the blood to the aorta, as well as what the left ventricle has to pump against. So if decrease afterload, just decrease pressure in the vessels, then it's easier for the heart to pump out. So stroke volume is increased with the decreased afterload. Stroke work, SW, is the work done by the ventricle to eject the stroke volume. This is stroke work. Work done by the ventricle to eject the stroke volume. Stroke work is proportional to the stroke volume, as well as the mean arterial pressure. Okay. Was this always there? Someone new to me? So stroke work is proportional to stroke volume times MAP. A failing heart has decreased stroke volume, so systolic or diastolic dysfunction. So yeah, makes sense. A failing heart has decreased stroke volume. It could be systolic and/or diastolic dysfunction, which means basically the heart is not pumping out. Okay, so contractility contractility and stroke volume increase with, we have catecholamine stimulation, increase intracellular calcium, decrease extracellular sodium, digoxin. So these are the 4 points. So let's see, catecholamine stimulation via beta-1 receptor. So it's happening via 2 ways. Activated protein kinase A causes phospholamban phosphorylation. Yeah, we're going to see that image later today. So activated protein kinase A leads to phospholamban phosphorylation, which leads to active calcium ATPase. So yeah, phospholamban is phosphorylated, meaning now it's active. So active calcium ATPase, active enzyme, increase calcium storage in the sarcoplasmic reticulum. And then activated protein kinase A also causes calcium channel phosphorylation. So one is the phospholamban phosphorylation. The second thing it phosphorylates is a calcium channel phosphorylation. Net effect, increased calcium entry and calcium-induced calcium release. So protein kinase A, so first thing, catecholamines are coming and stimulating the beta-1 receptor. When the stimulation happens, downstream effects happen, and then now we have second messenger pathway and everything, and now we have activated protein kinase A. So kinase will add a phosphate and activate enzymes or activate stuff. So phospholamban phosphorylation, causing active calcium ATPase. So now this enzyme is active, so increased calcium storage in the SR. Then activate protein kinase A also phosphorylates the calcium channel, leading to increased calcium entry, calcium-induced calcium release. Then contractility and stroke volume also increase with increased intercellular calcium, which makes sense. Decreased extracellular sodium. Why? Because of the decreased activity of sodium calcium exchanger. So indirectly reduces the intracellular calcium. So decreased extracellular sodium will also, no, I think I misspoke. So decreased extracellular sodium, decreased activity of the sodium calcium exchanger, so that lead to increased intracellular calcium. So thereby contractility and stroke volume will increase. So that makes sense. And then digoxin. So digoxin blocks I think we saw it somewhere else. Digoxin blocks the sodium potassium pump, increases intracellular sodium, decreases the sodium calcium exchange activity, leading to increased intracellular calcium. Okay. Then contractility and stroke volume decrease with, so these are all factors that increase contractility and stroke volume. What decreases contractility? The opposite. So beta-1 blockade, leading to decreased cyclic AMP, heart failure, which is systolic dysfunction, acidosis, hypoxia, hypercapnia, so decreased PO2 and increased PCO2, and non-dihydropyridine calcium channel blockers. So BHHAN. So yeah, Behen, for those who know Hindi, Urdu. I mean, but then most of it is understandable, like concept. So contractility decreases with beta blockade, decreased CAMP, heart failure with systolic dysfunction, hypoxia, hypercapnia, so either decreased oxygen or increased CO2, acidosis, and non-dihydropyridine calcium channel blockers. Okay.
Which ones? Verapamil and diltiazem.
Yeah, the non-dihydropyridine, right? Yeah, the two things, verapamil and diltiazem is correct. All right, thank you. Next is preload. Preload approximated by ventricular end diastolic volume depends on venous tone and circulating blood volume. So preload is approximated by the ventricular end diastolic volume. So yeah, because again, we said this is a passive stretch before the contraction. So what is creating this passive stretch is the end diastolic volume. It depends on the venous tone and the circulating blood volume. Venous vasodilators like nitroglycerin will decrease the preload. The other example is IV fluids, increase preload, increase ventricular myocardial sarcomere length. So we're going to see that in Frank Stalin in a bit. So that is preload, approximated by ventricular EDV, depends on venous tone and circulating blood volume. Then next we have afterload. Afterload is approximated by MAP. So afterload, MAP, preload, EDV. So increased wall tension per Laplace's law. Sorry, increased afterload, increased wall tension per Laplace's law leads to increased pressure and increased afterload. LV compensates for increased afterload by thickening hypertrophy in order to decrease wall stress. So we said afterload was the ventricular push of the blood. I believe this was Dr. Ryan from Boards and Beyond. Yeah, these words. So ventricular push of the blood to the aorta and what the LV has to pump against. So it is approximated by mean arterial pressure. So increased wall tension. So increased pressure and increased afterload, which makes sense, right? There's more pressure in the vessel, so it has to push against more stuff. So increased afterload. LV, left ventricle, compensates for increased afterload by thickening hypertrophy in order to decrease wall stress, which also makes sense. If it has to pump against more pressure on the other side, so this one will compensate by hypertrophy to decrease the wall stress. So arterial vasodilators like hydralazine decrease afterload. So A for AAA, decrease afterload. ACE inhibitors and ARBs both decrease both preload as well as afterload. So ACE and ARBs decrease both the preload, which is the passive stretch, as well as the afterload, which is what it has to pump against. So yeah, chronic hypertension, increased mean arterial pressure, leads to left ventricular hypertrophy. So chronic hypertension, which is an increase in the mean arterial pressure, will cause left hypertrophy, which also makes sense. Okay. Then we have cardiac oxygen demand. Myocardial oxygen demand is increased by CARD, CARD. Okay, so that's the mnemonic. What increases myocardial oxygen demand? We have increased contractility, increased afterload, which is proportional to arterial pressure, increased heart rate, and increased diameter of the ventricle. So increased wall tension. So what increases demand? Again, contractility, afterload, which is proportional to the arterial pressure, which makes sense. It's like a bicycle pump, right? So it has to pump against more arterial pressure. So that's afterload. Increase heart rate. If the heart is beating fast, increase myocardial oxygen demand, makes sense. Increase diameter of the ventricle. Increase diameter of the ventricle. Okay, yeah. So the thickness. So increase wall tension. So that will also increase myocardial oxygen demand. The coronary sinus contains most deoxygenated blood in the body. So as the doctor said, coronary sinus contains the most deoxygenated blood in the body. And it was derived from? Anyone? Okay. Left horn of the sinus. Yeah, left horn of the sinus venosus. Okay, then I also said coronary sinus communicates freely with the right atrium. Any factor that causes right atrial dilation, example, pulmonary artery hypertension, which is the most common cause of RA dilation, will lead to coronary sinus dilation. Yeah, this was also a question, I think.
Sorry.
So
what is written here? Sorry, can you repeat? Coronary sinus?
So coronary sinus, as we saw in the image which he shared, communicates freely with the right atrium, correct? So any factor that causes right atrial dilation, and the most common causes of pulmonary artery hypertension, it'll lead to coronary sinus dilation. So that was the
Okay, so any factor that increases right atrial dilation leads to right coronary sinus dilation.
Yeah.
Okay.
Yep. So that was, I believe, a question. So just put it over there. Okay, next, wall tension follows Laplace's law. Laplace's law. So wall tension equals pressure times radius. Wall stress equals pressure into radius divided by 2 times wall thickness. Other questions on this? I don't remember, but wall tension or tension equals pressure multiplied by the radius. Okay. Wall stress is this pressure into radius, which is nothing but the wall tension divided by 2 times of the wall thickness. 2 times the wall thickness. So more the thickness, less the stress. So which is why this happens. So yeah, it does make sense. Wall stress equals pressure into radius divided by 2 times wall thickness. So if you want to reduce the wall stress, we increase the wall thickness. So that is the LV hypertrophy. Okay, cool. So that's done with cardiac output variables. So stroke volume we saw, contractility, preload, afterload, and cardiac oxygen demand. Okay. So next we have cardiac output equations. What are these equations? Stroke volume, ejection fraction, cardiac output, pulse pressure. So yeah, stroke volume, ejection fraction, cardiac output, pulse pressure. So stroke volume is EDV minus ESV. This comes up a lot, even on those charts to determine EDV minus ESV. So stroke volume equals EDV minus ESV, where ESV is the systolic volume. Yes, ejection fraction is stroke volume divided by EDV. So therefore, stroke volume is EDV minus ESV divided by EDV. This comes up Oh, we have to calculate from the charts. So yeah, ejection fraction equals EDV minus ESV divided by EDV. So ejection fraction is an index of ventricular contractility, decrease in systolic heart failure, usually normal in diastolic heart failure. So ejection fraction is the index of ventricular contractility. So if it's decrease in systolic heart failure and usually normal, yeah, this is high yield point. Ejection fraction is normal in diastolic heart failure. Yep. Right, next is cardiac output. Cardiac output is equal to the symbol, I don't know, Q, I don't know what it's called. So it equals stroke volume times heart rate. Fixed principle, cardiac output equals rate of oxygen consumption divided by arterial oxygen content minus the venous oxygen content. I think this came up in some question of the calculation. So cardiac output is equal to rate of oxygen consumption divided by arterial oxygen content minus the venous oxygen content. So that's cardiac output. Okay. So in early stages of exercise, cardiac output is maintained by increased heart rate and increased stroke volume in early stages. In later stages, cardiac output is maintained by heart rate only because the stroke volume plateaus. Okay. In early stage of exercise, cardiac output is maintained by increased heart rate and increasing stroke volume. In later stages, cardiac output is maintained by heart rate only, stroke volume plateaus. So diastole is shortened with super high heart rate. This is high yield question again, same question. So diastole is shortened with increased heart rate. Example, ventricular tachycardia because of decreased diastolic filling time, decreased stroke volume, and decreasing cardiac output. So this all makes sense, right? Diastole, which is a relaxation phase, is shortened with increased heart rate, like VTAC. So there's decreased diastolic filling time, decreased stroke volume, and decreased cardiac output. We spoke about this in the previous days in some context. I don't remember what it was. Diastole is shortened with increased heart rate. Sorry. Okay, next we have pulse pressure. PP equals systolic minus diastolic. Yeah, that's pulse pressure, SDP minus diastolic blood pressure. So pulse pressure is directly proportional to the stroke volume and inversely proportional to the arterial compliance. So directly proportional to the stroke volume and inversely proportional to the arterial compliance. Increased pulse pressure in what? Decreased pulse pressure we see in what? Increased pulse pressure in AR, aortic stiffness, isolated systolic hypertension in older adults. I think we saw those images with the graphs. I said we discussed it when we did the receptors and stuff, epinephrine and stuff like that. So yeah, increased pulse pressure in aortic regurg, aortic stiffening with isolated systolic hypertension in older adults, obstructive sleep apnea. Why? Because of increased sympathetic tone. Yes, and then high output state like anemia and hyperthyroidism, exercise transiently. So yep. Decreased pulse pressure we seen in aortic stenosis, cardiogenic shock, cardiac tamponade, and advanced heart failure. Decreased pulse pressure, which is decreased difference between the systolic and diastolic. Where do we see this? Aortic stenosis, cardiogenic shock, cardiac tamponade, and advanced heart failure. So that makes sense, right? Decreased difference between the systolic and diastolic. Aortic stenosis because the left ventricle is not pumping out. Cardiogenic shock, again, pump failure. Cardiac tamponade, everything's compressing from outside, so it's not able to pump out. Advanced heart failure, again, cardiac pump is gone, it's not working, so there's very less difference between the systolic and diastolic in these cases. Everything else increased. So this was a mnemonic from our previous group friend in old age and aortic regurgitation. Systolic increase, so SID was a mnemonic. In old age and AR, systolic increases, diastolic decreases, so SID. In isolated systolic hypertension, age-related decrease in compliance. So we have increased stiffness of the aorta and the proximal branches. So yeah, systolic is more than 160, diastolic less than 90. So this is the cause, increased stiffness or decreased compliance of the aorta. Yeah, compliance is the kind of the stretchiness. So increased stiffness of the aorta. So next we have mean arterial pressure. MAP into cardiac is equal to mean arterial pressure equals the cardiac output time multiplied by the total peripheral resistance. MAP at resting heart rate equals 2/3 diastolic plus 1/3 systolic. DBP plus 1/3 of pulse pressure. I think this comes up in so many questions. Mean arterial pressure is equal to cardiac output times TPR. MAP at resting heart rate equals 2/3 the diastolic plus 1/3 of systolic, which if you simplify, this is DBP plus 1/3 of TP. Diastolic plus 1/3 of the pulse pressure. Okay.
I think Faisal has a mnemonic for that. Faisal, do you?
Say again, sorry.
Someone has mnemonic for this formula, MAP.
MAP.
I'm not wrong. No. For resting heart, diastolic blood pressure plus 1/3 of systolic blood pressure.
This one.
It's okay.
MAP. No memory. MAP equals 2/3 DBP plus 1/3 SBP. Anyone? Any mnemonics? I think we had it during the mixed dual, but I don't remember now. MAP 2/3 DBP plus 1/3 systolic. Okay. Yes, we'll see it on the group chat maybe. All right, so next we have the Starling curves. We had lots of discussion on this when we did Rahul's cardiac sessions. And sorry, I know I've forgotten I'm taking names, but if I do post this somewhere, I will cut out the parts with the names if we'd want to be anonymous. So please rest assured. So, okay. So what is Starling curves? Okay, let me read it first. Force of contraction is proportional to the end diastolic length of the cardiac muscle fiber preload. So the force of contraction is proportional to the end diastolic length of cardiac muscle fiber. Increased contractility is seen with catecholamines, positive inotropes like dobutamine, milrinone, and digoxin. And decreased contractility with loss of functional myocardium. It makes sense because force of contraction is proportional to the muscle fiber length. If you have less myocardium, meaning less muscle fibers like myocardial infarction, leads to decreased contractility. Beta blockers, acutely non-dihydropyridine calcium channel blockers, and heart failure. So force of contraction proportional to the end diastolic length of the cardiac muscle fiber. So here we're seeing ventricular EDV preload plotted against the stroke volume on the y-axis. So normal, it's the blue curve in excess. No, normal at rest is black, and normal with exercise is the blue curve. Rest, running, walking. So what happens is if there's heart failure plus or with a positive inotrope, the curve is coming down, decreased contractility with loss of functional myocardium. So less myocardium, less end diastolic length of the cardiac muscle fiber. So that's why the curve falls down. EDV is low. Yeah, and same with the heart failure.
First they are showing that the lower one, red one, that the heart failure is going down. In heart failure, stroke volume goes down. But when you add the inotrope, positive inotrope like dobutamine, and digoxin and milrinone, then it goes up.
Okay, because we're increasing the myocardial contractility. Is that what it was?
Yes.
Yes. Okay. Thank you, Hamna. I think I really need your help for the systems. But yeah, so heart failure. Then we add a positive inotrope, so it increases. That's what they're showing. Okay, my bad. Yeah, we did have some confusion. I don't know if it was settled back then, but yeah. Preload, afterload, and contractility. Preload is the initial stretching of the cardiac myocytes, muscle cells prior to contraction. It is related to ventricular filling. Afterload is the force or load against which the heart has to contract to eject the blood. This is from Google, I believe. Contractility is the intrinsic strength of the cardiac muscle, independent of preload, but a change in preload will affect the force of contraction. So it's the intrinsic strength of the cardiac muscle fibers itself, which is independent of the preload, but a change in preload will affect the force of contraction. So afterload is the load to which the heart muscle must, afterload is the load to which the heart must pump against. Afterload goes down when aortic pressure and SVR decreases through vasodilation, which makes sense. Yeah, when aortic pressure and systemic vascular resistance decreases through vasodilation. Decreasing afterload will affect the Doppler numbers and number of ways peak velocity may increase the heart easier to pump against decreased pressure. This will also affect the corrected flow times as the duration of aortic blood flow increases as the afterload increases. Okay, yeah. So I believe this is what we need to know. Anyone remembers how they asked this in questions with the Frank Starling? It's like A, B, and C and ask which curve matches, right? You have a few questions like that.
I think, yeah, and they gave this, this one first line is the question. I think force of contraction is proportional to end diastolic length of the cardiac muscle fiber, which is preload.
Okay.
And then they give this graph and I think they ask about if contractility increases with this catecholamines and positive inotrope, so graph goes up, and decreased contractility with loss of functional, like in MI beta blockers.
Okay.
And heart
So
failure.
they give us A, B, C, D options and we have to pick. Okay. So increased contractility with catecholamines. Sorry, go ahead.
No, go ahead, please. I think so.
Okay, so that's how they ask. Okay, thank you, Hamna. So increased contractility with catecholamines, positive inotropes, dobutamine, milrinone, digoxin. Decreased contractility with loss of functional myocardium, beta blockers, non-dihydropyridine calcium blockers. This is extra stuff. I don't think it's high yield. Okay. So that was cardiac output equations and Starling curves. Anyone would like to add anything? Please feel free. Okay. If not, moving on. Next page, we have resistance, pressure, and flow. Ventricular flow equals the flow velocity multiplied by the cross-sectional area. So ventricular flow rate, Q, equals the flow velocity, V, multiplied by the cross-sectional area. Resistance equals driving pressure, delta P, divided by the Q, okay, which was volumetric flow rate. Driving pressure, which is change in the pressure, delta P, divided by Q, equals 8 times eta. Apparently this was eta, I didn't know. 8 times eta, which is a symbol for viscosity, multiplied by length, divided by pi r4. I think this comes up in questions, right? Flow is proportional to r4 and resistance is inversely proportional. No, resistance is proportional to 1 by r power 4. So yeah, resistance is inversely proportional to the radius. Okay, so capillaries, okay. So total resistance of vessels in series is RT. Total resistance equals R1 plus R2 plus R3. Total resistance of vessels in parallel equals 1 over RT. So yeah, 1 over RT, which is for parallel, equals 1 by R1 plus R2 plus R3. So it's inverse. This comes up in questions, right? With the transplant and removal of an organ and adding of placenta and so on. So this is an important concept. So capillaries, these are also high-yield questions. Capillaries have the highest total cross-section area and the lowest flow velocity. So the highest total cross-section area and the lowest flow velocity is capillaries. Pressure gradient drives flow from high pressure to low pressure. This we understand by now. Pressure gradient drives flow from high pressure to low pressure. Arterioles, this is also a question. Arterioles account for most of the total peripheral resistance. Arterioles. Highest total cross-sectional area was capillaries. Most of the total TPR, total peripheral resistance, is arterioles. Veins, most of the blood storage capacity. So veins provide most of the blood storage capacity. And viscosity mostly depends on hematocrit. Viscosity increases in, this also makes sense. Viscosity depends mostly on hematocrit. Viscosity increases in hyperproteinemic states like multiple myeloma and polycythemia. Makes sense. And viscosity decreases in anemia. So yep, it comes together. All right, so that's resistance, pressure, flow. Next we have the khatarnak cardiac and vascular function curves.
And there is also some question regarding this, if you decrease the radius by 4, something like that, 16. Do you remember that?
Yeah, we had to do the square root, was it? Something like that. I don't remember clearly.
Yeah, square root. If
Yeah,
radius is decreased, so the flow will increase something.
if the radius decreases, and then the
Yeah,
resistance
flow will increase or something like that. If the radius,
yeah, it was a bit counterintuitive, right? That question, I
yeah.
know what you mean. Yeah, if you decrease the radius, the flow increases on the other side, on the proximal side. So we had to do, but there was a calculation question as well. Yep. Classic question with 2 large bore catheters. Yeah. Yep. Yep. I think it'd be a good idea to just like run through the UL questions after doing cardios just to see. We'll see. Probably will do it in a smaller group. Okay. So resistance, pressure, cardiac and vascular function curves. Anyone good at this who wants to try before I mumble jumble? Hamna, do you want to try? Okay.
Sorry, I'm very bad at it.
Okay, let me try. Then you can have pitch in maybe. Okay, so cardiac and vascular function curves. So we have the RAP, which is right atrial pressure, plotted against the cardiac output and venous return. Okay, so intersection of curves is the operating point of the heart. So intersection of the cardiac function curve and the vascular function curve. So this is the operating normal point of the heart. So venous return and cardiac output are equal at this point. So venous return and cardiac output are equal. So it's a balance. As circulatory system is a closed system. So it makes sense, right? Cardiac output, whatever is going out, is matching that what's coming back because it's a closed circuit system. So cardiac output, heart pumps out and comes back where the venous return. So this is equal. So that's the normal operating point of the heart. So that's vascular function curve against the cardiac function curve. So cardiac function is showing us what is the cardiac output, what is going out of the heart. Vascular function will determine what is the venous side. So if we think about it, right atrial pressure as the venous return increases, right atrial pressure also increases. So that makes sense, right? We have to look at it in reverse. So this, if they are saying this is a venous return, as the venous return increases, if we plot numbers, the right atrial pressure also increases. So at this point, right atrial pressure is actually, no, it doesn't make sense. Right atrial pressure is low. Nope, I don't get it. Okay, let's see. So this is the operating point of the heart. If it goes up, then there's increased inotropy, which is contractility. If it goes down, that is decreased contractility or decreased inotropy. Okay, let's see for curve A, inotropy, changes in cardiac contractility lead to altered stroke volume and altered cardiac output, a VR curve, and the RAP. So this has gone up. Changes in effect. Okay, so what is the graph inotropy? What's the effect? Changes in contractility leading to altered stroke volume, altered cardiac output versus CO divided by VR and RAP. So examples are catecholamines, dobutamine, milrinone, digoxin, and exercise. Okay, so stimulate. So that on the big picture, it does make sense. If there's catecholamines, dobutamine, milrinone, as we said, these are going to increase inotropy and exercise. So they will increase the contractility of the heart and the curve will shift up. Then 2, heart failure with reduced ejection fraction, narcotic overdose, and sympathetic inhibition. Contractility will go down. So the curve is shifting down. If we say this is the normal balance, normal ROC or operating point, then this goes up and this goes down, okay, with inotropy. With venous return, changes in circulating volume leads to altered right atrial pressure, altered stroke volume, and changes in cardiac output.
Hey, hi. I just want to clear in the B, like he'll give you nitric oxide, like he'll give you nitrates in the picture, and he'll ask you to, check for where does it act on. So it's on 4 actually. So it your preload. So
Say again, because
it decreases the preload. It acts on both the arteries and vein, but it has significant reduce in the preload.
Yeah, I remember that question. Yeah. Okay, so yeah, 4 is also nitrates. Yes. Yeah, that is important, right? Nitrates versus nitroprusside. Nitroprusside works equally. Nitrates works more on the veins. So it decreases the preload. So that makes sense that this curve will drop to this side. Yes. Thank you, doctor. Yes. Yep. So what are we saying? B is the venous return curve. So changes in circulating volume, altered right atrial pressure, altered stroke volume, changes in cardiac output. So 3 with fluid infusion makes sense. We're putting fluid into the veins and more into the circulatory system. So the curve shifts up. So either the increase for volume or venous tone. Sympathetic activity and arteriovenous shunt. Sympathetic activity, I think, because we are vasoconstricting the peripheral, that's increasing the volume of the venous return. And arteriovenous shunt, so again, more blood is coming to the venous side and coming back. So there's increased volume, the curve shifts up. Versus 4, if you're losing volume in the circulatory system, like acute hemorrhage and spinal anesthesia, it's decreasing. So, and as the doctor said, nitrates. So we have to pick this curve for nitrates. Okay. All right, then we have total peripheral resistance. Changes in total peripheral resistance lead to altered cardiac output, and changes in RAP, unpredictable. What are they saying? Changes in total peripheral resistance leads to altered cardiac output. Makes sense. Changes in right atrial pressure, unpredictable. So with vasopressors, it goes up. So again, if this is the normal curve with vasopressors,
Vasopressor is going down. Number 5.
oh, sorry, yeah, this one, number 5.
6
Okay, yeah, that's stuck. Okay, so with vasopressors, increased total peripheral resistance. So the curve is going down. Increased peripheral resistance, so peripheral vasoconstrictors. So
it'll decrease both the cardiac output and venous return, right?
Cardiac output goes down because it has to pump against more resistance.
Yeah.
Venous return is going down because
not letting the blood to flow and back to the heart.
With vasoconstriction, okay.
It is like a stasis is happening at the periphery, right? What I think of, if so much of the TPR would increase, right?
I mean,
yeah, stasis would be with.
No. That is with the vasodilation. Yeah. Wrong. Sorry. Yep.
No worries. So Hafsa said increased TPR after increased contractility and vice versa. Increased TPR after increases after load. Yes. So increases contractility. Yes, that makes sense. But why does the venous return go down? I'm not sure.
Sarah, I think the less cardiac output, then the less venous return would be there, right? I mean, that.
Right. That was the reason. So if output is less, then back return will also be less. So that's what it was. Yes. Thank you, Shruti. So yeah, with vasopressors, increase TPR, so increase the vasoconstriction on the peripheral side. So the heart has to pump against more resistance. So cardiac output is dropping. If less is going, less will come back. So that's venous return is also dropping. Yes. Awesome. We got it. Thank you. So with vasopressors, the curve is going down. And then with exercise and AV shunt, yeah, with exercise, we have adenosine and everything coming in the muscle, so it causes peripheral vasodilation. So TPR is falling, and now because there's vasodilation, it's easier for the heart to pump out. So cardiac output will also increase. So decreased TPR, leading to the curve shifting up. Cardiac output is increasing, venous return is also increasing. Okay.
But they both have the same end diastolic volume, right? Same.
Say again?
Same. They both have same end diastolic volume, right?
For which one you're saying? Exercise.
5 and 6.
5 and 6 both have the same end diastolic volume.
At the end when they come back.
That makes sense, yeah. Yeah. So although it's dropping, the end diastolic volume is still the same.
Because the point, as you see, from going from the mark to 6 and coming down to the 5, the rest renal arterial pressure is the same as EDV, right? End diastolic volume. So they both are on the same point. So basically, end diastolic volume will be the same, even though your cardiac output is decreased and venous return is decreased. They are opposite to each other, but end diastolic volume remains the same.
I see what you mean, yeah. Because we said the approximation preload was EDV, afterload was MAP. So you're saying EDV will still remain the same. Okay.
Isn't it like end diastolic is going to vary because the peripheral resistance is coming? So when the resistance is more, the heart is not able to pump much of the blood. So in that case, the EDV would increase, means diastolic volume would decrease, which stays back in the left ventricle. When the TPR is less, the cardiac output would increase, correct? So there would be the less end diastolic. So that would vary, but I think in here, the RAP is, the end, the right atrial pressure is not gonna change by changing the TPR, because whatever we are ejecting, the same thing is coming back, correct? So the pressure, the right atrial pressure is not changing with the change of the 5 and with the change of the peripheral resistance.
Where would we see EDV in this? Like, where would we plot it?
No, it's not plotted, but this is like analogy.
Interpretation.
Yeah, interpretation. Yeah.
Okay.
Means correct me if I'm wrong.
I think that if you are increasing your EDV, then your atrial pressures would automatically go up too. I think, like what happens in a congestive cardiac failure. Yeah.
Yeah, sorry for cutting. Go ahead, please.
No, it's fine.
Doctor.
Because the pressures in the atria are just a reflection of, like what we found earlier on, a reflection of the volumes in the ventricles. So if at the end of the day you have less or more because you are not ejecting a lot, then your pressures would be lower. I mean, it would be higher eventually. So they will change. This graph does not state, this graph does not plot what the pressures or the volumes would be. This graph just tells us about the cardiac output and the venous return, but eventually your right atrial pressures would alter depending on what's happening in there to your stroke volume.
Okay. Thank you. Yeah, that makes sense. Faiz, can you please repeat what you said about the EDV? I'm still trying to make sense of that.
No, because I thought that the right atrial pressure is same as end diastolic volume or preload. They all are the same, right? They go.
No, fast.
No.
End diastolic is after contracts stall, whatever is left in the heart, right? This is one way to say. There is the other way also.
Preload.
But right. No, preload is like what is filled. Okay, what is filled. Okay. End diastolic, you're somewhere. Okay. I am No, you're right.
Yeah,
I'm
I had
sorry. I'm
written
right.
it.
Yeah.
You're right.
So
I just made it like end systolic volume. You're saying end diastolic, right?
diastolic volume.
You're
Yeah.
right, Saz. Thank you so much. Yes.
So
That's why
it's the
if
end
you
diastolic volume, which is the volume left over at the end of relaxation. It doesn't change, you're saying, right?
Yeah, so the middle point, you see the middle, yeah.
Mhm.
So no matter if he takes phenylephrine or
Mhm.
if it's sepsis, right? If exercise or vasopressor, whatever you give, the end diastolic volume remains the same. The preload end diastolic volume will remain the same, and the TPR will, or cardiac output, will change. That's the only difference in this last one. Whereas the other first and the A and B, you see those changing. Right atrial pressure, or you call it end diastolic volume, or you call it preload, whatever you want to call it, you know.
Okay. So here they're showing it remains the same. Okay, yeah.
Yeah, because I remember there was a question for that specific total peripheral resistance. I don't know if it was sepsis, because I know number 6, you also have sepsis there. And
Yeah,
for
that
number
makes
5,
sense.
they
Sepsis
use
because decreased
phenylephrine in the
TPR.
question.
Yeah, sepsis makes sense, right? TPR falls, increase what do you call it's massive vasodilation. So yeah. So
Agree
probably
with
that.
Saz. Yeah, agree with Saz. I was just thinking of the end systolic, actually. I'm so sorry. End systolic volume.
No problem. Thank you.
Thank you so much.
Thank you, Fez. And thank you guys. So for conclusion, we're saying the end diastolic volume will remain the same. Sorry, I'm just making a note. Remains the same no matter the change in TPR. Okay. Okay, thank you. So then it also says changes often occur in tandem and may be reinforcing, like exercise increases inotropy as well as decreasing TPR to maximize cardiac output, which makes sense. So it's double effects. That's what they're saying. Reinforcing effects or compensatory, which is heart failure. We have decreased inotropy. So fluid retention to increase preload to maintain cardiac output. So heart failure, decrease inotropy, makes sense. And fluid retention to increase preload to maintain cardiac output. Okay. So the occur
Can
in
you
tandem.
summarize quickly if you can? What? Just this last one.
This part?
Because no,
Okay.
these last graph, TPR one.
TPR, okay. So changes in TPR causes altered cardiac output, which makes sense, right? So if, for example, let's start with exercise because I understand it better. So exercise, if we're running and then the muscle is contracting, there's a lot of adenosine that will cause vasodilation. If we vasodilate, then we are decreasing the resistance. If we're decreasing the resistance, the heart is able to, left ventricle, it's easier, so peripherally we're increasing we're causing vasodilation. So the left ventricle, if we visualize, it's easier for it to pump. So there's more cardiac output. Correct? So, and then more cardiac output, more venous return. So with 6, with exercise, we're seeing this cardiac output venous return curve going up. So that's with exercise and also with an AV shunt, because again, more volume is coming in because of the shunt. But in vasopressors, what are we doing? We are constricting these vessels, right, on the periphery. So here, this, instead of being this, it will be a very narrow vessel. So the ventricle has to pump against a tight vessel. So what happens? The cardiac output is going to drop. And because the vasopressors are working on the peripheral vessels, if this represents the peripheral vessels, it's working directly on the peripheral vessels. So TPR will go up and venous return will also drop, because less is in the vessels, less volume in the vessels. So cardiac output is also dropping because there's extra afterload. Cardiac output is dropping because of a lot of afterload. Venous return is also dropping because less is going into the vascular system. So with increased TPR, which meaning vasopressors, this is dropping. Cardiac output and venous return is dropping. So that's what was this last graph. And then he said the end diastolic volume will still remain the same. What is the end diastolic volume? It's the volume at the end, volume remaining in the ventricle at the end of relaxation. So that's not changing. What is pumping against, what is pumping outside, that's what is changing, right? So that's why they said EDV will remain the same. So that's what was the conclusion.
In the last case, EDV remains the same, right? In the last
Yeah.
graph.
In the last, yeah, this third graph.
Thank you.
All right, thank you. Hope that made a little bit sense at least.
That was good summary. Thank you.
Thank you. Thank you so much. All right, so moving on. Next, we have our favorite pressure volume loops and cardiac cycle. Okay, so this is not as bad because we have a mnemonic and easy way to remember. So let's see. So the black loop represents the normal cardiac physiology. So let's see what are the phases of, and these are all corresponding to the left ventricle. So 1 and 2. So here the mitral valve is closed. There's isovolumetric contraction, which is the period between mitral valve closing and aortic valve opening, which is the period of highest oxygen consumption. This also they asked in a question, I think. So the isovolumetric contraction, what do they mean? Volume is the same. So we are plotting the graph. What are we seeing? Left ventricular volume on the x-axis and left ventricular pressure on the y-axis. So volume is at the same point, but pressure is increasing 20, 40, 60, 80. So it's going up until the valve is flipped open. Aortic valve flips open at this pressure. So that's the isovolumetric contraction, period between the mitral valve closing and the aortic valve opening. And this is the period of highest oxygen consumption. So again, this is ventricular systole because the ventricle is contracting, pressure is increasing, but the volume has not changed. Then at point 2, the valve flipped open and now systolic ejection. So the period between the aortic valve opening and the aortic valve closing. So here we are seeing from this point, let's say if this is a volume, I'm just giving an example for ease of understanding. Let's say this is 100, 80, 70, 60, 50, 40, 30, 12, and so on. So the volume has gone down. So systolic ejection, the period between aortic valve opening and the aortic valve closing. So it's emptied out. So now the valve closes, giving the S2 heart sound. So these are still the ventricular systole, ventricle contracting. So 1 and 2 represents ventricular systole. Now we go to point 3, which is isovolumetric relaxation, which is the period between the aortic valve closing and the mitral valve opening. So the ventricle has ejected out. So now the ventricle is relaxing. So again, volume is still the same and systolic volume, but the pressure is falling. So pressure came down from 100, 80, 60, 40, 20. So this is isovolumetric relaxation. Isovolume, same volume, relaxation, pressure drop. So this is period between the aortic valve closing and the mitral valve opening. Next, we have 4, which is rapid filling. So the period just after the mitral valve opening. So there's rapid filling in this point 4. Then as it's now started to fill, there's reduced filling. So period just before the mitral valve closes again. So from here to here is again all ventricular diastole. First it relaxes, but no volume change. Then it's rapid filling and then reduced filling. So that's the phases of the left ventricle. And as some of us might know, our old mnemonic from UWorld, MAM COCO, so MAAMCACOCO. This was from our old study partner. I don't take credit for this. It's not my own. So that's to remember mitral valve closure. At this point 1, we get a few questions on, quite a few questions actually on this cardiac cycle curve. So 1, mitral valve closure, 2, aortic valve opening, 3, aortic closure, 4, mitral opening. Yeah, because sometimes it takes time to think about what's going on. So just a quick way, MAM COCO is a mnemonic, and S1 is at point 1, isovolumetric contraction. S2 is at point 3, isovolumetric relaxation. Extra heart sounds are also heard between 4 and 1. They usually ask this, right? S4, they give a scenario where there is an S4 heard, either volume overload or pregnancy, and S3 and S4, where are they heard? It will be between these points. So S3 is at the rapid ventricular phase, and S4 is just before S1. Actually, I should mark that here, yeah. S4 is just before S1. So that's the normal cardiac cycle. Then what else are we seeing here? So yeah, increased preload. This, I think it's easier to see in the individual, which comes up in the other page. But increased preload, increased stroke volume. I think this was Hamna's mnemonic. It looks like a P, so there was increased preload. This looks like an A, so it's increased afterload, increased aortic pressure, decreased stroke volume, increased ESV. We'll discuss in depth, I think, when we get to that page. But increased contractility, this looks like a C, so increased contractility. So when you see the before and after curves, you kind of have to visualize it. P is like this, so increased preload. A is like this, so increased afterload. C is like this, so increased contractility. So yeah, that's the little bit of a mnemonic to help. Okay, so next we have heart sounds. S1 is the mitral and tricuspid valve closure, loudest at the mitral area. So this, S1 is mitral and tricuspid valve closure, loudest at the mitral area. Then S2 is the AP valve closure, loudest at the left upper sternal border. So yeah, also I will make a note of, what was this topic? Cardiac vascular function curves to review later. Okay, so yeah, heart sounds, back to this. S1, mitral and tricuspid valve closure, loudest at the mitral area. S2 is aortic and pulmonary valve closure, loudest at the left upper sternal border. S3 in early diastole during rapid ventricular filling phase. So yeah, rapid ventricular filling phase is S3. What is S3? It's a sound produced by rapid filling of a compliant ventricle, versus S4 is the filling of the stiff ventricle. So as Dr. Ryan puts it, S4 always thinks stiff ventricle. And S3 is rapid filling of a compliant ventricle. So if there's volume overload, it's going to fill even faster. So that produces a sound. So S3 in early diastole during rapid ventricular filling phase, best heard at the apex with patient in the left lateral decubitus position. So yeah, that makes sense, right? Left lateral decubitus, we're putting the heart closer to the chest wall, and there's a volume overload state, so it will be heard better. Associated with increased filling pressures like MR, AR, heart failure, and thyrotoxicosis. And more common in dilated ventricles, but can be normal in children, young adults, athletes, and pregnancy. Yeah, so this is normal in this population because children, young adults, athletes, pregnancy, it makes sense. They're growing, they have more volumes. Athletes, they're working on more and stuff. So, and pregnancy, hyperdynamic state, yes. So turbulence caused by blood from LA. Turbulence caused by blood mixing from, turbulence caused by blood from the left atrium, mixing with the increased end systolic volume. Turbulence caused by blood from the left atrium, mixing with the, mixing with the stuff which is remaining in the ventricle. Increased end systolic volume. Yes, makes sense, right? Because it's a volume overload or hyperdynamic situation. The blood coming from the left atrium is mixing with some leftover blood. So that's causing turbulence that produces a sound. The turbulence is caused by blood from the left atrium mixing with the increased end systolic volume that is left behind after contraction, ventricular contraction. So it makes sense. Next, we have S4, which is in late diastole, as we saw here. This is known as the atrial kick. Turbulence caused by blood entering a stiffened left ventricle. It's best heard at the apex with the patient in left lateral decubitus position, again for the same reason. High atrial pressure associated with ventricular non-compliance like hypertrophy. Considered abnormal if palpable. Yeah, this is usually a buzzword. The palpable S4 or palpable thrill or something like that they say to indicate S4 in questions. So palpable, when they say, it's usually in relation to S4, and it's common in older adults. Because of the stiffness, as we said, compliance goes down. So they have stiff ventricles, so it's common in older adults. Okay, then we have the JVP. Okay, let's finish this and come to the curves. Okay, so what is the jugular venous pulse? My understanding is, I don't know the exact method, but we are measuring so we have the left ventricle, the right ventricle, we have the right atrium, we have the superior vena cava, the inferior vena cava, and that's connected somehow, I don't know exactly how, but to the jugular vein. So if we put a catheter or something and we measure the pressures in the jugular vein, that will create a reading. So that's what we are looking at, the JVP. That's causing a curve. So that's the right atrial pressure curve. So A wave, first the right atrial contraction. So that will cause increased pressure, right? This muscle is contracting. So that will cause an A wave, this A wave, prominent in AV dissociation, like a Canon A wave, which makes sense because the atria and ventricle are beating at their own pace. So that causes a Canon A wave, and it's absent in atrial fibrillation. So this is just vibrating in atrial fibrillation. So it doesn't give a good pressure reading. So it is absent in atrial fibrillation. So it makes sense. A wave is normal atrial contraction. Next is C wave. The right ventricle is now contracting. So this pressure is transmitted, and then it's read by the catheter. So that's the C wave, the right ventricular contraction against a closed tricuspid valve. Of course, the tricuspid valve is closed, but then the pressure transmits, and that's gone to the reading. So right ventricular contraction, closed tricuspid valve, bulging into the left atrium. That bulge creates a pressure. That pressure is transmitted to the jugular vein, and that's what we are reading. Then next is the X descent, atrial relaxation. And so atria is now relaxing and filling, right? So this valve dips down a little bit. So atrial relaxation and downward displacement of the closed tricuspid valve during rapid ventricular ejection phase. So that makes sense. This part is now contracting and ejecting to its associated, pulmonary trunk. So if this valve is dipping down, so that's the atrial relaxation and downward displacement of the closed tricuspid valve during rapid ventricular ejection phase. Reduced or absent in tricuspid regurg, it makes sense. There won't be this dip because the valve is loose and blood is regurgitating back, as well as right heart failure. Right heart failure means what? The right ventricle pump is gone. So it's not working. So right heart failure, again, no pressure generated for us to see the X descent. So reduced or absent X descent in tricuspid regurg and right heart failure because pressure gradients are reduced. So yeah, pressure between the atrial side and the ventricular side in heart failure will equalize almost the same. So that's the reason, we're not going to see X descent in right heart failure. Then V wave, the right atrial pressure, increased right atrial pressure due to more volume against a closed tricuspid valve. So if you visualize, right atrial pressure is building as it gets filled up. So increased right atrial pressure due to increased volume against a closed tricuspid valve. Then right atrium, next what happens? Right atrium empties into the right ventricle. That gives us the Y descent. So V wave, increased RA pressure due to increased volume against a closed tricuspid valve. Y descent, right atrium emptying to the right ventricle, prominent in constrictive pericarditis because there's inflammation of the pericardium. So there's not much room to stretch. Absent in cardiac tamponade, which makes sense. There's absolutely no room to stretch. So the Y descent is absent. So that's the jugular venous pressure. So, yeah. Sorry, someone's trying to enter. Okay, hopefully it made sense. So let's see here. So we said A was atrial contraction, C was right ventricular contraction, X descent was atrial relaxation, and then V was increased right atrial pressure due to increased volume. Okay, and then Y descent was right atrium emptying into the right ventricle. And then, so the ECG, okay, so let's come from the top. What are we seeing time with respect to pressure? So first, again, over here, we have ACX, VY. This is the left ventricular pressures. So mitral valve's closing, aortic valve opens. What am I saying? Left ventricular pressure. So left ventricular systole. So left ventricle is contracting. So it makes sense the pressure rose from 20, 30, 40, 100 up to 120. And then after the aortic valve closes, the pressure is falling. So that curve is the left ventricular pressure. This curve, what I'm seeing is the aortic pressure. So aortic valve opens, and the pressure is rising because at this point, we are ejecting, rapid ejection and then reduced ejection. Aortic valve, like this has done its job. So aortic valve is closing and the aortic pressure again falls. So that was the aortic pressure. Heart sounds. So yeah, mitral valve closure is corresponding to S1. Aortic valve closure corresponding to S2. And then extra heart sound. And we said S4 was just before S1. So that's the heart sounds. Ventricular volume. So yeah, if the ventricle is contracting, it's squeezing blood out. So the volume is dipping down. So that's corresponding. It's just an interpretation. Then we saw about the JVP and yeah, atrial contraction is P. Yeah, we're going to see ECG in detail, but yeah, QRS corresponds to. Sorry, someone saying something? Did I make a mistake? Feel free to correct me if I'm wrong. No, if I will not get offended.
Would you take the JVP again, especially as it relates to the first graph, the ventricular pressures? Yeah.
The ventricular pressure? Okay.
Yeah, the JVP. Just focus on the JVP on the bottom parts. Yeah,
So okay, this left ventricular curve corresponding to the right atrial pressure, right? Okay.
Okay.
So let's see what's happening. So first we said atrial contraction. So when the atria is contracting, if the atria is contracting, the ventricle is.
Well, it depends on the type of which atria. I mean, so the ventricles.
Yeah, correct. Right. Yeah, right. So we talk about right atrial pressure.
Yeah.
So if the right atrium is contracting, here at this point, the left ventricle is beginning to start contracting. So it's just beginning. So what phase would this be? Isovolumetric contraction. So when there is isovolumetric contraction with corresponding to the left ventricle, the atria has it finishes contraction, right? So this part start and here it's ended. So yeah, while the left ventricle is undergoing isovolumetric contraction, right atrium is actively contracting. So that's what is causing the A wave. Whereas we don't have an. Yeah, I wish they gave like another one for the atrium as well, but yeah, okay.
Yeah.
Then next we have the right ventricular contraction. This is still corresponding to the end of isovolumetric contraction of the left ventricle. So the right ventricle is now contracting. So now at this point, the left ventricle and the right ventricle are kind of in sync. But we are seeing the wave because we are measuring the wave in the vein. So it's kind of the right atrial pressure is what we're measuring. But actually what's correspondingly at the same time happening is the right ventricular contraction at point C. So that's the C wave. Then we have the X descent, which is the atrial relaxation and downward displacement of the closed tricuspid valve during the rapid ventricular ejection phase. So these two is what is happening. So as we see, first there is X descent. So here we're still talking about a right atrial relaxation. So when the right atrium is relaxing, the left ventricle is rapidly ejecting. It makes sense, right? When we studied basics, we said when the ventricle is contracting, the atria relaxes and vice versa. So here we're saying ventricle is now actively ejecting, left ventricle is actively contracting and ejecting. So the atria is now relaxing. So that's X descent. During corresponding to the rapid ventricular ejection. So that happens, and then rapid ejection, reduced ejection, complete ejection is complete, and aortic valve has closed. And now we wave increased right atrial pressure. So isovolumetric relaxation of the ventricle is going on. When there's increasing right atrial pressure and it's getting filled up. So at this point, the right atrium is also getting filled up. So which means the pressure is building, it's about to contract, and the ventricle is relaxing. So it makes sense, right? The right ventricle, the atria is about to contract and the ventricle is relaxing. So again, it makes sense that it's opposite. ventricular relaxation, atria about to contract.
Oh,
Then
okay.
this was the V wave. Increased right atrial pressure due to increased volume against closed right. It's contracting, it's about to eject. So next was Y descent. So yeah, right atrial emptying. So now the atria is contracting. And again, this is corresponding to the isovolumetric relaxation. Yeah, so and then we see the pressure has dropped. So the ventricle is completely relaxed. And the right atrium is contracting and emptying it into the right ventricle. So atria contracting, ventricular relaxation. So again, it matches. So Y descent is the right atrium emptying into the right ventricle. So that's, yeah. Then they said prominent in constrictive pericarditis because there's no room to empty it out, and absent in cardiac tamponade. So that was in
there's a proper reason, I think, for that. Absent in cardiac tamponade, prominent in constrictive
external
pericarditis.
compression, right? External compression, right? Because the fluid is filling here. So right atrium is trying to empty. If this was my right ventricle, and right atrium is trying to squeeze and push blood into the right ventricle, but there's fluid outside. The pericardium is inflamed, so it's not able to push. So it makes sense that it will be prominent because now there's more pressure. This fluid is causing some pressure. Versus in cardiac tamponade, it's like from outside we have more pressure. So that pressure is just transmitted. No, I think I'm wrong. I think I'm saying the other way around. Prominent and constrictive
fluid in cardiac tamponade, actually. Fluid in cardiac tamponade. So it doesn't allow it to expand properly.
Yeah.
So
cardiac tamponade is external compression. So that's not allowing any filling to happen. So there's no wave going to the jugular vein. But it's prominent in cardiac in pericarditis because there's some movement still. It's inflamed. So that is transmitting the pressure, I think, if I'm not wrong. Okay. Anyone else want to review anything, like to say it in a better way, more coherent? Okay, hopefully that made sense and was not just a jumble of words. All right, so moving on. So that's the pressure, volume loops and cardiac cycle.
It's nice, Ira. Thank you.
Guys, thank you.
Thank you so much.
Yeah, if I ever like mix things up or if it's too confusing, please jump in and take over. I'm okay with this for systems because this is not my strength. Okay. Next, we have pressure volume loops and valvular diseases. So what are these? We have aortic stenosis, aortic regurg, mitral stenosis, mitral regurg. So in aortic stenosis, yeah, we're pumping against a stenotic or a tight aortic valve. So increased left ventricular pressure, which makes sense because left ventricle has to squeeze more. So increased left ventricular pressure, increased systolic volume. Increase end systolic volume. It's not going to be able to pump out. So there's more left over. Increase end systolic volume. No change in the end diastolic volume. If mild. End diastolic volume, which is at the end of relaxation. Decreased stroke volume, makes sense. Ventricular hypertrophy, decreased ventricular compliance, increased EDP for given EDV. So ventricular hypertrophy, because if you remember that formula with the Laplace law, if you want to decrease wall stress, we cause hypertrophy. We increase the wall thickness. So just correlating Laplace's law. So yeah, ventricular hypertrophy will decrease the ventricular compliance and increases the end diastolic pressure for a given end diastolic volume. Okay, so what are we seeing in the curves? So this was the thing, right? It looks like an A, so it was aortic stenosis. We're increasing the afterloop. And then here, these questions are on NBMEs, like these curves. I remember it was the first question in one of the NBMEs. But yeah, here we're seeing left ventricular pressure, which is normally should be around 120. It's super high, so it's more than the aortic pressure. Then we have aortic regurg. So this looks like a P. So increased preload because the volume, blood is regurgitating back. So here we have no true isovolumetric phase. There's increase in end diastolic volume. increase in stroke volume because the volume keeps accumulating, and now we end up with more stroke volume. Loss of dichrotic notch. This usually mentioned questions. Loss of the notch that we're supposed to see. And then there's also large pulse pressure. So no true isovolumetric phase, increased EDV, increased stroke volume, loss of the dichrotic notch. Then we have mitral stenosis. I don't remember what the mnemonic was for this one. But we have increased left atrial pressure.
We have, sorry, we have increased diastolic volume because blood is regurgitating from the aorta. So more and more blood remains at the end of the diastole, right?
Yes, mitral stenosis.
No, in EDV
Wait,
and AR.
Stenosis, which one are you saying? This
AR.
or this? AR. Yeah, so regurgitating back, so more and more blood is returning and it's accumulating, so that leads to increased end diastolic volume. So because of that extra accumulated backflow, like what do you call it, leftover blood, that is increasing the stroke volume. That's the reason. Yeah, I know this is a bit confusing, right? If you're regurgitating, how are we increasing the stroke volume? So this blood that is regurgitated back is now added on, so that's increasing the stroke volume. And then there's a large pulse pressure, meaning the difference between the systolic and diastolic. Is that what you were saying?
Yes.
Hamna, I think you're good at this. You should explain.
No. I'm very bad. Sorry.
I'm trying. Let's see. Then we have mitral. No, but we used to say a mnemonic. This was A, so this was afterload. This was P, so more preload.
That was
this
A.
one I don't
Aortic
remember.
stenosis. Aortic stenosis, it's A because afterload is increasing, right? So that's why stroke volume goes down.
Yeah.
Yeah, and diastolic pressure increases because more and more left ventricle has to pump with more pressure for the given EDV. And in AR, because it's just like a balloon, so more and more blood coming back from the aorta into the left ventricle. So no isovolumetric phase, EDV increases, and more blood comes, like the usual stroke volume plus the backflow. So I think stroke volume increases. EDV increases, and there is loss of dichrotic notch and widened pulse pressure in this case.
Yeah. So that's a good one. No, but what was this? Did we have a way to remember quickly? Like this looks like a balloon. This one was what? Just a shrunken one?
Mitral stenosis, yeah. Mitral stenosis now. So left atrial pressure will go up. If you, the other curve, no, it's
this one. Right?
Yeah, this one goes up. So left atrial.
Yeah.
So I guess here on this curve, it's an A. So
that was normal. Left ventricle aortic is normal, but only the left atrium is
this one. So the dash on the A, that's the increase.
Because our cousin so from the base.
Sorry.
Because now.
And I just saw Muni. Is she in? She's trying to get in. Oh yeah, she is in. Okay. Yeah, sorry. Go ahead, Hamna.
Yeah, so in this case, mitral stenosis because the left atrial pressure increases as compared to the left ventricle pressure. So if you see the curve, the left ventricle and aortic curves are same, like no change, but the left atrial will be increased pressure in the left atrial pressure. Like it goes up. So mitral stenosis, so no decreased EDV because less blood goes into the left ventricle. So EDV will go down because of impaired ventricular filling. So decreased stroke volume decreased and systolic volume as well. Right?
Yes. Yes. So if we said afterload was MAP, okay, yeah. Yep, makes sense. Because it's not filling, decrease EDV. If it's not filling, there's decrease in systolic volume and decrease stroke volume. So yep, everything goes down. The quick way is this A is in the image, the question. Then we have mitral regurgitation. This one we said it was like a balloon, so no true isovolumetric phase. in decreased end systolic volume due to decreased resistance and increased regurg. So what is mitral regurg? We are regurgitating blood back into the left atrium. So decreased end systolic volume due to decreased resistance and increased regurg back into the LA during systole. Increased end diastolic volume due to increased LA volume and pressure from the regurg. So leads to increased ventricular filling. This is what is counterintuitive. So increased end systolic volume, which is volume remaining after the end of contraction due to decreased resistance and increased regurgitation into the left atrium during systole. The increase in end diastolic volume. Why do we have an increase in end diastolic volume? End diastolic means at the end of relaxation, because of increased left atrium volume and pressure from regurgitation. So net effect is increased ventricular filling. If there's increased ventricular filling, there's increased stroke volume. So forward flow into the systemic circulation plus the backflow volume, which came back into the LA. So net effect is increased stroke volume with mitral regurg. Okay. And this looks like a balloon. So that is mitral regurg. Okay.
So why is decreased ESV?
There's if we are regurgitating, there's less resistance. Let me picture it. End systolic means what? At the volume remaining in the ventricle at the end of contraction. So because there's less resistance, where this I don't know, and increased regurgitation. Yeah, makes sense, because from the ventricle, it's going back into the atrium. This regurgitating. So there's less left back here, right? At the end of ventricular systole. Because usually what's left over is going actually regurgitating into the atrium. So I think that's why they're saying here, increased regurgitation into the LA. So what's left behind is the ESV, that's less. Decreased resistance, I'm not sure I get it. Decreased resistance of what?
Valve is not getting close, so decrease resistance.
Decrease after load, right? You have decrease after load, so decrease resistance, that leads to decrease end systolic volume. Right?
Means, yeah.
Why decrease after load?
Because blood is backing up, right? From mitral regurgitation. Yeah. It's regurgitating, so you have less blood left over, so left after load, right?
Correct, agree.
So as a consequence of this, okay.
Two ways.
So there's less left over. Go ahead.
No, Sarah, same thing. Two ways it's going up also, it's going in aorta, both ways, right?
So due to decreased resistance. Okay, yeah. So normally this valve will be tight and shut. So it will go forward, but now it's loose and decreased resistance. So blood is going in two directions. Nice. I like the way you said that. Thank you, Shruti. And thanks, guys. So yeah, it's going this way and it's going that way. So decreased end systolic volume. What is left over is less. One is because of decreased resistance. So it's going back here and it's regurgitating as well as decreased resistance here. Okay, so it's going in both ways. So there's less left over in the ventricle. So decreased end systolic volume due to decreased resistance and increased regurg into the LA. Does that make sense? No?
Yes. Thank you.
Going both ways.
Yeah. And increased diastole because more and more blood coming from the left atrium into the you will increase left atrium.
Yeah.
Thank you.
So increase end diastolic volume to increase LA volume and pressure from the regurg. So it's refilling back again. So increase ventricular filling. So there's more filling in the now in the ventricle. So more forward flow. So increased stroke volume. Okay. Then this was just a screenshot of the UWorld question. I think this was from Kumar. So C was when we did the group session. Yeah, C was contractility. P looked like this preload. And then A was increasing afterload. And then we need to know what drugs increase contractility, what drugs increase preload, what drugs increase afterload, blah, blah, blah. So then sodium nitroprusside, this was even. I think we'll see it later, but it decreases both preload and afterload. So the the curve just shrinks to the left and down. Normal curve, yeah, this we've seen. End of diastole, 2 aortic valve opens, 3 end of systole, 4 mitral valve opens. This was just junk from my old book. No idea what I've written. Okay. But I think this is important, comes up in a UWorld question. Right atrial pressure. I don't know if you have to memorize this, but let's see. Right atrium minimum is 0 and max. So 0 to 8. Right ventricle is 4 to 25. Pulmonary arteries. This is also very old, so I would not depend on this. So 9 to 25. Left atrium 2 to 12. Left ventricle 9 to 130. Aorta 70 to 130. Okay. Left heart pressures are always more than right heart pressures. LV, aortic maximal pressure is close to systolic BP. Okay. But yeah, I think we should find a screenshot of the normal pressures because they give those images with the pressure changing, and we're supposed to find out where the defect is. So that was the question. All right. So next we have splitting of S2. Okay, so we have physiologic splitting, wide splitting, fixed splitting, and paradoxical splitting. So physiologic splitting, when we inspire, chest wall cavity is expanding. So drop in intrathoracic pressure. If we drop in intrathoracic pressure, there's easier for the venous return. It swoops in, so increase venous return, increase right ventricular filling. If the right ventricle is filled more, now we have increased right ventricular stroke volume, increased right ventricular ejection time, delayed closure of the pulmonic valve. So normally A2, P2 close almost the same. But if we have now increased right ventricular volume and leading to increased right ventricular ejection time, there is a delayed closure of the pulmonic valve. So this is a physiologic splitting seen with inspiration or deep inspiration. Decreased pulmonary impedance, which is increased capacity of the pulmonary circulation, also occurs during inspiration, which contributes to the delayed closure of the pulmonic valve. One more time, the decreased pulmonary impedance, which means the increased capacity of the pulmonary circulation, which makes sense because we're inspiring more circulation going on in the lung side. This also occurs during inspiration, which contributes to the delayed closure of the pulmonic valve. So 2 reasons. One is the drop in the intrathoracic pressure, leading to so and so and so and so. And then the other reason is decreased pulmonary impedance. So because of this, we see a physiologic splitting with inspiration. Now, what is a wide split? It's seen in conditions that delay RV emptying, such as pulmonic stenosis. So pulmonic stenosis means right ventricle is connected to the pulmonary trunk. If, let's say, pulmonary artery is stenosed, so pulmonic stenosis delays the right ventricular emptying. Right bundle branch block, also that's related to right ventricular issues. So it's going to delay right ventricular emptying, causes a delayed pulmonic sound, especially on inspiration. So already on inspiration, if it's deep inspiration, there is a delay. And this is a further delay. So it's an exaggeration of the normal splitting seen in conditions that delay RV emptying. So that's a wide splitting. So it makes sense. Next, we have the fixed splitting. And I think we said, okay, I'll come to it. So fixed splitting is heard in ASD. What is atrial septal defect? We have a left to right shunt. So blood is going from the left atria because it's high pressure towards the right atria. So increased RA and right ventricular volumes. So now increased flow going through the pulmonic valve. So delayed pulmonic valve closure. So it's going to be delayed nonetheless. So regardless of the independent of the respiration, because at any portion of the cardiac cycle, there's increased flow because of the ASD. So that's why it becomes fixed at this point in ASD. So there's a fixed splitting regardless of whether we are expiring or we're inspiring. Because here, if we see, it's only during inspiration. In expiration, it's normal. Inspiration, the split there was a normal delay. Here again, in wide splitting, expiration is the same, but inspiration, we're seeing a larger delay. Actually, no, this is an abnormal delay versus here there is a fixed delay between A2 and P2 is a fixed duration. So that's why it's called a fixed splitting. Where is it seen? Exclusive to ASD. That makes sense. Left to right shunt, increase RA and RV volumes. So increased flow through the pulmonic valve and delayed pulmonic valve closure, independent of respiration. That's the main thing. So whether we're expiring or inspiring, it's the same split, same amount of split. Versus here, we have a different in expiration and it's exaggerated in inspiration. Different in expiration, exaggerated in or delayed in inspiration. So mainly inspiration here, mainly inspiration here. This is fixed because expiration as well as inspiration is equal. Okay, next we have the paradoxical splitting. So heard in conditions that delay aortic valve closure, like aortic stenosis, left bundle branch block. So here, aortic is closing later. So that's the paradox. Normally P2 closes later. And if you have ASD or these situations, P2 closes later. The paradox is now P2 is actually the original location, but A2 has jumped and it's closing later. So that's why it's a paradox. Heard in conditions that cause delayed aortic valve closure, like aortic stenosis, left bundle branch block, normal order of semilunar valve closure is reversed. So paradoxical, reversed in paradoxical splitting, P2 occurs before A2. So P2 is occurring here, the normal delay of P2, but now A2 is even further delayed. So that's a paradoxical splitting. P2 is occurring. I think I misspoke. Hold on once again. So once again, we have P2, delayed P2 in inspiration. Yeah, I think I was right. Yeah, P2 slightly delayed in inspiratory phase, but A2 is closing later, even in expiration, regardless of expiration or inspiration, A2 is closing later. So that's the paradox. So normal order of semilunar valve closure is reversed because normally it's AP, that's the semilunar valves. In paradoxical splitting, P2 occurs before A2. PA, paradox, to remember P before A2. Okay, on inspiration, P2 closes later and moves closer to A2, paradoxically eliminating the split. So it's almost so close that you can't even hear it. So eliminating the split. On expiration, the split can be heard, which is opposite to the physiological splitting. So on expiration, we hear the split because normally the split is heard during the inspiratory phase. That's also the paradox. So one paradox is that A2 is closing later. So the second paradox is we hear the split in the expiratory phase. We hear it better in the expiratory phase. So on expiration, the split can be heard. On expiration, the split can be heard, which is opposite to the physiological splitting. So that's why full of paradoxes. So this was the UWorld image. Physiologic, we have A2, P2 on inspiration. We have a physiologic split. Expiration is closer to each other. Pathologic, if it's a wide split, this is in conditions of delayed P2. Pulmonic stenosis, pulmonary hypertension, ASD, or right bundle branch block, or early A2 like a VSD. This was the additional in UWorld, I believe. And then narrowed splitting. So in cases of aortic stenosis, systemic hypertension, left bundle branch, and HOCM, there is narrowed splitting on inspiration and a paradoxical split. What is a paradox? A2 is closing. I'm sorry, here is the paradox. Like A2 is closing. No, sorry, what am I saying? Paradoxical splitting. P2 is closing before A2. So that's the paradox. And it's heard in expiration. So that's the second paradox. So persistent wide split 2, this differs from, so wide differs from fixed split S2, which exhibits the same amount of splitting throughout the entire respiratory cycle and is explained below. So this was from our group discussions when we had it with Dr. Rahul. Yep. So persistent wide and fixed were different, but yep. Okay. Are we good with this? Splitting of S2, it's done. Okay, next coming to auscultation of the heart. Yeah, some notes are from the group sessions again. Let's see what's going on here. So where to listen? APTM. One sec, sorry. Okay, So APTM, apartment M. So yeah, we have the aortic area, pulmonary area, tricuspid and mitral. So aortic area is for systolic murmur, which is aortic stenosis, flow murmur, physiologic murmur, and aortic valve sclerosis. I think we had a mnemonic for this. I'm trying to find it, but okay. And then so tricuspid area, if it's a holosystolic murmur, I think the mnemonic was this D arms part. So diastolic is always the aortic regurgitation, mitral stenosis, and PRTS. Pulmonary regurg, tricuspid stenosis. Systolic was PS. Please sneak away slowly, Mr. Tiger. So please sneak pulmonary stenosis, aortic stenosis, MRTR. And this was for our Desi friends, Mrs. MS Dhoni, hard ass, was for mitral and tricuspid regurg, systolic, mitral and tricuspid stenosis, diastolic, aortic or pulmonary regurg is diastolic, and aortic pulmonary stenosis is again systolic. It's VSD and MVP are also systolic. So yeah, just to quickly remember. But then locations, I think they usually try to trap between questions between the valvular versus the other one. Let me see if I can find that mnemonic.
Aortic dilation and valvular, right?
Yeah. We said val for left sternal border, val left, and then something like that. I had written it down, but I can't find it. Okay, we'll see. We'll get to it.
In aortic area, it's always with Marfan syndrome, like aortic root dilation, right?
Mm-hmm.
And the other one, there's the aortic wall problem. Then it's this one, left sternal border.
Root was the sternal border?
No, aortic root
Valve.
dilation, which is in Marfan syndrome, that's aortic area.
Mm-hmm.
But the left sternal border, we have like normal valvular problem, like AR.
Mm-hmm. Okay, thank you. Yeah, my brain is stuck at recalling the mnemonic. Anyway, yeah, you're right. Okay. So aortic area, we have the systolic murmur, either it's aortic stenosis, flow murmur, aortic valve sclerosis. Tricuspid, we have either holosystolic or diastolic. If it's holosystolic, we know it's a VSD or a TR, not tested much. Diastolic murmur, tricuspid stenosis. And in the pulmonic side, systolic ejection murmur, we have pulmonic stenosis, ASD, and a flow murmur. Mitral area, again, we have either systolic or diastolic. D arm, so MS, and then the rest is systolic, MR and MVP. This is important. MVP is systolic murmur in the mitral area. Then left sternal border, this is usually the buzzword. So left sternal border, systolic murmur, HOCM, diastolic murmur, AR and PR. But I think instead of this, just remembering the mnemonics helps me. And this was from one of our group member in the bigger group. So SS, so she had said, because it is SS, put it in the middle. So RSSR, and then you put it in the order TPAM. So that's systolic pulmonary stenosis, systolic aortic stenosis, something like that, right? And for diastolic, so this SS comes in the middle. So this is the right opposite. SS comes outside, RR was inside, TPAM again. If it helps, I don't know, I just noted it down. Okay, then maneuver versus the cardiovascular changes. Murmurs that increase with the maneuver and murmurs that decrease with the maneuver. This is high yield. It's a sticky page for me at least. But yeah, you have to repeat on the go. So on standing or Valsalva strain phase, decrease preload. So when we stand or this is important, during the Valsalva strain phase, we decrease the preload, we decrease the left ventricular volume. So murmurs that increase with the maneuver are MVP and HOCM, which are usually the exceptions to the rule. So MVP, decrease left decrease LV volume with earlier mid-systolic click. Pro-click was Dr. Ryan's mnemonic. So MVP, mitral valve prolapse, pro-click. And this is, and then next is HOCM, left ventricular volume. This was Hamna's mnemonic. So empty vessels make more noise. So for HOCM and MVP, think they are louder. So increase with what am I saying? Empty vessels make more noise. So for HOCM and MVP, They are increased when the left ventricular volume is less. So empty vessel makes more noise for MVP and HOCM. Then murmurs are decreased with maneuver. Most murmurs decrease flow through the stenotic or regurgitant valve. So all the rest, they will decrease when we decrease the preload. So decrease flow to the stenotic or regurgitant valve, so making less sound. So next we have passive leg raise. When we raise legs, we increase the preload or increase LV volume. So if you remember in med school, anat labs, standing for a long time, but at the end of the day, everyone would faint. And you do passive leg raise pretty much to get the patient or the classmate to wake up. So passive leg raise. So yeah, whenever we raise legs, we're increasing the preload. So that's to increase the left ventricular volume. Then squatting, here we have increased preload, increased afterload, and increased left ventricular volume again. So when we squat as well, we're increasing preload as well as the afterload. Afterload because we are constricting the peripheral vessels, and preload because more is coming back. So most murmurs will be louder with squatting and passive leg raise because there's increased flow through the stenotic or regurgitant valve. So these two will be the opposite. They always want to be the odd ones out. So MVP and HOCM with increased left ventricular volume, they decrease in intensity. And another thing is there's a later mid-systolic click. So pro click that's supposed to be there comes in a bit later. Then hand grip again, we're contracting. If you want to show your biceps, you're contracting. So that's increased afterload, increased reverse flow across the aortic valve, which makes sense because peripheral resistance were increasing. So the left ventricle has to pump against a closed vessel, as we said. So if this is closed shut, or not shut, actually, that's wrong. If it's tighter, which is increased after load, there is reverse flow from across the aortic valve. So increased left ventricular volume. This is just a visual representation. It's not accurate. So yeah, increase afterload, increased reverse flow across the aortic valve, increased left ventricular volume. So most other left-sided murmurs, which is AR, MR, and VSD, will increase in intensity because more is going through the left side, which makes sense, right? Aortic regurg, mitral regurg, VSD, they will increase in intensity with hand grip. On the other side, aortic stenosis, with hand grip, stenosis murmurs will decrease. Because why? Because of decreased trans-aortic valve pressure gradient. So yeah, that's a bit counterintuitive. So this is important. So with aortic stenosis, when we do a hand grip, the murmur decreases in intensity. Why? Because there's decreased trans-aortic valve pressure. So on either side of the aorta, there's higher pressure. So there's decreased difference. So decreased trans-aortic valve pressure gradient. So that's the reason. And HOCM, why? Because by doing that, we're increasing the left ventricular volume. So again, it makes sense from our logic. So increased left ventricular volume, more volume, less noise. Then inspiration. So the mnemonic was rinspiration and lexi. Again, if you watch Grey's Anatomy, then you know. So lexi, lexpiration. Left-sided murmurs increase with expiration. Right-sided murmurs increase with inspiration. So yeah, what happens here? Increase venous return to the right heart and decrease venous return to the left heart. So most right-sided heart murmurs, rinspiration. So right will increase with inspiration and lexpiration. And so the vice versa, most left-sided murmurs will decrease. And lexpiration, left-sided murmurs will increase in intensity with expiration. And then another question keeps coming up is amyl nitrate. This decreases the afterload, decreases the left ventricular volume, worsens the MVP and HOCM. So yeah, they become empty, so they become loud. Okay, so that's done with auscultation. Next, we have heart murmur.
Can you repeat this amyl nitrate, please?
Yeah, so amyl nitrate, it is decreasing afterload. So by decreasing afterload, it decreases the pressure against which the ventricle has to pump. So if it's decreasing afterload, it's decreasing left ventricular volume.
It means that it increases ejection fraction and decreases end systolic volume. And that's why it worsens MVP and HOCM.
So this is wrong and right. Say again, sorry, let me make a note.
Yeah, so yeah, right. So if it decreases afterload, then it means that it's going to increase ejection fraction and decrease end systolic volume. And then effectively it will decrease left ventricular volume. And you already said that anything that decreases left ventricular volume will increase MVP and HCMMS because it's going to make an empty barrel. The left ventricle will have no volume at all.
Yes, thank you. Let me see the mechanism of action of amyl nitrate. It's a nitrate, so it should cause vasodilation, but let me double check. Is it here in the book? No, that's anyone knows? It's a vasodilator, that's what it says. I mean, yeah, that makes sense, but the exact how it does the vasodilation, I'm not sure. Alkyl nitrates are prepared with the reaction of alcohols.
Saira, that page is there, no, which is coming. So there it was given nitrate. Yeah, NO, it would through the NO nitrate would, and we know that it's vasodilators. Yeah, yeah. But it's in the picture, yep.
Coming up. So okay, so then I'll not get into it. All right, thank you. So are we all good with this page?
Yeah, thank you.
Thank you. So next is heart murmurs. Heart murmurs 97, 98. And then we'll take a break. Okay, so what are the heart murmurs? Again, we know systolic murmurs, again, are mnemonic D arms. So D are AR and MS, and parts, which they've not mentioned because they're not tested heavily. And systolic is please sneak away slowly, Mr. Tiger. So please sneak, again, pulmonic and tricuspid, they don't test much. So pulmonic stenosis, aortic stenosis, MRTR, MVP, and BSD are additional, which are systolic. All right, so let's see. So aortic stenosis, auscultation, we hear a crescendo, decrescendo ejection murmur, loudest at heart base and radiates to the carotids. Usually this is a key clue. It radiates to carotids, which is aortic stenosis. Soft S2 plus or minus ejection click, pulses parvus et tardus, which are weak pulses along with a delayed peak. Association, older, more than 60 years old patients, most commonly due to age-related calcification. In younger patients, most commonly due to early onset calcification of a bicuspid valve. So yeah. Then can lead to SAD, which is syncope, angina, and dyspnea on exertion. LV pressure is more than aortic pressure during systole. So left ventricular pressure is more than aortic pressure during systole. Left ventricular pressure is more than aortic pressure during contraction systole. Okay, yeah, makes sense. Then next we have MR and TR. These are holosystolic, high-pitched blowing murmurs. So blowing word is usually the key clue, and holosystolic, yeah. So MR, it's loudest at the apex, mitral area, and radiates towards the axilla. This is the key clue. Radiation to the axilla is MR, and radiates to the carotids is AS. Tricuspid, yeah, it's heard in the tricuspid area. So I feel like a lot of times just the location helps in answering a lot of the questions, even if, especially the audio ones, which I'm not good at. So Nilo said, amyl nitrate is a vasodilator, a drug that expands blood vessels, increasing blood flow, decreasing vascular resistance. Mechanism of action is involving the release of NO, potent vasodilator. When inhaled, it is rapidly absorbed by the lung alveoli into the bloodstream where it decomposes, releasing NO. NO then activates an enzyme called GMP. Yeah, so we're going to see that coming up. Yes, thank you. Okay, so associations MR, often due to ischemic heart disease post-MI. Yeah, this comes up in the post-MI complications, MVP, LV dilation, and rheumatic fever, which is mitral regurg. So yeah, often due to ischemic heart disease, post-MI, MVP, LV dilatation, and rheumatic fever. TR is often due to right ventricular dilation. Either MR or TR could be seen in infective endocarditis. So it can be either mitral regurg or tricuspid. But yeah, I think for the sake of steps, usually it's tricuspid. But yeah, it could be either. Then we have MV prolapse. So pro-click, that's the quick way to remember this. So although ejection click is for stenosis, we should remember this is a pro-click. Mitral valve prolapse also has a mid-systolic click. So MC for MVP, that's the main thing. So this is to remember pro-click versus steno snap, mitral stenosis snap. So this is the mnemonic stand for the mitral murmurs. So MBP, there's a late decrescendo murmur. So late crescendo, so it's increasing. Here we saw crescendo, decrescendo. Here it was holosystolic, so even throughout the systole. And this is late crescendo, so at second half of systole. Yeah, also, I think so just quickly to remember S1, S2, between S1, S2 systole, S2 to S1 again. The next one is diastole, S3, S4. S4 is just before S1. Just a quick visual. So yeah, back to where I was. So yeah, late crescendo murmur. So it's increasing the crescendo, what do you call the peaks, amplitude, whatever that sounds are increasing. So late crescendo murmur with mesosolic click that occurs after the carotid pulse. Best heard over the apex, of course, because it's a mitral area, and loudest just before S2. So the click is loudest just before S2. Usually benign, but can predispose to infective endocarditis, can be caused by rheumatic fever, chordae rupture, or myxomatous degeneration, primary or secondary to connective tissues. Most common due to sudden tensing of the chordae tendineae as the mitral leaflets prolapse into the LA. So chordae cause crescendo with the click, that's a mnemonic. So yeah, they have a good video on UWorld for this because of the sudden tensing. What was it? They used the word, the minimal filling. Yeah, I don't remember clearly. Let me not get into it. So most commonly due to sudden tensing of the chordae tendineae as mitral valve leaflets prolapse into the LA. Then we have VSD. This is again a holosystolic. So when it comes to holosystolic, is either MR, TR or VSD. So MR or VSD mostly for the sake of boards. Holosystolic, harsh sounding murmur, loudest at the tricuspid. Congenital causes like TOF and larger VSDs have lower intensity murmur than smaller VSDs. So yeah, this is important. So larger VSD have lower intensity murmurs than smaller VSD. So small septal defect will make a louder noise. Larger VSDs have lower intensity murmur than smaller VSDs. So if you remember, small kids will make more noise, but as you get larger or older and wiser, there's lesser intensity because you know when to keep quiet. So larger VSDs have lower intensity murmur than smaller VSDs. Okay, then diastolic D arms, so AR and MS. So early diastolic, so what is this? Early diastolic, so it's after S2, between the S2 and the next S1. So early diastolic, decrescendo, so it's dropping down, going down. So decrescendo, high-pitched blowing murmur. Best heard at the aortic root dilation or left sternal border valvular disease. So early diastolic, decrescendo, high-pitched blowing murmur, best heard at the aortic root dilation or left sternal border valvular disease. Causes include BARE, bicuspid aortic valve, endocarditis, aortic root dilation, and rheumatic fever. So wide pulse pressure, pistol short femoral. These are all clues in the questions. Wide pulse pressure, which they may not mention, but we will see that the systolic BP and the diastolic have a big difference. So it's very subtle. So wide pulse pressure, pistol short femoral pulse, pulsing nail bed, which is known as a Quincke's pulse. This is mentioned sometimes. And head bobbing is also a very important clue. Hyperdynamic pulse and head bobbing. So these are all for aortic regurgitation. All the bobbing, wide pulse pressure, pistol and pulsing. And yeah, you all had said this is de Mosset sign. So hyperdynamic pulse and head bobbing when severe and chronic can progress to left heart failure, LV dilation and eccentric hypertrophy. Okay. The next we have mitral stenosis. So steno snap was Dr. Ryan's mnemonic. So follows the opening snap, delayed rumbling mid to late murmur, and there's decrease interval. This is a question, actually, it's a high yield question. Decrease interval between S2 and the opening snap correlates with increased severity. So your mitral stenosis, it follows opening snap, delayed rumbling mid to late diastolic murmur, decrease interval between S2 and O2, OS correlates with increasing severity. So yeah, clinical associations with late and highly specific sequelae of rheumatic fever, chronic MS can result in left atrial dilation and pulmonary congestion, AFib, Ortner syndrome, which was compression of the esophagus and the left recurrent laryngeal nerve, causing dysphagia and hoarseness. And so Ortner syndrome, hemoptysis, and right heart failure. So opening snap due to abrupt, why do we hear opening snap? It's due to the abrupt halt in the leaflet motion in diastole after rapid opening due to fusion at the leaflet tips. So left atrial pressures are super high, more than the left ventricular pressure during diastole. So yeah, here aortic regurgitation associated with left ventricular dilation, mitral stenosis associated with left atrial dilation, which makes sense, right? It's backing up. So yeah, left atrial dilation, that will back up into the pulmonary system. So pulmonary congestion, AFib, because if you remember those, what was it? The site where the ostia of the, what was it? Ostia, the pulmonary veins, was it? Where the AFib arises. I think that was the most common site, something like that. Yeah, it'll come later when you do patho. So yeah, atrial fibrillation, Ortner syndrome, hemoptysis, and right heart failure. Hemoptysis makes sense because it's backing up in the pulmonary side, so they get overloaded, and hemoptysis is right heart failure. Then continuous murmur is mainly for PDA, continuous machine-like murmur, heard best at the left infraclavicular area, loudest at S2, often due to congenital rubella or prematurity. Often due to congenital rubella or prematurity, you need a patent for that machine. So this was pulmonary regurg, but yeah, it's not tested. So it's a decrescendo configuration murmur, early diastolic. Okay, never mind. So yeah, PDA is a continuous machine-like murmur, best heard at the left infraclavicular area, loudest at S2, often due to congenital rubella or prematurity. So recall rubella was a Matona virus currently. It previously used to be classified under the Toga virus family. Okay, next, coming to myocardial action potential. Pacemaker action potential, and then EKG.
Saira? In the previous page, here, there is a question of the MR and TR. They have given whole the scenario, and then both the option and the cardiophonogram was there. Phonocardiogram, in which they were showing this, very much like the murmurs. So the answer was, I think it was TR, because TR increases with the inspiration. Remember, something like that was there, like TR
both options.
And the scenario was looked like we cannot distinguish in between, like it would, the scenario what they have given, it was very confusing in between MR or TR. But the cardiophonogram what they have given is like it's very it's like it's showing the murmur is very much increased with the inspiration. So they have given expiration, inspiration, expiration, inspiration, and when you see the inspiration, there is so much of the length between, the gaps between, these murmurs were very close. Yeah, so it is something like TR is increases with the inspiration. That was the one thing. So we need to pick it.
That's a good one. Do you have the?
I'm checking.
Okay, I remember the question you're talking about. Yeah, it was very sneaky.
Yeah.
So what we needed to know is the right-sided increase on inspiration and left-sided on expiration. So that would be the only difference between an MR and a TR. Yeah, nice. Thank you for pointing that out. That was a good one. Yep. Yeah, if you find that ID, that will be a good one. Yes, rubella matona. Yes. Thank you. Okay. Next we have myocardial action potential and the pacemaker action potential. Okay, so phase 0 is the rapid upstroke and depolarization. So mainly because of the voltage gated sodium channels opening. Phase 1 is initial repolarization. So we know that the baseline is resting membrane is -85 for the myocardium. And so the rapid upstroke from negative, because of the influx of sodium, is becoming positive. So upstroke and depolarization. Depolarization means this increased positive charge, the polarity is lost. So rapid upstroke and depolarization because of the voltage gated sodium channels are open. Then we have phase 1, which is the initial repolarization, inactivation of voltage-gated sodium channels. So that's where it dips a little bit. Voltage-gated potassium channels begin to open. That's the phase 1. Phase 2, or the plateau, two things. So calcium influx through the voltage-gated calcium channels balances the potassium efflux. So the calcium influx through the voltage-gated calcium channels balances the efflux. So calcium influx triggers calcium release from the sarcoplasmic reticulum. So calcium induced calcium release, right? Calcium influx triggers more calcium release from the sarcoplasmic reticulum and myocyte contraction, and that leads to the excitation contraction coupling. So one more time, phase 2 is the plateau. Calcium influx through the voltage-gated calcium channels balances the potassium efflux. So both are positively charged and they're balancing each other out. So that leads to the plateau. Yeah, so the calcium influx triggers calcium release from the sarcoplasmic reticulum and myocyte contraction, leading to the excitation contraction coupling, which we'll be seeing later. The next is phase 3. Phase 3 is a rapid repolarization. Re means it's coming back to its negative resting state. So rapid repolarization, massive potassium efflux. So if potassium is leaving the cell, the inside of the cell is going to become back to negative. So rapid repolarization, massive potassium efflux due to opening of the voltage-gated delayed rectifier potassium channels. This they ask a question on, and closure of the voltage-gated calcium channels. So yeah, rapid repolarization, massive potassium efflux due to opening of the voltage-gated slow delayed rectifier channels. So potassium tends to go out of the cell. So by opening these channels, potassium is going out, the inside of the cell is becoming negative. So the membrane potential is returning back to its negative resting state. So there's also closure of the voltage-gated calcium channels. So no more positive stuff coming inside. So repolarization phase. Next is phase 4, the resting potential, high potassium permeability through the potassium channels. So potassium permeability is still leaking out. So if potassium is still going out, the inside of the cell is negative. So it maintains at the minus 85 millivolts. So yeah, this occurs where in all cardiac myocytes, except for the SA and AV nodes. And for SA AV nodes, it's the pacemaker potential and slightly different. So yeah, so 200 millisecond is the effective refractory period. Refractory period means no other current can happen at this time. So everything is refractory. So the quick mnemonic was MAP or VAP 0, 1, 2, 3 and KC. I don't know if this helps. It helps me sometimes if I don't have to think about the whole thing. So 0, 1, 2, 3 NKCK, in, out, in, out. So that's MAP. And yeah, so equilibrium potentials, this comes up in a couple of questions. I think even an NBME question actually. So potassium is approximately minus 95. Chloride is at minus 76. Sodium is plus 70. Calcium is plus 125. Ion always diffuses in a direction that brings the membrane equilibrium towards, equilibrium potential, I believe, I'm not sure. Membrane towards its equilibrium too, yeah. ME was, thank you, Shruti. 1983, okay. Ion always diffuses in a direction that brings the membrane equilibrium, membrane potential, I think, towards its equilibrium. Okay, so in contrast to skeletal muscle, the cardiac muscle action potential has a plateau. Yeah, in contrast to skeletal muscle, the cardiac muscle action potential has a plateau due to calcium influx and potassium efflux. Cardiac muscle contraction requires calcium. Yeah, this is important. Cardiac muscle contraction requires calcium influx from the ECF to induce calcium release from the sarcoplasmic reticulum, which is a phenomenon known as calcium-induced calcium release. Cardiac myocytes are electrically coupled to each other by gap junctions. This is also high yield. So how is one myocyte communicating with the other? Via gap junctions, electrically coupled. Okay, so that's myocardial action potential. The next we have pacemaker action potential, where does this occur? SA and AV nodes. Key differences from the ventricular action potential include the phase 0 upstroke. Okay, let's see. So phase 0, the upstroke, opening of voltage-gated L-type calcium channels, which are long-lasting dihydropyridine sensitive calcium channels, which is the L-type. So yeah, upstroke is the opening of the voltage-gated calcium channels. Fast voltage-gated sodium channels are permanently inactivated. because of the less negative resting potential of these cells. So this is the key difference. So the fast voltage gated sodium channels that occur over here, they are permanently inactivated in the SA and AV node. Why? Because of the less negative, as we see here, the negative resting membrane potential is -60 versus here it was -85. So fast gated sodium channels are permanently inactivated because of the less negative resting potential of the SA and AV node cells, results in a slow conduction velocity that is used by the AV node to prolong transmission from the atria to ventricles. So it's beneficial over here. So there was a reason why they did that. So it results in slow conduction velocity that is used by the AV node to prolong transmission from the atria to the ventricles. So phase 1 and phase 2 are absent. That is another key difference. Next, phase 3, repolarization. Inactivation of the calcium channels, and increased activation of the potassium channels. So yeah, inactivation of the calcium. So calcium is no more in play. Increased activation of the potassium channels. So increased potassium efflux. So if potassium is positively charged, if it's leaving out of the cell, what happens to the cell inside is becoming negative. So this is returning to its resting membrane potential. Okay, now next is phase 4. What is phase 4? It's a slow, spontaneous depolarization due to the funny current. This is super high yield. Funny current. It's a slow, spontaneous diastolic depolarization. Depolarization means what? Again, we're losing polarity. The inside of the cell is usually negative. Outside of the cell is positive. So when this changes, that is a depolarization. Polarity is lost. So slow, spontaneous diastolic depolarization due to the funny current. IF channels are responsible for a slow mixed sodium inward, potassium outward current. So these funny channels are responsible for a slow mixed sodium inside and potassium outward. So which makes sense, right? We said if sodium is going in, positively charged, potassium is going out, but there are slow changes in such a way that the net effect is the inside of the cell is becoming positive. So the funny channels are responsible for the phase 4 mainly. Slow mixed sodium inward and potassium outward current. Different from the influx of sodium in phase 0 of the ventricular action potential. So they are different channels. Sorry, where did I go? So yeah, different from influx of sodium in the phase 0 ventricular action potential, accounts for automacity of the SA and AV nodes. This is important. What is responsible for the automaticity of the SA and AV node? It's the funny current. Yeah, that's what I've said here. IF funny current responsible for automaticity. Okay, the slope of the phase 4 in SA node determines the heart rate. This is also super high yield fact, which makes sense. The slope of the phase 4 in the SA node determines the heart rate. So between the two, pacemaker potentials, the phase 4 is what determines the heart rate. So if it's a short phase 4, then we know there is an increased heart rate. So the slope of the phase 4 in SA node determines the heart rate. Acetylcholine and adenosine decrease the rate of diastolic depolarization and decrease heart rate. Acetylcholine and adenosine decrease the rate of diastolic depolarization, and that's how they decrease the heart rate. Makes sense. While catecholamines increase the depolarization, so they increase this thing to trigger and shoot. So catecholamines will have more depolarizations, thereby increasing the heart rate. So it makes perfect sense from our correlation. So catecholamines increase depolarization and increase heart rate. Adenosine and acetylcholine decrease the rate of diastolic depolarization and therefore decrease heart rate. Sympathetic stimulation increases the chance that the funny current channels are open, and that's how they increase the heart rate. Sympathetic stimulation increase the chance that the funny channels are open and thus increase the heart rate. So that was the phase 4. So again, quick way to remember: PAP 403 and CK in out. So it's slightly different, but if you remember these two, then it's just a quick way to recall.
Can you repeat these mnemonics, please?
Yeah, VAP or MAP 0, 1, 2, 3. So it has all the phases, right? 0 phase, 1, 2, 3. NK, CK. So yeah, NK, CK is a mnemonic. In, out. So it's alternating. Then, yeah, you can make funny mnemonics out of this if you want to remember. Next is PAP, which is the pacemaker action potential. This is just remember it is a code 403 NCK, which are the actually pretty much the main players. So NCK. I don't know, people watch cricket or the games, you can always make some mnemonics. And 403 NCK in and out.
In out, sodium
In out.
potassium.
Sodium in flux, calcium in flux, and potassium going out. So that's the thing. Efflux, influx, efflux. So in out meaning influx, influx, and efflux.
Okay. So in and out, but above in out, right?
Yeah, this is to remember the whether the influx or outflux, but then the curve is slightly different. But yeah, curve we visually remember. The problem is what is happening. I always forget. So that's why I made this. So then MAP versus PAP, the phase 0 is different. So in MAP, we said there's in phase 0, it's the inward flux of sodium. I think I made a mistake. Inward flux of sodium, and this is inward flux of this calcium. This is ulta. I've made a mistake here. So this is PAP versus MAP actually. So in phase, so the main difference is, I think there was a question on this. So phase 0 in myocardial action potential, it's mainly the main player is sodium. Phase 0 in PAP or pacemaker, it's calcium. So this was a question. Okay, I'll correct it later.
And these are L-type calcium channels, which you said these are non-dihydropyridine calcium channels.
Correct.
Right?
These are no. These are dihydropyridine sensitive calcium channels, L-type, long-lasting dihydropyridine sensitive calcium channels. The L-type ones, which makes sense, right? That's where the dihydropyridine calcium channel blockers work. So that's why it's mentioned like that. I think I picked it up from PNB.
But dihydropyridine doesn't work on vessels. These are non-dihydropyridines work on the heart. No?
Dihydropyridine sensitive calcium channels means, okay, yeah, I'm not sure. I think I need to check this. Well, yeah, what you're saying makes sense. L-type dihydropyridine sensitive calcium channel means it will work. Maybe it's non-dihydropyridine. Yeah, I'm not sure about this. Let me check and get back. I'm sorry. Let me mark this.
Maybe I'm wrong.
Anyone knows? I'm not sure. Some of these notes I've written long ago. Even I myself don't remember what I've written sometimes. Long-lasting dihydropyridine sensitive. I think it makes sense, right? Because that's where the dihydropyridine drugs will work. But yeah, let's check and get back on that. I'll check during break. Should we take a break or should we continue with the next pages, 2 pages, and then take a break?
Yes, we should take a break now.
3 hours limit. Okay. Yeah, I think it was intense stuff. Okay, guys, let's take a 15-minute break.
Intense, yes. Thanks, Srini.
Come back.
Very intense. Oh my God.
Okay, guys, thank you. Let me pause this recording. I'll put a timer. See you all in 15. Hi, everyone. Welcome back from break. Thank you, doctor, for sharing this image. So just looking at it, actually. So yeah, it's the Canon A wave, which we saw over here. So it's caused by atrial contracting against a closed tricuspid valve. So it makes sense that it's because the atria is contracting, that reading is going to be, the pressure is going to be transmitted into the jugular vein. So yeah, it's caused against a closed tricuspid valve. AV dissociation, the Canon A wave, so it's like a cannon shooting out. So the Canon A wave usually occurs intermittently. When it occurs with every beat, it indicates an AV dissociation. Yeah, so AV dissociation, atria is beating on its own, ventricles contracting on its own, so it's causing intermittent waves with every beat, actually. So it occurs with every beat, it indicates AV dissociation and retrograde atrial activation from SVT, SVT-tachy, like a junctional rhythm. So that was it was a cool image. Thank you for sharing. Yeah, and we have some cool stuff going on the WhatsApp group. All right, so continuing on, we were going to start.
And Canon waves intermittently are normal, right?
No, it said if it's every beat, then it's AV junction. If it's intermittent, then it was something else. No, No, it is a pathological, right? Usually it occurs intermittently, but if it occurs with every beat, then it is AV dissociation. So if it's intermittent, then it's usually like a tricuspid stenosis, I think. So that's what they're saying. Now, if we see a Canon A wave, that's indicating a pathology. But if it's occurring with every beat, then it's specific for AV dissociation. Or plus retrograde atrial activation from SVT. Yeah, so that's what I understood. I don't think Canon wave is not normal. It's pathologic.
Okay, thank you.
Thank you. Okay. Moving back on. And yeah, I did check during the break. L-type. So this channel is voltage gated calcium channels, which are of the L-type. And they are dihydropyridine channel. So yeah. Just confirming that because I wasn't sure. Okay.
Thank you.
No worries. Thank you. So next we have moving on to EKG. So the conduction pathway is this way familiar. SA node to the atria, to the AV node, to the bundle of His, the right and left bundle branches, the Purkinje fibers, and then the ventricles. So SA node, atria, AV node, bundle of His, right and left bundle branches, Purkinje fibers, and ventricles. Yep, so the left bundle branch then divides into the left anterior and left posterior fascicles. So the SA node is located in the upper part of the crista terminalis. This comes up in questions. So the SA node is located in the upper part of the crista terminalis near the SVC opening. It's the pacemaker inherent dominance with slow phase of upstroke. Pacemaker inherent dominance with a slow phase of upstroke. So this is the dominant pacemaker. It's technically, normally that's what it should be. Then this here is showing the crista terminalis. I think this was when we did on the group sessions. One of our group member had shared. So yeah, crista terminalis. And yeah, it's located in the upper part of the crista terminalis near the SVC opening, which is the blue one here. So somewhere here is where the SA node is going to be. And then next we have the AV node. So this is located in the interatrial septum near the coronary sinus opening. And coronary sinus, we said, was in the left AV groove area, right? So AV node is in the interatrial septum. Is it here? Yeah. So coronary sinus orifice is here. Interatrial septum near the coronary sinus opening is where the AV node is. So SA is over here, close to the SVC opening. Crista terminalis near the SVC opening is SA node. AV node is interatrial septum near the coronary sinus opening. So blood supply is usually from the RCA. 100 millisecond delay allows time for the ventricular filling. So blood supply for the AV node is usually from the RCA. 100 millisecond delay allows time for ventricular filling. Next, pacemaker rates. This is high yield question even on NBMEs. There is a question. So yeah, SA node, AV node, bundle of His, Purkinje, and ventricles. And they usually try to trap us by giving it in different forward and reverse orders. So we have to pay attention to that. So pacemaker rates rate is SA more than AV, more than bundle of His, more than Purkinje ventricles, versus speed of conduction is the mnemonic he parks at Ventura Avenue. So his Purkinje is the fastest speed of conduction, but pacemaker rate starts with SA, AV, bundle of His, and Purkinje. Okay, makes sense, right? This is the inherent dominant pacemaker. And then speed of conduction, his Purkinje, atria, and ventricles. So, and then AV node. So he parks at Ventura Avenue. I think did I get the image? Yeah, UL has an image with the different speeds as well. I think I didn't catch that. Anyway, so P wave is corresponding to the atrial depolarization. PR interval is the time from the start of atrial depolarization to the start of ventricular depolarization. So first we have the P wave, which is atrial depolarization, Then we have the PR interval, time from the start of atrial depolarization to the start of ventricular depolarization. So PR segment to the start. So from here to here, this PR segment. Then we have the QRS complex, and this is normally 120 to 200 milliseconds. QRS complex is representing ventricular depolarization, which is normally less than 100 milliseconds. Then we have the QT interval, ventricular depolarization. QT is starting from Q, including RS, all the way up to completion of repolarization. So QT interval is ventricular depolarization plus the mechanical contraction of the ventricles, plus which is not, it doesn't show up, and then ventricular depolarization, mechanical contraction plus the ventricular repolarization is all QT interval. Next, we have the T wave, which is ventricular repolarization, meaning, yeah, so ventricular repolarization. So when you said repolarization is coming back to its resting membrane potential, if you correlate with the action potential curves. So T wave is ventricular repolarization. All right, pop quiz. Anyone remembers what were the QT in with respect to pharmacology? We had a mnemonic, very QT, mechanism of resistance. What was it for?
Vancomycin, fluoroquinolones, and tetracyclines.
Yes, they have
Porins, efflux pumps. Sorry.
Yeah, nice. Porins and efflux pumps. So very cute pumps was the mnemonic. Nice, thank you. So yeah, so QT includes ventricular depolarization, mechanical contraction of the ventricles, and ventricular repolarization. Next, we have T wave, which is ventricular repolarization, T wave inversion. T wave inversion may indicate ischemia or recent MI. This is important. This comes up in questions. T wave inversion indicates ischemia or recent MI. Then we have the J point. So it looks like a J. Junction, or J for junction. So J between the end of QRS complex and the start of the ST segment. I don't know what its significance is, though. J point is the junction between the end of QRS and the start of the ST segments. Okay, good to know. Next, we have ST segment, which is between S and the start of T wave. Okay, so isoelectric ventricles are depolarized. Isoelectric ventricles depolarized. Isoelectric. I think that's why it's important. Isoelectric. That's why if you have ST elevation and ST depression, it means something's off. So ST segment is supposed to be isoelectric. Ventricles are depolarized. Next, we have the U wave, which is prominent in hypokalemia. Think hypokalemia and bradycardia. So yeah, prominent in hypokalemia and bradycardia. Okay, and then what else? So here, so yeah. PR is the beginning of atrial depolarization to the beginning of ventricular, same thing, beginning of ventricular depolarization. The longer the PR, the longer for the electrical stimulation to travel from the SA to AV node. Sorry, someone said something. Okay, so PR represents the beginning of the atrial depolarization to the beginning of ventricular depolarization. So if we have a longer PR, so atrial to ventricular, right? So we're seeing P to R from atrial to ventricular. So if we have a longer PR, it's indicating longer time for electrical stimulation or stimuli to travel from the SA to the AV node, to the ventricle, to the bundle, and to the vesicles, which means traveling from the atria to ventricles. So we know something is off. So again, longer PR that's what it's indicating. Longer time to travel. So yeah, what else on this EKG? So P wave, we said atrial depolarization. PR segment was normally 120 to 200. QRS represents ventricular depolarization. J point was the junction. ST segment is isoelectric. T wave is ventricular repolarization. U wave for hypokalemia. And what else? Board relevant, ST elevation, ST depression, which we'll see. Okay, and then this image is just showing SA node, and then the impulses travel to the AV node, and then to the other side where the Bachman bundle, I don't remember this, the Bachman bundle, okay. And then So yeah, we said AV node is close to the coronary sinus orifice, and then bundle of his, and we said coronary sinus is at the junction of the what was it, groove? What was the interatrial groove, was it? Yeah, I think so. Okay, then so yeah, from the bundle of his, it's splitting to the left bundle branch and going to the left side, left anterior fascicle and left posterior fascicle, and then the Purkinje fibers. On the right side, again, right bundle branch, right bundle branch, and then the Purkinje fibers. Okay, important point to remember, which in images. So crista terminalis, SA node is located in the upper part of the crista terminalis near the SVC opening. Okay, so that's the EKG. Anything else anyone wants to add? Are we good? Okay. Yeah, we had a question on UWorld where they gave it in a reverse order. If you remember that question, yeah, they gave AV, and then, so yeah, we had to pay attention to the order in reverse. But it's fairly easy. He parks at Ventura Avenue. Okay, next we have ANP, BNP, baroreceptors, and chemoreceptors. So let's see what it's about. So ANP is atrial natriuretic peptide. It's released from atrial myocytes in response to increased blood volume and atrial pressure. So they respond to stretch. So whenever there's increased blood volume and increased atrial pressure, the myocytes get triggered and they release ANP. This is important. It acts via cyclic GMP, causes vasodilation and natriuresis, so decreased sodium reabsorption at the renal collecting tubule. So yeah, it acts via cyclic GMP. If we recall, that's also, I think, the NO pathway, but we'll see that later today. So it causes vasodilation and decreased sodium reabsorption at the renal collecting tubule. It dilates the afferent renal arterioles and constricts the efferent. So yeah, ANP dilates the afferent renal arterioles and constricts the efferent, promoting diuresis and contributing to an aldosterone escape mechanism, which is super duper high yield for step 1. Yep, aldosterone escape, which is how the sodium excretion and reabsorption is balanced out, preventing edema. We'll see that in renal, but yeah, ANP is responsible for or contributing to the aldosterone escape mechanism. So then BNP, brain natriuretic peptide. This is a misnomer. As we know, it's not produced in the brain. It is released from the ventricular myocytes in response to increased tension. So this responds to increased blood volume and atrial pressure, versus here it's responding to increased tension. Okay, increased blood volume and pressure. Here it's responding to increased tension. Okay. Similar physiologic action to ANP with the longer half-life. BNP blood test is useful for diagnosing HF. I think this is a question. It has very good negative predictive value. NPV, if you recall, everything is negative. So true negative divided by true negative plus false negative. So NNNN, all the last name is L, just recalling formula for memory jog. So yeah, BNP is used to test, BNP blood test used for diagnosing heart failure. So next, coming to baroreceptors and chemoreceptors, let me try. But yeah, then we can pitch in because this is an important and a tricky concept. So what are the baroreceptors and chemoreceptors? So barometer, we usually check pressure. Chemo is like chemicals, right? So something to do with changes in chemicals. So let's see, receptors, we have aortic arch and carotid sinus. So aortic arch transmits via vagus nerve to the solitary nucleus of medulla, which responds to changes in blood pressure. So the aortic arch, where do we have that here? So aortic arch receptors transmits via the vagus nerve to the solitary nucleus of the medulla. Medulla is responsible for all this autonomic changes, so responds to changes in blood pressure. Next, we have the carotid sinus. So carotid sinus receptors, the dilated region superior to the bifurcation of the carotid arteries, transmits via the glossopharyngeal nerve. So aortic arch, vagus nerve, carotid sinus, glossopharyngeal nerve, to where? Again, to the solitary nucleus of medulla, which responds to the changes in blood pressure. So these are the main receptors. So chemoreceptors versus baroreceptors. Chemo, again, we have peripheral and central. So peripheral chemoreceptors, we have the carotid and aortic bodies. These are stimulated. So that's why they are peripheral, because they are in the peripheral nervous system or peripheral system of the body. These are stimulated by increased PCO2, decreased pH of blood, and decreased PO2. So decreased less than 60 millimeters of mercury. So carotid and aortic bodies are stimulated by what? Three things: increased PCO2, so increased carbon dioxide, decreased pH, and decreased PO2, so decreased oxygen less than 60 millimeters of mercury. So decreased pH is again acidosis, yeah. So increased PCO2, decreased pH, and decreased PO2. So then central, these are stimulated by changes in pH and PCO2 from where? Specifically from the brain interstitial fluid, which in turn are influenced by arterial CO2, as the H+ cannot cross the BBB. Do not directly respond to PO2, so this is important. The central chemoreceptors do not directly respond to partial pressure of oxygen. Central chemoreceptors become less responsive with, this is a high yield question. Central chemoreceptors become less responsive with chronically increased PCO2 like COPD. And in these patients, the dependence is on the peripheral chemoreceptors to detect decreased oxygen to drive respiration. Yeah. In COPD, central chemoreceptors are punctured, not working anymore. So now we're depending on the peripheral chemoreceptors. So COPD patients, they have increased dependence on peripheral chemoreceptors to detect decrease in oxygen to drive respiration. So this is super high yield. All right, so that's peripheral and central. So as we said, they are chemoreceptors. So changes in the chemistry, in the blood chemistry. So PCO2, decreased pH and decreased PO2 versus central changes in pH and PCO2 of the brain interstitial fluid, which is indirectly influenced by the arterial CO2, as the H+ cannot cross the BBB. Okay, so that's chemoreceptors. Then next we have the baroreceptors. So baro meaning pressure. So they are going to sense pressures. So they respond to hypotension, carotid massage, and then component of Cushing's reflex. So we see. So baroreceptors, whenever there's hypotension, decrease arterial pressure. So decreased pressure, so that's they'll get triggered off. Decrease stretch, decrease afferent baroreceptor firing, increase efferent sympathetic firing, and decrease efferent parasympathetic stimulation. So we're increasing the sympathetic and decreasing the parasympathetic, such that the net effect is vasoconstriction. If we vasoconstriction also increasing a heart rate and increasing contractility. So thereby increasing the blood pressure. So they responded to hypotension and now they're bringing the blood pressure back to normal. So this is trying to maintain the normal homeostasis of the body. So these are extremely important in response to hypovolemic shock, which makes sense, right? Whenever there's a hypotension, one more time, hypotension, decrease arterial pressure. Decreased pressure means less blood flowing through the vessel, less stretch. If there is a less stretch, decrease afferent baroreceptor firing. I think we should see this over here in a minute. So increase efferent sympathetic firing. So this takes over and there's a drop in the efferent parasympathetic stimulation. So net effect is vasoconstriction, because we know sympathetic increase heart rate. So increase sympathetic firing, increase heart rate, and increase contractility, increase blood pressure. So if we recall, the heart rate increase would be via beta 1, vasoconstriction would be via alpha 1. These are all sympathetics, and contractility also directly from beta 1 effect. So yeah, they'll all increase because of increased efferent sympathetic firing. So they're important in response to hypovolemic shock. Okay, so that's one thing. Next, where is the baroreceptors involved in carotid massage? This is high yield. We have questions, a couple of questions actually. So carotid massage, when we massage the carotid area, there's increased carotid sinus pressure. So if it senses pressure, again, because it's the baroreceptor, so increase afferent baroreceptor firing, increase AV node refractory period, because we saw earlier that this AV node, if you remember, the sympathetic stimulation increases the chance of, so sympathetic net effect increasing the heart rate. And what else did we say? So yeah, in that context, if does it correlate? Not sure anymore. Sinus pressure. AV node refractory period. I may be wrong. Okay. But anyway, the refractory period is when, I thought I read it somewhere. So refractory period is when there is no stimulation happening, no changes happening here. So cannot have a second action potential. So anyway, so if there is increased afferent baroreceptor firing, there's an increase in AV node refractory period, decreasing the heart rate and decreasing cardiac output. So it also leads to peripheral vasodilation. So can cause syncope or presyncope. And it's exaggerated in underlying atherosclerosis. It makes sense because the vessels are stiff. So the pressure is increasing. They just get triggered randomly. So yeah, increased carotid sinus pressure, increased baroreceptor firing with atherosclerosis, prior neck surgery, which makes sense. That's the area where we have the carotid receptors, and old age. Again, old age, think stiff vessels, so that will also trigger them off. So that's where they're more likely for presyncope and syncope. Then next, and then this also we have questions, right? Patient, they have hypersensitive carotid receptors. If you recall, there are 2 or 3 questions. One was person was putting a tie, and then they get triggered and the patient faints. Then the other was the shaving, while shaving they got triggered and stuff. So those are important correlations. Carotid sinus overactivation and the presyncope and syncope. And we never do it on both sides because then that can lead to immense collapse. And it's actually used in something, actually. I think some type of
There are nice pictures in UWorld actually, which explains it better.
For this? Yeah, I remember. I
for this
should
one.
put it. Let me get it in a sec. Hold on. It's better we do it there. Anyone has the question ID by any chance? Let me say baroreceptor. Oops, I think I have to re-log in. Yes, sec. Okay. Was it this?
Yeah, this one also, but you know, the full
pathway.
When it goes to the brain, yeah, the full pathway, yeah.
Was it this?
Yeah, this one, yeah, this one is good.
Yeah, you want to please explain, Hamna?
Okay, so from the carotid body, we have carotid body chemoreceptors and carotid sinus baroreceptors. So baroreceptors, you just said that it's for blood pressure sensing, right?
Pressure sensing, yeah.
Yeah, and chemoreceptors for chemicals like PCO2 and pH and PO2 chemistry. So from the carotid sinus, when there is hypertension, right, decreased arterial pressure, so there will be less stretch in these carotid sinuses, right? So decreased firing via cranial nerve 9, glossopharyngeal nerve. So it goes towards the solitary nucleus of the medulla And the efferent comes via vagus. So efferent is always vagus, I guess.
Efferent
Right?
always
Efferent is
vagus.
always vagus, yeah. So increased efferent sympathetic firing and decreased efferent parasympathetic firing. So sympathetic firing increase, that leads to more vasoconstriction and increased heart rate and contractility, right? So it has to increase the blood pressure by all these means.
Correct.
By increasing vasoconstriction, increased contractility, increasing heart rate, increasing BP. And it's important in the response. Just it's the initial response. If it's prolonged, then it doesn't make sense. Like accidents occur and so much blood loss. So it's the initial response to hypovolemic shock. And you said that like in and from the aortic arch baroreceptors, vagus nerve goes up, afferent via afferent to the solitary nucleus of the medulla, and efferent also comes via vagus nerve. I think if you pull out some next question, there are more pathway.
Detailed pathways, right? Yeah, I
Detailed
remember.
pathway.
Saw it somewhere. This one, right?
Yeah, this one, yeah.
Yeah.
This is so from the aortic baroreceptors. Yeah, so in baroreceptors decreased firing, then leads to sensory fibers decreased signaling. So carotid sinus baroreceptors, it goes to the cardioregulatory center. And then via the parasympathetic fibers, if it's increased firing, then decreased signaling, or sympathetic fibers will be increased signaling. And then it goes to the myocardium and the SA and AV nodes. So increased heart rate and contractility, and on the blood vessels, it causes vasoconstriction.
Yeah, I like this. This is a good one.
Thank you. Yeah, that makes sense now. Thank you.
Thank you, Hamna. That was very nice. And this was what we yesterday were mentioning, right? Pituitary stalk was here.
Yeah, pituitary stalk. Where is mammillary body? This is mammillary body, right?
Yeah, samne wala. The beak was the mammillary body. I think this one.
Yeah, the hanging one is the pituitary.
This is pituitary.
Yeah,
this was the mammillary body.
Yes.
This was also something I forget. This was the pineal gland. Maybe this was also something I forget. Anyway, so
this is splenium of the corpus callosum.
Yeah, correct. Splenium of the corpus callosum. Yeah, that's what it was. And then the ventricle. Yep. So this is in the solitary nucleus of the medulla. So that's why it's showing here.
So yeah, and that's also a question, right? You just mentioned that central chemoreceptors become less responsive with chronically increased PCO2, like COPD patients. So more dependence on peripheral chemoreceptors to detect decrease when the PO2 less than 60 to drive respiratory.
Yeah, correct. So joke. Okay, so back to where we were. So yeah, correlating with this, are we good? Should we still do this or are we good? This is a bit confusing, I know. So as you said, efferent is always the vagus, so parasympathetic vagus nerve for both the pathways, going to the blood vessels. No, sympathetic chain. So here we're seeing efferent coming to the sympathetic nerves, going to the blood vessels. Yeah, I think that was a better image. Same thing what you said. Okay, so that's done then. And then next, oh yeah, this is important, right? I think I didn't do this. So component of Cushing's reflex. So what is the components of Cushing? Yeah, so baroreceptors are a component of the Cushing reflex. What is the Cushing reflex? It's a triad of hypertension, bradycardia, and respiratory depression, which leads to, triad of hypertension, high blood pressure, low heart rate, and respiratory depression. So it's a weird triad. So that's Cushing reflex. So what happens here? Increased intracranial pressure constricts the arterioles of the cranium. So cerebral ischemia. If there's ischemia, carbon dioxide is building up. So increased PCO2 and drop in pH, acidosis. So as we said, so the brain will detect it, I guess. Anyway, no, let me not go off track. So yeah, increased intracranial pressure constricts the arterioles, causes cerebral ischemia. What is ischemia? We have increased PCO2 and decrease in the pH. This will trigger the central reflex sympathetic increase in perfusion pressure. Central I think it's related to this, the central chemoreceptor. The central reflex sympathetic increase in perfusion pressure causing hypertension. So now because there's hypertension, there's increased stretch, causes the peripheral reflex baroreceptors induced bradycardia. So it's starting off with the increased intracranial pressure, causing cerebral ischemia, so PCO2 is building up. So increased PCO2 and decrease in pH. That triggers a central reflex sympathetic pathway in perfusion pressure, causing the hypertension. So that's one of the triad. Then that causes increased stretch and peripheral reflex baroreceptor induced bradycardia. So we have hypertension and bradycardia as well as respiratory depression. So basically they're showing us that the baroreceptors are part or taking a main component of the Cushing's reflex. Okay, does that make sense? We used to have some confusion about this, right? Forgot what was the confusion and what was the answer. Anyway.
Yeah, something like that. Increased. Yeah.
Hello.
Yeah,
Hello.
Sorry, go ahead. Yes,
Yeah.
we can hear you.
If you could go over the first aid diagram rapidly, I think it clears everything.
Okay, let me see. This image you want me to go over, right?
Okay. Yeah.
Okay. So the afferent we have coming in from the solitary nucleus of the medulla. So we have going from the, let me start with this. So yeah, glossopharyngeal nerve going to the carotid sinus baroreceptor. We have the baroreceptor and the chemoreceptor. And then from the medulla, we have the 10th or vagus nerve going to the aortic chemoreceptor. Okay, yeah. One sec. So yeah, from the solitary nucleus of the medulla going into the aortic chemoreceptor. Then from the medulla, we have going through the spinal cord, crossing via the sympathetic chain. And the outside one is going to the blood vessels, a sympathetic control to the blood vessels. And then the other one, sympathetic nerves going to the SA node and the AV node, as well as the myocardium. So that's how they're controlling the heart rate, where the SA and AV node, as well as the myocardium, so contractility as well. So yeah, whenever there is a increased efferent sympathetic and a drop in the parasympathetic, that leads to vasoconstriction. So yeah, that's detected by hypotension. So the net effect is to bring the blood pressure back to normal. And then whenever we have a carotid massage, there is increased carotid sinus pressure, increased afferent baroreceptor firing, and increased AV node refractory period, because it comes back to the AV node. So it goes from here, goes, and then it's coming back where the sympathetics coming back to the AV node. So AV node refractory period is increased, decreasing the heart rate and decreasing the cardiac output. Also leads to peripheral vasodilation. Why? Because we have the sympathetics connected to the blood vessels. So it makes sense. Right? So yeah, I think this image is much better. I don't.
If there is increased intracranial pressure, so constricts arterioles.
Mm-hmm.
So isn't why it's increased PCO2 there?
It's constricting arterioles. So remember how the brain is unique in that whenever there's ischemia, it will constrict the arterioles, or and then increasing. Yeah, PCO2 is building.
In ischemia, basically more PCO2, more vasodilation, no, in the brain.
Yeah. That was our confusion actually. Yeah. Increased PCO2 will lead to
vasodilation.
Constriction actually. That's what was unique, right? Actually, yeah.
No. Hold on. Unique in the lungs now. If hypoxia, then it leads to vasoconstriction.
Vasoconstriction, that's unique in the lungs.
PCO2 leads to more vasodilation in the brain.
Correct, you're right. So intracranial. No, I think that's the consequence. But here it's starting off with the, because there's a bleeding or something like that, if there is a head injury and there's, increased intracranial pressure, And that's constricting the arterioles because of external pressure from the blood. That's constricting the arterioles. So the arterioles are not so able to supply blood. So that's causing the ischemia. And if there is ischemia, we have increased PCO2 starts building up and a drop in the pH, and that's triggering it. So this is the consequence of the increased intracranial pressure. Versus that, what we are saying is whenever there is increased PCO2, for example, with hypoventilation, that's the starting point. PCO2 will build up, and that will lead to the consequence of cerebral vasodilation. Correct?
Okay, so starting point here is the head injury, or like that leads to or cerebral edema, you can say.
Yeah,
so constriction of the
bleed. Yeah.
Yeah, constriction of arterioles, so no blood going in. So that's why it leads to PCO2 buildup and
yeah.
Okay.
Over there, that's the starting point, right? PCO2 is a starting point, so the consequence will be vasodilation, blah, blah, blah. Here also, technically, it should happen as a consequence of this, but yeah, I'm not sure if it does. Increased PCO2 and decreased pH, central reflex sympathetic, increased perfusion pressure, hypertension, increased stretch, increased peripheral receptor. Yeah, I think it probably does happen as a consequence, but here we're focusing more on what's happening in the baroreceptor. So that's why they've not mentioned it. Does that make sense? Kind of, sort of. That's how I've it in my
I think,
brain.
Increased PCO2 and decreased pH. So central reflex sympathetic increase.
Hmm.
So more stretch, right? Because of increased PCO2, there will be sympathetic increase, right? Central reflex.
Yeah, correct.
Okay.
Yeah, because here we said, right, the converse of this central chemo, where did we say? This central chemoreceptor is stimulated by changes in pH and PCO2 of brain interstitial fluid. Here we're talking about the brain interstitial fluid only, right? So increased PCO2 will trigger these central reflex sympathetics in the perfusion pressure, and that will cause increased stretch. So central chemoreceptors, what are they doing? So we said they are stimulated by changes in pH and PCO2 of brain interstitial fluid. This factor we've reached here already. We've hit it. So increased PCO2 is happening. So yeah, now these centrals are triggered. So central reflex sympathetics are firing. If they fire, we have hypertension. Because of this hypertension, there's increased stretch. Because of this stretch, as a consequence, baroreceptors are getting stimulated. And these baroreceptors are causing bradycardia. So that's why it's a weird triangle or triad. So that's how I understood. I hope it made sense. Yeah. If anyone has any input about the intracranial versus the vasodilation, PCO2, please let us know. We'll appreciate it. Okay. Thank you. So next we have normal resting cardiac pressures. So PCWP, which is pulmonary capillary wedge pressure in millimeters of mercury, is a good approximation of left atrial pressures. Yeah, this is high yield point. PCWP is approximation of LAP, except in mitral stenosis. So yeah, exceptions USMLE loves. So exception is mitral stenosis when the PCWP is more than the left ventricular end diastolic pressure. So mitral stenosis is connecting the left atrium with the left ventricle. If it's stenotic, then there's no way for the left atrium to push blood into the left ventricle because of the stenotic valve. So blood is collecting in the left atrium, increasing the left atrial pressure, so increasing the PCWP. So mitral stenosis is the exception to the rule when PCWP pressure is higher than the left ventricular EDP and diastolic pressure. So PCWP is measured with a pulmonary artery catheter, which is known as a Swan-Ganz catheter. So PCWP is approximately equal to the LA pressure, which is the LA EDP. Normal diastole, left, I don't know where I picked this from. So normal diastole, LA EDP is approximately equal to left ventricular and diastolic pressure because of normal mitral valve, minimal resistance to flow between chambers. LA EDP, yeah, same thing what we said here. LA EDP more than LV EDP in the case of mitral stenosis. And these values are important. They came up in questions. So starting from what we know the aortic pressure, which is blood pressure, is 120/80. If you trace it back to the left ventricle, it's 120, but a systolic 120, diastolic is less than 12. So then tracing back, left atrium is less than 12. And so what else? So right atrium is less than 5. We know that right atrial pressures are very low compared to the left. So right atrial pressure, right atrium is less than 5. Right ventricle 25/5. And then 25/5 going to the pulmonary trunk, 25/8. And when we measure it in the Swan-Ganz catheter, 4 to 12 is what we measure as the left PCWP, which is corresponding or approximated to the left atrial pressure. I think you all had an image of the Swan-Ganz and how it's blocked and how it's measured and stuff. So 4 to 12 in the pulmonary capillaries. So yeah, we occlude them. So it's kind of a indirect measure of the left atrial pressure. Okay, so that's normal testing.
How this pressure changes helps from blood to go from one chamber to another. For example, in left atrium, it is less than 12.
Mm-hmm.
And in the left ventricle, it is 120/12. So how is it helping blood to come from left atria to left ventricle?
Your voice got cut off in the beginning. What is your question? Are you asking how the pressure changes from the atrium to the ventricle?
No, I am asking how the pressure changes helps in forward flow of blood from one chamber to another.
How the pressure change helps in forward flow from one chamber to another. So left atrium, you have less than 12, 120 over to less than 12. Anyone? I'm not sure if I'm going to be good at answering her question. Anyone who can word it in a good way?
Could you repeat the question, please?
Fauzia asks, a doctor asks, the change in pressure, how does it help push the blood forward? That's what I understood. Is that correct, Fauzia? Is that your question?
Yeah.
So how does the change in pressure help in pushing the blood forward, she asks. So these are normal at rest pressures. Like if there's no movement or no contraction happening, I believe that was what it was like at rest when the heart is normally contracting without any exercise or, when it's sitting still. Yeah, go ahead.
Blood would move from the lower pressure zone to the higher pressure zone. So it will be very difficult to move against the pressure gradient. That is why when an afterload increases, the left ventricle has to work harder. So if we can compare from the right atrium and the right ventricle, you see your right atrial pressure is about less than 5. And then your right ventricular pressure resting is about 25. So then you can easily move across. When there is a change and there's a reverse, it becomes difficult to move blood. And we can say the same for the left side, where your left ventricular pressure at rest is about less than 12. And that enables a forward movement. Your left atrial pressure is less than 12. And that's why blood can move through the bicuspid valve into your left ventricle. In instances where there is a reverse, it's very difficult. So sorry. I don't know if I've answered her question.
Yeah, that makes perfect sense. It was an excellent answer. Thank you so much. So yeah, main thing, the bottom line, which what I understood was blood, it is important, right? Blood flows from the high pressure to, low pressure to a high pressure area. So here it's less than 12 and here it is less than 12. So it's moving from a left atrium. So it's easy for the left atrium to pump into the left ventricle. Here, if you see the diastolic pressure is 80. So yeah, it's again, no, this doesn't make sense. Hold on. What did you say, Doc?
So you mean between the
left ventricle and the aorta?
Yes. So remember that before the blood starts.
The systolic pressure.
Go ahead.
You complete.
Go ahead. Yeah. Go ahead, Dr. Andy.
I remember, doctor. I remember now. I can try to explain. In left atrium, the blood is coming from the lungs, and the left atrial chamber pressure is less than 12. At this pressure, blood is coming to the left atrium, and with the same pressure, less than 12 pressure, when it equalizes with the left ventricle, it goes to the left ventricle, which is also less than 12 pressure. After reaching the left ventricle, the pressure rises to 120. When this pressure equalizes with the pressure of the aorta, which is also 120 systolic pressure, it goes to the aorta. Blood goes to the aorta.
Yeah, nice.
After going to the aorta, the pressure I think decreases to 80, and with that pressure, it goes to the systemic circulation. And after that, in the venous set, it is coming back to the right heart. With the pressure is very low there, it is only less than 5, so blood easily goes there. And with this less than 5 pressure, with the equal pressure, it goes to the right ventricle. In the right ventricle, the pressure slightly goes up to 25, and
As
with that same and the 25 pressure is equal to the pulmonary arterial pressure, systolic pressure, which is also 25. So 25 in both chambers. So blood goes from one to another. That means from right ventricle to the pulmonary trunk, and it like this.
Yes, nice. That was awesome. Thank you, guys.
Thank
Yeah.
you.
So when
Thank
the pressure equalizes and then pressure exceeds as the systole is happening, it flips the valve open, and then blood will flow. It flows until it drops to 8, and then it goes like that. Yeah, that was amazing. Thank you, guys. When I forgot that. Thank you. All right, are we good with this? Normal resting cardiac pressures. Okay, thank you. So next we have auto-regulation. What is auto-regulation? It's how blood flows to an organ. How blood flow to an organ remains constant. Thank you, doctors, all of them. I'm trying not to take names only because this is being recorded, so just being a bit careful. But yeah, Dr. Haroon, did you want to pitch in? Did you want to say something, or are we good?
We're good.
Okay, all right, thank you. Okay, next is autoregulation. What is autoregulation? How blood flow to an organ remains constant over a wide range of perfusion pressures. So how blood flow to an organ remains constant over a wide range of perfusion pressures. Okay. Yeah, this is high yield, and it's very tricky sometimes in questions. So in lungs, as we said a bit ago, as Hamna said, hypoxia. In lungs, hypoxia causes vasoconstriction. In the lungs, hypoxia causes vasoconstriction. We've seen a lot of this in palm. In the heart, local metabolites are vasodilatory, like NO, CO2, and decrease in oxygen will cause vasodilation. In the brain, local metabolites that cause vasodilation are CO2 and pH indirectly, because we said H+ does not cross the BBB. In the kidneys, myogenic and tubuloglomerular feedback. So two things in the kidneys, which is myogenic, which is stretch, myo muscle, stretch dependent response of the afferent arteriole, and the tubuloglomerular feedback. In the skeletal muscle, which is chalk, local metabolites during exercise which are vasodilatory are CO2, H+, adenosine, lactate, and K+. At rest, it is the sympathetic tone in the arteries. Okay, makes sense. In the skin, sympathetic vasoconstriction. Sympathetic vasoconstriction is most important mechanism for temperature control. This comes up in questions with respect to, what was it, atropine and organophosphate, and what happens in the skin and so on. So yeah, skin, sympathetic vasoconstriction, most important mechanism for temperature control. So this is high yield fact. The pulmonary vasculature is unique in that alveolar hypoxia causes vasoconstriction, so that only well-ventilated areas are perfused. In other organs, hypoxia causes vasodilation. So yeah, by default, hypoxia in any part of the body will cause vasodilation. The pulmonary vasculature is unique in that alveolar hypoxia causes vasoconstriction. Why? So that well-ventilated areas are perfused. So that's autoregulation. Okay. So heart, NO, CO2, and drop in oxygen. Brain, it's CO2 mainly. Kidneys is myogenic and tubular-glomerular. Skeletal muscle is chalk, CO2, H+, adenosine, lactate, and K+. Skin, it's a sympathetic vasoconstriction. And lungs, yeah, hypoxia causing vasoconstriction. All right, next, moving on, capillary fluid exchange, very high yield, tested in multiple ways. So Starling forces determine fluid movement through the capillary membranes. So we have PC, which is, sorry, it's not, okay. So we have PC, which is the capillary hydrostatic pressure, pushes the fluid out of capillary. PI, which is the interstitial hydrostatic pressure, pushes fluid into the capillary. Pi C, which is plasma oncotic pressure. Oncotic is always going to draw, and it's like a suction pressure, so it pulls fluid into the capillary. Pi I, which is interstitial fluid oncotic pressure, again pulls fluid out of the capillary. Because it is located in the interstitium, it's going to pull towards it. So JV, which is net fluid flow, equals KF, which is the capillary permeability to fluid, multiplied by PC minus PI, which is a difference in the hydrostatic pressure between the capillary and the interstitium, minus sigma, which is the reflection coefficient, measure of capillary impermeability to protein. So it's some type of constant, multiplied by difference between the oncotic pressure in the capillary and the interstitium. So that's net fluid flow, KF into PC minus PI minus sigma pi C minus pi I. So this is a reflection coefficient, which is a measure of capillary impermeability to protein. Not seen it on questions, but okay, good to know. Then edema, high yield. So excess fluid outflow into the interstitium, commonly caused by, as we know, this what do I call it? The rhyme or the jingle, cirrhotic nephrotic CHF. So whenever there is increased capillary pressure PC, example, heart failure, increased capillary permeability, which is increasing the KF, which is capillary permeability to fluid. For example, toxins, infections, and burns. It would lead to edema. Increased interstitial fluid oncotic pressure, which is increased pi I, for example, a lymphatic blockage. And also we saw lymphatic outflow obstruction by malignancy or rheumatic disease. We've seen that before. And the fourth one is decreased plasma protein, which is decreasing the pi C. Example, nephrotic, we're losing protein. Liver failure, we're not synthesizing protein. Protein malnutrition, we're not taking in enough protein. So that any or all of these factors will cause edema. So this is an image showing net fluid flow, KF into PC minus PI minus sigma pi C minus pi I. So we are seeing interstitium and arteriole end of the capillary. So filtration is the filtering out. So net flow out of the capillary. And reabsorption is net flow into the capillary or reabsorption. So we're seeing hydrostatic pressure here. So it's filtering out, reabsorbing back in. And the balance is what is net fluid flow. If any of the factors variates, then we lead to edema. Okay. I think you all had a good image of that cirrhotic nephrotic CHF thing that I'm talking about, but I think we saw it recently somewhere or in some other context.
Yeah, you all has better.
Yeah, that's a better image, right? More visual. Should I pull it up or are we good? Okay, so capillary fluid exchange is done. Next, we have cardiac pathology. This was, I think, during the group discussions before. Mnemonic to differentiate between, if it zooms in, central and peripheral cyanosis, cold palms. I think Kumar had shared this. So mnemonic, cold, obstruction, LVF, and shock, as well as D. All the D. Cold is for peripheral cyanosis, cold weather or cold temperature, obstruction, LVF, and shock, and decreased cardiac output. Versus the palms is for central cyanosis, polycythemia, altitude, high altitude, lung disease, met-sulf-hemoglobinemia, and shunt central. Okay, just on a side note. So next, on this page, we have congenital heart disease, right to left shunts, persistent truncus, transposition, tricuspid tetralogy of Fallot. TAPVR, Epstein's anomaly. Next we go to, so yeah, these are all the right to left shunts. Next page we have left to right shunts. All right, so let's see. So right to left shunts, early cyanosis of blue babies, often diagnosed prenatally or become evident immediately after birth, which makes sense because there will be Apgar score will be low. So usually require urgent surgical treatment and or maintenance of a PDA. So these are questions, right? Maintenance of PDA until surgery is done, what do you do? And so on. We have questions. So right to left shunts are the 5 T's. One is truncus arteriosus, one vessel. So number 1, 2 is transposition. So 2 switched vessels. 3 is tricuspid atresia. So tri for 3. 4 is tetralogy. So 4 tetralogy of Fallow, and 5 TAPVR, which is 5 letters. So 1, 2, 3, 4, 5 to remember the 5 T's of right to left shunts. Okay, so first is persistent truncus arteriosus. The truncus arteriosus fails to divide into the pulmonary trunk and aorta due to, this is important, right? Failure of aorticopulmonary septum formation, which we saw in embryology. Most patients have an accompanying VSD. Yeah, so persistent truncus along with the VSD. Then we have transposition of great arteries. So they're transposed, meaning the position is wrong. So aorta leaves the RV and the pulmonary trunk. So aorta is supposed to come off from the LV, but it's leaving from the RV anterior, and pulmonary trunk leaves the left ventricle. This is because separation of the systemic, therefore causing a separation of the systemic and pulmonary circulation, which makes sense. So this is looping around. So what do we see here? So right ventricle, aorta is leaving the right ventricle. So it's going to the body and coming back. So it's just causing one loop. And pulmonary trunk is leaving the left ventricle. So it's going to the lungs and coming back. So it's just forming loops and separation of the circulation. So separation of systemic and pulmonary circulations, not compatible with life unless a shunt is present. Yeah, so it's not compatible with life unless a shunt is present to allow mixing of blood. Example, BSD, PDA, or PFO. Due to failure, so yeah, what's the cause? There's a due to a failure of aorticopulmonary septum to spiral. Narrow superior mediastinum causes egg on a string appearance on chest X-ray. So this is a clue. So egg on a string appearance of chest X-ray. Without surgical intervention, most infants die within the first few months of life. So yeah. So if you see this X-ray, it looks like an egg is hanging on a string. So that's the visual. So that's the key X-ray finding in transposition of great arteries. So here we are saying right ventricle is giving off the aorta, left ventricle is giving off the pulmonary artery. So that's transposition. Next, we have tricuspid atresia. So this is absence of the tricuspid valve. Tricuspid valve absence, hypoplastic right ventricle, and requires both ASD and VSD for viability. So it's absence of the tricuspid valve, hypoplastic right ventricle, and requires both ASD and VSD for viability. Makes sense, right? Tricuspid valve is absent, and there's a hypoplastic right ventricle. So it requires an ASD and a VSD so that blood will mix and some oxygen is still reaching the body, rest of the body. So yeah, it needs both an ASD and a VSD for viability. Okay, tricuspid atresia. Next, we have tetralogy of Fallow. We all know high yield. It's caused by the anterior superior displacement of the infundibular septum. Anterior superior displacement of the infundibular septum. So during embryology, it's the most common cause of early childhood cyanosis. So we have 4 components. PROV is the mnemonic, PROV. So what is P? It's pulmonary infundibular stenosis, which is the most important determinant of for prognosis. The pulmonary infundibular stenosis, most important determinant for prognosis. Number 2, we have right ventricular hypertrophy, which causes a boot-shaped heart on X-ray. So if you see the image, you can see it looks like a boot, and overriding aorta. So number 3, overriding aorta. So it's kind of overlapping. And then 4 is VSD. Ventricular septal defect, yeah, and then overriding aorta. So yeah, 4 components: pulmonary stenosis, RVH, overriding aorta, and AVSD. So pulmonary stenosis, it's stenotic. So it forces a right to left flow because now right ventricular pressure increases and high pressure to low pressure. So it's going to go from blood flows going this side. So forces right to left flow across the VSD, causing a right ventricular hypertrophy. And TET spells. What are TET spells? They are often caused by crying, fever, and exercise. So if because the baby is crying, it exacerbates this whole phenomenon. So it's often caused by crying, fever, and exercise due to exacerbation of the right ventricular outflow obstruction. So squatting, as we saw on the table, squatting increases the resistance, decreases. So if you decrease the resistance, again, we're increasing the pressure on the left side. So it decreases the right to left shunt and improves cyanosis. So classic buzzwords in the question, squatting will improve the cyanosis in tetralogy of Fallot. And this is associated with 22q11 syndromes, which was a velocardiofacial as well as the DiGeorge syndrome. All right, next we have total anomalous pulmonary venous return. So pulmonary veins are draining into the right heart circulation. Pulmonary veins, normally they bring back oxygenated blood to the left atrium. But here they are bringing oxygenated blood and draining into the right heart circulation, either the SVC or the coronary sinus, etc. So it's associated with atrial septal defect. So it comes together with ASD and sometimes PDA to allow for right to left shunting to maintain cardiac output. So yeah, pulmonary veins are bringing oxygenated blood into the right heart, so superior vena cava or coronary sinus, and it's associated with an atrial septal defect, so that from the right atrium, it can go into the other side or sometimes the patent ductus, so that it allows the right to left shunting and maintains the cardiac output. So that's TAPVR. Next, we have Epstein's anomaly. Here, there's displacement of the tricuspid valve leaflets downward into the right ventricle, artificially atrializing the ventricle. So it makes sense, right? So we normally have the right atrium, right ventricle. So if there's displacement so much so that it looks like a single chamber, so it's atrializing the ventricle as well. So it becomes like a single chamber. So displacement of the tricuspid valve leaflets downward into the right ventricle, artificially atrializing the ventricle, associated with TR, makes sense because everything's going to regurgitate. It's the valve leaflets are displaced. So associated with TR, accessory conduction pathways, and right-sided heart failure. So yeah, volume overload on this side, right ventricle cannot cope, and it's going to lead to right-sided heart failure. And this is high yield, can be caused by lithium exposure in utero. Yeah, we saw this when we did drugs. It's caused by lithium exposure in utero. Epstein anomaly. Then anyone recalls any other side effects of lithium? We saw hypothyroidism. There was a list, right? Lithium was a list. What else?
Nephrogenic DI.
Yeah, that was important. And we said the exclusive medication according to UWorld was amiloride, right? Amiloride. Mm-hmm. Yeah. And then what else was there on the side effects? Let me see. This is page number 302. Lithium, warning, these drugs are lethal. So this came up in low therapeutic index. What else did we see? Lithium side effects, yeah, DI, nephrogenic, hyper and hypothyroidism. And then, okay, this page. Prenatal lithium exposure, nephrogenic DI cause. Okay. Yeah, I think we saw it in psych. Yeah, mood stabilizer. We said broad spectrum for manic and depressive episodes. And adverse effects are DI, hypothyroidism, tremors, Epstein's anomaly. What else did we see it for? Lithium toxicity. Yeah, we saw hydrate aggressively with isotonic sodium chloride. We said sodium chloride stabilizes the membrane, the cardiac membrane, and consider hemodialysis. So yeah, What was this? Manifestation is hyperreflexia. Okay.
And I think it's important to know the drugs that can cause lithium toxicity.
Yeah, right. This is important too, right? Medications affecting clearance like ACE inhibitors, thiazides, NSAIDs can all precipitate lithium toxicity. So that will be the subtle clues in the question. Thank you, Doc. Then we have bipolar treatment, lithium. Yeah, this was in morning. So low thyroid or high thyroid, Epstein's anomaly, nephrogenic DI, and unwanted movements, so tremor. Yeah, this was what we saw. Almost exclusively excreted by kidneys, and most is reabsorbed at PCT via sodium channels. Okay, that's that. So back to Epstein's anomaly. That's why we went on a tangent.
It is excreted by the PCT or
reabsorbed at the kidney. Excreted, hold on. It was reabsorbed mostly at the kidney, excreted by the, oh my God, just read it.
Proximal
Kidneys,
convoluted.
general, kidneys, yeah. And reabsorbed at the PCT via sodium channels. So that was the fact. Narrow therapeutic window requires close monitoring of serum levels. So thiazides, ACE inhibitors, NSAIDs, and other drugs affecting clearance are implicated in lithium tox. And it can also cause mild, so tremors, hypothyroidism, hyperthyroidism, mild hypercalcemia, polyuria because of nephrogenic DI, teratogenesis, Epstein's, narrow, yeah, this we saw. Use mood stabilizer for bipolar, treats acute manic episodes and prevents relapse. What is the mechanism? It affects neurotransmission, it decreases excitatory and increases inhibitory second messenger systems like G proteins. Alrighty, back to Epstein's anomaly, lithium connection, memory jog done. Back to Epstein's anomaly, yes. So yeah, Epstein's anomaly caused by lithium exposure in utero. All right, okay, next page we have left to right heart shunts. These are acyanotic at presentation. As we said just now, right to left are cyanotic, so they're detected early. These are acyanotic at presentation, and cyanosis may occur years later. Frequency, VSD more than ASD more than PDA. So right to left, early cyanosis, RL. Left to right to remind us, later cyanosis, so LR. So what do we have here? We have VSD, ASD, PDA, and Eisenmengers. Okay. So VSD, these are asymptomatic at birth and may manifest weeks later or remain asymptomatic throughout life. Most smaller defects resolve, and larger defects, if surgically untreated, most smaller ones will resolve. Larger defects, if left surgically untreated, can cause increased pulmonary blood flow, ventricular septal defect. So yeah, increased pulmonary blood flow over time, left ventricular overload, and may progress to heart failure. So oxygen saturation increases in right ventricle. So one more time, oxygen saturation increases in right ventricle because yeah, it's a VSD, as well as in the pulmonary artery. These questions we have in that heart images with the oxygen saturation given. I think if you guys recall, UWorld has a few questions on that. And the trick is they give the chambers which are connected. And I think I remember when we did a group mixed questions, it was confusing, but we have to focus on the PO2. So wherever there's a sudden change or drop, that's where the issue is. So yeah, oxygen saturation will increase in RV and pulmonary artery for VSD. So next we have ASD. What is ASD? Atrial septal defect. So there's a defect in the interatrial septum as seen in C. So yeah, this is not closed off. There is an opening. So that's the ASD. Again, we said from earlier, wide fixed split S2. And then ostium secundum defects, most common and usually an isolated finding. So ostium secundum defects, most common. So this is the key word. Ostium secundum defects are most common and usually an isolated finding. Ostium primum defects are rarer and usually occur with other cardiac anomalies. Symptoms range from none to heart failure, distinct from patent foramen oval, which is due to failed fusion. So this is important. Here it is a defect in the interatrial septum, which is different from PFO, where it is due to failed fusion. So here, what happens to the oxygen saturation is increase in RA, RV, and pulmonary artery, which makes sense. So atrial septal defect. So blood is going from the left atrium to the right atrium. So oxygen saturation increase in the RA. From the RA, it goes to the RV. So RV. And from the RV is going to the pulmonary artery. So it's increased in all those places. So it may lead to the paradoxical emboli, which we saw earlier. Systemic venous emboli use ASD to bypass the lungs and become systemic arterial emboli. So they're coming from the veins, actually. Patient had a DVT. From the lower limbs, it's coming to the heart, to the sorry, give me a sec. Okay. So it may lead to a paradoxical emboli, systemic venous emboli. Yeah, so from the deep venous thrombosis, it's coming back to the heart, to the right atrium. From the right atrium, it's using the ASD to bypass into the left atrium, left ventricle, and no, I think I'm going wrong here. So systemic vein, it's coming to the right atrium via the vena cava, and then using the ASD to bypass the lungs and going to the systemic side. Yep. So it's going to from the right atrium to the left atrium, going to the left ventricle, then to the aorta, and now it's going and causing a stroke. That's a common scenario. So that's a paradoxical emboli, and it's associated with Down syndrome, ASD. All right, so that's ASD. Next, we have PDA.
And mostly with ASD, we have septum primum defects, right?
Yeah, septum primum is more common. Yep.
And this
secondum most common, they're saying. You're saying
associated. Yeah, but with Down syndrome, we have ostium primum defects.
Yeah, correct. Okay, for Downs, specifically the primum. Yes, agreed.
And
sorry.
The paradoxical emboli also happened with the PFO, right? The patent fossa ovalis, different from the ASD.
Yes. Yeah, they both cause paradoxical emboli. You're right.
That is more common. ASD is the defect, but that is most common found in the people, which is undetected most of the time.
Which is more common?
PFO.
Yeah.
I think.
Didn't it come up somewhere where we saw? Because the fusion doesn't happen, so it's very quiet and it's left behind, and that's why PFO, paradoxical emboli, are more common. Yeah, I think so.
Something like that. And here, I don't know, but in you word it.
Yeah. I agree. It makes sense because we saw it somewhere here too. In embryology, I remember mentioning the paradox. So PFO was more common because they remain unfused here. Paradoxical emboli, venous thromboemboli entering the systemic, as can occur in ASD. Yeah, PFO as well as ASD can cause paradoxical emboli, but this is more common. You're right, because in a lot of compared to ASD, this remains unfused, and that can cause the paradoxical. Yes, agreed. And ASD is more common in the Downs population, and with ASD, we said more specifically the ostium primum issues. As compared to the rest of the population, non-Downs patient, it is the ostium secundum. Where did it go? Yep. So yeah, ostium secundum defects most commonly, but it's associated with Downs. And in the Down syndrome, it was I think this was UWorld, yeah. Ostium primum defects more commonly. Okay. Then what else? So yeah, so we're done with ASD. Next we have PDA, patent ductus arteriosus. So in fetal period, shunt is right to left, which is a normal physiological shunt. So in the fetal period, shunt is right to left, which is normal. In neonatal period, there is decreased pulmonary vascular resistance. So yeah, so this sudden change, right? Fetus is delivered, placenta is removed, and that causes, and baby takes a breath. Immediately, fetus becomes a neonate. So in neonatal period, there's decrease in pulmonary vascular resistance. The shunt becomes left to right. Progressive, so especially in this patent ductin patients, there is progressive right ventricular hypertrophy and or LVH and heart failure. So it's associated with a continuous machine-like murmur. patency is maintained by PGE synthesis and low oxygen tension. So uncorrected PDA can eventually result in late cyanosis in the lower extremities. So this is a buzzword. Or they wouldn't tell us directly it's differential. We have to interpret. They would give us the PCO2 or no PO2 values. Yep. So in one more time, in what is PDA in the fetal period? Normally the shunt is right to left, which is normal. But in neonatal period, there is a decreased pulmonary vascular resistance. Shunt becomes left to right. But the ductus is still open. So progressive right ventricular hypertrophy and or left ventricular hypertrophy and heart failure. So it's associated with the continuous machine-like murmur. Patency is maintained by PGE synthesis and low oxygen tension. Uncorrected PDA can result in late cyanosis in the lower extremities, differential cyanosis. So PDA is normally neutral and normally, PDA is normally neutral and normally closes only after birth. So if it remains open, that's the PDA situation. And the buzzword is thrill over the upper left sternal edge or sternal border for these questions, thrill. Then next we have Eisenmenger syndrome, comes up a lot in questions.
Usually, they say the infraclavicular region, right? Or the mid-scapular, if I'm not wrong.
Yeah, that also, I think. Thrill over there, and what you're saying is heard loudest, right? Auscultatory, what you're saying?
I think so, yeah. Infraclavicular region and the mid-scapular region.
Let me make a note. Infraclavicular and mid-scapular.
Yeah, infraclavicular, I'm sure, and mid-scapular, I remember something. Anyone? Shruti?
And these are for auscultation, loud auscultation, or was it for? Because this one, what I'm saying is palpation finding. Thrill over the left sternum on palpation. I think what you're saying is auscultatory, right? It's heard louder.
Yeah, auscultatory.
In infraclavicular and mid-scapular, yeah, auscultation. Thank you. And thrill over uppers, they'll say on palpation. Because something, this is what we palpate or thrill. Okay. Thank you. So that was PDA. Next, we have Eisenmenger syndrome. What is Eisenmenger syndrome?
And this differential cyanosis, we have a question. You remember?
Yeah, I remember. It was very subtle. That's what I'm saying. They didn't clearly give it. They gave the PO2 values or something, right? Do you have the question ID by any chance? Well, let me look it up. Let's see.
It's unconnected PDA, so
yeah, let me check.
The lower extremities differential cyanosis.
Yeah, it was a very interesting question. It got me. Cyanosis. Uncorrected PDA. Was it this one? Sorry?
That was one, the shunt reverse right to left.
Shunt reversal PDA. Let me just go over this. Let's see. This is bicuspid. This is coarctation. B. This is just Eisenmenger's. Maybe this image is good. Okay, just. Yeah, someone asked me the other day how I take screenshots. On record, unofficially, I just use shortkeys on my thing. And one of my good friends, she taught me, and the GoodNote app has the option to just copy paste. So it was, yes, thanks to my friend who's here. Yep. So PDA was I think this was a question, right? Pulse ox was the right hand shows 99%, but then bilateral cyanosis. So right hand is normal, but then cyanosis of the lower extremity. So very subtly, they gave the differential cyanosis. So 10-year-old boy immigrated from overseas, brought to the office due to exertional dyspnea and fatigability. Boy tires easily when walking. So yeah, 10-year-old, this itself tells us, okay, it's a left to right shunt, because all right to left will present way early in the infant stage. So that's the first clue. So immigrated, boy tires easily, when walking cannot keep up with his peers. According to his parents, he was diagnosed with congenital heart disease in infancy, but corrective treatment was unavailable. They cannot recall the details of diagnosis. He takes a multivite and no meds. Pulse ox on the right hand shows 99. Physical exam, no murmurs, but there's bilateral cyanosis and clubbing of the toes. So that is telling us differential cyanosis very subtly. The fingers are normal. All extremity pulses are full and equal. Which of the following is most likely diagnosis? So as soon as you see this, we know the answer is a PDA. So low extremity differential clubbing and cyanosis without pulse discrepancy is caused by large PDA, complicated by Eisenmenger syndrome, so reversal of shunt flow from LR to RL. In contrast, intracardiac right to left shunting in patients with large septal defects and TOF result in whole body cyanosis. Yeah, this is a key word. This is just TOF. Okie dokie. Next.
What is this last point? Sorry, you said just.
So in Eisenmenger, so here it says other things, right? All others, intracardiac right to left shunting in patients with large septal defects and TOF will result in whole body. So they're just differentiating differential versus the whole body. And then this was the other question we've seen where there is sudden drop. Where are we seeing the change? So yeah, from 70. So blood is collecting SVC, IVC, bringing in 70, suddenly it changed to 81%. How? Because there's a mixing. So this had to be a VSD at this level. So then they didn't tell us it was VSD. They asked what murmur will we find? So the answer was holosystolic murmur of the, so that's a 2-jump question. Holosystolic murmur of the left sternal border. Okay, then so following is the most likely cause of patient's murmur. So this was coarctation, hearing, and S4. Continuous murmur, best, yeah, here you go, interscapular area for coarctation of aorta. And then no murmur, distal pulses are prominent, but dorsal spurious and posterior tibial pulses are difficult to palpate. So yeah, pulse differentiation, what was the word? Again, differential cyanosis, and one more word, palpable pulsations on the, yeah.
Brachiofemoral delay.
Yeah, that's the word. Thank you. Brachiofemoral delay. So yeah, they won't say brachiofemoral delay. They'll say distal pulses in the radial arteries are prominent, but the dorsal spurious and posterior tibial pulses are difficult to palpate. So what are they saying? Brachiofemoral delay. What should we think of? Coarctation of aorta. So which of the following is the most likely cause? Increased blood flow through the collaterals. Cause of the murmur, they're asking. Okay. Continuous murmur, best auscultated over the back of the left interscapular area. That was a fun question. Next. Again here, this was also a question. Pulse ox readings were 98 in the right hand and 83 in the left foot. Again, indicating differential cyanosis. So it was a right to left via PDA. Differential cyanosis post-ductal, less than preductal oxygen saturation. In a neonate, suggests right to left shunting across a PDA, such as a persistent pulmonary hypertension of the newborn. Patients with PPHN typically have an underlying pulmonary disorder with respiratory distress and strong femoral pulses. Yeah, this we saw in Palm, I think. Okay, PPHN. Okay, so that was just a quick question jog. Next we have,
Thank you so much.
Thank you. That was a good one, yeah. Okay, so next we have Eisenmenger syndrome. Whenever there's an uncorrected left to right shunt, like BSD, ASD, and PDA, there's increased pulmonary blood flow, causing a pathologic remodeling of the vasculature. So left to right shunt, so from the left atria or ventricle, ventricular septal, atrial septal, or a patent ductus arteriosus, so coming back to both the chambers. PDA, yeah, connecting these two, yes. So pathologic remodeling of the vasculature causing pulmonary arterial hypertension. So this is keyword. So pulmonary arterial hypertension, right ventricular hypertrophy occurs to compensate, because recall Laplace law, hypertrophy will decrease the wall stress. So RVH occurs to compensate, shunt becomes right to left. When RV, right ventricular increases, right ventricular pressure exceeds the left ventricular pressure. See this illustration. So yeah, reversal causes late cyanosis, clubbing, and polycythemia. This is important, we discussed it before, right? Polycythemia is occurring. Age of onset varies depending on size and severity of the initial left to right shunt. So I think this UWorld image was much better, which we just saw. Not this one. Yeah, this one. So either in the case of left-right shunting through ASD, VSD, or PDA, what is happening is here they're showing the diameter of the pulmonary vessel. So over time, pulmonary vascular resistance. So yeah, more and more blood is going to the left side. It's being overloaded. So more going to the more going to the body and returning to the IVC, and lots of blood going to the pulmonary side. Because of the VSD, for example, in this image. So over time, pulmonary vascular resistance increases to compensate. So this, we're seeing the diameter went down. So pulmonary vascular resistance leading to bidirectional flow. So it's going to push it backwards. So when it becomes really severe, so continued increase in PVR leads to the shunt reversal. So now it's going to go in the opposite direction. So normally in healthy heart, high left-sided pressures are high, but here there's mixing. So over time, this side becomes so high that it's stronger enough now to cause right to left flow. So continued increase in the PVR leads to shunt reversal, right to left, or which is known as Eisenmenger syndrome by definition. Okay, so yeah, uncorrected left to right shunt ending up in a right to left shunt. So that's basically Eisenmenger syndrome. Age of onset varies depending on the size and severity of the initial left to right shunt. Okay, cool. Next, we have coarctation of aorta, persistent pulmonary hypertension of the newborn, congenital cardiac defect associations, and hypertension. On the next page, okay, let's see. So coarctation of aorta, aortic narrowing, as we're seeing here in image A, near insertion of the ductus. Near insertion of the ductus is the juxtaductal one, associated with bicuspid aortic valve. So yeah, coarctation is associated with bicuspid, other heart defects, and Turner's. And we know Turner's is coarctation now, and bicuspid aortic. Yeah, Turner's is associated with coarctation, sorry. Coarctation is associated with bicuspid aortic valve, so only two cusps, other heart defects, and Turner syndrome. Hypertension in upper extremities. Yeah, this is the key clue. Hypertension in upper extremities. Lower extremities are cold with weak delayed pulses. So this is known as brachiofemoral delay, as we said. With age, intercostal arteries enlarge due to collateral circulation. Arteries erode ribs and cause a notched appearance on chest X-ray, which is usually buzzword. So brachiofemoral delay, notched appearance on chest X-ray. And what are the complications of coarctation? We have heart failure, increased risk of cerebral hemorrhage, like berry aneurysms, aortic rupture, and possible infective endocarditis. So complications include heart failure, increased risk of cerebral hemorrhage, like berry aneurysms, aortic rupture, and possible infective endocarditis. So I think this was from the older book. So infantile so it's juxtaductal close to the heart. In adults, it's distal to the ductus. So maybe it comes somewhere else. Maybe adult is distal to the ductus. Okay, so next, so that was coarctation of aorta. Next, we have PP, persistent pulmonary hypertension of the newborn, which we just saw in that question. So here there is persistently increased pulmonary vascular resistance.
Sorry, just to add one thing.
Yeah, sure.
We also find the question is hyperplasia of tunica media and intima here.
Say again. I didn't hear you clearly.
There is a figure 3 sign on the chest X-ray as well, in coarctation of aorta. Right.
Figure 3 sign on chest X-ray.
Yeah, figure 3 sign on the chest X-ray, and also we have I have written hyperplasia of tunica media and intima.
Hyperplasia of tunica intima and media. Makes sense. So that's causing the coarctation. Figure 3 sign meaning like this, right? This whole thing?
Yeah, I think so. Yeah. Specific? It's on chest X-ray. Mostly.
Okay, on X-ray. This is different. Okay.
Chest X-ray and hyperplasia of tunica media and intima there. And these are intercostal arteries enlarged due to collateral circulation between intercostal and internal thoracic arteries.
So this collateral circulation is between
intercostal and internal thoracic.
Intercostal arteries and internal thoracic. Yeah. Thank you. Thank you. I had forgotten that internal thoracic. Yeah. Let me see if I can pull up a figure 3 sign just for visual memory. Figure 3 sign coarctation. Formed by pre-stenotic dilatation of the aortic arch and left subclavian artery, and an indentation at the coarctation site known as the tuck, and the post-stenotic dilation of the descending aorta. Okay, so like this, there's a tuck and then there's a dilation. Nice. Cool stuff. And there's rib notching as well, which they're showing here. Not very clear though. Rib notching. Okay, yeah. This one, right? Cool. Nice. Thank you. Thank you. So that's all seen with coarctation. Figure 3 sign. Notched ribs. Why we have seen notched ribs? Because of the intercostal arteries are enlarged due to collaterals, and that's causing a notched appearance. And hyperplasia of which layers of the vessels? Tunica, intima, and media. Thank you so much. Then we have persistent pulmonary hypertension of the newborn. So here, persistence of increased pulmonary vascular resistance after birth. So after birth, this is supposed to drop, but it's persistently high, associated with abnormal development and postpartum adaptation of the pulmonary vasculature. Risk factors include aspiration of meconium-stained amniotic fluid and neonatal pneumonia. Leads to right-left shunt through the foramen ovale and ductus arteriosus. Newborn presence with signs of respiratory distress like tachypnea and cyanosis. Preductal oxygen saturation is often higher than postductal. So equal pulses, no delay. So versus here, there is brachiofemoral delay for coarctation. Here, no delay. Because here also, I think there'll be difference between the preductal and postductal saturation. So here, preductal, postductal difference plus femoral delay. Here, its preductal oxygen saturation is higher than postductal and no delay. Okay. All right. So next, that was persistent pulmonary hypertension of newborn. I think I should repeat this one more time. Persistent of pulmonary vascular resistance after birth associated with abnormal development and postpartum adaptation of the pulmonary vasculature. Risk factors include aspiration of meconium, stained amniotic fluid, and neonatal pneumonia. Leads to right-left shunt through the foramen ovale and the ductus arteriosus. So right-left shunts as through the foramen ovale and the ductus. Newborn presents with signs of respiratory distress like tachypnea and cyanosis. Preductal oxygen saturation is often higher than postductal. Equal pulses, no delay. Okay, so congenital cardiac defect associations. So what is the association? What's the defect associated with? So prenatal alcohol exposure, fetal alcohol syndrome, VSD, PDA, ASD, TOF. Fetal alcohol, smooth philtrum was the key buzzword, right? The ones with fetal alcohol. Smooth philtrum, I think so. Okay, then we have congenital rubella.
Yeah, smooth philtrum, thin vermilion border.
Yeah, thin vermilion border, smooth philtrum. That's the main buzzword for fetal alcohol. Yes, thank you. Then we have congenital rubella. Defect is PDA, pulmonary artery stenosis, and septal defects. Rubella, PDA, pulmonary artery stenosis, and septal defects. Then Down syndromes, AV septal defect, endocardial cushion defect, VSD, ASD. So yeah, endocardial cushion defects with Downs is high yield, VSD, ASD, of course. Infant of patient with diabetes during pregnancy. This is transposition, truncus, tricuspid. So TTT and then VSD. So then Marfan syndrome, mitral valve prolapse. Yeah, this is a key association. Mitral valve Marfan's with MVP, thoracic aortic aneurysm and dissection, and aortic recurge. Prenatal lithium, we saw Epstein, Turner's with bicuspid aortic valve and coarctation. This we saw coarctation for Turner's, as well as actually both bicuspid and coarctation for Turner's. Williams syndrome, supravalvular aortic stenosis. Williams was the deletion of the long arm of chromosome something. 7, I think. Does anyone remember?
Long arm of 7p, maybe.
7p, right? And then deletion of short arm was Cre2-Shart. So yeah,
Mhm.
Williams syndrome's associated defect is, thank you, Amna, supravalvular aortic stenosis. And then 22q11 syndrome, so that we said velocardiofacial and DiGeorge, they are associated with truncus arteriosus and TOF, which comes up in questions. So yeah, biochem, genetics, and cardio, everything's correlated, so multi-system questions. Okay, so that's congenital cardiac defect associations. Next, we have hypertension. What is hypertension? Persistent systolic BP of more than or equal to 130 and or a diastolic BP of more than or equal to 80 millimeters of mercury. Sorry, I've not been looking at the chat for a bit. Yeah, this was the image. Thank you. Park at Ventura Avenue. First aid has added he parks at Ventura Avenue. The image, yes, thank you. I don't know, sorry Neela, I don't know what you said to repeat. It's been like almost an hour ago, my bad. Local metabolites as vasodilators was your question. For heart, don't know what potential. Okay. Rubella finding. What was rubella finding? Oh, PDA. Okay, yeah. Okay, sorry, just caught up with the chat. Thank you guys. All right, so that's done with congenital cardiac defect association. So now coming to hypertension. So persistent systolic BP more than or equal to 130 millimeters of mercury and or diastolic BP more than or equal to 80 millimeters of mercury. So risk factors: increased age, obesity, diabetes, physical inactivity, high sodium diet, excess alcohol intake, tobacco, smoking, family history, incidence greatest in Black, more than white, more than Asian populations. So yeah, that's risk factors. Then we have features. 90% of hypertension is primary, which is essential and related to increased cardiac output and increased TPR. Remaining 10% mostly secondary to renal or renovascular diseases such as fibromuscular dysplasia, which comes up. Characteristic string of bead appearance of renal artery, usually seen in adult females, and atherosclerotic renal artery stenosis. So remaining 10% is all this secondary to renovascular disease, atherosclerotic renal artery stenosis, primary hyperaldo, or OSA. So yeah, 90% is primary. The rest are secondary. Okay, so primary is associated with increased cardiac output and increased TPR. Okay, next, what is hypertensive urgency? This is severely high blood pressure, more than or equal to 180 systolic, divided by more than or equal to 120, without acute end organ damage. So that's keyword, without end organ damage, versus it becomes a hypertensive emergency, formerly called malignant hypertension. Severe hypertension with the evidence of acute end organ damage. Yeah, severe hypertension with the evidence of acute end organ damage. So what is the end organ damage? Encephalopathy, stroke, retinal hemorrhages, and exudates, papilledema, MI, heart failure, aortic dissection, kidney injury, and MAHA and eclampsia, microangiopathic hemolytic anemia and eclampsia. Arterioles may show fibrinoid necrosis. This is key word. Arterioles may show fibrinoid necrosis. Predisposes to coronary artery disease, LVH, left ventricular hypertrophy, heart failure, AFib, A dissection, aortic aneurysm, stroke, CKD, hypertension, nephropathy, and retinopathy. Yes, we are familiar hypertension. And then string on bead. What was it? String of beads appearance on renal artery. This is an NBME question. Fibromuscular dysplasia, females. Yep, renal artery. Okay, so next we have hyperlipidemia signs, atherosclerosis. Okay. This we saw when we did familial hyperlipidemia syndromes a little bit. Yeah. So hyperlipidemia signs, what are they? It can be xanthomas, tendinous xanthomas, or corneal arcus. Xanthomas are plaques or nodules composed of lipid-laden histiocytes in the skin, especially in the eyelids. If it's in the eyelids, that's known as xanthelasma, as seen in this B. Okay. So yeah, xanthomas are plaques or nodules composed of lipid-laden histiocytes in the skin. I think histiocytes are the scavengers in the skin, so they collect lipid and form plaques. So lipid-laden histiocytes in the skin, especially in the eyelids, xanthelasma. Tendinous xanthoma, lipid deposition in the tendon, as the word says, especially in the Achilles tendon and finger extensions. And then finger extensors, sorry. So we're seeing in the tendon, okay, finger extensors. Okay, cool. Then, so yeah, in the skin, so this is xanthomas in the skin, xanthelasmas in the eyelids, lipid deposition extensors of the hand, finger extensors, so tendinous xanthoma, and then corneal arcus, which is lipid deposition in the cornea. Common in older adults, which is called as arcus senilis, which we see here. And but appears earlier in life with hypercholesterolemia. So anyone remembers which type we said? 2 eyes. So we said type 2, right? Shruti had said, I remember. Two eyes, so corneal arcus in the eye. That was type 2. Okay.
And xanthomas are in type 2 and type 3, right? Type 2, it's a Archilles xanthoma in type 2. And type 3 is the palmar xanthoma.
So xanthomas are in two things, in type 1 and type 3. One has in the, I forgot, what did you say?
Sorry. In 1, 2, 3, in all 3 xanthomas are there, okay?
Okay.
So first one, remember, it's a eruptive or pruritic xanthoma. Okay, the picture what they're showing here, right? A picture. Okay. There are 2 palms. So type 2 xanthomas are Archilles xanthomas are type 2. And type 3 is the palmar xanthomas.
Yeah, correct. Type 3 for palmar. So 1 is pruritic, 2 is tendon, 2 for tendon TT. And then third one was the palmar, yeah.
So xanthoma is coming actually, pehle itching hui pair mein, then Archilles pe pahuncha, and then it comes to the palm. So retrograde from down to above, like that means a way to remember.
Oh, nice. So 3, 2, 1. So first in the palm, then in the tendon.
First wala पैरों में खुजली हुई, the itching in your foot, okay? Or whatever, the itching has started in your skin. Anything happens first, any rash and all, it start from the skin, right? So type 1 hyperlipidemia is the pruritic or eruptive xanthoma, okay? Then it started coming from the Archilles and then into the palm. So second one is the Archilles xanthoma. And third hyperlipidemia is the palmar xanthoma.
Okay, nice. Nice,
thank you. Corneal arcus also with type 2, Shruti?
Yes. 2 eyes, cornea is 2. So I mean that way.
Okay. 2 tendons and 2 Achilles tendons and 2 eyes. Thank you.
Yeah, and then also the second alphabet is B. So we said B48, no, B100, right? I think B100. That's the defect. Correct?
Correct.
Arcus. So sorry, what is this page now? 3 or 5? This one. No. Yeah, this is the one. So we said pruritic, then tendon with the corneal arcus, and then the palmar. So 1, 2, 3, 4. So 1 was all the C stuff. C2, chylomicron cholesterol, creamy layer. 2 was type 2. Second alphabet B100. T for tendon, 2 legs. So tendon, 2 eyes, so corneal. Type 3 is all the E stuff, Apo E type 3. And yeah, then type 4, VLDL, because 4 alphabets, and hypertriglyceridemia. Okay, cool. Thank you. So back to our question or our page. So yeah, so that was a recall with familial hyperlipidemia syndromes. Thank you guys. Yep, so done with this. Next we have atherosclerosis. Just give me one sec. So atherosclerosis is a very common form of arteriosclerosis. Sclerosis hardening. So hardening of the arteries. Disease of elastic arteries. This is important. Disease of elastic arteries and large as well as medium-sized arteries, muscular arteries, caused by buildup of cholesterol plaques in the tunica intima. So for that we said intima and media, which was coarctation. Here we're seeing atherosclerosis. Main thing is intima. Okay.
What did you say about coarctation? You said intima or media?
Intima and media.
Both of them.
So hyperplasia of intima and media for coarctation. Yeah.
Okay.
Hamna said this. Thank you. Yeah. So this atherosclerosis is plaque buildup in the intima, as we see in the image. We'll see it shortly. So next, so location, most common in the, so a copycat named Willis. So abdominal aorta, coronary artery, popliteal artery, carotid artery, then circle of Willis. So abdominal artery is most common. In my head, I always thought coronary. So abdominal aorta, more than coronary, then popliteal, then carotid, then circle of Willis. So copycat named Willis. Okay. Risk factors, modifiable and non-modifiable. This we know. Modifiable is hypertension, tobacco smoking, dyslipidemia, increase LDL, decrease HDL, and diabetes. So quick recall, what are the 2 things that HDL gives away? ApoC2 and
ApoE.
ApoE. Yes, thank you. ApoC2 and ApoE. Yes, thank you. So yeah, so in atherosclerosis, we have increased LDL, which is bad cholesterol, and decreased HDL, diabetes. Non-modifiable, age, male sex, postmenopausal status, and family history. Symptoms are angina, claudication. It can be asymptomatic. So what are the symptoms of atherosclerosis? Angina, claudication, but it can also be asymptomatic. So progression, inflammation important in pathogenesis. So this first thing is endothelial cell dysfunction. It causes macrophage and LDL accumulation, foam cell formation, fatty streaks, smooth muscle cell migration. So involves PDGF and FGF, proliferation and extracellular matrix deposition, fibrous plaque causing complex atheromas. So what the 2 factors which are important is platelet-derived growth factor and fibroblast growth factor. So all this leads to calcification. The calcium content correlates with the risk of complications. So the more the calcium, the more the complication. So one more time, the inflammation is important pathogenesis. It starts off with endothelial dysfunction, leads to macrophages and LDL accumulation. Foam cells are formed, fatty streak formation. Smooth muscle cell migration. So these smooth muscles are migrating. How? Because it releases FGF and PDGF, extracellular matrix deposition, and fibrous plaque is formed. So this is known as a complex atheroma. And so seen here, we're seeing this complex atheroma. Calcification correlates, calcium content correlates with the risk of complications. So vascular reaction to endothelial and intimal injury is internal hyperplasia and fibrosis, predominantly mediated by reactive smooth muscle cells that migrate from the media to the intima. From the media going to the intima. Okay. And then we're seeing the cholesterol cleft thing. So that's the key clue for atherosclerosis. But one more thing which had this cleft-like appearance is the echinococcus cyst, right? Does anyone remember the image? It has like some parts of the echinococcus which looked like clefts. B and E. No, it used to be in the old book, I think. Or maybe I'm recalling from UWorld, no idea. Cyst-like things. Okay, never mind. So back to where we were. Yeah, so cholesterol clefts is
Cholesterol emboli you are talking about, right?
Yeah, cholesterol emboli also has cholesterol clefts, but I'm saying echinococcus cyst, it is not cholesterol cleft, but it just looks like it has this cleft-like things in that cyst. So I was just correlating. But yeah, they're not related. It's just different facts. Just
that's hydrated cyst we're talking about, right?
Yeah, hydrated cyst. Yeah, that's the one. Yep. Okay, so what are the complications of atherosclerosis? Ischemia, infarction, aneurysm formation, peripheral vascular disease, thrombosis and embolism. What are my notes? Symptoms occur after more than 70%. Yeah, this is a question, I believe, or it came up in a question. Symptoms start occurring after 70%, more than 70% of stenosis. Yeah, atherosclerotic emboli, hallmark is cholesterol clefts. So what are we seeing? First, endothelial dysfunction. Monocytes are coming in. There's a damaged endothelium, monocytes coming in. We have lipid-laden macrophages. So macrophages have taken up the excess LDL, and now they're becoming foam cells. There's a fatty streak, so fatty streak formation. And now smooth muscles have come into the picture because of PDGF and FGF. So there's a fibrous plaque formation and what is it called? Fibrous plaque, complex atheroma. Complex atheroma. All right, cool. So that's atherosclerosis. Next, we have cholesterol emboli syndrome. This comes up in questions. What is this? It's a microembolization of cholesterol displaced from the atherosclerotic plaque in large arteries, usually the aorta. Okay. So yeah, microembolization of cholesterol displaced from the atherosclerotic plaques in large arteries, usually the aorta, results in end organ damage due to small artery emboli and inflammatory response, like we see livedo reticularis, digital ischemia, blue toe syndrome, acute renal failure, and cerebrovascular accident, as well as gut ischemia. Pulses remain palpable because larger arteries are unaffected. So versus here, we said large and medium-sized muscular arteries, elastic arteries as well. Here it is large arteries are unaffected, so pulses are unaffected. This is mainly in the small vessels. Displaced from the large arteries and going into the small arteries. May follow invasive procedures. Yeah, this can be iatrogenic, like angiography, angioplasty, and endovascular grafting. So that's cholesterol emboli syndrome. Next, we have arteriolosclerosis. So common form of arteriosclerosis. Arterio meaning arterial hardening. Here it is arteriolo, so subtype, affecting the small arteries by definition and arterioles. Two types, high yield, hyaline, and hyperplastic. So hyaline, what do we have? We have vessel thickening, secondary to plasma protein leak into the subendothelium. Plasma protein is leaking into the subendothelium in hypertension or DM. So this hypertension, DM, classic buzzword, hyaline arteriolosclerosis. Why is this happening? In hypertension, there's so much blood pressure going through the vessels, creating so much pressure that the increased BP forces the protein into the wall. So hyaline is like a protein forced into the wall. So that's hyaline arteriolosclerosis, secondary to hypertension. In diabetes, what is happening? There's a lot of blood sugar floating around in the blood vessel. So it causes non-enzymatic glycosylation of the basement membrane. So now they are glycosylated. Non-enzymatic means no enzyme is involved. They just go around distributing sugar. So that sugar is attached to the basement membrane. Now the basement membrane is damaged. It becomes leaky. So leaky blood vessel causing protein leak. It's pretty cool. So hyaline, hypertension or DM, different mechanisms, but ending up causing squeezed protein, plasma protein leak into the subendothelium. So next is hyperplastic. This is onion skinning. So as we see here, in severe hypertension with proliferation of smooth muscles. So here the addition is there is the smooth muscle proliferation. So smooth muscle proliferates in circles like that. So it gives like an onion ring appearance. Yeah, and death of blood vessel wall. If we recall from pathology, it causes fibrinoid necrosis. So this will be seen in malignant hypertension and vasculitis, especially in polyarteritis nodosa. Fibrinoid necrosis is the buzzword for these two, either malignant hypertension or vasculitis. So yeah, that was a side note. So next we have aortic.
And we said fibrinoid necrosis previously in atherosclerosis, I guess. Where?
Yeah. Yep.
Hypertension. Yeah, sorry, malignant
Hypertension. Here we saw it, right? Yeah. Arterioles may show fibrinoid necrosis.
And pan and here.
Malignant hypertension. Basically, malignant, they changed it to hypertensive emergency. Maybe because it was a misnomer, people probably thought it. Layman would think it's malignancy. So hypertensive emergency.
I think in Arthur's reaction, something also with this fibrinoid necrosis, if I'm not wrong.
Arthur's reaction?
Yeah.
I not remember that. Let me see. Yeah, nice. Arthur's reaction, fibrinoid necrosis. Awesome. So it's characterized by edema, fibrinoid necrosis, and activation of complement.
Also, polyarteritis nodosa.
Sorry?
Also, you see it in polyarteritis nodosa, right?
Yeah, also in PAN, yep. Polyarteritis nodosa. So yeah, we would add three things now then. Polyarteritis nodosa, malignant hypertension, also known as hypertensive emergency. Number 3 is Arthur's reaction.
And also hyperacute rejection.
And also hyperacute rejection. Awesome. Yes, you're right. I think I remember. Somewhere here, right? So 4 things we have. All 3 hypersensitivity reactions have fibrinoid necrosis. Okay, awesome. So hypersensitivity reactions. So now our list will be Arthur's reaction, so which is part of the hypersensitivity reaction, malignant hypertension, and what we're currently doing. Was it? No, PAN, polyarteritis nodosa. All right, nice. Back to where we were.
Last you said hyperacute rejection?
Yeah.
Or hypersensitivity reaction.
Hyperacute rejection, I think Neelu said. But I was reading from the chat, Hafsa said all 3 hypersensitivity reactions have fibrinoid necrosis.
Yeah.
I didn't recall that. Yeah. Let me check hyperacute actually, just for visual memory. Sometimes it sticks better when I see it. Yeah, fibrinoid necrosis. It makes sense, right? Because the blood vessel is what is getting injured in all of these things. So there would be fibrinoid necrosis. Yeah, extrapolating from general path makes sense. It comes together. Yeah. Nice. Thank you, guys. 305 was it? 306. Okay. Yeah, anytime there's blood vessel wall issues, then it's going to be fibrinoid necrosis. So I should add in here malignant hypertension, vasculitis like PAN, hypersensitivity reactions, more specifically Arthus, and hyperacute rejection as well. Okay, 306.
I think in this edition, they have removed the Monckeberger sclerosis, right? It is supposed to be here, no?
I think they put it somewhere else, though. It's still there somewhere. I remember seeing it, but they moved it around. Yeah.
Yeah, maybe. Yeah. Thank you.
Monckeberg and the other yeah, it comes under, yeah, it used to be somewhere here, actually. Yeah, you're right. Yes, hyperacute. Okay, cool. So next we have aortic aneurysm. So what is this? This is a localized pathologic dilation of the aorta, may cause abdominal and/or back pain, which is a sign of leaking, dissection, or imminent rupture. So localized pathologic dilation of the aorta may cause abdominal and/or back pain. So this is classic history, radiating to abdominal pain or radiating to the chest pain, radiating to the back, which is a sign of leaking, dissection, or imminent rupture. Yeah, my friends who watch Grey's Anatomy, you know, there was a recent episode with this aortic dissection patient. It's pretty cool. Anyway, so coming back, so aortic aneurysm, localized pathologic dilation of the aorta, of leaking, may cause abdominal pain, abdominal and/or back pain, which is a sign of leaking, dissection, or imminent rupture. Yeah, sadly, that patient died. So thoracic aortic aneurysm and abdominal aortic aneurysm. So associated with cystic medial degeneration. Risk factors include hypertension, bicuspid aortic valve, connective tissue disease like Marfan syndrome, also associated with tertiary syphilis. This is high yield. Obliterative endarteritis of the vasa vasorum. And what do we see finding? That was a NBME question. Tertiary syphilis. Then they gave the options. Blah, blah, blah. The answer was gummas, however you pronounce it. So yeah, they gave a situation of vasa vasorum. Aortic. Anyway, so thoracic aortic aneurysm. This is associated with cystic medial degeneration. Risk factors: hypertension, bicuspid aortic valve, connective tissue disease like Marfan's, and associated with tertiary syphilis. So obliterative endarteritis of the vasa vasorum. Aortic root dilatation may lead to aortic valve regurg. All right, next we have abdominal aortic aneurysm. Here it is associated with the transmural, all three layers, inflammation and extracellular matrix degradation. Risk factors include tobacco use, increased age, male sex, family history. And may present as palpable pulsatile abdominal mass. So yeah, palpable pulsatile abdominal mass.
Sorry, Saya, we have a question of like cystic collection of mucopolysaccharidosis, like basket weave pattern appearance in thoracic aortic aneurysm.
Thoracic aortic. Yeah, I remember basket weave. That was the buzzword. Basket weave appearance. Thoracic aortic. Thank you, Hamna. Does basket weave come in nephro somewhere?
Alport, kya? There
so.
also, right?
Let me see. Yeah, I think so. Alport, I think. Yeah, you're right. Let me check.
What did you say, Hamna? Basket wave in what?
In thoracic aortic aneurysm, because it's a cystic medial degeneration of the aorta. So it's cystic collection of mucopolysaccharidosis, basket weave pattern appearance.
Oh, thank you. Thank you so much.
Mucopolysaccharidosis. And the muco was Hunter's and Hurler's, right? Just tangent mucopolysaccharidosis? Or was it the bigger list?
Yeah.
Muco was Hurler's and Hunter's, right? Yeah, okay. And yeah, the basket weave, other one was Alport's. Thank you. Thank you. Nice. So back to 306. Okay, yeah. Cystic collection of mucopolysaccharides. Thank you, guys. So next we have abdominal aortic aneurysm. So here associated with all three layers, so it's transmural. So this is just the media. So cystic medial degeneration versus transmural is abdominal aortic is all three layers. Inflammation and extracellular matrix degradation. So this is collection of mucopolysaccharides. Here this is ECM degradation. So it's important to differentiate. Okay. Risk factors include tobacco use, increasing age, male sex, family history. Aversion to smoking was seen in weird fact, which we said. Anyone remembers?
Hep C.
Hep A, right? Or Hep C?
Yeah, no, you're right. I think it's Hep A.
Hep A or C? Yeah, one of the hepatitis. Hep A, I think.
You're correct, I guess. Yeah, let me check.
Sorry, what was the question?
One of the NBME questions, the clue was the patient has an aversion to smoking. I think
hepatitis
it was
A.
That is
the one with the apoptotic body question, right? That was the question, actually. Apoptotic bodies, councilman bodies, Hep A, aversion to smoking, death, extrinsic pathway, all of that, same question. Okay. So may present as palpable pulsatile abdominal mass, arrows in A, where is this? Okay, yes. So yeah. Point to the outer dilated wall, aortic wall. Okay, so rupture may present as a triad of pulsatile abdominal mass, acute abdominal or back pain, and resistant hypotension. So most often infrarenal distribution of vasa vasorum is reduced. Most often infrarenal, so below the kidney, distribution of vasa vasorum over here is reduced. Okay. So here we're seeing color coding, ascending thoracic aorta. So here is just the medial degeneration. So they're showing that outpouching, then aortic arch, descending thoracic aorta, and abdominal aorta. So it's a fusiform aneurysm versus a saccular. It forms a sac-like outpouching. Okay. All right, cool. So that's done with aortic aneurysm.
What is in the CD showing?
This one?
Yeah.
So they're showing this outpouched collection, right? So if you see this is the actual outer rim or outer pouch. This is the actual aorta. Does that make sense?
Okay. So yeah, filled one is aorta.
This one is the outpouch, and this.
Mhm.
Am I right?
Yeah.
This is the main
contrast. Contrast.
So contrast is filling the aorta, and then this just little bit is trickling into that outer rim.
Correct. Okay.
Thank you.
Thank you, guys. So now please. Okay. So cystic medial versus this is transmural. Media only, this is transmural. And here we said intima, and then here the previous. So okay, one more time, quick review. So coarctation, we said hyperplasia of intima and media. Atherosclerosis, the problem is mainly in the intima. Thoracic aortic aneurysm is medial issue, media layer, and abdominal aortic is all three transmural. Okay. So next we have traumatic aortic rupture. I think this also we have questions. So due to trauma and or deceleration injury, most commonly at the aortic isthmus. This is also a question, right? The most that's why it's tethered here. So this is the most site of traumatic rupture. Yeah. So yeah, one more time. Due to trauma or deceleration injury, most common at aortic isthmus, proximal descending aorta. What is the isthmus? It's the proximal descending aorta, just distal to the origin of the left subclavian artery. X-ray may reveal widened mediastinum, which is the clue. Okay. Aortic dissection. What is aortic dissection? This is a longitudinal intimal tear forming a false lumen. It's associated with hypertension, which is the most important risk factor. Bicuspid aortic valve, inherited connective tissue disorders like Marfan's can present with tearing, sudden onset chest pain radiating to the back, which is the key clues. Plus or minus a markedly unequal BP in arms. So unequal blood pressure in the arms. That's important. Then chest X-ray can show mediastinal widening, can result in organ ischemia, aortic rupture, and death. So we have Stanford type A and Stanford type B. A is proximal, involves the A for ascending aorta, which is red arrow in A. Okay, here. So this is the ascending aorta. So yeah, aorta is dissecting. You can see that little split-like thing. Okay. So Stanford type A proximal involves ascending aorta. Red arrow in A may extend to the aortic arch or descending aorta, which is the blue arrow in A. Okay. So this is ascending aorta and descending aorta. So it's extending from the ascending and then going all the way to the descending. So when we see a cross section like this, we're seeing both the places. So may result in acute aortic regurgitation or cardiac tamponade. Yeah. So acute AR, when they say usually an acute onset of a murmur, new onset murmur in an elderly patient who has hypertension, blah, 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 they're pointing towards aortic dissection. So yeah, may result in acute AR or cardiac tamponade. Treatment is surgery. Then Stanford type B, which is distal, B for below. So it involves only the descending aorta below the left subclavian artery. So B for below the left subclavian artery. Treatment here is beta blockers, then vasodilators, and surgery is reserved only for complications. And then what did we say was the type of murmur in aortic stenosis? Or aortic regurg, sorry. Anyone remembers?
D-arm.
Follow diastolic.
Yeah.
D arms, right? So diastolic and decrescendo murmur. Okay, so sudden onset diastolic decrescendo murmur should have a sink of aortic dissection. Then, yeah, so for type B, it's beta blockers, then vasodilators, surgery is reserved for complications.
Sorry,
so
what you said for last murmur thing?
So I said, if the question says a sudden onset diastolic decrescendo or like a new murmur, then they are pointing to acute AR, and that we should make us think of aortic dissection in our differential is what I'm saying. Does that make sense?
Okay.
Because
so
they
it's
won't say it's acute AR, they say the murmur, new murmur is heard, new onset murmur will be there.
Okay, good.
Does that make sense? I was just correlating because he said acute AR and cardiac tamponade. Okay.
I think these are the complications, no, these are the complications of these aortic dissection leads to acute AR or cardiac tamponade.
Yeah. That's what I'm saying. So AR situation, they would give us that the patient now has a new onset murmur. They're asking for diagnosis. So then we say aortic dissection. What led to this new onset murmur was, I think it was the question you earlier, Harun also says it's a question. What led to this new onset murmur was a question, I believe. And then the answer was dissection, because dissection will complicate to the acute AR, right? Does that make sense? That's what I was saying.
Yeah, thanks.
Thank you.
And one thing, do you remember what is the mechanism of action of beta blocker in treating dissection?
Oh my God, yes, that was such a good question.
Yeah.
Esmolol thing, right? Decreased, I think,
Yeah.
left ventricular contraction, something like that.
Decrease the shearing wall stress, something.
Yeah. But I don't remember it.
Don't remember the exact words. I feel like I took a screenshot. Yeah, but I didn't put it on here. Let me see. So it's
Decrease aortic wall shear stress.
Decrease
Aortic wall
diastolic
shear stress.
aortic wall shear stress. No, they use another wording also for the esmolol thingy. Maybe that's what it was. Aortic wall shearing stress. Okay, cool. Thank you, guys. Esmolol was the treatment because esmolol will decrease the aortic wall stress. And that was first line, I believe. This one, right? Yeah, I should make a note.
Esmolol will decrease the left ventricular contraction velocity and heart rate. That's what I heard.
That was the reason, actually. That was the answer. So it says, say again, please, so that I can drill it.
Esmolol beta 1 will decrease left ventricular contraction velocity and heart rate.
Left ventricular contraction velocity and heart rate. So thereby it helps to decrease the aortic wall shear stress, shearing stress.
First, you have the aortic wall decrease in aortic wall shear stress, and that leads you to. Oh no, yeah, you're right.
Yeah. So because the left ventricle is contracting slower and heart rate has gone down, so the aortic wall shear stress is less, and that's how it's beneficial. Right?
Yes.
Thank you. So yeah, esmolol is high yield. Beta blockers, specifically esmolol, is UL question. Yes, thank you so much, guys. Thank you, guys. Next, we have subclavian steal syndrome. This also, we have a couple of questions. Stenosis of the subclavian artery proximal to the origin of the vertebral artery. So yeah, stenosis of the subclavian vessels. So here, proximal to the origin of the vertebral artery, before vertebral artery comes off. Okay, so this area. So hypoperfusion distal to the stenosis leads to reverse blood flow in the ipsilateral vertebral artery. So hypoperfusion in the what are they saying? Hypoperfusion distal to the stenosis, which is on this side, leads to reverse blood flow in the ipsilateral vertebral artery here, and reduces cerebral cerebral perfusion. Okay, makes sense. So because there is hypoperfusion over here, so blood, instead of going up to the brain, it's going here. Okay, point of least resistance. So less resistance here, I mean less blood flow, so it's going here. So reverse blood flow to the into the ipsilateral vertebral artery. So reverse blood flow in the ipsilateral vertebral artery, reduce cerebral perfusion on exertion of the affected arm. So it causes arm ischemia, pain, paresthesia, vertebrobasilar insufficiency like dizziness, vertigo, more than 15 millimeter mercury difference in systolic BP between arms. So more than 15 millimeter AG difference in systolic BP between the arms, associated with arteriolosclerosis, Takayasu arthritis, and heart surgery. So iatrogenic stenosis, I believe, heart surgery. Okay, interesting. So arteriolosclerosis, Takayasu arthritis, and heart surgery. The subclavian steal syndrome. This was some random fact, I think, on UOL or somewhere else. Ingestion of beta, I don't know, myxomatous change in the media. I don't know if it's board relevant. Ingestion of beta aminopropiononitrile, a chemical found in certain kinds of sweet peas, causes angiolaterism, a change in the elasticity of the outer myxomatous degeneration seen in muffins, inhibits lysyl oxidase, an enzyme responsible for cross-linking. Okay, not board relevant. Okay, so yeah, aortic dissection and subclavian steal syndrome, we're done. So next we have ischemic heart disease manifestations. So yeah, what are they? Angina, coronary steal syndrome, sudden cardiac death, chronic ischemic heart disease, myocardial infarction. Okay, so ischemic heart disease manifestations: angina, steal syndrome, sudden cardiac death, chronic ischemic heart disease, MI. So angina, chest pain due to ischemic myocardium, secondary to coronary artery narrowing or spasm. So either the coronary artery is narrowed or it's spasming. There's no necrosis. This is important. No necrosis. So we have stable, vasospastic, and unstable. So stable angina is usually secondary to atherosclerosis. So we said stiffening, and symptoms will show up more than equal to 70% occlusion. Exertional chest pain in classic distribution, possibly with ST depression on EKG, resolving with rest or nitroglycerin. So at stable angina, secondary to atherosclerosis, more than equal to 70% occlusion. Exertional chest pain in classic distribution, possibly with ST depression on EKG. Yeah, resolving with rest or nitroglycerin. Then next we have vasospastic angina, formerly known as Prinzmetal or variant angina. So we should know these synonyms. They're used interchangeably. Prinzmetal or variant angina occurs at rest, secondary to coronary artery spasm. So this is the one where we have spasm. So first is atherosclerosis, then vasospastic is because of coronary artery spasm, transient ST elevation on EKG. So this is ST depression with stable. This is possibly transient ST elevation on EKG. Tobacco smoking is a risk factor. Hypertension and hypercholesterolemia are not, which is again counterintuitive. So hypertension and hypercholesterolemia are not a risk factor for vasospastic. The main risk factor is tobacco. Then triggers include cocaine. Yeah, this we saw somewhere. I think when we did the drugs in psych, cocaine, alcohol, and triptans can cause vasospastic angina. It's been the cause of death in many celebrities and stuff. Cocaine, or even a lot of young people, cocaine abuse or cocaine intoxication can lead to vasospastic angina and sudden death. So yeah, alcohol and triptans, treat with calcium channel blockers, nitrates, and smoking cessation if applicable. So then we have unstable. Here it's thrombosis with incomplete coronary artery occlusion. So the key word here is incomplete coronary artery occlusion. That's why it's unstable. It may or may not have ST depression and or T wave inversion on EKG, but no cardiac biomarker elevation, unlike non-STMI, so which will have the biomarker elevation. So it's no cardiac biomarker elevation. Increase in frequency or intensity of chest pain or any chest pain at rest. So either there's increase in frequency or an increase in intensity of chest pain or any chest pain at rest. It's indicative of unstable angina. So ST depression is indicative of subendocardial ischemia versus ST elevation is transmural. Okay. So ST depression.
Sarah, can you summarize? In stable, we have ST depression, right?
Mm-hmm.
In vasospastic, with transient ST elevation.
Correct.
In unstable, although it's thrombosis, but it's incomplete. So presents with ST depression.
Correct.
Or T-wave inversion. T-wave inversion in ECG, you said the causes were either acute ischemia or
we said acute ischemia. What else was it? I forgot. Recent MI. Ischemia or recent MI. So for T-wave inversion.
Okay.
Yeah.
Okay. Yeah. So these are okay. So that's a differentiating point between STEMI and non-STEMI.
Yeah.
Okay. Okay.
STEMI and non-STEMI. Yeah. Differentiate. Here also it comes up, right? Okay, let's see. I think if we do this table, it'll be more clear than the words. So again, angina, we have stable, unstable, non-ST elevation and ST elevation. MI. So pain, stable angina, so it's only on exertion. Unstable angina, mild exertion or at rest. So I think usually they usually say at rest, right, for unstable. And STEMI, again, at rest. So these are all at rest. So we know something's really going wrong. Troponin level, no elevation, unstable, but still no elevation. STEMI and NSTMI, it's elevated because at this point, the myocardiums are beginning to be ischemic or really severely damaged, starting to just get destroyed actually. So troponin levels, trops are elevated. Infarction, none, which correlates, it makes sense, right? That's why there's no troponin. Troponin is present in the cardiac myocytes. So if they get damaged, they leak out in the serum. So here it is elevated because we are seeing subendocardial ischemia and myocyte damage. Here transmural, so it will be elevated. So full thickness damage to the full thickness in ischemia. So thereby giving an ST elevation. So EKG changes, stable angina will be none. All they'll have is chest pain on exertion. That's it. Unstable angina, they may have mild exertion or chest pain at rest with possible ST depression and or T-wave inversion. So that's why they said transient ST elevation. So by the time they get to the hospital and do an EKG, it might not even show up. So that's unstable, possibly ST depression and or T-wave inversion. Versus non-ST elevation, by definition, it's not elevation, but it is depression and or T-wave inversion. So T-wave inversion, as we said, it is indicating of either of ischemia or a recent MI. So that makes sense. And then ST elevation by definition, so STEMI, so ST elevation. Okay. So that's angina. Keyword, any of this, there's no necrosis. So yeah, tropes are elevated in STM and non-ST elevation MI. And this is important. Tobacco is a risk factor, hypertension and hypercholesterolemia are not. Okay, so next.
And so even in STEMI, there is no necrosis, or just angina, there is no necrosis?
Actually, yeah, sorry, only on angina. This comes to MI, myocardial infarction. This will have necrosis. So that's the difference, right? Yeah. No necrosis, no myocyte damage. So no tropes, no necrosis. Versus when we come to, sorry, my bad. Thank you for correcting me. Yeah. STEMI and STMI, there will be necrosis, which is coming down here. Yep. Yeah, thank you. So this was just for angina. I need to remember this. Angina, no necrosis. Okay. Then next we have coronary steal syndrome. So distal to the coronary stenosis, vessels are maximally dilated at baseline. So administration of vasodilators like dipyrimidine or regadenoson, it dilates the normal vessels. I think UWorld has a good image for this, right? Vasodilators. So yeah, distal to the coronary stenosis, they're already maximally dilated at baseline. So by giving vasodilators, it dilates the other normal vessels. Blood is shunted towards the well-perfused area. Ischemia in myocardium perfused by stenosed vessels. So there's ischemia in myocardium, which is perfused by the stenosed vessel. This is the principle behind pharmacological stress test with coronary vasodilators. And regadenoson was a PDE3 inhibitor. So it called, and sorry, dipyrimidine, as we saw, was a PDE3 inhibitor. And this regadenoson is an adenosine receptor analog. So they both will cause vasodilation. So when we dilate these normal vessels, blood is shunted towards the well-perfused areas, leading to further ischemia in the myocardium, which was being perfused by the stenosed vessels. So it is a principle behind pharmacologic stress tests with coronary vasodilators. Let me see if I can find the image. Coronary steal syndrome. This one, right? Yeah. So what are we seeing?
This one is subclavian. This one is subclavian still.
Yeah, we're talking coronary steal. Sorry, my bad. This one. Yeah, this is the one. That was subclavian, my bad. That's coming up later, I think, today. Okay, so what is the coronary steal syndrome? So yeah, we have a flow limiting stenosis. So at rest, distal to it, they are maximally dilated. So here, normal myocardium. And here it is ischemic myocardium. So arterioles are maximally dilated to maintain flow. So that flow is maintained equally on both sides. So here they are maximally dilated already. By giving adenosine or any of these PDE3 inhibitor drugs type of a thing, so now we are vasodilating the normal vasculature. These are stenos, so even they won't respond to the vasodilators. Here they are being, by causing vasodilation, blood is going towards this side and going even less or very less to the post-stenotic vessel. So here what happens here, arterial dilation increases flow. Here arterioles cannot dilate further, so they cannot respond to it. They are already maximally dilated, so flow is stolen. So that's why it's known as coronary steal with adenosine, or dipyrimidine. So this was the coronary steal syndrome. So it will precipitate ischemia. All right, so blood is shunted towards well-perfused areas, ischemia and myocardium perfused by the stenotic vessels. This is principle behind stress test with coronary vasodilators. So next we have sudden cardiac death. There's an unexpected death due to cardiac causes within 1 hour of symptom onset. Most commonly due to lethal arrhythmias like VFib associated with CAD in up to 70% of cases, cardiomyopathy, hypertrophic or dilated, and hereditary channelopathies like long QT syndrome and Brugada syndrome, preventable with implantable cardioverter defib. So yeah, CAD, hereditary channelopathies, that's why regular screening is so important, so that they can get an implantable cardioverter defib so that we can prevent sudden cardiac deaths. And then just a tangent, we had a question, a lady was donating a massive amount of money, and what would be the most beneficial was the question. Anyone remembers? It was an NBME question, by the way. Would you give statins?
Defibrillators, cardioverter, something.
Yeah, automatic AEDs, you distribute them because that's the fastest way to prevent sudden cardiac death. So yeah, that question I remember. So yeah, you give AED. It's a public health question, yeah. Okay. Next, chronic ischemic heart disease, progressive onset of heart failure over many years due to chronic ischemic myocardial damage. So progressive onset of heart failure over many years due to chronic ischemic chronic ischemic myocardial damage. So this was a question, right? Myocardial hibernation. So this is a potentially reversible LV systolic dysfunction in the setting of chronic ischemia. So yeah, this is just trying to conserve energy, so it is reversible. It's a left ventricular systolic dysfunction in the setting of chronic ischemia. Contrast with myocardial stunning, which is a transient LV systolic dysfunction after a brief episode of acute ischemia. Transient LV systolic dysfunction after a brief period of acute ischemia. So yeah, this is kind of like when we are fasting, we just go into hibernation. All you want to do is just conserve energy. So that's like irreversible LV systolic dysfunction in the setting of chronic ischemia versus stunning. You're just shocked. Like if somebody startles you, that's just a stun, right? So a transient LV systolic dysfunction after a brief episode of acute ischemia. So that's the difference. Okay, then we have myocardial infarction. What is MI? It's often due to rupture of coronary atherosclerotic plaque. So the plaque
Sorry, Saira.
Yeah.
I'm so sorry. So myocardial stunning, we have a question, right?
Yeah.
Myocardial hibernation. So the key word here is chronic ischemia, right?
Yep.
And there's a question
chronic
that
disease. I remember
after
these words came in. I don't remember the question. What was the
after
scenario?
after I think my husband fighting with his wife, so something like. Do you remember that question?
No, I don't.
Okay.
Let me see if I can pull it up on you.
No, it's okay. It's
You
okay.
question? No, it's okay. I'm
Yeah,
interested.
you would.
Since you said fighting, just kidding.
Maybe it was like fighting or something like. Miro, do you remember?
So because of the cardiac stress, something happened, right? Vaguely remember what you're saying, but
Because of cardiac stress, it hibernate, right? That question you're talking about?
this one?
This is hibernating myocardium, right?
Yeah, this is hibernating myocardium. Refers to the presence of LV systolic dysfunction due to reduced coronary blood flow at rest that is partially or completely reversible by coronary revascularization. So an older man with dyspnea, chronic exertion angina, evaluated for coronary revasc, hypertension type 2 DM, blah, blah, blah. Fourth heart sound is present, hypokinesia of the anterior wall of the left ventricle, and LVEF is 35%.
And
Repeat
that's
echo.
preconditioning your.
Yeah, preconditioning. Repeated echo 10 days after the surgery shows hypokinesia is no longer evident, and LVF is back to 50%. So then they asked, what is the reason for this? Which of the following best explains the changes in the cardiac contractility and wall motion? The answer was a hibernating myocardium. So at this point, it was hibernating. Then patient underwent the bypass graft, so it became normal. And that's why the hypokinesia is no longer evident. LVF went up back to 50%. So that's they were testing. Yeah, preconditioning was also with chronic ischemia. So the heart is able to manage ischemic preconditioning. We said is a phenomenon in which brief repetitive episodes of myocardial ischemia followed by reperfusion protect the myocardium from subsequent prolonged episodes of ischemia. We said some funny story for this, I forget. It's a phenomenon in which brief episodes of myocardial ischemia followed by reperfusion protect the myocardium from subsequent prolonged episodes of ischemia. In clinical terms, repetitive
So
episodes.
that the heart get used to.
Yeah, so it gets used
after
to it.
brief repetitive episodes, yeah. So whenever there is whenever there is sudden ischemia or something, so massive ischemia, so it has the ability to
manage, yeah, correct. So ischemic preconditioning is a phenomenon in which brief repetitive episodes of MI followed by reperfusion protect the myocardium. So it's conditioned now, so it's able to protect the myocardium from subsequent prolonged episodes. So in clinical terms, repetitive episodes of angina prior to MI can delay cell death or after complete coronary occlusion. So in repetitive episodes of angina prior to MI can delay cell death. Yeah, it's counterintuitive, right? Angina is actually protective for MI, so that's why it's weird. But it's interesting though. So repetitive episodes of angina prior to MI can delay cell death after complete coronary artery occlusion and therefore provide a greater time for myocardial salvage with coronary revascularization procedure. Yeah. Then post-infarction scarring refers to the replacement of myocardium with collagen and fibrous tissue. So if this was the case, LVF won't go back up. So it leads to complete loss of myocardial contractile function and cardiac contractility would not be expected to improve. Reperf, further damage due to restoration of blood flow. So we saw this somewhere. Free radicals will destroy, so it will get worse. It will not get better. Ventricular remodeling. So this refers to a change in the structure, cardiac mass, or dimension or function of the heart in response to cardiac injury or hemodynamic changes. Remodeling can occur with long-term myocardial hibernation, but it would take weeks to months, not days. So yeah, that's why it's the wrong answer. So yeah, it was a close second. And the question you were talking about, this is trastuzumab. Was it this one? No, this is Takotsubo heart. The death of the husband and stuff is causing catecholamine-induced myocardial stunning.
Maybe
This is
it
the
is.
one?
I think so. Yeah, I worded it wrongly. Yeah, Takotsubo cardiomyopathy, maybe. Yeah, it's also catecholamine-induced stunning, right?
Yeah, correct. This is also stunning. Yeah. So yeah, but secondary to catecholamine surge and setting of physical or emotional stress. Postmenopausal women. ECG will show evidence of ischemia like ST elevation, T wave insertion in the anterior precordial leads. Coronary angio typically reveals absence of coronary artery disease. Yeah, that was the buzzword. Yep, here. So no evidence of obstructive coronary artery disease. Then death of a loved one. So this should trigger us with catecholamines, myocardial stunning.
Thank you. Thank you so much.
Thank you. What was the toxin induced? Alcohol, cocaine, anthracyclines. These lead to dilated cardiomyopathy. Okay. The toxins we saw, Sigua toxin, those do they do anything to the heart? I don't remember. One was sodium channel. There was a mnemonic, right? One was sodium channel.
I think bradycardia causes bradycardia, cigotoxin.
Yeah, bradycardia, heart block, and yeah, this is the cardiac manifestations. Nice, thank you. Yeah, so the mnemonic was histamine, total block of sodium, and opening of sodium channels to cause depolarization. So yeah, bradycardia and heart blocks, TPCD. Hamna said yeah. Okay, cool, nice. So back to where we were.
Yeah, Tetrodo prevents depolarization and Sigua causes depolarization.
Yeah, TPCD, yes. Where were we? Yeah. So yeah, myocardial hibernation is the reversible LV systolic dysfunction in the setting of chronic ischemia. Stunning is transient LV systolic dysfunction after a brief episode. So this is, stunning is with acute, chronic, I mean, how do I say? Hibernation is with chronic, 8C. Stunning is with acute. You stun when you see acute. So goofy. Okay, so stun is acute. Chronic is hibernation. Okay. Okay, next we have myocardial infarction. Most often due to rupture of coronary artery atherosclerotic plaque. So we said over here, if it's an unstable atheroma, it can lead to a rupture. Yeah, so complex atheroma can rupture and cause an MI. So what is it? So most often due to rupture of the coronary artery atherosclerotic plaque, causing an acute thrombosis, leading to increased cardiac biomarkers. So yeah, this is keyword. So increased cardiac biomarkers, CK, MB, and troponins are diagnostic. So we saw STEMI and NSTEMI. So NSTEMI, infarct location is subendocardial, STEMI is transmural, layers involved is subendocardium, which is the inner 1/3, especially, yeah, this is keyword. This is the question actually. Subendocardium, which is the inner 1/3 of the subendo, is especially vulnerable to ischemia. Transmural, so full thickness. ECG changes, ST segment depression. So it's not elevation, so obviously it's going to cause depression. And along with another wave inversion, which is T wave inversion. This by definition, STEMI, pathologic Q waves is the additional thing. STEMI, okay. Yeah, this metalloproteins, it's an older book thing, but then it's, I don't know why, I feel like they like it. So I started liking it. So likelihood of acute plaque change, especially rupture, produces an acute coronary syndrome where superimposed thrombosis and or thromboembolism is most related to plaque stability. Plaque stability depends significantly on mechanical strength of the fibrous cap. Inflammatory macrophages in the intima may reduce plaque stability by secreting metalloproteinases. So as we saw, proteinase, so it's going to destroy and causes plaque, reduces plaque stability. So it degrades collagen and causes plaque rupture. Just a side note. Okay, so next, our favorite page, most important, they comes up in almost every NBME, I feel like. Okay, so evaluation of MI, commonly occluded coronary arteries are lady, followed by RCA, followed by circumflex. So yeah. So yeah, commonly occluded arteries, lady, followed by RCA, then circumflex. Symptoms are diaphoresis, nausea, vomiting, severe retrospinal pain, pain in the left arm and or jaw. So shortness of breath and fatigue. So we have duration 0 to 24, 1 to 3, 3 to 14, and 2 weeks to several months. So 0 to 24, then 1 to 3, 3 to 14, 2 weeks, more than 2 weeks to several months. And usually this is the pattern, right? First, we have necrosis and stuff, eosinophilic situation, then N, then macrophages. Even in the neuro, if we recall, first it is the eosinophilic stuff, then the neutrophils, then the macrophages, and then the fibrosis and the scar. Okay, so let's see. So 0 to 24 hours, we have wavy fibers within 4 hours. So first comes the wave, then comes the coagulative necrosis within 4 to 24 hours. So we're seeing in A, cell content is released into blood, edema and hemorrhage is seen. And then reperfusion injury, which is tested, increased free radicals and increased calcium influx leads to hypercontraction of the myofibrils, which appears as eosinophilic stripes. These are called contraction bands. So on gross appearance at this point, within 24 hours, we have an occluded artery and causes the dark mottling, which is pale with tetrazolium stain. So it's pale if you see compared to the other areas. So dark mottling, pale with tetrazolium stain. So what are the complications? Ventricular arrhythmia, heart failure, and cardiogenic shock. At this point, patient can go into arrhythmia, heart failure, and cardiogenic shock. So next, within 1 to 3 days, what happens? There is a hyperemia. So extensive coagulative necrosis. Tissues surrounding infarct show acute inflammation with neutrophils. So yeah, first we have eosinophilic stripes, then we have neutrophils coming into the picture. So acute inflammation with neutrophils, and at this point, complications are post-infarction fibrinous pericarditis is tested. Fibrinous pericarditis makes sense, right? Neutrophils, so itis, inflammation is. Sorry. Okay, so post-infectious fibrinous pericarditis, and then 3 to 14 days, we have a hyperemic border with a central yellow-brown softening, which kind of correlates with the granulation tissue. So macrophages have come in here, then the granulation tissue at the margins. So in C, we're seeing lots of cells, and I don't know what they mean. Okay, maybe this granulation tissue at the margins. So here the complications are free wall rupture causing a tamponade, papillary muscle rupture leading to mitral regurgitation, yeah, acute onset mitral regurgitation post-MI. Interventricular septal rupture due to macrophage-mediated structural degradation leading to a left to right shunt. So septal rupture. And LV pseudoaneurysm, which is an impending risk of rupture. So that is 3 to 14 days. So first we had ventricular arrhythmias, which makes sense. Any chemical changes going on will trigger an arrhythmia, then heart failure, and patient can go into shock if the pump is not working. So then neutrophils, so inflammation, so pericarditis. What kind of pericarditis? Fibrinous. And coagulated necrosis in the microscopic level. So then 3 to 14 days in macrophages, then granulation tissue at margins. So here, granulation tissue is a weaker tissue, so it can rupture through, causing a tamponade. Papillary muscle rupture can happen, causing MR. Interventricular septal rupture due to macrophage-mediated structural degeneration, causing a left to right shunt. LV pseudoaneurysm, risk of a rupture. All right, next we have 2 weeks to several months. Here, there's a contracted scar complete. And then we had a question on you all, right? It said, they did an autopsy of a man. I think we spoke about this earlier too. 1 year later, what type of collagen would you see? The answer was type 1, right? So
Yeah.
type 3 is replaced by type 1 at that point, 1 year later. So yeah, 1 is a stronger one. So scar will have type 1 collagen. So the complications at this point are post cardiac injury syndrome, heart failure arrhythmias, true ventricular aneurysm compared to this is pseudo, and this is true. So pseudo with 14 days and true within 2 weeks to several months. And there's a risk of mural thrombus. So post-cardiac injury syndrome, heart failure, arrhythmias again, true ventricular aneurysm, risk of mural thrombus. Mural means, the word means like something that's really attached to the wall, kind of like a painting, right? A mural painting, we say. So that's something that's attached to the wall. So true ventricular aneurysm can occur because of risk of mural thrombus. So yeah. So at this point, we see a gray-white scar. Sorry, I skipped this, I think. So first, within 24 hours, we see dark mottling and pale with tetrazolium stain. This is mentioned in the question. I think 1 or 2 questions. Then we have hyperemia. Then we have a hyperemic border, but central yellow-brown softening. It's corresponding kind of to the granulation tissue. And then by the time it's 2 weeks to several months, there's a gray-white scar corresponding to the type 1 collagen. So type 1.
Dressler syndrome is type 3 hypersensitivity.
Yeah, that's important. Type 3 hypersensitivity. That was used to be in the old book, right? Did they remove it?
Yeah, after 2 weeks, it's in the Dressler's Dressler syndrome.
Yeah, Dressler syndrome. And I remember we used to contrast Dressler's with the Dress syndrome, which is drug-related eosinophilia, something. I don't remember anymore. Dressler's was fibrinous. What was this? Pericarditis within 2 weeks. It mentioned somewhere else.
After 2 weeks.
Autoantibodies against.
Okay, so it's coming later on. Okay.
But the old book, it was there also.
Yeah. I remember. Why do they do this to us? Anyway, suppose already full dimag ka bhurta hai, so they want more.
I have one silly mnemonic.
Yes, please share.
So go back to that page. I'll just share.
Okay, give me a sec. So we were at 306.
Yeah, please, Shruti. I was about to ask her anything for this page.
But it's very silly. I
For
don't
complications, it's okay.
The sillier, the better.
Anything would work.
So okay, so 1 second. I have this gross and what you call the gross and this histo together, and then I'll talk about the this complication later. Okay. So this is a story of a baby, okay, a boy. So when the newborn they born, right? So when they born, so how their skin looks like, isn't it a wavy color? Like it's wavy, loose skin and very pink, correct? So wavy fiber. Okay. And the eosinophilic, dark eosinophilic strips is there in the 0 to 4 hours, 24 hours. Okay. Then when a kid is of 1 to 3 years, so kids are nalayak. I'm sorry, I'm using some Hindi words, which is my original language. So, right. So nalayak, 1 to 3 years, they turn nalayak. So neutrophil come here. Okay. And because they are nalayak, they keep on roaming around and, they turn red, right? तो भागते रहते, शैतानी करते रहते, तो वो red हो जाते. तो gross is the hyperemia, right? And nalayak with the neutrophil. So 1 to 3 years of kid. Then when they grow up, 3 to 14, they become more notorious. They started having the marijuana. Okay, so macrophage come into the picture, and because they are having the marijuana, so they turn yellow brown, right? Pale ho jate. So gross is the yellow brown softening. Okay. Then because they are having marijuana, the police will come and they would caught them and beat them. And what happened is scar would form, they turn gray. So the contracted scar would come after 2 weeks. So like that.
Nice. Love it.
So initially when they were born, so wavy fibers, and what else you said?
wavy or pink hote na bade, like you can think about them, they looks very pinkish, right? And amniotic bands and all is also there, so you can think about the contraction, this hyper contraction of the contraction bands is also there in the kids, like when the newborns, right? In that way I keep on thinking about this 0 to 24. Then 1 to 3, they are nalayak, so neutrophil come into the action, they are keep on roaming around and they turn red. And then 3 to 4 is they are started having marijuana with the friends, so they turn pale, which is the yellow color in the gross of this heart. And the macrophage, and wherever a macrophage would come, there is the granulation, as Sarah already told. And then afterward, when they are caught up by the, because they are having marijuana, they are caught up by the police and got beaten up. So when someone get beaten up, what would happen is scar. So contraction and a scar would form on the boy's head. So like that.
Nice. Thank you so much.
And
like, how would we translate for our other friends, non-Hindi friends?
Pata nahi yaar, Sarah.
Useless, I think, nalayak.
Nalayak is useless, but
yeah. The N was for neutrophils, M marijuana was for macrophages, the police beats and forms a scar was for the gray-white scar. Nice. Thank you.
Or ek na maine picture I have shared in the group. That is from the Picmonic. So I think maximum of our friends would be knowing it. So I'll just,
this one.
Yeah. So I don't remember exact story of that, but I'll just simplify how do I remember. So there is the cardiac sign above. Can you see myo? His butt is in my mayonnaise, right? Yeah. So this is the that is what the evolution of myocardial infarction. So he is basically the cardiac myocardiac. Okay, myocardiac. So he's a notorious one. He want to really upset his friends. So he's farting here. Okay, and his fart is very, very, very bad and injurious. Okay, so he farted in the vent, vent, so that his friends get not there, above only, above he farted in the, yeah, and the different rooms his friend is trying to escape it from that fart, so going to the different room to escape from his fart because it filled up whole the building, whole the factory, whatever you can think of. So what happened when they have given the division like hours to days. It is not exactly with matches with the FA, but it would able to do the question quite easier. Yeah. So hour to days, and then before 7 days, yeah, and before 14 days and after 14 days. So it's easier to remember: 0 to days, before 7, before 14, and after 14. So when he farted, what happened is one of his friend, you can see just his one of his friend, because of this is so injurious, he fell down on the drum. Okay, so what would happen? The arrhythmia would happen here. Rhythm has broke here, right? So this is arrhythmia it's causing. Then he ran to the another room. When he ran to the another room, you can see at the side note that where the everything is written at the side. Can you see this one, before 7 days? Yes.
Oh yeah.
Exactly. Yes. So this is the interpretation. There are the numbers. Can you see? 1 is here. So 1, 0 to 10 days above. Yeah, arrhythmia is there, like broken arrhythmic drum, the way to remember it. Okay. Then he ran to the another room. When he went to another room, what would happen? There was the peer. Okay. So he just ate the peer because he was literally suffocated and was drained and trying to find out a way to go out of this very fart-filled building. Okay. So that is the fibrinous pericarditis, peer pericarditis, fibrous peer, heart on fire. Okay. And he somehow, the stuff is there, he put that peer on the stuff, something like that has happened. Then you can see there is the paper. Can you see paper? It got teared up. Yeah. So that's the papillary muscle rupture. So he's somehow trying to escape it, and he's doing all this thing, open out this stuff, trying to, take out the notes, like where is the map, and it got teared up, and this stuff on that, the pericard, this tears got born, like that is happening. Then he tried to put the scepters. Can you see the scepter is in hand? So he want to put it in the vent and try to escape it. So it took him like 7 days to do all this thing to find this whole way out. Still, he's not able to. Okay. Then he went to the other room. In the other room, what happened? He wanted to go out of the vent, but there is already one sumo is, already stuck in the vent. So it's a pseudo sumo instead of pseudo sumo. Okay. Yeah. Is stuck in vent. So always remember, like before 2 weeks, it's a pseudo, right? Pseudo aneurysm, that's the main point. And because this sumo is very heavy, so wall of that wall, can you see it's got broken? So ventricular free wall rupture is happening.
Yes.
Yeah. And then finally he went to another room. It took him like 14 days. After 14 days, he went there, and then he tried to put, dresser, and he climbed on that, and he saw there is another true aneurysm is already stuck there. So he was like, oh my God, what I'm supposed to do? Then he found one way to escape, and down you can see he's laughing, ha ha ha. So left ventricular failure. This vent has failed. His what do you call, the notorious friend planned to, make him die because of his injurious fart has failed. He escaped. So this is the left ventricular failure. So that's how.
So this was for Dressler's. This is for true aneurysm.
Yes.
Okay, nice.
If anyone have picmonic, you can listen it, like it's a nice story, funny also. I tried to say it, but I don't know how much justification I did.
It was good. It was really good. Thank you. So that's for remembering all the complications. Okay. So drum broken, so ventricular arrhythmia, fibrous pure heart on fire, so pericarditis, fibrinous pericarditis. Then what did we say? The paper has torn, so papillary muscle rupture.
Yes.
Interventricular septal rupture was 4, which is
Here in the vent. Scepters are stuck in the vent.
Okay, yes. Scepter in the vent. So in vent scept for interventricular septal rupture.
So
Then for the sumo for pseudo aneurysm. Then the wall is rupture, free wall rupture. That's before 14. And then we said true aneurysm in the vent, Dressler, and those two. And then finally it's the fail. Okay.
Cool. Yeah.
Thank you, Shruti. Really nice.
Thank you.
Yeah, that page is such a struggle. I hope this will really help. I hope, this will help me a lot. Thank you. Thank you for sharing. So anything else on this page? I like this story also. So this story is to remember the gross and the light microscopy, and the complications we remember with the picmonic. Okay, cool. Thank you. Thank you. So next, I don't know how far we are on the pages. Yeah, okay, a few more pages and we'll stop before 314, page 314. All right, so next we have diagnosis of MI. In the first 6 hours, ECG is a gold standard. First 6 hours, ECG is a gold standard. Cardiac troponin 1 rises after 4 hours. So troponin rises within hours, so 4 hours, and peaks at 24 hours, and is elevated for about 7 to 10 days. It's more specific than other protein markers. So we're talking about cardiac troponin 1. So trop 1 rises after 4 hours, peaks at 24, peak at 1 day, so 24 hours, and is increased for 7 to 10 days, so which is more specific than other protein markers. CKMB, this increases after 6 to 12 hours. So we're seeing 6 to 12 hours, peaks at 16 hours. So it's like just before 24. Okay, peaks at 16 to 24 hours, and it's predominantly found in the myocardium, but can also be released from skeletal muscles. Then that's why this is non-specific. So useful in diagnosing reinfarction. So this is important. I think this is a question. Useful in diagnosing reinfarction following acute MI, because levels return to normal after 48 hours. So return to almost normal after 48 hours. So it helps if there's elevated CKMB again, then we know it's a reinfarction. So this is important. Then ECG changes can include STEMI for a transmural infarct, ST depression with an NSTEMI or subendocardial infarct, hyperacute peaked T waves. Peak T waves with this, okay, if TROPS is elevated, T wave inversion and pathologic Q wave. So we said Q waves was for STEMI, the extra thing for the STEMI, and T wave inversion was for NSTEMI. So, okay, all of these are coming in here. Or poor R wave progression. This is something extra, like unique. So this is poor R wave progression, stands for evolving or old transmural infarct. So yeah, old, evolving or old transmural infarct. So poor R wave progression, evolving or old transmural infarct. Okay, cool. So next we have EKG localization of STEMI. This comes up in questions a lot, as we all know. So we have anteroceptal, which is lady, V1 to V2, anteroapical distal lady, so V3 to V4, anterolateral lady or left circumflex, V5 to V6, lateral LCX, so 1 AVL. So if we see something in AVL, we know it's lateral, so L for L. Inferior RCA, it's 2-3 AVF. So if we see F, we think for real, and AVF is always RCA. And then PDA is V7 to V9 depression, V7 to V9, ST depression in V1 to V3 with tall R waves. So PDA is, where would we see it? V7 to V9, ST depression in V1 to V3 was also with the tall R waves. R wave progression is for evolving or old transmural infarct versus PDA, we're saying tall R waves. Okay, so correlation with the image. So we're seeing anteroceptal is, so yeah, leads we usually put like if, yeah, we know, right? So V1, 2, 3, 4, 5, 6, 2, these are chest leads. And then I believe these go in the arms. Yeah, so left arm, right arm. And then these are the leg leads, I think, if I'm not wrong. Someone please correct me. It's been a long time since clinicals. So yeah, 2, 3 AVF, V leads. And so yeah, scapula is here. Sternum and scapula. So these are showing anterior going to posterior. So it makes sense, right? Anteroceptal, V1 to V2, if there's any issues in these leads, we know it's an anteroceptal, which is supplied by the lady. Then V3 to V4 is anteroapical. So apex is on the side, so mitral, apex. So we know that's the distal LAD. Then anterolateral, LAD or LCX, which is V5 to V6. Lateral is 1 AVL. So this is going more lateral. So 1 AVL, L for lateral, L for LCX. But then this is not a good mnemonic because it can also be confuse us with lady. So I don't know, anyone, any mnemonics, please share. 1 AVL, L for lateral, L for LCX. Then inferior, it's 2, 3 AVF. So it's, limb leads. So 2, 3 AVF. So that's for real, should remind us R for RCA. F inferior, F 2, 3 AVF. F, and then R for the RCA. Then PDA, V7 to V9. V7 to V9, SC depression in V1 to V3. So there's posterior. It makes sense because these leads are on the posterior side. So V7 to V9 elevation plus an ST depression in V1 to V3. So this is all the PDA. ST depression in V1 to V3 with tall R waves. So now if you look at the EKG, they're shown it with color codes. So let's see, V1 to V2. So this is showing ST elevation, and these will read in the reverse direction, I believe. So am I right? Oh no, here it is actually. No, so these are straight leads. So V1, so we are seeing ST elevation in V2. So this is an LAD issue, lady issue. Then V3 to V4 is this and this lighter blue one. So this would be distal LAD issue. Then we have anterolateral V5 and V6, which is the darker blue with the stripe. So that's for V5 to V6. Darker blue with the stripe showing ST elevation. And then lateral circumflex is 1 AVL. So if you're seeing ST elevations there, that's LCX, lateral LCX, lateral lux. Okay. Then inferior RCA, which is 2, 3 AVF. So this is, yep, ST elevations here will be for real. So R should tell us this is RCA. I think I should just write it down here. RCA, A1 AVL is lat LCX, lady, and lady, distal lady. So if you see in the ECG, it is proximal distal. So lady, distal LAD, and anterolateral. Okay. So 2, lead 2 is also for RCA. 2, 3 AVF. Okay, anyone good at this? Any mnemonics? Please share, please. Come forward. No? Okay.
I think lateral with most P correspond with 1 AVL and V5, V6, right? And if it's, I think, total left side gone, then V1 to whole V6. We have nice questions in UWorld, I think, in ECG. More better than if you want.
Better than this? Okay. Yeah, I can put it up. This is a
Just you can write ECG and
okay. Let me see. Okay, so this was showing subendo versus transmural. This is a good image. Okay, subendo for ST depression versus ST elevation for transmural, which makes sense, right? It's such a big thickness, so here it's more elevated. EKGs, no, it's just mentioned, I guess. Let me see next. This is WPW coming later. Aortic dissection we saw. Hypertension with type A aortic dissection. How many do I have? Okay. Can go faster. So yeah, this one, no. Okay, this is repolarization, exercise physio. Where are the EKGs? Okay, normally ECG, they tested esmolol infusion produces rapid relief and heart slowing, which the following portion of ECG will be affected most significantly by the medication. So beta blockers decrease, yeah, this was, we discussed this, I think, decrease AV nodal conduction, and AV nodal conduction corresponds to the PR, leading to an increased AV nodal refractory period. This correlates to the PR interval prolongation on EKG. So very indirect but relevant question. So AFib, okay, this is AFib. Looking for MI, but we'll come to this. This one, the ST elevation leads 1 in AVL. So yeah, this is a good visual to say how the corresponds to the anatomy. So 1 in AVL, so this is, let me see if they put better one here, no. So 1 in AVL, so it was L for lux, left circumflex. So that was the answer. Deactivated. This one was accessory bypass. Okay, coming later.
Yeah, if you correspond with that image, V1, V2 corresponds with interoceptal, right? And that ECG.
Yeah. The one which I should have noted.
Yeah. And one
with the
AVL,
Just one.
yes, this one image, one AVL lateral side. And if V1 to V6 whole gone, then it's entire, I think, left side is gone. V1 and V2 interoceptal, V3, V4 entire apical, and V5, V6 is also lateral.
Yeah, there was a table or something which was good actually. Yeah, thank you, Anna. So yeah, if it's V1 to V6, you said all of the left is gone, right? LED, full complete LED occlusion. Yeah, that was somewhere we saw. If anyone has made a note, please let me know. So this was ST elevation. Okay, this is a good image. Typical blood supply to the cardiac conduction system. Right-sided blood supply, SAV node bundle of His coming from the SC nodal branch of RCA. Left-sided blood supply, left bundle branch block, and right bundle branch. Okay, sorry, not the block. The branch bundles are supplied by the left side, versus the nodes and the bundle of His is supplied by the right side, RCA. Okay, SA nodal branch of RCA. This was the question, yeah. Takotsubu, let's see. Okay, EKG question. What did they say? ECG obtained in the emergency department is shown. So we are seeing delayed P wave. Okay, so this is coming later. 6 sinus syndrome. So sinus is supplied by the right atrial wall. We'll come to it later. SVT, okay. Oh yeah, this was this crazy question. 21037. We should look at this. We'll come to it maybe. Is it 21307? Okay. Yeah, I think I didn't find a better image.
That was a question in NBME, right?
NBME, yeah. NBME 2607, yes.
Junctional something.
So premature ventricular contraction is recognized on EKG by a wide QRS complex, opposite facing T wave, and a brief ensuing pause. So left ventricular filling is less than normal at the time of the PVC. The ensuing sinus pause, the sinus pause allows for greater than normal filling during the post PVC beat. So the question asked, which of the following best represents the relative LV EDV just prior to the heartbeats presented? So Z will have more volume than X, will have more volume than Y. Why? So that's why E was the answer. Yeah, it was a weird question. But
yeah, so Z will have more volume, right?
Yeah, because it has more time, because of the pause, it has more time to fill. So EDV volume will be higher. Followed by X, followed by Y.
Okay, thank you. And there is the same question, I think, but
yeah, I think the way they worded was something in NBME, right? Don't
but
remember.
the point there, but the point and there when this beat occur, premature beat occur, it's at that point something, the stroke volume decreased or increased, something like that.
Yeah, I remember this concept came up, but I don't remember that question. Okay. Thank you. Okay, so back to where we were. So yeah, basically, as you said, if all front leads, then we know it's complete LAD obstruction. LCX, if it is V5, V6, 1 AVL is lux, and 2, 3 AVF is for real. So RCA, PDA is V7 to V9, and SC depression V1 to V3 with tall R waves. Right. Is everybody okay? It's too quiet. Except me and Hamna, I think. Shruti, yeah.
I'm okay.
Hope everyone's doing okay. Okay, guys. Thank you. Just checking in. Okay, so next we have, so yeah, done with this page. Yeah, so diagnosis of MI, ECG, localization of STEMI. This was just an old image. Okay. So next we have narrow complex tachys. Okay, so narrow complex tachycardias, we have narrow QRS complex less than 120 milliseconds, rapid ventricular activation via normal ventricular conduction system. Tachycardia originates within or above the AV node. So this is supraventricular. So above, so supraventricular, above the AV node. So what are these tachycardias? They are narrow complex by definition, less than 120 milliseconds, rapid ventricular activation via normal ventricular conduction system. Tachycardia originates within or above AV node, so supraventricular tachyarrhythmias. So what do we see in this? We have AFib, multifocal atrial tachy, atrial flutter, paroxysmal SVT, and then this is a different one. Okay, so AFib, multifocal atrial tachy, atrial flutter, and paroxysmal SVT. Okay, so let's see. So AFib, irregular rate and rhythm. So I think there's a UL question, right? Even if we don't know the EKG, they say the rate is irregular and no P waves are there. So that's AFib. No discrete P waves. As we saw earlier, if the atrium is just fibrillating, it's not going to produce any waves, and also no JV pulse. We saw it in that page also. So anyway, so irregular rate and rhythm with no discrete P waves. Arrhythmogenic activity usually originates from automatic, this is a question, high yield question, automatic foci near the pulmonary vein ostia in the left atrium. UL question, I think also comes up in NBME or some exam. So automatic foci near the pulmonary vein ostia in the left atrium. Common risk factors include hypertension and CAD, may predispose to thromboembolic events, particularly stroke. Management, rate and rhythm control, cardioversion. So management is rate and rhythm control, cardioversion. Definitive treatment is ablation. And we have a question, right? While ablating, what nerve gets damaged or something like that? It was a very
Phrenic nerve.
Phrenic, right? Yeah, phrenic. Okay, thank you. So yeah, ablation of pulmonary vein ostia, phrenic nerve injury correlation. Consider anticoagulation based on stroke risk. So that was the CHATS criteria, I believe, but I don't think it's step one, high yield for step one. Okay, so yeah, so this will injure the phrenic nerve. All right, so that's AFib. What are we seeing? Main thing we need to know is absent P waves. It's irregular. So this is easy to pick up on EKGs. So it's not going to be equally spaced. It's irregular and irregularly irregular. So RR1 not equal to RR2, not equal to the third, or not equal to the fourth. So that's AFib. Most common chronic arrhythmia, most common cause of valvular abnormalities. Precipitating factors for isolated episodes of AF, binge alcohol consumption, holiday heart syndrome, I think this was UL, increased cardiac sympathetic tone, and pericarditis. Absent P waves because there's no coordinated atrial contraction. Okay, so that's AFib. Next, we have multifocal atrial tachycardia. Here also we have irregular rate and rhythm with at least 3 distinct P wave morphologies. So which makes sense, right? Multifocal, so 3 distinct P wave morphologies due to multiple ectopic foci in the atria. So associated with underlying conditions such as COPD, pneumonia, and heart failure. So yeah, multiple foci. So 3 morphologies, at least 3 morphologies of P waves, irregular rate and rhythm again. So it's irregular, number 1. And then we're seeing P waves of 3 different types. So here one, here another, and here a different one. So at least 3 distinct P wave morphologies. So that's multifocal atrial tachy. Then we have atrial flutter. So here, rapid succession of identical consecutive atrial depolarization causing a sawtooth appearance of P waves. So yeah, the main thing here is sawtooth appearance of P waves. So should not confuse this with the fib. This will be like the sawtooth pattern. So that's atrial flutter. Arrhythmogenic activity, usually this is a question, right? Re-entry circuit around tricuspid annulus in the right atrium. So yeah, sawtooth P waves. So rapid succession of identical consecutive atrial depolarization, atrial dipoles, causing a sawtooth appearance of P waves. Arrhythmogenic activity usually originates from where? Re-entry circuit around the tricuspid annulus in the right atrium. So here it is near the pulmonary vein ostia in the left atrium. Here it is in the right atrium. So fibrillation is for left, fibrillation for LA and flutter for RA.
Sorry, what did you say?
Fibrillation, it's originating in the left atrium, right? Pulmonary vein ostia near the LA. So just to remember quickly, fibrillation is LA and flutter is the tricuspid annulus in the right atrium. So flutter for RA.
Yeah, it is called the tricuspid cavoisthmus.
Tricuspid
Cavoisthmus. Yeah.
Cavoisthmus. Yes, thank you. Cavoisthmus. Tricuspid. Okay, nice. Thank you. So yeah, fibrillation LA, where in the LA? Near the pulmonary vein ostia in the yeah. So fib LA, flutter RA. Where in the RA, re-entry circuit around the tricuspid annulus. As Hamna said, that's also known as the tricuspid cavoisthmus. So cavoisthmus. Okay, thank you. So this flutter we treat like AFib, with or without catheter ablation of regional. If we treat like AFib, where we consider the anticoagulants based on the stroke, plus or minus catheter ablation of region between the tricuspid annulus and IVC. Yeah, this was a question on UWorld. So they cause ablation of the region between the, where would you do the ablation was the question. That was the answer, right? Cavo, tricuspid, something. Cavoisthmus. Thank you. So yeah, it's rapid succession. So here RR1 equals RR2 equals RR3, but we'll see the classic sawtooth pattern. So this is 1, 2, 3, 4, then 1, 1, 2, 3, 4, then 1, and so on. So 4:1 sawtooth pattern, but it can also be 3:1 and so on. So main clue here is RR equals to 1 and the sawtooth pattern. Then next we have paroxysmal supraventricular tachy. So this is most often due to a reentrant tract between the atrium and the ventricle, most commonly in the AV node. So for this, it is the AV node. Then commonly presents with sudden onset palpitations. Sudden onset palpitations, palpitations, lightheadedness, and diaphoresis. So most often due to a reentrant tract between the atrium and the ventricle, most commonly between the A and V, which is AV node, most commonly presents with a sudden onset palpitations, lightheadedness, and diaphoresis. Treatment, terminate reentry rhythm by, this was the one, by slowing AV node conduction. How? By vagal maneuvers, IV adenosine, electrical cardioversion if hemodynamically unstable. Definitive treatment is catheter ablation of the reentry tract. So treatment, we treat with the terminate the reentry rhythm by slowing the AV node conduction. Vagal maneuvers. So yeah, I think vagal maneuvers is where you ask the patient to like compress on the vagal point, I think in the neck. So it can cause, we can reduce the, what do you call, tachy. I think that was the baroreceptor thing, because you're causing pressure and stimulating the baroreceptors, if I'm not wrong. So anyway, so that's vagal maneuvers, IV adenosine,
dipping in cold water, something, immerse the face in cold water.
And that also, yeah, when you immerse face, cold showers, all this trending these days is like vagal maneuvers, right, to calm your heart. So they say that's very good. So yeah, cold water splash, that's also vagal maneuver to slow, to correct, or to help SVT in patients at home. So yeah, by slowing AV node conduction, vagal maneuvers, IV adenosine, electrical cardioversion if hemodynamically unstable. Definitive treatment is catheter ablation of reentry tract. So the EKG, what are we seeing? Just supraventricular tachycardia. So ventricular things are high, right? Sorry.
Yeah, this ECG is good when in the UWorld when you do the WPW syndrome. So these are correlating with this PSVT thing. You know, in questions, these two things are correlating, WPW and PSVT.
Yeah, I think this question, SVT. So super SVT, so here P wave is not visible, buried in the QRS or T wave. So we're seeing rate usually, so yeah, by definition, we can see it's tachycardia just by looking at it. So much fast heart rate. So rate usually more than 150 and there's a regular RR rhythm. P wave is not even visible because the ventricle is contracting or no. The other waves are so high. Yeah, P wave gets lost or buried in the QRS or T wave. So what was the scenario here? 6-month-old boy. Blood pressure is low, 240, tachycardia, so we know it's tachy, and respiration is 52. Pale and perspiring, so yeah, diaphoresis. Capillary filling time is less than 2 seconds. Lungs are clear, no murmurs. Yeah, heart rate of 240 with narrow QRS complexes, no identifiable P waves. So we are diagnosed it as SVT. Now they're asking which of the following is the most likely cause of this patient's hypotension. Yeah, this was also a question. Shortening of ventricular diastole, because this is when there's no room, there's no time for diastole here. So SVT is characterized by elevated heart rate with regular rhythm, narrow QRS complexes due to an abnormal electrical impulse originating above the ventricles. Sustained tachycardia shortens ventricular diastole, leading to a decreased stroke volume and decreased cardiac output, therefore having subsequent hypotension. So the reason is a shortening of ventricular diastole. Yeah, this was normal pathway, SA to AV to the bundle to the Purkinje. AV node reentrant tachycardia. So this, when we do the next one, we'll come back to this. Okay, video. Okay. So, yeah, regular, but very high heart rates. That's paroxysmal SVT. So done with a narrow complex. Next, we have WPW. This is the most common. So this was all atrial fib, multifocal atrial tachy, atrial flutter, supraventricular tachy. So it's all above the ventricle. Now coming to the most common type of ventricular pre-excitation syndrome is WPW. There's an abnormal fast accessory conduction pathway from the atria to the ventricle, which is known as the bundle of Kent, which bypasses rate slowing AV node. So as we saw, AV node is the reason we saw that phase 4 was the reason for slow progression, so that there's no multiple impulses and so on. So here it correlates, right? So abnormal fast conduction pathway from the atria to the ventricle, which is bypassing the rate slowing AV node. So ventricles partially depolarize earlier, leading to a characteristic delta wave with a widened QRS complex and a shortened PR interval. May result in a reentrant circuit causing a supraventricular tachycardia. So if it re-enters, it will cause a supraventricular tachycardia. Treatment is procainamide. Avoid AV nodal blocking drugs. So this is important. I think this came up in a question. So we give procainamide for WPW. And this was a mnemonic on a previous group session. So WPW, think W, so wave, what wave? Delta wave. P for PR interval, short PR interval. W for W again, wide QRS complex. So it has it in the name. And it's a type of ventricular pre-excitation. So yeah, treat with procainamide. So delta wave, shortened PR interval versus the normal would be starting here. And what was the third one? Wide QRS, yes. Okay. Are we good? Next comes the wide complex. So wide QRS complex. So these by definition are all narrow QRS complex. So this was ventricular, but it has a wide QRS. Now, what are the other wide QRS? So we said this was the most common WPW. Next, we have the wide complex. Yes. So we'll take a break when we come to this stage. So we'll just finish these two and we'll take a break. Lunch break. Okay. So wide complex tachycardias. So by definition, QRS complex more than 120 milliseconds. So here we said less than 120 for narrow. So by definition, this is more than 120 milliseconds. Slow ventricular activation outside the normal ventricular conduction system. Slow ventricular activation outside the normal ventricular conduction system. Tachycardia originates below the AV node. In the previous, we saw above the AV node. So this is below the AV node. Thereby, it is a ventricular arrhythmias. So what do we have here? We have VTAC, we have torsa du pont, we have VFib. Hereditary channelopathies. Okay, so we'll come to that. So these we have VTACI and torsa du pont and VFib. So what is VTAC? Typical regular rhythm rate is more than 100, most commonly due to a structural heart disease like cardiomyopathy, scarring after MI, and high risk of sudden cardiac death. So EKG findings, we're seeing wide QRS complexes and more than 120 milliseconds. So yeah, heart rate makes sense, right? Wide QRS complex, so VTAC. Due to structural heart disease, cardiomyopathy, scarring after MI, and high risk of sudden cardiac death. Next, we have this torsa du pont or point, I think that's the French word or something. Well, anyway, polymorphic ventricular tachycardia. Polymorphic by definition, poly, many forms. So many forms, VTAC. Shifting sinusoidal waveforms may progress to VFib. Long QT interval predisposes to torsa du pont. So long QT interval predisposes to torsa du pont caused by drugs, either drugs or decreased potassium, decreased magnesium, decreased calcium. Torsa du pont literally translates to twisting of the point. So it looks like it's twisting of the points. Treatment is DFib for unstable patients, max sulfur stable patients. So yeah, DFib if they're unstable, max sulfur stable patients. Drug-induced QT, high yield, we've seen this before. So A, B, C, D, E, F plus NO. Antiarrhythmics 1A and 3, arsenic, antibiotics, macrolides, and fluoroquinolones, antipsychotics, haldol and chloroquine, antidepressants and diuretics, thiazides, antiemetics, ondansetron, antifungals, fluconazole, navir, protease inhibitors, opioids, methadone. So they're all prolonged QT syndrome. So yeah, polymorphic VTAC, shifting sinusoidal waveforms may progress to VFib. So causes drugs, these drugs, decreased potassium, so hypokalemia, hypomagnesemia, hypocalcemia. DFib, treat with MaxSulf. So this is important. If they're stable. So yeah, DFib for unstable patients. Next, we have VFib. This is disorganized rhythm with no identifiable waves. But even though they're not discernible, we can see that they are wide QRS. So all these three are wide QRS. Disorganized rhythm with no identifiable waves. Treatment fatal without immediate CPR and DFib. So VFib is fatal and usually patients die. Yeah. No discernible rhythm, but vaguely we can see wide QRS. So that's all the wide complex tachycardias. Next, we have hereditary channelopathies. These are Brugada syndrome and congenital QT syndrome. So inherited mutations of the cardiac ion channels. So what is the problem here? The basic defect is inherited mutation of the cardiac ion channels. So leading to an abnormal myocardial action potential, increasing the risk of ventricular tachy and sudden cardiac death. So abnormal myocardial action potential, increased risk of ventricular tachy and sudden cardiac death. So Brugada and congenital QT. So what is happening here? This is, there was a mnemonic used to say, this is dominant. This is also autosomal dominant. The jewelry was the recessive one. Yep. So Brugada, autosomal dominant, most commonly due to loss of function of what channels? Mutation, loss of function mutation of sodium channels versus loss of function mutation of potassium channels for these two. So autosomal dominant, most commonly due to loss of function of mutation of sodium channels, increased prevalence in Asian males. EKG pattern is ECG pattern of pseudo right bundle branch block and SC segment elevations leads V1 to V2. Prevent sudden cardiac death with cardioversion. What was ICD? DFib, intracardiac defib. I don't know. I'm just guessing at this point. Does anyone know what was ICD? They mentioned it somewhere. ICD. Check. Implantable cardioverter defibrillator. Implantable cardioverter defib. Okay, yeah, makes sense. 312. Okay, yeah. So EKG pattern of pseudo right bundle branch block and SC segment elevations in leads V1 to V2. So makes sense, sodium channel, and prevent SCD with ICD. SCD with prevent sudden cardiac death with ICD. Then congenital long QT syndrome, most commonly due to loss of function mutation of potassium channels. It affects the repolarization, includes Romano-Ward and Jervell and Lange-Nielsen syndrome. Romano-Ward is autosomal dominant, pure cardiac phenotype. So the main thing is the cardiac issue. Here in Jervell and Lange-Nielsen syndrome, autosomal recessive with sensory neural difference. The mnemonic we had in the group, Jervell, think jewelry. I know it's spelled it wrong, just to correlate the V and the V. So Jervell is jewelry, think hearing, think sensory neural deafness. So yeah, recessive with a sensory neural deafness. Then sick sinus syndrome. This is age-related degeneration. I think we have a question on this in New World. So age-related degeneration of SA node, EKG can show bradycardia, sinus pauses, sinus arrest, and junctional escape beats. So we have a sinus pause, can show bradycardia, slowing heart rate, sinus pause, sinus arrest, junctional escape beats. So yeah. Prolonged sinus pause, and then this is QRS, and I think this is an escape beat. Not sure. So that's sick sinus syndrome, age-related degeneration. Sorry?
You opened the question recently in UWorld about this sick sinus syndrome.
Oh yeah, correct, actually. Somewhere here. This one, right? Yeah. Yep. So the scenario is 77-year-old woman brought to the ED with severe lightheadedness, near syncope that began early in the day. Over the past several months, she has experienced occasional episodes of lightheadedness, feeling unsteady, which she attributes to old age, not had chest pain, shortness of breath, or low extremity swelling. She was diagnosed with hypertension 10 years ago. Been taking losartan. The patient was not taking any of the meds, lives alone independent of daily activities. EKG obtained is shown. Cell degeneration, which of the following locations is most likely responsible? Okay, so we are seeing prolonged sinus pauses, and what else do we see? Delayed P wave. P wave is expected, so delayed P wave, that's a sinus pause. Again, a sinus arrest where there's a drop P wave, and a junctional escape beat. So I think this is a much better image. So that's sick sinus syndrome, and the most common results from age-related degeneration of the SA node, which is located on the right atrial wall and is responsible for initiating normal cardiac conduction. Impaired signaling from the SA node can markedly slow the rate of ventricular contraction, leading to reduced cardiac output and symptoms of dyspnea, fatigue, lightheadedness, syncope, pre-syncope, and syncope. Typical ECG findings: bradycardia, sinus pause, sinus arrest, which is prolonged delay of a P wave such that the P wave is dropped. Because the AV node triggers conduction based on its own pacemaker, if it does not receive a timely signal from the SA node, because the AV node triggers conduction based on its own pacemaker, if it does not receive a timely signal from the SA node, sinus arrest will lead to a junctional escape beat, a narrow QRS complex preceded by a long pause and no P wave. If it doesn't receive a signal from the SA node, sinus arrest will lead to a junctional escape beat. Okay. Sick sinus syndrome can also cause brief episodes of atrial tachy, AFib alternating with bradycardia. So it can be tachy alternating with bradycardia. It's a unique thing, I guess. So atrial tachy alternating with brady is for sick sinus syndrome. Okay, cool. So that's done. Next, we have conduction blocks. Should we take a break and then come back?
Yes, please.
Yeah, we'll come back. This is again pretty intense. Okay, guys, let's take a lunch break. We'll come back in 1 hour. Thank you so much. Hi, everyone. Welcome back from break. Just waiting for a few more people to join in, but we will continue in a sec. Okay.
Yeah, before starting, anyone has mnemonics for this second degree AV blocks? Really appreciate that, especially for this
Yes.
Venky back.
Yes.
Thank you.
Thank you. Yeah, if not, we'll have to create the mnemonics for this too. All right, so let's start. Just an overview. We have like about 16 pages, I believe. So yeah, we're going to see conduction blocks, MI complications, 1, 2, 3, 4. Yep, okay, about 16 pages. Hopefully I push through and get done with cardio today. Sure. Okay, so here goes. So first, we were doing, we did all the narrow complex tachycardias, we did wide complex tachycardias, we did hereditary channelopathies, sick sinus syndrome, and now coming to conduction blocks. Yeah, if anyone has good ways to remember these, please pitch in. Thank you. So okay, so first we have first degree block and second degree block. Under second degree, we have Mobitz type 1, Mobitz type 2, and then bundle branch block. All right, so what is first degree AV block? Here we have a prolonged PR interval. So treatment none required, benign and asymptomatic. So the heart rate is more than 200 milliseconds. So PR1 equals PR2. So it's equal intervals, but they are prolonged. So equal intervals, but still they are prolonged. So then second degree AV block, we have Mobitz type 1, which is Wenke back. I think there are videos which had these Wenke back song and something, but yeah, I've forgotten it. So it wasn't really helpful. Anyway, so second degree, we have Mobitz 1, Mobitz 2, and bundle branch block. So Mobitz 1, Wenke back, and progressive lengthening of the PR interval until a beat is dropped. So it lengthens, and then drops. So yeah, PR1 is less than PR2, less than PR3, and then a drop. So length, and drop. So drop is P wave is not followed by a QRS complex. So that's known as a drop. Variable RR interval with a pattern which is regularly irregular. So variable RR interval. So PR interval, it's less. PR1 is less than PR2, less than PR3, and then there's a P wave which is absent, and P wave and an absent QRS. So beat has been dropped. But then a variable RR interval with a pattern which is regularly irregular. Treatment, again, none is required, usually asymptomatic. So both of these are asymptomatic. Then coming to Mobitz type 2, here drop beats that are not preceded by a change in PR interval. So PR changes and then a drop. Here, drop beats that are not preceded by a change in the PR interval. So this may progress to a third degree block, as it usually indicates a structural abnormality such as ischemia or fibrosis. Treatment, they usually need a pacemaker. So pacemaker is needed. So here we are seeing PR1 equals PR2, P wave, and then an absent QRS. So a difference between this and this, Mobitz 1 and Mobitz 2, here there is a change in the progressive lengthening of the PR interval. Here, no change in the PR interval, but a drop in the QRS, so absent QRS. That's Mobitz type 2. So yeah, PR interval is
Sorry. Go ahead. I'll do that after.
Okay. P waves are intermittently blocked, which means they're not followed by a QRS. So yeah, P waves are still there. PR interval is still 280 in this EKG. So the drops are in the QRS. So drop, there's no QRS here. So P, QRST, P, QRST, P, QRST, P, nothing, then another P. So yeah, here also there's a drop. P wave followed by nothing, and then another new P wave. So drop in QRSQ complex is Mobitz type 2. Then we have third degree AV block. Okay, yeah, second degree, third degree AV block, and bundle branch. Second degree. So under third degree, we have, which is a complete heart block. Complete AV block. So since it's a complete AV block, P waves and QRS complexes are rhythmically dissociated. Atria and ventricles are beating independently of each other. So P waves and QRS complexes are dissociated and they beat independently of each other. So atrial rate is more than the ventricular rate, may be caused by Lyme's disease. So the E, if you flip, it looks like a 3. So to remind us that it's a 3rd degree AV block. So yeah, it's a complication of Lyme's disease. Treatment for this again is a pacemaker. So if you see the EKG, yeah, go ahead, Hamna, you were saying something.
No, please you go ahead. I just your voice will echo, otherwise you'll get disturbed. Okay, yeah, I just had a ceftriaxone for Lyme disease, and right?
Yeah.
Okay. I just need to stop it. For Lyme disease, we add a ceftriaxone, and for type 1, it's just a PR interval, like constant PR interval, constant but prolonged. But Moffitt's type 1, it's keeps on prolonging, then dropped. Moffitt's type 2, no prolongation, same PR interval, but just block. And 3rd degree, we all know that it's AV dissociation.
Yeah.
Atrial and ventricle dissociation.
Yes.
Okay. Yeah. Sorry for that.
No worries. And for Lyme's, we said treatment was CEF if IV was required. Doxy was first line.
Yeah, but doxy we cannot give for if neural and cardiac involvement is there. If it's neural and cardiac involvement, then we have to give ceftriaxone.
Okay. So yeah, makes sense actually. If neural and cardiac, yeah, I think I saw this on UWorld. Neural and CNS, I'm sorry, cardiac involvement is there, then we have to give CEF.
Yes.
And also in pregnant and children less than 8, we give CEF. I'm sorry, we give amoxicillin.
Amoxicillin.
Yeah. Okay, nice. So the Lyme's disease is associated with the 3rd degree AV block. Okay. All right. So yeah, just for visually representing. So here we are prolonged. That was the only thing. Here prolonged, drop. Here just a drop. Here AV event, they're on their own. So just for a quick, yeah, 1st degree is drop, prolonged, drop, A and V on their own. Random. Then bundle branch block. Here there is an interruption of conduction of normal left or right bundle branches. So main thing here is interruption of conduction of the normal right or left bundle branches. So this is further, yeah, from the name it suggests like it's further down, right? So interruption of conduction of the normal left or right bundle branches. Affected ventricle depolarizes via slower myocyte to myocyte conduction from the unaffected ventricle. So one more time here it says affected ventricle depolarizes via slower myocyte to myocyte conduction from the unaffected ventricle, which depolarizes via the faster His-Purkinje system. So the affected ventricle is depolarizing via slower myocyte to myocyte conduction from the unaffected ventricle, which depolarizes via the faster His-Purkinje system. Yeah, commonly due to degenerative changes like cardiomyopathy.
Sorry, I didn't get this line, Saira. Can you explain this?
I didn't. So I was like, maybe I should look on UWorld for this bundle branch block because these wordings are like too many words, not making sense. Affected ventricle. So we have an affected ventricle and an unaffected ventricle, which is normal, just visual representation may not be accurate. So affected ventricle depolarizes via slower myocyte to myocyte conduction, slower myocyte to myocyte conduction from the unaffected ventricle. So from this side, it's coming to this side, right?
Yeah, got it.
Affected one.
So one.
Go ahead.
Yeah. One ventricle is normal, like that gets normal depolarization via faster His-Purkinje system, and the affected ventricle, it gets depolarized via another ventricle via myocyte to myocyte conduction, which was slower.
This is unaffected, which is normally getting conducted from the Purkinje. This myocyte to myocyte is getting transferred and it's getting depolarized. Correct? That's what it is, right?
Yes.
Yeah. So affected ventricle, which is this side, depolarizes via slower myocyte to myocyte conduction from the unaffected ventricle. And this unaffected ventricle depolarizes via the faster His-Purkinje system. So this one is normal. So it's going via the normal bundle branch and then His-Purkinje. So this is okay. But this one has to get the myocyte to myocyte conduction, and then it continues on. So that's what I think they're saying.
Yeah, via gap
Because
junction.
the bundle of his is where the blockage is, right? So that's where the problem is.
And we saw that via gap junctions, right? And because they are
Yeah,
electrically
correct.
coupled.
Yeah, that's a great point. Because yeah, gap junctions we saw in embryology, like initial parts. Yeah. Okay, nice. So that is bundle branch block. So they're saying one more time, interruption of conduction of normal left or right bundle branches. The affected ventricle depolarizes how? Via slower myocyte to myocyte conduction coming in from the unaffected ventricle. Then we have the unaffected ventricle. How is this one depolarizing? From the faster His-Purkinje system, which is the normal pathway. So commonly due to degenerative changes like cardiomyopathy and infiltrative disease, which actually makes sense. So that's blocking the bundle. Okay, cool. But yeah, they didn't show an EKG. So let me see if they have it here.
And someone in the group, I think Dr. Adi or something, someone, it's W for William and M for Marrow. Anyone remembers that? For a left bundle branch block and right bundle branch block.
Okay, to split the diseases,
Yeah.
the titles.
How it looks on the ECG. Left bundle branch block and right bundle branch block. One he made W, it looks like a William, and one is M for Marrow.
Oh yeah, I vaguely remember when we did the bigger session. Yeah.
Yeah, he was very good in explaining, very good. But
yeah.
Now it's all gone.
Yep, let's see. Williams, was it? We'll find an image online. Williams bundle branch block. Wait, was William the name of the person who explained it? What is the name?
No. It looks like
like a W.
Yeah, it looks like a W.
Oh yeah, I saw something here. William Marrow, classic mnemonic. Okay, yeah. So William, so VILLM. So V1 LVB. Okay, so that's left bundle branch block V1 V6. Marrow for V1 to V6, right bundle branch block. How do the EKGs look? Okay. So this is normal. William was left bundle branch block. So this looks like a W, yeah. After Braunwald versus this one looks like an M. It makes sense, right? Do you guys see my screen? Because I don't know if I shared. You see my screen?
Yeah.
Yes.
Yeah. Left.
Thank you. So yeah, this is like an M, right? M versus this is like a W. So nice.
This is left bundle branch block. Both looks like W. Yeah. Here is also W.
So here it's coming W here, right? In V1, V6 will be inverted waves. So the W ka ulta M. But then here, if you focus, it's coming like this, right? So M. And yeah, it's not very clear on V6 to me. But yeah, if you see this, uska, one thing is small and then the other one is big. So M like this.
Yeah, looks like it. Okay.
Yes, if you see this part, if you focus, the RSR, that's what is showing the M. Then yeah, E wave inversion, okay. So yeah, V6. Okay, I think I'll share this page on the group later. So this was from William and Marrow. William Marrow is the classic mnemonic, but Wilhelm Maroon is more accurate, they say. V1. Okay, fine. I'll share this page later on the group. So let me see if you all had anything about bundle branch.
Yeah, thank you, Sarah.
No problem. This was Jervell and Lynch-Nielsen syndrome, congenital, which we saw. So the scenario, yeah, sensory neural hearing loss, buzzword. Sensory neural hearing with a prolonged QT should tell us this is a Jervell-Nielsen, and they're asking where was the issue. So that was potassium, and we said the other one was sodium. Sodium D was Brugada. A as well. Okay, calcium and sodium is Brugada. Kidoki, then pericarditis. Yeah, so bundle branch choice B. Okay, no ECGs. This is fibrillatory waves with AFib, irregular rhythm. Which of the following factors most likely determines the ventricular contraction rate? It's the AV node refractory. Yeah, we discussed this earlier today before lunch. This question we saw. This is okay, care sign. This we saw sick sinus syndrome with the delayed P wave and the junctional escape beat. Typical blood supply. Okay, yeah. Nothing else pulled up. Did I look in the wrong place? Coarctation. Okay, this was our previous search. Okay. Okay, so that was William and was the other one? Maroon. Left bundle branch block and right bundle branch block. All right, so next we have premature beats. Under this, we have premature atrial contraction and premature ventricular contraction. So what are these premature beats? Premature atrial contraction, so then extra beats arising from ectopic foci in the atria instead of the SA node, often secondary to increased adrenergic drive like caffeine consumption, but benign but may increase risk for AFib and aflutter. Narrow QRS complexes with preceding P wave on EKG. So extra beats arising from ectopic foci in the atria instead of the SA node, often secondary to increased adrenergic drive like caffeine consumption. Benign but may increase risk for AFib and flutter. Narrow QRS complex with preceding P wave on EKG. So narrow QRS with the preceding P wave on EKG. Okay. Then we have premature ventricular contraction. Here, ectopic beats arising from the ventricle. So from, as the name suggests, this is from atria, this is from ventricle instead of the SA node. Shortened diastolic filling time. I think we saw this somewhere. So also in VTAC, right? So the shortened diastolic filling time, decreased stroke volume compared to a normal beat. Prognosis is largely influenced by underlying heart disease. So prognosis is largely influenced by underlying heart disease. Wide QRS complex with the no preceding P wave. So the difference is this is narrow QRS complex with the preceding wave, P wave. Here we have a wide QRS complex with no preceding P wave. This was the previous wave's T wave. So no P, QRS T, which is wide. So premature ventricular contraction. Again, this is due to underlying heart disease. Okay, this is due to caffeine or adrenergic. This is due to underlying heart disease. Okay, cool. So next we have myocardial infarction complications. What are the complications? So yeah, they move this page. So arrhythmia, peri-infarction pericarditis, papillary muscle rupture, interventricular septal rupture, ventricular pseudoaneurysm, free wall rupture, true ventricular aneurysm, post-cardiac injury syndrome. So this should be very nicely explained with the Picponic image. So this should be fairly easy now. So first few days to several months. Thank you, Shruti. So yeah, cardiac arrhythmia, first few days to several months, can be SVT, ventricular arrhythmias, or conduction blocks. Yep, can be SVT, ventricular arrhythmias or conduction blocks. Notes: due to myocardial death and scarring, important cause of death before reaching the hospital within the first 48 hours post-MI. So yeah, death before reaching the hospital. I think this came up in some context in the question. So yeah, cardiac arrhythmia is the cause of death before reaching the hospital within the first 48 hours post-MI. Why? Because here we have myocardial death and scarring. Then we have peri-infarction pericarditis. This was the pure in the fire fibrinous one, which we saw in the image. So peri-infarction pericarditis, 1 to 3 days.
So it's not post-infarction pericarditis anymore. I think, and there they didn't correct it, but now it's peri-infarction pericarditis. Because it was confusing with, yeah, it was confusing with Dressler syndrome. So that's why they changed it, peri-infarction pericarditis.
I see, okay. Okay, I see what you mean. So post-cardiac injury is Dressler's. So this is due to autoimmune reaction versus peri. So to differentiate this and this, they've changed the naming. Okay. So peri-infarction, thank you, Amna. Peri-infarction pericarditis is within the first 1 to 3 days. Pleuritic chest pain, pericardial friction rub. So yeah, this is a clue. Pericardial friction rub is clue for pericarditis. EKG changes and or small pericardial effusion, which is usually self-limited. So peri-infarction meaning soon after versus post-cardiac injury syndrome. Okay. So this is within first 1 to 3 days versus this is after weeks to several months. All right, so coming back to this, papillary muscle rupture is within 1 week. It can result in, where this was the mnemonic was the paper, right? That paper was torn. So before 1 week, paper was torn. So papillary muscle rupture can result in acute MR, leading to cardiogenic shock, severe pulmonary edema. And posteromedial papillary muscle rupture is more common than anterolateral. I think this comes up in a UWorld question, as seen in A. So we are seeing the papillary muscle has ruptured, and it's more common in the posteromedial side. Okay, as the posteromedial has a, yeah, this is actually a high yield question. It's a UWorld question. So as posteromedial papillary muscle has a single blood supply from the PDA, whereas the anterolateral has dual. So yeah, anterolateral has dual from the LAD and lux, LAD and the lux, but posteromedial has only from the PDA. So it's more prone to rupture. Okay, next we have interventricular septal rupture, 3 to 5 days. Symptoms can range from mild to severe with cardiogenic shock and pulmonary edema. Interventricular septal rupture, this was the wall breaking down in the picmonic. So yeah, symptoms can range from mild to severe with cardiogenic shock and pulmonary edema. So this is macrophage-mediated degradation causing VSD, increased oxygen saturation, and increased pressure in the right ventricle. So macrophage-mediated degradation. So yeah, 3 to 5 days. Before that, it's neutrophils. So now we have macrophages. So macrophage-mediated degradation leads to ventricular septal defect, increased oxygen saturation, and increased pressure in the right ventricle. So yeah, mild to severe with cardiogenic shock and pulmonary edema. Next, we have ventricular pseudoaneurysm, which is 3 to 14 days, so 2 weeks. So we said first it was the SUMO, so pseudoaneurysm coming through the window. So maybe asymptomatic. Symptoms may include chest pain, murmur, arrhythmia, syncope, heart failure, embolus from mural thrombus. Rupture leads to cardiac tamponade. So ventricular pseudoaneurysm can lead to tamponade. And yeah, as we said, mural means something that's in contact with the wall or endocardium, like a mural painting and stuff. So it's always in contact with the wall or the endocardium. So ventricular pseudoaneurysm. So why is it pseudo? Because the free wall rupture is still contained. It's contained by the adherent pericardium. Contained by the adherent pericardium or scar tissue. It does not contain endocardium or myocardium, which is why it is a pseudo. Does not contain endocardium or myocardium, more likely to rupture than true aneurysm. So this, although it's pseudoaneurysm, it's still more likely to rupture than a true one.
On that page, isn't mural thrombus is more associated with ventricular true aneurysm?
Let me check. Risk of mural thrombus with the true aneurysm. No, but there they're saying pseudoaneurysm is at risk for rupture, but mural thrombus is risk for both then. So this presence or findings of a pseudoaneurysm is the mural thrombus. Mural thrombus also for true ventricular aneurysm. So if it's a true outpouching, then blood collects and that can cause a mural thrombus to attach to the wall. Here they're saying ventricular pseudoaneurysm can also have a embolus from the mural thrombus. So both have mural thrombus, I think. The true aneurysm and a pseudoaneurysm will have mural thrombus, but pseudoaneurysm is more likely to rupture. The aneurysm itself, which is different from the thrombi, right? Yeah.
Yeah. Which one is more prone to rupture? Pseudo?
Pseudo.
No? Yeah.
Yeah. Pseudoaneurysm
because it doesn't
more likely
contain
to rupture than true.
Okay.
Because it contained this only two endocardium and the myocardium, right? So easily to rupture. Anything pseudo have the like less layers, and whatever is true is always have all the three layers, right?
Correct.
In normal rule, right? I mean, correct me.
Yeah. No, you're right. You're right. That makes complete sense. That's a good general statement, we can say. Pseudo doesn't have all layers, like a true divergent versus pseudo. Yeah, same thing. So that makes total sense. That was a nice one. Yeah. So yeah, this is a pseudo, so it doesn't contain all layers. It doesn't contain endocardium or myocardium, so it is more likely to rupture, which makes complete sense. Nice. Thank you. And yeah, and conclusion about mural, both have chances for mural thrombus. And complications of myocarditis is also mural thrombus. So yeah, just search for mural thrombus. Okay. All right, so back to this. So ventricular free wall rupture, again, 5 to 14 days. What was the key in the pick for this one? Free wall rupture. I think I may have mixed these two up.
Yeah, this is the one. But Sarah, you're too good. Once you saw it and you remember, even I don't remember.
No, that's because you described it so nicely. You asked me tomorrow, it'll be gone. Yeah, let's see. Let me pull it up. It was a good one. The way you explained it was so funny. It's so cute. So I remembered it, but tomorrow it'll be gone. Which is why repetition. Where did it go? I think it's on chat. Let me see. Oh, but thank you for sharing. That made this page so much more digestible, because otherwise it was super scary. Okay, yeah. So let me see if I can put it side by side. Okay. So where were we? So we said interventricular was the scepter, as you said, the scepter actually. So that was the interventricular. The free wall rupture was this wall actually. Scepter. I learned a new word today. This thing is called a scepter. Okay. Did not know that. All right. So ventricular free wall rupture. 5 to 14 days. Sorry, go ahead.
No, same thing I was telling, like before 7, after like 14 days, before 14 days, like, you know, they have given it more specifically in FA, but it's easier to remember with, you know, this.
But in a broader range, so they're going before this, right? Before 14 is the free wall rupture, the pericarditis, and okay, yeah. Versus after 14 is the Dressler and the true one. Okay, so if you remember it just these two, then it helps much more. Yeah. Thank you. Yeah. So ventricular free wall rupture, 5 to 14 days. Here we have true. So yeah, free wall rupture, which is shown in B. Okay, yeah, this free wall has ruptured. Cardiac tamponade, acute form usually leads to sudden death, which makes sense. This is all the blood, left ventricular high pressure area. If the wall has ruptured, all the blood will collect and will cause acute death, sudden death. Yes. Left ventricular hypertrophy and previous MI protect, which makes sense, right? Because if it's hypertrophy, it's a thicker one. It's protecting from rupture. So that's so counterintuitive. Left ventricular hypertrophy and previous MI actually protects against a free wall rupture. Yeah. Okay, then we have a true ventricular aneurysm. So again, this picture was true. So 2 weeks to several months, similar to pseudoaneurysm, which was here. But the outward bulge with contraction, dyskinesia associated with fibrosis. So here there is an outward bulge with contraction known as dyskinesia. So movement, bad movement, outward bulge. So that's what is the bulge, outward bulge with contraction, dyskinesia associated with fibrosis. 2 weeks to several months. Again, post-cardiac injury syndrome, weeks to several months. This is fibrinous pericarditis due to autoimmune reaction. Again, this is an autoimmune phenomenon. Versus this is an infectious one. Small effusion. Okay, so this is autoimmune, also called Dressler syndrome. Cardiac antigens released after the injury lead to deposition of immune complex in the pericardium, leading to inflammation. So makes sense. It's an autoimmune, which means it's chronic. So it's more weeks to several months. And then what was this? Failure, right? In the end, can also cause heart failure as a complication. Okay, so here again, ventricular aneurysm versus a pseudo. So it doesn't have outer layers of endocardium, myocardium. Yeah, it's just contained by either the pericardium or the scar tissue. Alrighty, nice. So back to first aid. All right. So that's MI complications. Yeah, thank you so much. It's definitely so much better now.
Yeah, but thank you so much, Shruti. So if we say all these ruptures like papillary muscle rupture, interventricular rupture, interventricular septal rupture, ventricular pseudoaneurysm, and all this free wall rupture, 2 to 7 days. So it's now we cannot generalize it.
Okay, again, what are you
If all
saying?
these ruptures, are generalized within 2 to 7 days, so is it true or not?
Yeah, we can, right? All ruptures are happening before 2 weeks. So first 2 weeks after MI is most it's a crucial time, right? So ruptures having within 1 week is the papillary muscle rupture, 2 to 7 days, then 3 to 14 days. No, sorry, not this one. 3 to 5 days. And so, yeah, in general, we can say rupture less than 2 weeks. Yeah, I don't think they'll test so like specifically, right? What happens on the 4th day? How would they create a question like that?
Usually they give the autopsy thing, isn't it? Like either autopsy or something like the MI happened, what would you find? Something like that, right? I mean, if what I could recall. Not only the autopsy, I'm sorry. Autopsy from the previous page, but
yeah. No, they do that, right? This a patient for similar autopsy from a similar patient was so showing this and this and this. So, so either autopsy or we should look for an EKG because that would be correlated with some arrhythmia or
correct.
Yeah, or they can show these things with a free wall rupture and ask the timeline, how many days, or it'll be an easy duration. Won't be so like too close options. I think so. I hope so.
Free wall rupture and aneurysm is the more like this is high yield, but out of that is more high yield. What I have seen in the question.
Which one? Free wall and
the aneurysm.
Yeah, it makes sense, right? They can create so many scenarios with that free wall rupture causing a tamponade, pseudoaneurysm and asking what layer is involved, blah blah blah. So yeah, nice. A papillary muscle rupture, they can say sudden new onset murmur, acute mitral regurg murmur situation, and then be like, what is the complication? It would be papillary muscle rupture. I think that's an actual UL question. Or they can give this scenario and say, okay, why did this posteromedial ruptured more? And then we have to know that it's a single blood supply. So yeah.
That's a question actually. Yep. Agree.
Thank
you.
Thank you. All right, so moving on. Next page, we have acute coronary syndrome treatments, cardiomyopathies. All right, let's see. So acute coronary syndrome treatments, we have for unstable angina and STEMI and STEMI. So for this, we give anticoagulation like heparin, antiplatelet therapy aspirin, plus ADP receptor inhibitors like clopidogrel, beta blockers, ACE inhibitors, and statins. Symptom control with nitroglycerin plus or minus morphine. So yeah, unstable, the present with chest pain and STEMI. So yeah, makes sense. Anticoagulation with heparin, antiplatelet therapy with aspirin, ADP receptor inhibitors like clopidogrel, beta blockers, ACE inhibitors, and statins. Symptom control with nitroglycerin plus or minus morphine. Then STEMI, in addition to the above, reperfusion therapy is most important, like percutaneous coronary intervention preferred over fibrinolysis, so PCI more than fibrinolysis. If the right ventricle is affected, meaning RCA occlusion, support venous return / preload to maintain cardiac output, which is give IV fluids and avoiding nitroglycerin. So if right ventricle is affected, which is an RCA occlusion, support venous return / preload to maintain cardiac output. How would we support venous return and increasing preload is by giving IV fluids and avoiding nitroglycerin, because as we said, nitroglycerin causes venodilation, so it will reduce the preload. So basically we need to remember avoid nitroglycerin if it's an RCA occlusion. Okay, then next.
And there is also bradycardia and RCA occlusion, right?
Yeah, because that's the branch. What was it? SA nodal branch of the RCA supplying the
SA and AV node both.
SA and AV node both. Okay. Yeah, nice. Then we have cardiomyopathies.
What was that, Sarah? You said something. Nodal branch.
Yeah. So when we look through the UL questions, we saw right the nodal branch of the right coronary artery supplies the SA and AV node. So if RCA is occluded, that branch will also not get supply. So the nodes are not working, so that will lead to bradycardia.
Only AV node. SA is utterly like it's completely, yeah, correct. If it is right dominant, right? Yeah, correct.
Yeah.
If it is left dominant, then that atrioventricular branch, AV node is supplied by that nodal branch from the circumflex, right? So
Yeah,
SA is always supplied by the right coronary, but AV is supplied by whatever is dominant is there, right?
Yeah, you're right. Thank you. I had completely forgotten that. Yeah. So SC node is always supplied by RCA no matter what. AV node supply is variable depending on the dominance. Yes. Nice. Thank you. I need to make note of that. Okay. Then next we have cardiomyopathies. Thank you, Shruti. So cardiomyopathies, we have dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive infiltrative cardiomyopathy. So yeah, we've seen lots of questions on these. So most common cardiomyopathy is dilated, 90% of cases, often idiopathic or familial due to mutation of the TTN gene, encoding the sarcoplasmic protein titin. Other etiologies include drugs like alcohol, cocaine, and doxorubicin. Yeah, we saw this when we did cocaine the other day. Doxorubicin, also we spoke about. Doxo and Dono both cause dilated cardiomyopathy. Irreversible, I think. Trastuzumab was reversible. We trust her, so it's reversible. So infection, example, Coxsackie-B virus. This also we saw in micro Chagas disease. So they can all lead to dilated cardiomyopathy. Coxsackie-B, yeah, Chagas, Trypanosoma cruzi. So ischemia, example, CAD, systemic conditions like hemochromatosis, sarcoidosis, thyrotoxicosis, wet beriberi, and peripartum cardiomyopathy. So it all makes sense. Yeah, so here's volume overload. Hemochromatosis is, what was it? Iron deposition? Iron deposition. Sarcoid is getting accumulated, thyrotoxicosis, yeah. So they're all going to cause dilated cardiomyopathy. Then what are the findings? Heart failure and S3. S3 is the key clue. Systolic regurgitant murmur, dilated heart on echo, balloon appearance of heart on chest X-ray. So findings, there can be heart failure, there can be an S3, systolic regurgitant murmur, and a dilated heart on echocardiogram, balloon appearance of the heart on chest X-ray. So treatment, sodium restriction, because we know it's volume overload states, ACE and ARBs, ACE inhibitors and ARBs, beta blockers. So A, B, C for sacubitril, D for diuretics. Sodium restriction, A, B, C, D, mineralocorticoid receptors, and it's not anymore. So mineralocorticoid receptor blockers like spironolactone. So A, B, D, C, D, S, ICD, which you said was intra something defib, I already forgot.
Implanted cardiac
implanted cardio implantable cardioverter defibrillator. I need to write this. I keep forgetting. Implantable cardioverter defibrillator. Cardio and defib. Okay. Implantable cardio defib. Okay.
Thank you.
You're welcome. So, so these are all the treatment for dilated cardiomyopathy. What can it lead to? Systolic dysfunction, which means the heart won't pump. The left ventricle, so systolic dysfunction, displays eccentric hypertrophy. Sarcomeres are added in series. So yeah, from a previous group, we used to say TV series. Series has episodes. So series has episodes. So eccentric is sarcomeres added in series. Just to remember this connection. So then compared to athlete's heart, where LV and RV enlargement facilitates increase in stroke volume and cardiac output. So here it displays eccentric hypertrophy as seen in A. So eccentric hypertrophy or eccentric, how you pronounce it, sarcomeres added in series. Compared to athlete's heart, where left ventricle and right ventricular enlargement facilitates the increase in stroke volume and cardiac output. Yeah, we're going to see the athlete's heart in a sec.
You know, like it's a little silly, but I used to remember it like, tiffin dabba. 1 case above that, right? So D is a dabba, Tintin is the protein, and always we keep the dabba as 1/1. So it is in the series.
Okay.
Dabba. Tintin is the, we know the gene, and TTN is the gene, and the protein is the titin, sorry. So that
Just
I
to
used to say
remember. Okay,
Tintin,
nice.
yeah, yeah. And
I
we
like
put
it.
1/1, so it's this series.
No, but series is okay. So you mean 1 and 1 and 1 like this, the dabba. So
Yeah, like yeah,
series. Okay. Tintin, what was it? Dabba, lunch dabba.
dabba, lunch dabba, tiffin dabba actually. So yeah.
Tiffin dabba, and D was for dilated. Nice. D for dilated. Tin should remind us. Tiffin should remind us Tintin. And then you said dabba is stacked, so that's series. Okay. Nice. Thank you so much. Okay. So then, yeah. So compared to athlete's heart, where the left ventricle and the right ventricle enlargement facilitates increase in SV and increase in cardiac output. So then we have stress cardiomyopathy, as we saw earlier in the image, also called Takotsubo cardiomyopathy, which is also known as broken heart syndrome. The ventricular apical ballooning, likely due to increased sympathetic stimulation, like stressful situations, yeah, like the death of a loved one. So yeah, catecholamine induced, what was the wording they used? Cardiomyopathy, I think. So stress cardiomyopathy, also known as Takotsubo cardiomyopathy, broken heart syndrome. Ventricular apical ballooning, likely due to increased sympathetic stimulation. Okay. Then we have
catecholamine-induced myocardial stunning.
Myocardial?
Stunning.
Okay, yeah. Thank you. Yeah, that's what I was looking for. Catecholamine-induced myocardial stunning. So yeah, Takotsubo's cardiomyopathy. Okay, so next we have hypertrophic cardiomyopathy. So this was most common, 90%. This 60 to 70% of the HOCM cases are familial. So yeah, we are familiar with this. So this is familial autosomal dominant, most commonly due to mutations in genes encoding the sarcomeric proteins. What are these proteins? Myosin binding protein C and beta myosin heavy chain. This comes up in questions, right? Myosin binding protein C and beta myosin heavy chain. So it causes syncope during exercise and may lead to sudden death. Example in young athletes due to ventricular arrhythmias. I think our guys in the group might be knowing some basketball player. I think Dr. Ryan mentioned it. Someone just actually happened in real life. Some basketball player just collapsed and died, right? Because of HOCM. I don't know, basketball or maybe American football, not sure. Okay, yeah. So myosin binding protein C, beta myosin heavy chain. It causes syncope during exercise and may lead to sudden death, like young athletes due to ventricular arrhythmia. So findings is S4, and then as a systolic murmur, may see mitral regurg due to impaired mitral valve closure. Treatment, cessation of high intensity athletics. Yeah, they have to quit athletics, use of beta blockers. So yeah, what are the treatments here? Cessation of the athletics, whatever they're doing, use of beta blocker or non-dihydropyridine calcium channel blockers like verapamil, ICD, which was implantable cardio gone again. Oh my
Cardioverter. I think KB has put it. Thank you.
Implantable cardioverter defib. Okay, yeah. So ICD if there is a high risk. So that's that. And avoid drugs that decrease preload. So here we avoided sodium. Here we avoid drugs that decrease preload. And here, okay, so acute coronary syndrome treatment, if it was RCA, we avoid nitroglycerin. If it is dilated, we're avoiding sodium. If it is HOCM, we're avoiding any drug that decreases preload, like diuretics and vasodilators. I think this is a question. Avoid drugs that decrease preload, like diuretics and vasodilators. Makes sense because we're reducing the volume. As we saw in the murmur location, empty vessels make more noise. These are going to remove fluid out of the body or cause decreased preload, vasodilation, pooling in the peripheral vessels, so it'll exaggerate the HOCM outflow tract obstruction. So that's HOCM here. So we said in dilated, we said systolic function leads to systolic function. Here, diastolic dysfunction ensues. So because it is so hypertrophic, the ventricle cannot relax properly. It's so much hypertrophy. So diastolic dysfunction is a problem. Displaced ventricular concentric hypertrophy, and here sarcomeres are added in parallel. So concentric hypertrophy, sarcomeres are added in parallel here. So concentric, it's parallel. Often septal predominance. So usually in the question also they give us little scale to indicate that this is the thickened portion. So yeah, septal hypertrophy predominance, myofibrillar disarray, and fibrosis. So, and yeah, that's usually a clue. Like if they give the scale, we know that they're pointing that we need to pay attention to that particular ball. So yeah, myofibrillar disarray and fibrosis are going to be seen. Next, classified as hypertrophic obstructive cardiomyopathy when, actually it becomes obstructive or HOCM when left ventricular outflow tract is obstructed. Asymmetric septal hypertrophy and systolic anterior motion of the mitral valve leads to outflow obstruction, dyspnea, and possible syncope. So if there is asymmetric septal hypertrophy and systolic anterior motion of the mitral valve, systolic mitral valve anterior motion. So systolic anterior motion of the mitral valve. Okay, makes sense. So that leads to outflow obstruction and dyspnea, possibly syncope. Other causes of concentric LV hypertrophy is chronic hypertension and Friedreich's ataxia. Yeah, this we've seen before, like frataxin protein, somewhere came up. The trinucleotide. So yeah, concentric left. The other causes are chronic hypertension and Friedreich's ataxia. Well, it's not trinucleotide, is it? Vitamin C ke context mein we saw. It mimics Friedreich's ataxia. We did vitamins, I believe.
Vitamin E, I guess.
Vitamin E.
Yeah.
Frataxin, yeah. Okay, frataxin protein, something. So that's Friedreich's ataxia, which can also cause concentric LV hypertrophy.
What was the relation between Friedreich's ataxia and vitamin E?
The vitamin E deficiency mimics Friedreich's ataxia.
Oh, okay. Thank you.
Yeah.
Spinocerebellar degeneration in both of them.
Yeah, CD in both.
Ataxia, that's it.
Ataxia in both. And then one thing was a way to differentiate.
Hemolytic anemia in vitamin E, but not
correct.
in Friedreich's.
Yeah. I think I'm not spelling it correctly.
Saira, there is a question. Do you remember stress cardiomyopathy Takotsubo? Here is ventricular apical ballooning due to increased sympathetic stimulation, stressful situations. They have make a comparison with Chagas disease. So is this biventricular? In Chagas, there's both ventricles are involved, or in stress it's only one ventricle, something like that.
I think Chagas was both. Yeah. I think I vaguely remember. Chagas is both because everything gets dilated over there. I think that's how we said it. Let me see it. I think I'll pull up the Takotsubo. Because yeah, that was the differential on the choices, right, for Takotsubo. What? Broken heart. That's what I searched. What's life these days? Stress cardiomyopathy. Yeah, this one. Yeah, okay, yeah. This was only one chamber, correct? Versus the what is it? Chagas is, I think, both chambers. Let me see. So this objective was stress-induced cardiomyopathy is characterized by hyperkinesis of the mid and apical segments and hyperkinesis of the basal segments of the left ventricle. Yeah, this is just left ventricle, resulting in systolic dysfunction. The condition is likely caused by surge of catecholamines. Yeah, wording was catechol-induced myocardial stunning. In the setting of physical or emotional stress, usually affects postmenopausal women, resolves on its own within several weeks. And Chagas, was it here? So ischemia-induced transmural myocardial necrosis. This is with acute MI. Myocardial hypertrophy and fibrosis due to uncontrolled hypertension. This is again diastolic dysfunction without systolic wall motion abnormalities. Myocardial infiltration by mature lymphocytes. This is seen with acute viral myocarditis. Yeah, here we go. Toxin-induced myocardial injury can occur with exposure to a variety of agents, including alcohol, cocaine, and certain chemo drugs. Okay, no, still not. I'm talking about Lyme's. These myocardial insults typically lead to dilated cardiomyopathy with global rather than segmental. So all the other toxins and chemos are global dilated cardiomyopathy, but what about Chagas? Yeah, so this we said Lyme, the E looks like 3, so 3rd degree heart block. Okay, let's go through this also. So while we're here, 3rd degree complete AV block, pathophys complete blockage of AV conduction, atrial ventricles contact independently. Key features: ventricular rate less than 50 beats per minute with faster atrial rate. Yeah, I think the images on for UWorld are far superior. So regular PP and RR intervals, complete dissociation of P waves and QRS complexes, wide QRS complexes, so junctional escape rhythm is also seen. Okay. This was okay. How do we estimate ventricular rate on EKG? Method 1, the large boxes between QRS complexes. So 1, 2. Yeah, this used to be the shortcut, right? 300, 150, 100, 75, 60, 50. So yeah, start. So this will be 300 if it's between the two QRS, 150, 100, 75. So this is a heart rate of 60 on this one. So rate is beats per minute. So 300 divided by number of large boxes between QRS complexes. Method 2 is QRS complexes per 10 seconds. So within 10 seconds, how many do we have? 1, 2, 3. Number of QRS complexes into 6. Okay, here 18 in this case. I counted only 16. What? Okay, yeah, including this. Yeah. So from time 0, yeah. So it makes sense. So 18 into 6, which is 108 in this case. Okay, cool. So this was just typically each strip is 10 seconds long. That is 50 large boxes. Okay, just quick review. 6 sinus we saw. LV tachy. Yeah. So this is narrow complex. No, sorry, wide QRS. How do we know it's wide QRS? More than 0.12, which is like more than 3 small squares. Okay, 1, 2. Okay, so these tiny, they're talking about these tiny squares, right? So more than 3 small squares, and heart rate is regular. Okay, so that's VTAC. Flutter. So yeah, sawtooth we said. So atrial rate is approximately 300 per minute, constant flutter wave intervals with a sawtooth pattern. Okay. AFib, irregularly irregular, so it's pretty easier visually. So fibrillatory waves present, but no P waves. Yeah, let's see. This we said targetoid or bullseye rash. So yeah, targetoid and bullseye is actually synonymous. So expands from central tick bite due to Lyme's disease. Okay, geography. First at the point. So yeah, this is twisting of points. We said polymorphic because multiple forms. V-tachy. This is an important. Yeah, we said A, B, C, D, E, F, N, O. What is this question talking about? Methadone. So yeah, the NOO was opioid, right? So he was taking heroin abuse. Okay. So, and then they asked, not directly that what is causing it. They asked, what are the EKG findings will be seen? So it's QT prolongation. Okay. Prolonged QT. Okay, that's what we're seeing. Complete heart block. So we said atrial and ventricular beat are unrelated to each other. So PP and RR intervals are regular but unrelated. Okay. This is polymorphic ventricular tachycardia. Whoa, this is just... No, monomorphic, sorry. With previous MI. What is this? Monomorphic because it's the same pattern. Okay, so single form, which makes sense. So this is indicating deep Q waves on EKG typically represent a previous MI. Patients with a history of MI at risk for monomorphic V-tachy, causing syncope or sudden cardiac death, but a prior MI in this relatively young patient without significant cardiovascular risk factors. So yeah, hypertension, smoking, family history, sinus pauses, we've seen, okay. This is WPW. So yeah, we saw this. Yeah, this also, did we go through this? I think we did it in the other group the other day.
Oh yeah, that's remaining actually WPW and PS. This is PSVT. This is the.
So this is just
yeah, PSVT.
Yeah, this is PSVT. Yeah. It becomes a syndrome when there is a reentrant tachycardia. When there's a reentrant circuit, it becomes a syndrome. So when there's just a WPW pattern with the wide QRS, the delta, and the, what's the third one? Delta
shortened PR interval.
Shortened PR interval. So that's just a WPW pattern. So there's ventricular pre-excitation where there's an accessory pathway and ventricular pre-excitation impulse. When this impulse is going back and causing a reentrant circuit repeatedly, and that's, yeah, there's genetic predisposition. So that's WPW syndrome when there is a reentrant tachycardia. So we still see it, but then it's more tachycardia as well, along with these WPW pattern plus the tachy. So that's the difference. Yeah, this is important. It came up in a few questions. What was I actually looking for? I forgot. Lyme's disease, the ventricular changes, right?
Chagas.
Yeah, Chagas. Yeah, biventricular. See, biventricular heart failure, you're right. Cardiac biventricular for Chagas and only the left ventricular systole for Takotsubo. Right?
Yeah, thank you. Yeah, trypomastigotes this one.
Extracellular. Sorry, trypomastigotes for Cruzy, Trypanosoma cruzi. Yes, all this we're good with for now. Okay, so
thank you.
Thank you. That was a good one. All right, so that was yeah. So coming back, yeah. So we were saying we went from Chagas, which causes dilated cardiomyopathy. So biventricular. So I need to make a note for this. So Chagas is biventricular cardiomyopathy versus Takotsubo, which is this one. Stress cardiomyopathy is left ventricle only. 315. Okay, thank you. So then we have the third type, which is restrictive or infiltrative cardiomyopathy. Please help. That's the mnemonic. Post-radiation fibrosis, low-flow endocarditis, endocardial fibroelastosis, which is thick fibroelastic tissue in endocardium of young children. So this condition is known as what? Endocardial fibroelastosis, amyloidosis, sarcoidosis, hemochromatosis. So it all makes sense, right? These are all infiltrative diseases. Fibrosis alone is going to cause restriction. Yeah, either restriction or infiltrative cardiomyopathy. Loeffler's was what? Loeffler's syndrome was something to do with some bug. Is that the same thing? Going into the lungs, Loeffler's syndrome. I think they're different though. Not sure. So Loeffler's endocarditis.
Some parasite, I guess.
Yeah, goes, but that was with the lung, so maybe that goes to the heart and
Strongyloid?
carditis.
Something like
This was
strongyloids or
Loeffler's
something.
medium. Strongyloids, I think. Let me see. This is Loeffler's media for Corymacron. That's different. The media. This, I think it just came up in this list right in the end. Yeah, this dyspnea, wheezing, and dry cough is called Loeffler's, but I guess it's not high yield for step one. They don't use the names as much. But yeah, I don't know if this same thing
It's
goes.
it's an FA. I think it's an FA.
I think because of the spelling O, it doesn't come up. Maybe.
Yeah, it's LOE. I think over there maybe. Loeffler.
Yeah, you're right. LOE. So yeah, you're right. Ascaris lumbricoids, giant rat.
Ascaris, yeah.
Yeah, Ascaris is scary because it goes to the alveoli. So migration of larvae to alveoli causing Loeffler syndrome or Loeffler syndrome causing pulmonary eosinophilia. So now we're talking about Loeffler's endocarditis, which is spelled OFF. So we know Loeffler's medium for Corynebacterium diphtheria. Don't know if it's high yield, but okay. Loeffler's syndrome for Ascaris lumbricoids, and then Loeffler's endocarditis. So that's then cause of infiltrative or restrictive cardiomyopathy. Then we have endocardial fibroblastosis, thick fibroelastic tissue in the endocardium of young children, amyloidosis, sarcoidosis, hemochromatosis. So here also we have diastolic dysfunction. So one more time, here it's dilated is always systolic dysfunction, hypertrophic HOCM, or I just generally call it HCM, HOCM for ease, hypertrophic cardiomyopathy, and restrictive infiltrative. This is diastolic dysfunction. So this can have low voltage EKG, despite thick myocardium, especially amyloidosis. Where did we say yesterday? Slow wave on EKG, slow rhythm.
Delirium.
Was it delirium? Yeah, yes. Hamna. Nice, mashallah. Yes, it was delirium.
You were very enthusiastic about that. Slow wave. That's why it got stuck.
Yeah, I know. It was like, what is this about? Yeah. Never thought that delirium correlate with EKG changes. So yeah, that was not filling up. Am I spelling it wrong? Delirium. Yes, diffuse background rhythm slowing EKG. So yeah, coming back to Loeffler's. So yeah, nice. So now we're seeing low voltage EKG. That was slower rhythm for delirium. So yeah, for restrictive infiltrative cardiomyopathy, we have low voltage ECG despite thick myocardium, especially in amyloidosis. Low voltage EKG despite thick myocardium. Loeffler's, okay, it's right here. I'm blind. So yeah, Loeffler's endocarditis. What is this? It's associated with hypereosinophilic syndrome. Histology shows eosinophilic infiltrates in the myocardium. So yeah, it is kind of similar, right? That also has eosinophilic stuff. So this is also eosinophilic. Loeffler's endocarditis associated with hypereosinophilic syndrome. Histology shows eosinophilic infiltrates in the myocardium. Okay, nice. So then next we have athlete's heart adaptations. This is just a UWorld image to show that in endurance training, there is eccentric LVH versus strength training is concentric. I think it came up in a question. So with the endurance training, what do we have? We have increased left ventricular cavity size, eccentric hypertrophy, increased right ventricular cavity size as well, increased diastolic filling and stroke volume, and unchanged LVEF. So this is important, unchanged LVEF versus in strength training. Increased LV wall thickness, like concentric hypertrophy, no RV changes, no right ventricular changes, unchanged diastolic filling. Here we have increased diastolic filling and stroke volume because there's more space. Here this is unchanged diastolic filling. LVEF unchanged or slightly increased. This comes up in arrow questions. I think there's an arrow question. So yeah.
So in both conditions, LVEF unchanged, right?
Yeah, but for because this is concentric, it might pump a little bit more strongly, so it'll be slightly increased. Because I know some question they gave normal, another question they gave increased. So that's why it was tricky. But it can be normal, which is unchanged, or slightly increased with concentric. because more muscle, so they can press out more, so slightly increased. Okay, next we have heart failure. So heart failure, clinical syndrome of cardiac pump dysfunction. What do we see? Congestion and low perfusion. Symptoms include dyspnea, orthopnea, fatigue. Signs include S3 heart sounds, rales, JV distension, and pitting edema. So this comes in a cirrhotic nephrotic CHF. So it will be exudate or transudate. Anyone?
Transudate, right?
Yes, transudate. Yep. Exudate was only just quick jog. Exudate was infection or
Malignancy, rheumatic diseases.
Malignancy, rheumatic diseases. Yes, nice. Thank you. So yeah, here we'll see S3. Why? Because it's a volume overload state. Rales, JV distension because of backup, and pitting edema. So we can have systolic dysfunction, diastolic dysfunction. So let's see, systolic dysfunction, heart failure with, so yeah, this is HFrEF. Heart failure with the reduced ejection fraction. So here we have increased end diastolic volume, end diastole. So at the end of ventricular relaxation, there's a lot of volume left over. Decreased contractility because the systolic pump failed. So there obviously there's decreased contractility, often secondary to either ischemia or MI or dilated cardiomyopathy. As we saw before, this is dilated is systolic, hypertrophic and restrictive is diastolic dysfunction. Okay. So yeah, secondary ischemia, MI or dilated cardiomyopathy. Then diastolic dysfunction, heart failure with preserved ejection fraction. So HFpEF, here we have normal end diastolic volume. End diastolic volume. So at the end of relaxation, this is a diastolic function. So the volume is still okay. There is room for it to fill. So it's normal. Here it is increased EDV. It's backing up. Okay. In decreased compliance, increased end diastolic pressure, decreased compliance, which is decreased compliance, okay, of the wall, and increased end diastolic pressure, often secondary to myocardial hypertrophy. Can someone explain this? Decreased compliance is like how far it can stretch open, right? So that is decreased.
Because the wall is thick now.
Right. Yeah, makes sense.
Wall
So
is thick, so compliance is is low. So EDV normal. Somehow it can accumulate the whole fluid, but the pressure will be more. So end diastolic pressure will be more for a given EDV.
Makes sense. Nice, thank you. So yeah, decreased compliance because of the hypertrophy. So increased pressure and normal end diastolic volume. Okay, nice, thank you. Next, right heart failure most often results in, we've studied this from, I remember from med school, most common cause of right heart failure is left heart failure. Cor pulmonale refers to isolated right heart failure due to pulmonary cause. So cor pulmonale refers to isolated right heart failure due to pulmonary cause. Then, so drugs, ACE inhibitors, ARBs, angiotensin receptor, neprilysin inhibitors, beta blockers, except in acute decompensated heart failure, and aldosterone receptor antagonists decrease mortality in HFrEF. So all of these will decrease mortality. So yeah, this is tested. Beta blockers decrease mortality except in acute decompensated heart failure. So it's an exception to the rule. Exception, decompensated heart failure. So yeah, they all decrease mortality in HFrEF. Loop and thiazide diuretics are used mainly for symptomatic relief. Loops and thiazides, they're not going to cure the problem, so they're just symptomatic relief. Hydralazine with nitrate therapy improves both symptoms and mortality in select patients. So hydralazine, what was alpha-1 selective? I think we're seeing it later on in pharm. Okay, anyway, hydralazine with nitrate therapy improves both symptoms and mortality in select patients. Okay, so we have left heart failure versus right heart failure. So in left heart failure, we see orthopnea, PND, and pulmonary edema. In right heart failure, we see CHF, JV distension, and peripheral edema. So yeah, orthopnea, why? Shortness of breath when, what is orthopnea? Shortness of breath when lying supine. Why? Because increased venous return from redistribution of blood. immediate gravity effect. Increase venous return. So they're already volume overload. So they suddenly increase venous return from redistribution of blood. Immediate gravity effect exacerbates the pulmonary vascular congestion. Okay, makes sense. So yeah, immediate gravity effect exacerbates the pulmonary vascular already existing pulmonary vascular congestion. So that's orthopnea. Then we have PND, paroxysmal nocturnal dyspnea. What is this? Breathless awakening from sleep, increased venous return from redistribution of blood, reabsorption of peripheral edema. So both lead to breathless awakening from sleep. Pulmonary edema, increased pulmonary venous pressure, pulmonary venous distension, and transudation of fluid. So as we said, cirrhotic nephrotic CHF is transudate. Presence of hemosiderin-laden macrophages. This is high yield heart failure cells in lungs. Okay, so transudation and heart failure cells in lungs.
So orthopnea is just when you lie down, so shortness of breath, right? PND is just breathless awakening from the sleep, right?
Yeah.
You just wake up from the sleep.
Just position versus this is from sleep. Yep.
Okay.
Okay. And yeah, there was another name for heart failure cells. I mean, hemosiderin-laden macrophages and heart failure cells. Okay, anyway. Then right heart failure, we have congestive hepatomegaly, JV distension, peripheral edema. So why congestive heart failure? We have increased right heart is failing. So right ventricle will back up into the right atrium. Right atrium is connected to the IVC and SVC. So increased central venous pressure. So it's going back up, and increased resistance to portal flow rarely leads to cardiac cirrhosis. So cardiac cause leading to cirrhosis is known as cardiac cirrhosis. So it's associated with nutmeg liver, which is a mottled appearance on close exam. Yeah. Nutmeg liver also comes up. Yeah, it's for cirrhosis actually. So then JV distension because of increased venous pressure, makes sense. Peripheral edema, again, increased venous pressure and fluid transudation. So these curves I yield, let me try. So where do I start? So decreased cardiac output. If there is decreased cardiac output, what is happening is there's increased sympathetic tone, which makes sense, and the RAS is activated. So decreased cardiac output, so it's sensed by the RAS system in the kidney, low blood flow, so low sodium is sensed by the macula densa, so it gets activated. So this is going to renin, angiotensin, aldosterone system. So angiotensin, aldosterone, everything is going to be produced. So AT2 ADH on V1 is going to cause vasoconstriction. AT2 aldosterone and ADH on V2 is going to increase circulating volume. So V2 is the aquaporin channels, blah, blah, blah. So increase circulating volume, thereby causing increased venous return to heart preload. And on this side, we're increasing vasoconstriction from the V1 receptors. Recall, we saw this somewhere. V1 is for vasoconstriction, V2 is for the aquaporin channels. So increased venous tone. And on this side, the vasoconstriction, so yeah, also arterial tone. So both vaso meaning arterial tone and venous tone, both are increased. So because arterial tone is maintained, we have maintained blood pressure. Okay, so maintain blood pressure. Because there's increased venous return to the heart, we're adding the preload. So the A is in increasing the stroke volume. If stroke volume is increased, it maintains the cardiac output. If cardiac output is maintained, again, we maintain the BP. So we started off with low cardiac output, and now we're maintaining the cardiac output. So on
you
the other hand,
you remember the diagram in IU World, which is it's a very nice diagram. This one.
This one, right?
This one and the other, compensated and non-compensated above and below.
Correct, I agree with that.
You just pull it up, yeah.
ANP is also involved.
ANP and BNP was also involved. Neurohormonal stress.
The one with the okay. I think I remember. Okay, I'll get it. So here, sympathetic tone, so increased catacola means, I don't know what this means. 2 degrees, I guess. I don't know. 1, maybe there's a receptor, and actually sometimes some words are lost in this book, PDF. So what would increase heart rate and contractility? Those get triggered and increase maintaining cardiac output and stroke volume. So yeah, hemodynamic stress, no neurohormonal stress, all this adds to the deleterious cardiac remodeling. So if I search for remodeling, should pull up, right? Let me see.
Yeah, neurohormonal stress also.
Let me do neurohormonal. Okay, so chronic heart failure, yeah. Okay, stop me if you see that image. This one?
No,
No,
not
next.
detailed.
Yeah.
It is the upfront one only. No,
Yeah, this one.
This one?
this is the
Yes.
one. Yep.
Hamna, you want to go over it, please?
Okay. So first, starting with the heart failure, right? So volume overload and reduced cardiac output and myocardial split. So first there is a first there is a natriuretic pathway. So natriuretic pathway because of increased because heart is not pumping out, so reduced cardiac output, so leads to increased myocardial split. So ANP and BNP is increased. That leads to more. We know that it dilates efferent arterioles and causes vasodilation and natriuresis, salt and water excretion. So by this mechanism, it decreases afterload and preload. And this is compensatory, basically, counteracts heart failure. But this is a short term, eventually overcome by this chronic heart failure. Then what happens if the symptoms continue? Then decreased renal perfusion, so decreased baroreceptor stretch. So it leads to vasoconstriction and salt and water retention. And RAS pathway will be activated. So RAS path, when there is decreased renal perfusion, basically then RAS and sympathetic pathways are activated. So because of this RAS, more and more salt, aldosterone, salt and water retention, angiotensin 2 leads to vasoconstriction. And because of decreased baroreceptor stretch, sympathetic pathways get activated. So it leads to more increased afterload and preload. So it will exacerbate the heart failure further.
Yeah.
So first is initial compensatory and then
chronic cycle, yeah.
Yeah. First ANP and BNP mediated, and then it's RAS and sympathetic pathways mediated. And if you go to the previous question, then where do you pull the diagram? Until that situation, it's this one. Yeah, this one. This one, or you have in FA that picture. At this stage, it will remain asymptomatic, and then it will become symptomatic.
Which one? This.
I think in the first
this one.
Yeah, this one, yeah.
Yeah. This is eccentric LVH, LV enlargement and heart failure. Okay.
You want to go?
No, please go ahead.
Okay. Sorry for the background noise. Okay. So asymptomatic, same left ventricular systolic dysfunction like in ischemia and cardiomyopathy. So left ventricular volume overload, so lead to left ventricular stretch, increased stroke volume via Frank-Starling mechanism. So initially it maintains cardiac output by this stretching and all these things. It maintains the stroke volume. Then the chronic volume overload leads to eccentric hypertrophy. It's like dilated cardiomyopathy. And then stroke volume maintained at the expense of the increased wall stress. So till then it preserves cardiac output. But the overwhelming wall stress leads to left ventricular enlargement and contractile dysfunction. At that stage, decompensated heart failure and the patient becomes asymptomatic. Until before that stage, patient becomes asymptomatic. It's either due to left ventricular systolic dysfunction like ischemia or cardiomyopathy, or due to valvular dysfunction like AR or MR.
Nice. So this is the starting point.
Yeah.
Initially, it's maintained, somehow preserved, but then it's overcome, and that leads to decompensated heart failure. Okay. And then it becomes a vicious cycle at this point. Okay. And then these images. So let me try. Maybe you can pitch in. So volume both. And so here, reduced ejection fraction. So ejection is not happening. So here volume has increased, contractility has gone down. Again, ejection is not happening, so decreased contractility. So that curve which it passes through that corner point has come down. Here, heart failure with preserved ejection fraction. So the volume has not increased as much as this. This is stark increase in volume. Here, not as much, but compliance went down because the main problem here is the compliance. So here, initial was the black curve. So now compliance went down. No, went down here.
Yeah, but here the volume is somehow maintained, right? That's why they say that preserved ejection fraction.
Nice, yeah. So that's why we're not seeing that much of a difference. Okay.
Okay.
We have questions on this, right?
Yes,
Something they
yes,
have asked
so
us.
many. And do you remember this congestive hepatomegaly? We have a question in NBME, like ascites, what happens? All the features except
Yeah.
Do you?
Little.
Yeah. Increased central venous pressure.
Yeah. I know what you're talking about. Everything was increased except one. Does anyone remember that NBME question? It was either 26 or 27.
Everything was increased except is it JVD something?
Yeah, I think JVD actually, because here it's preserved, right? So it won't increase. I think so. I'll look it up later today. Yeah, it's in the file somewhere. All right, so moving on. Next, we have high output heart failure. All right, let me speed up a bit. So high output heart failure, uncommon form of heart failure characterized by increased cardiac output. So there is increased uncommon form of heart failure characterized by increased cardiac output. So that's why it's uncommon, because although the heart is failing, there is increased cardiac output. So high output heart failure. The high output state is due to decreased SVR from either vasodilation or AV shunting. Causes include severe obesity, advanced cirrhosis, severe anemia, hyperthyroidism, wet beriberi, and Paget's disease of the bone. So that's why we call them, there's high output states, but it's because of decreased SVR from either vasodilation or AV shunting. So obesity, decreased SVR, advanced cirrhosis, okay, makes sense because we're not synthesizing proteins, severe anemia, hyperthyroidism, wet beriberi, Paget's disease of bone. Okay, so they're present with symptoms and signs of pulmonary and/or systemic venous congestions. Increased cardiac output, but yet the heart is failing. Decreased SVR is the reason. From where? Either vasodilation or AV shunting. AV shunting is the Paget's disease of bone, I think. If I'm wrong. Okay, anyway, next we have shock. High yield, but yeah, they've made some changes from the old to the new book, so it has been a bit annoying. Okay, so what is shock? Inadequate organ perfusion and delivery of nutrients necessary for normal tissue and cellular function. So inadequate oxygen perfusion and delivery of nutrients necessary for normal tissue and cellular function initially may be reversible, but life-threatening if not treated promptly. So we have hypovolemic, cardiogenic, obstructive, or distributive. So what happens in hypovolemic is less hypovolume, so hemorrhage, dehydration, burns. Mechanism, as it says, volume depletion. So what happens to the central venous pressure? Less volume in the veins, so it drops. Pulmonary capillary wedge pressure is reflective of the left atrial pressure, so it's a volume loss state, so it's going to fall. Cardiac output less. SVR is increased as a, what do you call that, response? Reflex, right? So the body is trying to maintain homeostasis, so SVR increases. Decreased SpO2 because the body is trying to extract all the oxygen it can, so it will be decreased. So next is cardiogenic shock. Here we have so PCW, and this is the primary disturbance driving the shock. So the first thing is left atrial pressure falling, then the central venous pressure and everything else. So this is the primary disturbance, and the only thing increased here is the SVR. Then we have cardiogenic shock. What's the problem here? The left heart is dysfunctioning, so the left ventricle is not pumping out. What is it caused by? MI, heart failure, valvular dysfunction, and arrhythmia. So the skin is cold and clammy in all of these. So distributive, which is sepsis or sinus injury, is when it's warm. So all of this, the skin is cold and clammy. So yeah, coming back to cardiogenic shock, the primary dysfunction is left ventricle not pumping. So what happens, it backs up into the left atrium, going back into the pulmonary side, coming back to the left atrium. So left atrial pressure is high. The veins are congested, obviously, because everything's backing up. So CVP is also high. SVR is high because it's not getting blood supplied to the periphery. So again, as a reflex, the SVR will go up. SVO2 is down because tissues are trying to extract as much as they can again. So that
Excuse me. Could you please explain the reason for increasing PCWP? I saw the question.
In which one?
Yes.
Cardiogenic?
Yeah.
Okay. All right, let me see. So the main disturbance is in the left ventricular not pumping out, right? So if you visualize it, the left ventricle is not pumping out. Left ventricle, so all this blood is going backwards. It's going to fill in the left atrium. From the left atrium, it's going where left atrium is connected to the pulmonary veins. So it's going to the pulmonary side. From the pulmonary side, it's going to the lungs. From the lungs, it will go to where the pulmonary... No, actually, I think I made a mistake. Did I? No, pulmonary veins over here. So yeah, left ventricle is not pumping out, going back to the left atrium. From the left atrium, it's backing up into the pulmonary veins. Pulmonary veins going to the lungs. From the lungs, why is it not matching? What am I doing wrong?
Yeah, it's all the backup of backflow of blood, no? That leads to pulmonary edema, cardiogenic shock, cardiogenic pulmonary edema.
Pulmonary
So
veins
lungs will be filled.
Yeah, so actually I'm missing a step here. So yeah, eventually it goes to the lungs, volume overload. So the lungs are returning more blood to the right atrium. So whenever there's a lung overload state, the pulmonary capillary wedge pressure is increased because it's representative of the left atrial pressure, basically. So just from this part itself, we've got our answer, right? There's left ventricle is not pumping out. It's pushing blood or backing up into the left atrium. And as we saw earlier, if you think about the Swan scans catheter and how it works, so PCWP is representative of the left atrium. So that's why the LA pressure is high. Does that make sense?
Guys, yeah, thank you. And the only I think just in cardiogenic shock and in cardiac tamponade, we have increasing PCWP.
Yeah, exactly. That's a good observation. So only in these two cases, we have increased PCWP, but it's for different reasons. Here it's backed up. Here it's externally compressed by the tamponade. So that pressure just transmits and the catheter will detect an increased pressure. So it's just a direct external compression causing the increased PCWP. So that we have to remember, and they try to always trap us with that. Yep. So yeah, it's a good observation.
For backward flow. Thank you.
Backward flow in PCWP, tamponade is because of external compression. Yeah, that's the reason. You're welcome. So yeah, that was cardiogenic. Then yeah, we had finished this. Okay, obstructive, they've divided into PE, tension pneumo, and cardiac tamponade compared to the old book. So here there is impeded cardiopulmonary blood flow. Impeded cardiopulmonary blood flow, so either a pulmonary embolism or a tension pneumothorax. So the primary triggering event or the primary disturbance is again cardiac output is not able to be maintained. So what happens next? Pulmonary embolism. So there's a big emboli stuck in the lungs. So there's not enough cardiac output. So again, SVR will be a reflex. How do we go from here? So obstructive, if it's pulmonary embolism or a tension pneumo. So tension pneumo, for example, there's excess air in the cavity, in the chest cavity, so the heart is not able to expand. So it won't be able to pump out. Left atrial pressure is also less because everything is getting squeezed from outside, right? I'm not sure about this. Increased central venous pressure. Anyone? The obstructive shock? Hamna, please. Anyone?
I think pulmonary embolism or tension pneumothorax, there is obstruction at the level of the pulmonary arteries or at the level of the lungs, right? So less blood will go into the left atrium, so PCWP will be increased and the backflow of blood leads to CVP increased.
Wait, say again. If
at the level of the lungs, pulmonary embolism in the pulmonary arteries, there is thrombus obstruction, right? Tension pneumothorax also at the level of the lungs.
Yes.
Right. So I think less blood will go towards the left atrium.
Correct.
So we know that PCWP is the left atrial pressure, almost.
Yeah.
So PCWP will be decreased in this case. CVP due to backflow of blood in the right heart, it will lead to increased CVP, and because less heart goes into the less blood flows into the left heart, so PCWP will go down, and cardiac output will go down, and because of that, SVR will go up, and SVO2 increases because we said that why it increases.
We said because of the phenomenon of what is it, shunting, because this is going on in the lungs, the shunting occurs. So the what do we say, the hypoxic regions will
perfused.
so they're not extracting oxygen, so it ends up more in the venous side. Sorry,
so hypoxia occurs. Okay.
Yeah.
So more and more oxygen will retain in the blood. Okay. SVO2 will be increased. Okay.
Not hypoxia. It was the hypoxic vasoconstriction, like that.
Hypoxic vasoconstriction.
Yeah, that phenomenon. Yeah. Sorry, Shruti, go ahead. And also, someone else was saying, I didn't recognize.
No, I mean, can you please explain SVO2 again in the pulmonary, this obstructive shock? And second thing is like, is it like, the less blood is going to the lungs and then the less blood would go to the left atrium, right? Hamna, yeah, lungs mein ja raha hai, but
I think the problem is at the level of the lungs now.
Yeah, so
because
less
pulmonary embolism, so less will go into the left heart then after that.
Okay.
Because it's a impeded cardiopulmonary blood flow.
Agree.
Yeah, so lungs say what will bring it to the heart is the pulmonary veins. Pulmonary veins are connected to the left atrium. Then we have the left ventricle, right? Just rough diagram. So if the block is here because of a pulmonary emboli, veins are not going to carry anything. So less coming to the left heart, less coming to the right heart. So this again is the left heart is the PCWP, right? Representation. So it's decreasing because nothing is coming back. So that's what she said.
So basically pulmonary capillary wedge pressure, even in the pulmonary also it's less, and that is recording in the left atrium. So that's coming, right?
Exactly.
And I did not understand SVO2 why it's more in obstructive pulmonary side. Can you please explain again?
Sure, let me try. So we said this when we did pulm, I think. So what the story was is, so the lungs are unique, right? We said that's an exception to the rule. In the rest of the body, if there is a hypoxia, which is low oxygen tension, what does it cause? If there's a vessel, for example, and there's low oxygen tension in this vessel, so it will vasodilate so that more oxygen comes in. That's the normal response, right? But in the lungs, it's unique in that whenever there is less oxygen coming in, it will close off and be like, yahan pe nahi hai oxygen, go somewhere else. So that, remember in detail, if we said we saw it in pulm. So because of this low oxygen, the blood is shunted now. Actually, the other image which we draw for the
better ventilated area, right?
Yeah, alveoli, and let me use a different color. It's too much green glaring. So yeah, we said, actually, never mind. So we said if this is the alveoli and then the vessel going around it, let's say there is less oxygen coming in. So it's a hypoxic situation. So let's say there is an embola, right? So that's where it's blocking at some small, actually no, here. So if it's a pulmonary emboli, what will happen? It will be shunted. So I don't remember exactly if I'm saying the right thing, but the
Yeah,
rough.
correct. Shunting to the better ventilated alveoli. You're right.
Yeah. So because there's no oxygen coming in here, everything will get shunted towards the better ventilated alveoli. So what happens is, because it's shunting so fast, all of the volume is just moving so fast and being shunted, right? So what happens is there's not enough time for the tissues to extract the oxygen because of this rapid, quick shunting. So that's why the SpO2 increases. So when you measure it in the end in the venous side, the oxygen has not been extracted at all. It's just like itna jaldi pada raha ho ki I cannot absorb anything. Kind of that situation.
But it is at the means lung side, and tissue extraction would be happen to the peripheral tissue
Yeah,
side, which is
I'm going to
absolutely
try.
normal.
Let me try and explain.
Sure. Okay, go ahead, doctor.
It may not make sense, but so because the primary pathology is in the pulmonary side, okay, you don't have, you don't have ventilation happening because there's a blockage before the lungs or in the lungs. So you have inadequate ventilation and perfusion. So once the oxygen that is leaving the pulmonary circulation hasn't been well ventilated, once exchange has not taken place, you are not going to deliver any oxygen to the tissues. The SvO2 is just a measure of how much the tissues extract. Okay, and because the blood that went into the lungs have not been involved in ventilation, you cannot give, you can't give what you don't have. The blood that went through the stenosis pulmonary vessels did not get adequate ventilation. So the blood that will get into the systemic circulation will have, the tissues are not going to pick up the little oxygen in the blood. That's why the SvO2 will be high. I don't know if it makes sense.
Yeah, that did make sense.
If I have blood going to the lungs to receive oxygen, then that blood can go and supply nutrients to the tissues. But in pulmonary embolism and these diseases, the blood in the lungs, they're not even getting there. But even if they do get there, they're just getting a little bit of ventilation. So the tissues are not going to grab those oxygen. So every time you check the SvO2, which is a marker of the tissue oxygenation, it will be high because the tissue didn't take any oxygen from that blood. That's what I think.
So the incoming itself to the tissue is less, right, doctor?
Yes.
Okay, so the incoming is less. That's why tissue is not extracting because it is already less out there.
Yes.
So,
yes.
Okay. Thank you so much. Thank you so much, Sarah. Thank you so much, Dr. Kiwi.
So yeah, with let me just review this because I think I got stuck over there. So normally without hypoxic vasoconstriction, we have obstruction here 20, 104, 104, 20, 20. So the net effect is it's become 60 because it's mixing with the this did not exchange. So with hypoxic vasoconstriction, because there is less in the alveoli, this side it vasoconstricts. So that is known as hypoxic vasoconstriction. In response to this hypoxia, there's vasoconstriction, which is unique to the lung. So because now this is vasoconstriction, when vasoconstricted, all of this blood needs to go via this vessel alone, because this is blocked off now or very less. So most of it is going through here. So now this is the decreased intrapulmonary shunt effect. Yeah, normal shunting is not taking place here. So it's a decreased intrapulmonary shunt effect. So the net effect is the PaO2, which is 104, has now become 1 or 90. So this 90 is what is reaching the peripheral tissues, and they are unable to pick up. Yeah, that was a very challenging topic. Why that SpO2? But then what Dr. KB said is because you cannot give what you don't have. The way he said that was nice. So because it's not having, so it's not taking up. That's why the SpO2 is high. Did I understand correctly?
Yeah, she said that the same thing, but my concept was, I know it's wrong, but mine was like, if less oxygen is coming to, so tissue will try to extract as much as it is there, right? So that's what I was thinking, like always. That was my doubt since I have seen this arrow. So, but
Yeah,
okay.
that is a tricky, and we had resolved it, but I
I
think
know
it's lost
something
again.
new. Yeah, I remember something was discussed there, but I could not recall, and I forgot.
So yeah, so in all other conditions like hypovolemic and cardiogenic shock, isn't it the same thing because they don't have enough oxygen, so they are
Extracting
tissues
more.
are extracting more. Yeah, so that's why SpO2 is less in.
There was a reason which we found, but that's lost. Let me see if it
No, like what I feel like rest everywhere, the cardiac output is going low, right? Except this distributive, because infection is only happened there, right? So you cannot help it out, right? So obviously in the distributive, if you see sepsis, it's increased. Why it's increased? Because obviously infection is going on, so much of expulsion of the fluid is happening, so that is justifiable. Rest everywhere, wherever SvO2 has decreased, you can see cardiac output has decreased, right? So you're giving less oxygen, right? Like does it make sense, right?
So we're giving less, so extraction is more, so SvO2 is less, which makes
Correct,
sense.
right.
And here also we're giving less, so extraction is maximal, so SvO2 is less.
Right.
So here is where it is like confusing.
Here also, no, cardiac output is less in the pulmonary. That is also fine. The next one,
This is also fine. Cardiac tamponade makes sense.
Yeah.
Here it's sepsis, so everything is leaky.
Yeah, so definitely it cannot extract it. So SvO2 would increase, like venous O2 would increase because infection is going on periphery, right?
Yeah,
CNS, yeah, CNS injury, it's mostly normal, but then it increases sometimes. So that is also okay about it. But
Yeah. This is the
but
only tricky one. I think I've made a note of this that time only. Let me see. So conversely, in distributive shock, the SvO2 is usually greater than 70% due to failure of the peripheral tissues to extract oxygen and microcirculatory shunt. Very high values, more than 90% have been associated with worse outcomes. No, this is still talking about distributive shock. What are we talking about? Cardiogenic was the confusing one, right? No.
Pulmonary one. Obstructive, the pulmonary cause. Yes. Pulmonary cause. Yep.
No, this is not having the answer. So from what Dr. KB said, it was because there's less going in, or the lungs is where there is a point of obstruction. So the lungs are not able to oxygenate those particular vessels. So there's less oxygen going down to the peripheral tissues, and that's why
it's they are very understandable. So they are not taking much and letting do there and go by.
Okay. Yeah.
Thank you, everyone. Thank you.
Yeah, I need to sit with it and think about it, but it's okay. Let me move on. We'll come back and discuss that. This always happens, no matter how many times we do it.
Agree.
I feel like next time I do it, it's gone. I need to write notes or something.
So just two things. Remember two things: SvO2 increase in sepsis and the pulmonary embolism, right? Tension pneumothorax. That's it.
Yeah. Just
and better. I'm not.
Yeah, something we have to plan.
Yeah. That's it. This one is high. Everything else is.
It's just that it's different from the last edition. No, they have included it, and for what reason they have changed it, don't know. And whatever they change is the higher it, like everyone says. So yeah, but I think I agree with Hamnat. So we can move. Yeah. Thank you so much.
So decrease in
sorry.
shock. Neurogenic shock is it may be decreased due to impaired sympathetic reflexes. In tamponade, left-sided preload is decreased, but measured PCWP is paradoxically increased due to external compression. Okay, this we knew. Yeah. Anyway, yeah, let's move on. I'll find out. And if I get a good answer, I'll definitely share on the group. This is always a sticky topic. I'll make a note. What was it? SvO2 in the obstructive shock. Okay. Okay, next we had cardiac tamponade. Yeah, because of external compression, PCWP is high. We said that. Because the heart is now surrounded by this fluid, there's no cardiac output, which makes sense. Increase SVR as a reflex. Increase SVO2 makes sense because decrease SVO2 makes sense because already cardiac output is low, so everything is being extracted. Central venous pressure is high because that pressure reading is just transmitted from the external compression, so central and also the backup, so CVP is high. Next, we have distributive shock, sepsis, or early anaphylaxis. Here there is a mechanism of systemic vasodilation. Skin is warm and dry. So here the triggering issue is decrease in SVR. Yeah, makes sense. All the inflammatory mediators will cause massive vasodilation. So decrease SVR, cardiac output increases to try to maintain volume status, to try to maintain homeostasis. So it increases. PCWP drops because there's no volume coming back to the heart. So yeah, less volume, so less left atrial pressure, so PCWP is less. And yeah, again, everything's third spacing, so CVP is less. SCO2 is high because again, tissues are not able to extract because of the microcirculatory failure of the peripheral tissues to extract oxygen and microcirculatory shunt. So yeah, the tissues are all like stressed out because of the infection. They can't do anything. They're not able to extract. Then we have CNS injury. Here, the main issue is the SVR is the problem. And so because it has to pump against more resistance, cardiac output is less. PCWP was less because SCO2 is decreased due to impaired sympathetic reflexes. So it can be normal or increased, but here they said
why SVR is the primary problem here in CNS injury?
SVR, I think it's because they said here, right? Neurogenic shock, impaired sympathetic reflexes.
Vasoconstriction is not taking place, so everything is like that is the way to increase the SVR, peripheral resistance, by vasoconstriction through alpha-1 under sympathetic stimulation, right? That is impaired, and SVR would decrease. Basically, everything decreases in this, and SVO to normal or increase. Yeah.
So, Shruti, I didn't hear you clearly. So you're saying those receptors are controlled by the CNS, the ones that are controlling the vascular resistance. So because CNS injury is there, they're not controlled properly. So the SVR drops, correct?
Correct. So alpha-1 is the one, right, which vasoconstriction may use hota hai. So
Correct,
sympathetic is gone, then vasoconstriction kaise hoga? Then resistance increase.
Makes sense.
Am I saying opposite? I think I'm saying
SVR decreases.
Yeah, you're right. So
yeah,
the compensatory mechanism is from the spinal cord. I mean, that's where the ganglion is where the sympathetic fibers arise from, and they are the reasons for the alpha-1 that would stimulate the alpha-1. So without it in spinal shock, you'll not be able to have a compensatory or a reflex mechanism, and that's why it will be lower. Yeah.
Nice. Yeah, that makes sense. So the spinal sympathetics is where the SVR is maintained. So that is injured. So SVR drops. So cardiac output is now less. How does this get affected? For the same reason, the receptors that are controlling are not functional. So cardiac output less, left atrial pressure less, venous pressure less.
Yeah, what I think like SVR is decreased, right? Like
again, vasodilation. So same scenario kind of, right?
Correct.
But then no, cardiac output went down. I don't know why.
Even like maybe sympathetic is gone, then contractility is gone, beta-1 sympathetic stimulation, right? So that is going down, right? Then PCWP beta-2 bhi chala jayega kya nahi? I don't know.
No, that makes sense, right? If the cardiac output is not there, no blood is pumping out, no blood is returning to the other side, no blood is going to the lungs. So again, nothing comes back. So
yeah, contractility is only
as a consequence
in such case.
Yeah. So yeah, that makes sense. So nothing is going forward, so nothing returns, and nothing is in the venous return too. Venous side is also less. So that makes sense. The main thing is the receptors. So beta-1 controlling the heart is gone. So no contractility, no cardiac output. Alpha-1 controlling the peripheral vessels is gone. So no SVR or decreased SVR, because so that's vasodilation. Makes sense. Yes. Awesome. Thank you. Sorry, we went a bit extra, but this is high yield, so it's worth it. So next is cardiac tamponade. Yeah, this is also, we have so many questions. Compression of the heart by fluid, either blood or effusions, leading to decreased cardiac output. So this is equilibration of diastolic pressure in all 4 chambers. Findings are Beck's triad, which is hypotension, distending neck veins, and heart sounds. Increased heart rate, pulsus paradoxus, which is key buzzword, pulsus paradoxus. ECG shows low voltage QRS, low voltage QRS, which they mentioned in questions, and electrical alternance. Why? Because of the swinging movement of the heart in large effusion. So we are seeing electrical alternance. So it's here, then, so it's like a swinging movement, right? So that's electrical alternance due to swinging movement of the heart in the effusion. Echocardiogram shows the pericardial effusion, which are the arrows in B. So we're seeing so much fluid is built up. So left ventricle, right ventricle, and the fluid around the, in the pericardial space. Systolic right atrial collapse, diastolic right ventricular collapse. So during systole, right atrium collapses, diastolic right ventricular collapse. Yeah, because these are less pressure chambers, they get collapsed. And then there's also IVC plethora. Yeah, because of things getting squeezed, IVC plethora is seen. So then treatment is pericardiocentesis or surgical drainage. Okay. So this is like the similar to the SVC, right? IVC plethora, when they say it's back up.
Yeah, SVC syndrome, like.
Yeah.
Why is this systolic right atrial collapse and diastolic right ventricular collapse? Sorry, I didn't get it.
Because in systole, when they say systole, whenever they say it, they mean the left, the right ventricle, right? Correct? So right atrium, right ventricle. Sorry, what am I saying? Left atrium, this is left ventricle, for example. And here we have the right atrium and the right ventricle. Correct? So, and then this is fully covered by fluid. It has so much fluid over here. So when the left ventricle is contracting, this pressure will displace the fluid in such a way that the atrium collapses. Does it make sense? Systolic right atrium, meaning when the left ventricle is contracting, the fluid is displaced in such a way that it collapses the right atrium, because this is a smaller, low pressure chamber.
Yeah. And
correct?
Yeah, correct.
Similarly, the left ventricle diastolic, when the diastolic, meaning what? They are referring to the left ventricular relaxation. So when the left ventricle relaxes, again, the fluid is pushed in such a way that the right ventricle is collapsed. So does that make sense?
Okay, so when systole happens, contraction happens, then fluid will compress the right atrium. And when the heart is trying to fill the ventricle, so it will collapse the right ventricle, right?
Correct.
Diastolic
Because it has
right
no
ventricle.
room, right? It has no room. All this is filled with fluid outside. So the only way for it to go is like this and push collapse the right ventricle. So that's why.
Thank you so much.
No problem. I don't know if my random images are making any sense, but lots of color. All right. So next we have pulsus paradoxus, which they test a lot, are clues for us to diagnose. So what is pulsus paradoxus? There's a decrease in amplitude of systolic BP by more than 10 millimeters during inspiration. So increased venous return. So one more time, what is pulsus paradoxus? It's a decrease in amplitude of the systolic blood pressure by more than 10 millimeters during inspiration. Increased venous return during inspiration. Increased venous return, yeah. So normally when we inspire, like we said earlier, chest wall opens up. There's more venous return, more right ventricular filling. But then now it's in a closed cavity with this extra fluid. So the interventricular septum bows towards the left ventricle due to pericardial compliance. So that causes decreased left ventricular ejection volume and decreased systolic blood pressure. So this is kind of opposite to what we saw here. So during inspiration, that in extra, what do you call it? When we expand the chest cavity, this extra venous return and the right ventricle is now filled. So this right ventricle is filling. Again, it has no room because we have fluid around here. So this will bow the interventricular septum towards the LV. So now LV is collapsed. So opposite of this, what we saw earlier. So now LV is collapsed due to pericardial compliance. Again, because the fluid moves around in such a way that the LV is collapsed. So now LV cannot eject into the aorta. So decrease LV ejection volume, decrease systolic BP. So which is what we're seeing clinically as decrease in BP during inspiration. Make sense? No?
Yeah.
Should I repeat? Or if someone else wants to pitch in, Dr. KB?
I think you're right. So if you could draw your thing again, the 4 chambers. Yeah.
Sure. Let me see. Let me use, should have logged in from my iPad. So we have the left atrium, left ventricle, for example, and then we have, sorry, give me a sec. So then we have the right atrium and the right ventricle, for example, just visual representation. And then we have all this surrounded by a capsule, but this capsule is now filled with fluid or blood or whatever the fluid is accumulating, so effusion. Go ahead.
Yeah, so I think you're saying that. So normally in inspiration, you have increased preload. So you have a lot of blood coming through the right atrium into the right ventricle, and that blood goes into the left side. But this time, because you have some pericardial fluid constricting how well the right ventricle can take in the increased preload, the fluid still has to find some space. So the fluid distends or pushes against the interventricular septum towards the left ventricle. So you have more fluid in the right ventricle than what you have in the left ventricle. So what happens is that per the Frank-Starling mechanism, you have decreased left ventricular sarcomere or fiber length. So your ejection fraction and your contractility will decrease. And that is what will decrease your blood pressure, which is paradoxical to what we normally see in normal inspiration. Because in normal inspiration, your blood pressure is supposed to go up by at least 10 millimeters of mercury. But this time we are going to decrease it because of this less contractility from the fluid. Yeah.
Nice. Thank you so much. Does that make sense?
Yes, thank you so much.
Visualize it, it makes sense. Yeah. Okay. All right. So yeah, normally when we inspire, it should it should be a
it should increase.
drop.
Yeah.
No, it should increase.
It should increase. So inspiration increases your cardiac output and your blood pressure. Yeah.
Yeah. When we expand the chest, more coming to the right atrium, more coming to the right ventricle, somehow it comes to the left side. So more volume, more pressure. Okay. Yeah. And actually from the Frank-Starling, the way you said that, yeah. So Frank-Starling, so there has to be increase in blood pressure, but here it's not happening because this fluid that's coming in has no room to go. It's pushing the interventricular septum in such a way that now there's lesser stretch, lesser output. So decrease left ventricular ejection volume, thereby a decrease in the blood pressure. Oops, why is it not going? Okay.
So Sarah, it will go towards the left ventricle, right? So that's why left ventricular ejection volume is decreased and systolic BP will go down.
Yeah, it's bowing. So yeah, we can say just visually, you can say that less volume also and less stretch as well, right? Because now there's less room for the myocardial individual fibers to stretch. So if there's less stretch, they cannot contract more. So it's like a rubber band, right? The more you stretch, the more you can push out. So here we're not able to stretch as much. So we cannot eject out more. So that's why there's decreased left ventricular ejection volume. And you can also say visually, you can see that there's less space for the volume to fill in. So less will go to via the aorta. So decrease systolic BP. If you break it down, why the decrease in LV volume, then you go into the Laplace law and wall stress and everything. But even visually, if you see, it makes sense, right? This is bowing inside. So now decrease will be ejected. Actually, no, this my diagram arrow is wrong. From left atrium, left ventricle should be at this side to the aorta. So decrease LV ejection. If less blood is going in the aorta, that's pretty much systolic blood pressure. So decrease systolic blood pressure. Make sense? You good?
Very nice, Saira. Very nice, Dr. KV. Thank you.
Thank you. Thank you, guys. Okay, so next. So yeah, we're done with this, right? Let's move on. So where was I? So seen in, where do we see pulsus paradoxus? We see it in conditions like, so the mnemonic is P-COAT. P for pericarditis, COAT for croup, OSA, asthma, and COPD. So pulsus paradoxus, we see it in P-COAT. So what is pulsus paradoxus? Decrease in amplitude of systolic BP by more than 10 millimeters during inspiration. Okay, let me move on. Thank you, thank you. So next we have syncope, transient loss of consciousness caused by a period of decreased cerebral blood flow. Types are reflex syncope, orthostatic syncope, and cardiac. So we have quite a few questions on this. Reflex is most common vasovagal. If you'll remember that question between the patient getting a vaccine and blah, blah, blah. And now it's all about thinking about hypersensitivity reaction. But actually she was just scared of the needle and she had a vasovagal syncope. You remember that? That was really tricky. So yeah, it could be a reflex vasovagal syncope. It could be situational, like coughing or sneezing, swallowing, defecation, or micturition. So that's situational. And carotid sinus hypersensitivity. So yeah, we have questions on that too. Next is orthostatic hypotension, hypovolemia, and drugs like antihypertensive, autonomic dysfunction. Cardiac, we have arrhythmia, structural, like in the case of aortic stenosis and HOCM. Okay, then we have infective endocarditis and non-bacterial thrombotic endocarditis. Okay, so what do we have about infective? So this is infection, as the name says, endocardial surface of the heart, typically involving more than one heart valves. So it's caused by bacteria more than fungi. Forms are acute and subacute. So acute, classically Staph aureus, which is high virulence, large destructive vegetations as seen on A. So yeah, they put a scale, so that's pointing. So yeah, this is the vegetation. Okay, so large destructive vegetations on previously normal valves. So previously normal, keyword, previously normal versus, so yeah, and this is rapid onset. So Staph aureus, main thing. Subacute, it's classically Readathon strep, low virulence, smaller vegetations on congenitally abnormal. So yeah, this is previously normal versus here it is congenitally abnormal or diseased valves. Sequelae of dental procedures, gradual onset. Okay. Readathon strep, because they form the dextrans. So when the patient gets a dental procedure, it goes to the heart and then causes an endocarditis. Anyone remembers what kind of organism Readathon was? We said dentist, so we don't like to go. So it was optokin resistant, PIYR resistant. And there was another mnemonic which Dr. Rahul had shared. Anyone?
Bile resistant.
Say again, sorry?
It's bile resistant, right? Viridance.
Was bile for this? Let me check. No, it was virile. Let me see. Viridance.
Bile resistant means grow in bile.
This was not bile soluble. Yeah, bile resistant. You're right. Yeah, it's optokin sensitive. No, actually, it's optokin resistant and bile insoluble, both, as you said. Yep, it's bile insoluble. Thank you. So going back. Yep. So it is optokin resistant, does not grow in bile. Or bile solubility negative. Okay. So sequel of dental procedures, gradual onset, and then presence with fever, most common, new murmur. So yeah, new onset murmur is usually a clue. Fever is a clue, fever and heart disease, most likely endocarditis. Vascular immunologic phenomena. So we have vascular phenomena and immunologic phenomena. What are these? Septic embolism, petechiae. So vascular phenomena are septic embolism, petechiae, splinter hemorrhages, which are linear hemorrhagic lesions on nail bed. So on nail bed, which is seen here, Janeway lesions, which are painless flat erythematous lesions on palms or soles. Immunologic phenomena, immune complex deposition, glomerulonephritis. So oscillars nodes, painful ouchy, raised violaceous. So oscillars, so painful ouchy, raised violaceous lesions on finger or toe pads, and rot spots, which are retinal hemorrhages with pale centers. So yeah, we saw this somewhere, I think. So yeah, retinal hemorrhage with this bleeding with some pale areas. Actually, no, the same one. So we are seeing the hemorrhage with this pale center in the middle. Okay, so oscillars ouchy versus something else which were not painful. Anyway, so this is associated with glomerulonephritis, oscillar nodes, rot spots. So mitral valve is most common, more than the aortic valve. Tricuspid valve involvement is associated with injection drugs, drug use. So don't try drugs. This was the mnemonic. Common associations is prosthetic valves, epidermidis, GIGU, enterococcus. We saw this in micro, colon cancer, galolyticus. And then there was another bug we said was colon, what was it? Galolyticus and
what was that?
Malignancy. Sorry?
That was something septicum. What was that? Cholesterol.
Septicum, which was associated with colonic malignancy. Clostridium, yeah. Clostridium septicum. That was the one. Nice. Thank you, Nilu. So yeah, colon cancer, and that was associated with colonic malignancy. So gram-negative is Haystack organism, which is Haemophilus aggregatibacter, formerly Actinobacillus. C is Cardiobacterium, Echinella kingella. So culture negative, Coxiella. So gram-negative is these organisms, Haystack. Culture negative is Coxiella bartonella. Injection drug use is Pseudomonas aeruginosa, Pseudomonas, what am I saying? Staph aureus, Pseudomonas, and Candida. So then we have endothelial injury can lead to formation of vegetations consisting of platelets, fibrin, and microbes on the heart valves, leading to valve regurgitation, septic embolism. So what is septic embolism? So systemic circulation in left-sided endocarditis and pulmonary in right-sided. Diagnosis requires multiple blood cultures and echo. Okay, so this was the vegetations. This was the nail splinter hemorrhages. Splinter hemorrhages, yes, thank you. And this was the ouchy oscillar nodes. And this was the rot spots with the pale center. Okay, cool. What about non-bacterial thrombotic endocarditis? These are also known as merantic. Merantic in Greek, meaning Greek word is merantikos, which means wasting away, which is related to the wasting state in cancer. So anytime you see merantic, think cancer related. So rare, non-infective. Vegetation typically arises on the mitral or aortic valves. So here we said mitral more than aortic for infective. Here also it is mitral or aortic, but they consist of differences. Here it is no infection, sterile, platelet-rich thrombi that dislodge easily, usually asymptomatic until embolism occurs. So associated with hypocoagulable states, so that makes sense. So seen with advanced malignancy, as we know, that's a hypocoagulable state, especially pancreatic adenocarcinoma. And yeah, that's another clue is, I think I heard it in BNB. He says, anytime you hear migratory thrombophlebitis, I don't know if it's BNB or Dr. Sattar. So they say, anytime you hear migratory thrombophlebitis, think cancer. So I think usually it was pancreas or colon. And anytime you hear merantic, that also is cancer and usually pancreatic adenocarcinoma. Or SLE called Lieben-Sachs endocarditis in this setting. So yeah, either pancreatic adenocarcinoma or SLE. If SLE is causing the non-bacterial thrombotic endocarditis, that is known as Lieben-Sachs. Okay, so done. Next, we have rheumatic fever. We are all familiar with this. So consequence of pharyngeal infection with group A, beta hemolytic step. Late sequelae include rheumatic heart disease, which affects the heart valves, mitral more than aortic again, but aortic more than tricuspid. So high pressure valves are affected most. Early valvular regurg, late valvular stenosis. Early valvular will cause regurgitation, late valvular will cause stenosis. Then this is associated with Askoff bodies. This comes up. What are these? These are granuloma with giant cells. Anyone remembers the cells we see in measles complication?
Pneumonia with giant cell.
Warthin. Something.
Yes, that one. Orthin, Finkel, D, Finkel, something. They are the fused giant lymphocytes, I think. So yeah, just recalling from the giant cells. So those are Worthin, Finkel, D, something, something. So that's associated with measles. Here we're seeing granular Ashkoff bodies. What are Ashkoff bodies? Granuloma with giant cells. And then we have Anichkov cells also. These are enlarged macrophages with the ovoid, wavy, rod-like nucleus. Increased ASO titer and increased DNase V titers. We saw this in when we did micro. Increased ASO titer and increased anti-DNase B titers. Because these are released by the strep. So the antibodies to the streptolysin and antibodies to the DNase. But then the question said was, you do a strep, what was it? The throat swab and then start empiric treatment. That's some weird, funny question, if you remember on UWorld. But anyway,
yeah,
so
throat swab, an outpatient service, an outpatient throat swab, I think is more rapid.
That was the catch, right? Because it's rapid, we know the diagnosis rapidly, we use that. Even though this is more specific, because we want to start rapid treatment, that was the answer.
Yeah, so culture we don't do normally because it takes time.
Yeah, correct. You're right. Thank you. So then, rheumatic fever is associated with immune-mediated type 2 hypersensitivity. It's not a direct effect of the bacteria. This gets tested, right? We've seen a question, I think. It's immune-mediated type 2 hypersensitivity. It is not a direct effect of the bacteria. Antibodies to M protein, yeah, molecular mimicry. Antibodies to M protein cross-react with the self-antigens, often on myosin of the heart. So molecular mimicry, treatment with penicillin. Jones criteria is joint, which is migratory polyarthritis, heart, carditis, nodules in skin, subcutaneous, erythema marginatum, evanescent rash with the ring margin, Sydenham scoria, which is involuntary regular movements of the limb and face. Okay, then, yeah, I think in our older group, if you watch the video of Sydenham scoria, you can never forget. Involuntary irregular movements of the limb and face. I'll try to find it. Note. So yeah, Sydenham scoria.
Then, and they have minor criteria as well, I think, which they have a fever, ESR increased, ESR, CRP is increased, arthralgias are there, and prolonged PR interval with leukocytosis.
Say again, please.
Yeah,
I have no memory.
Fever, CRP and ESR increased, arthralgias are there, leukocytosis is there, and prolonged PR interval.
Yeah. This is on UWorld, right? But, as a table, I think.
Yeah, this is minor criteria, but I think this was major criteria is like major. So.
Yeah. No, it's good to know there are clues on the question. So thank you. And okay, so that's rheumatic fever, major and minor criteria. Next, going on to syphilitic heart disease. This is tertiary syphilis. We saw this somewhere before. So tertiary syphilis disrupts the vasa vasorum of the aorta with the consequent atrophy of the vessel wall and dilation of the aorta and valve ring. So tertiary syphilis disrupting the vasa vasorum. Yeah, the buzzword is vasa vasorum endarteritis. So this is specifically happening where? In the aorta with consequent atrophy of vessel wall and dilation of the aorta and the valve ring. So then we may see calcification of the aortic root, ascending aortic arch, as well as the thoracic aorta. Leads to tree bark appearance of the aorta. Can result in aneurysm of ascending aorta or aortic arch and aortic insufficiency. Tree bark appearance of the aorta. Let me see. Yeah. It looks like a tree bark. Marked aneurysm dilation of the aortic root with extensive, I believe, tree barking. Not sure. Yep. It does look like a tree bark. Okay, so back to where we were. So that tree bark appearance is seen in syphilitic heart disease. And then they asked the question, I think I've mentioned this before too, but for the 100th time, vasa vasorum, and then they ask about what else do you see? The answer is gummas. Then next is
And on
acute.
histology, what do you find? Lymphoplasmacytic infiltration, right?
Yeah, correct. Was for this one, lymphoplasmacytic infiltration. Yeah,
But,
that's
yeah.
yeah. And then we said it was what the type of granuloma was caseous, massively caseous. We found out, right? Someone had found online. Yeah. And this can cause ataxia, Romberg sign, and Charcot's joint, stroke without hypertension, vasa vasorum destruction, tabes dorsalis, and Arigal Robertson pupil. And tertiary syphilis, we treat with penicillin if allergic, ceftriaxone. Okay, all right, sorry, back to this. Okay. So next is acute pericarditis. There's inflammation of the pericardium, shown in red arrows in A. So the pericardium, if you see, this is inflamed. And then commonly presents with sharp pain. Yeah, this is a classic buzzword. Sharp pain aggravated by inspirations. So inspiratory chest pain relieved by sitting up and leaning forward. Often complicated by pericardial effusion, which is between the yellow layers. So yeah, this is very nice image. So pericardial effusion between the yellow arrows, A, okay. So presence with friction rub, as you know, friction rub is buzzword for pericarditis stuff. ECG changes include widespread or diffuse ST elevation and or PR depression. Yeah, usually idiopathic, but maybe due to viral infection like Coxsackie B, malignancy, metastasis, cardiac surgery, thoracic radiotherapy, early, MI, post-cardiac injury syndrome, autoimmune disease like SLE and rheumatoid, renal failure, uremia. Treatment is NSAIDs, colchicine, glucocorticoids, dialysis, and uremia. So next we have constrictive pericarditis. There is a chronic inflammation of the pericardium. Chronic inflammation leading to fibrosis with or without calcification, limited space for expansion, causing decreased ventricular filling. So it's usually idiopathic, but maybe due to viral infections, cardiac surgery, and radiotherapy, similar to this one. Cardiac surgery, radiotherapy. Oh yeah, viral infections. So it can cause acute pericarditis or constrictive pericarditis in the late stage. Yeah, early was acute pericarditis, late was constrictive pericarditis. TB is the most common cause in resource limited countries. Decreased end-diastolic volume. So volume remaining at the end of diastole is decreased because of the pericardial inflammation. So it cannot, it's not compliant anymore. So decrease EDV, decreased cardiac output, decreased venous return. Presence for dyspnea, peripheral edema, JV distension, Kussmaul sign, pulses, paradoxus, which we saw just now, and pericardial knock, which is usually a buzzword. What was Kussmaul sign? I forget. Kussmaul sign. Let me see.
It's in next page, Sarah. Next
Okay,
page.
it's coming up. Okay, perfect. All right, thank you. So this was the image showing constrictive pericarditis with a water bottle heart, right? I think this was shared in the group when we did the previous sessions. It's a good image. Okay, right here. Thank you. So what is Kussmaul sign? It's a paradoxical increase in JVP on inspiration. Normally, inspiration will, there is a negative intrathoracic pressure. So air is getting sucked in. So that's why it's a negative intrathoracic pressure, which increases venous return, and there's a drop in JVP. There should be a drop in JVP, but in these patients, because of the pericarditis or due to other reasons, there's a paradoxical increase in JVP on inspiration. So again, impaired RV filling, as in the case of a pericarditis, for example, or impaired RV filling due to any cause, the RV cannot accommodate in the increased venous return which occurs during inspiration. Blood backs up into the vena cava and causes a Kussmaul sign. It may be seen with constrictive pericarditis, restrictive cardiomyopathy, right heart failure, massive pulmonary embolism, right atrial or ventricular tumors. Okay, so that's Kussmaul sign. Next, we have myocarditis.
Sorry, Saira, what's the major difference between acute and chronic pericarditis other than the different one or two words, fibrosis?
Let's see. So this will have sharp
Friction
pain.
rub is present in acute pericarditis, right? But not
Yeah.
in chronic.
Not in chronic, yes. So first of all, the pain, because it's itis and it's acute, it's going to have pain. Second is the friction rub. Then is the ECG changes, widespread diffuse ST elevation, and PR depression. So yeah, that's the main thing. 3 things for acute pericarditis. Oh yeah, actually I missed this. I think treatment was NSAIDs, colchicine, glucocorticoids, dialysis, and uremia. Did I read this? Let me read it again. So acute pericarditis is usually idiopathic, but maybe due to viral infections like Coxsackie B, malignancy or METS, cardiac surgery, thoracic radiotherapy, early phases, MI, post-cardiac injury syndrome, autoimmune disease like SLE, rheumatoid, and renal failure, uremia. So it makes sense that treatment is NSAIDs to reduce inflammation, colchicine, glucocorticoids, dialysis, and uremia. Okay. Yeah, so 3 things: pain, friction rub, ECG changes. Versus constrictive pericarditis, it's fibrosis, so decreased ventricular filling. So this patient will present with dyspnea, peripheral edema, and JV distension. Kussmaul sign, pulses, paradoxus, pericardial knock. So for us, for the sake of boards, here we look for pain, friction rub, and ECG changes. Here we look for Kussmaul sign, pulses, paradoxus, or pericardial knock will be the buzzwords. And of course, dyspnea makes sense, but that's a very non-specific sign. JV distension, okay. Kussmaul sign, pulses, paradoxus. So these 3 should be the main clues.
Pericardial knock, and what was pericardial knock? Sorry, I cannot recall it.
Pericardial knock was, let me check, I'm not sure either. High-pitched early diastolic sound. Diastolic sound that occurs when unyielding pericardium, results in a sudden arrest of the ventricular filling. So makes sense, right? Ventricle is not filling because of the pericarditis, which has occurred chronically. So when the blood is filling, so it's a high-pitched early diastolic sound that occurs when unyielding pericardium results in sudden arrest of ventricular filling. Kind of like S4,
so pericardial
right?
knock.
Stiff ventricle.
Yeah, sort of, because it doesn't allow the heart to properly.
So heart valves have lost elasticity, reducing the ability to close completely. So yeah, pericardial knock. Okay. Okay, so that was comparison between acute and constrictive pericarditis.
And we see water bottle sign in constrictive, right?
Yeah, constrictive.
Okay.
No. Was it? No, I think I put it here, but it was for.
I think it was cardiac tamponade, no?
Yeah, I think it was for tamponade. Yeah, I don't know why I put it here. Water bottle heart was for tamponade. Yeah, it's not for this. I think this was also showing paradoxes, so maybe I just searched the wrong page and put it. Yeah, thank you. That was a good catch. It should have been here. But constrictive pericarditis also leads to, paradoxes. So I think I might have searched for paradoxes to put and then put it in the wrong place. Thank you. Yeah, this is wrong. It can lead to paradoxes, and then that's the connection. So pulsus paradoxus will be seen in tamponade as well as pericarditis. So that's why I probably was confused.
Yeah, so the water bottle sign is mostly in the cardiac tamponade.
Tamponade, yeah. Yes.
Yeah, thank you.
Yes. Thank you. Okay, so then, we did Kussmaul sign. How are we doing on time? It's before farm, maybe we should take a break. Okay, let me just finish the page and we'll see. Okay, so myocarditis was next. As the name says, itis, so inflammation of the myocardium, major cause of sudden cardiac death in adults less than 40 years old. Presentation is highly variable, can include dyspnea, chest pain, fever, arrhythmias, persistent tachycardia out of proportion to the fever is characteristic. So presentation is highly variable and can include dyspnea, chest pain, fever, arrhythmias, and there's persistent tachycardia out of proportion to the fever is characteristic. Okay, so this is the key clue for myocarditis. Tachycardia out of proportion to the fever. Multiple causes: viral, parasitic, bacterial, toxins, rheumatic fever, drugs, autoimmune. What are the viral? Adenovirus, Coxsackie B, parvovirus B19, HIV, HHV6, COVID-19. Lymphocytic infiltrate with the focal necrosis is, this is key, this is important. Lymphocytic infiltrate with the focal necrosis is highly indicative of viral myocarditis. Then parasitic Trypanosoma cruzi, Toxoplasma gondii, bacterial Borrelia burgdorferi, Mycoplasma pneumoniae, Corynebacterium diphtheriae. Toxins, carbon monoxide, black widow venom. It's a spider, right? Black widow spider venom. Okay. So that can cause myocarditis, yeah. And then rheumatic fever, drugs, doxorubicin and cocaine. Autoimmune Kawasaki, sarcoidosis, SLE, polymyositis, and dermatomyositis. And this is, we said this was CD8, this was CD4, or was it switched? Something, it's coming up later though.
Dermato is, I think, DP4, so yeah, CD4, dermato.
This is, yeah. Poly was more, so this was CD8, yeah.
Yeah.
That's what we said, yes. So complications, thank you. Complications include sudden death, arrhythmias, heart block. So complications of myocarditis, what are they? These are sudden death. So yeah, because it's a major cause of SCD in less than 40. So that will be the main complication. Then arrhythmias, then heart block, then dilated cardiomyopathy, heart failure, mural thrombus with systemic emboli. Okay, cool. So next we have hereditary hemorrhagic telangiectasia. So yeah, this is high yield. Multi-system, so it comes up Osler-Weber-Rendu syndrome. This is autosomal dominant disorder of blood vessels. Findings are blanching lesions, which are telangiectasias on skin and mucous membranes, recurrent epistaxis, AVMs, GI bleeding, and hematuria. AV malformation, so there's abnormal high flow connection between the artery and the vein. What was the one with the anosmia? The syndrome, the anosmia.
Syndrome?
Sorry?
Kallman syndrome?
Kallman syndrome, thank you. Yeah, that was Kallman syndrome. But this is Osler-Weber-Rendu, which is the hereditary hemorrhagic telangiectasia. Yep. Okay, cool. Thank you. So next we have cardiac tumors. The most common cardiac tumor is the metastasis. This is a melanoma. Yep, this was important. Melanoma goes to the, so most common cardiac tumor is melanoma. Myxomas, this comes up. Myxoma, the most common primary cardiac tumor in adults is an atrial myxoma. And yeah, it's a myxoma and 90% occur in the atria. So most common cardiac tumor, atrial myxoma, mostly in the left atrium. Myxomas are usually described as a ball valve-like obstruction in the left atrium associated with multiple syncopal episodes. So IL-6 production by tumor, and IL-6 was the acute phase reactant, correct? The K in the hot T-bone steak.
Yes.
Yes, thank you. So IL-6 production by the tumor leads to constitutional symptoms like fever and weight loss, may auscultate early diastolic tumor plop sound that mimics the mitral stenosis. This is early diastolic tumor plop sound that mimics MS. Histology, there's a gelatinous material, myxoma cells immersed in glycosaminoglycans. This is mentioned in the question, I think. GAGs. Adults make 6 mixed drinks. To remind us, adults, most common primary cardiac tumor, make 6 IL-6 mixed for myxoma drinks. Okay. And then that makes them gag to remember glycosaminoglycans. So rhabdomyomas, most frequent primary cardiac tumor in children associated with tuberous sclerosis. Histology, there's hematomatous growths. And these are most common in the ventricles. So primary cardiac tumor in adults is an atrial myxoma. Primary cardiac tumor in children is the ventricular rhabdomyoma. Okay, cool. So next, so we have 1, 2, 3, 4, 5, 6, 7, 8 pages more. Okay. Should we take a break and come back? 15 minutes break. So starting with cardiovascular pharmacology, we have hypertension treatment, primary essential hypertension, hypertension with heart failure, hypertension with DM, hypertension in asthma, and hypertension in pregnancy. Yep. Okay. All right. So what is the treatment for primary essential hypertension? It is thiazide diuretics, ACE inhibitors, AT2 receptor blockers, ARBs, or dihydropyridine calcium channel blockers. What about treatment for hypertension with heart failure, diuretics? So this we said A, B, C, D. So ACE inhibitors and ARBs. B was beta blockers. Actually, no, A was ARBs, B was beta blocker. The C is for C, ACE inhibitors, and D was diuretics. So yeah, aldosterone antagonists as well, which was spironolactone. Yeah. So hypertension with heart failure, we gave ACE inhibitors, aldosterone antagonists, B for beta blockers, and diuretics. So beta blockers must be used cautiously in patients with decompensated heart failure and contraindicated in cardiogenic shock. So this gets tested, right? So it must be used cautiously in patients with decompensated heart failure, and they are absolutely contraindicated in patients with cardiogenic shock. Yeah, which makes sense because as it is, the pump is, well, the left ventricle is not pumping out. So if you give a beta blocker, it's even more going to get worse. So in heart failure, ARBs may be combined with a neprilysin inhibitor. So yeah, ARB, neprilysin inhibitor, sacubitril combo for heart failure. So hypertension with DM, what do we give? ACE inhibitors, ARBs, calcium channel blockers, thiazides, and beta blockers. So yeah, ACE and ARBs are protective against diabetic nephropathy. So that's why they're beneficial. And beta blockers can mask hypoglycemia symptoms. Okay. Yeah. Beta blockers can mask hypoglycemia symptoms. This gets tested a lot. Then we have hypertension and asthma, ARBs, which is angiotensin receptor blockers, calcium channel blockers, thiazide, and cardioselective. Avoid non-selective beta blockers to prevent beta-2 receptor. Sorry, one more time. Avoid non-selective beta blockers to prevent beta-2 receptor-induced bronchoconstriction. Yeah, we said the other day beta-2 was in the lungs, 2 for lungs. So non-selective we shouldn't avoid to prevent the beta-2 receptor-induced bronchoconstriction. Avoid ACE inhibitors to prevent confusion between drug or asthma-related cough. Yeah, this is important. That's why they didn't put ACE here. It was only ARBs. We avoid ACE to prevent confusion between drug-induced cough or asthma-related cough. Then hypertension pregnancy, yeah, new moms love hugs or hydra-LMN. New moms love hugs is for nifedamine, methyl-dopa, labetalol, and hydralazine. Yeah, this is important.
Someone gave the mnemonic. Do you remember ABCD something?
Sorry, I can't hear. Your voice is very far away.
Someone gave the mnemonic just ABCD for all these drugs.
Yeah. For all of them, right? Exception is here we don't have ACE inhibitors. So I think A was aldosterone antagonist, B was the beta blockers, C was a we highlight the C, so ACE inhibitors. C sounds like so. C was for C inhibitors. D was diuretics. So that's hypertension and heart failure. Here also we have. So yeah, certain exceptions I think we have to remember. Here ACE and ARBs, calcium channel blockers, and thiazide and beta blockers. What we don't give is, we have to be careful with beta blockers. I think that's a question, right? Although beta blockers may mask hypoglycemia symptoms, it's still beneficial, benefits outweigh the risk. So we just have to be careful. Was it for beta blockers? I'm not sure.
Yeah, beta blockers can mask hypoglycemia symptoms. I think they will catecholamine-induced sweating and all these things. But I think sweating will be preserved. All these tremors and all these things
are blocked off, right? Yeah, that was the thing. What is the next, like the exception to the rule, which still continues, was the thing. Tachycardia is not there. I think sweating also goes away, right? Not sure.
Sweating is, I think, under the influence of that.
Oh yeah.
Sympathetic, no?
Muscarinic. Yeah.
Muscarinic, yeah, something like.
Yeah. So that's why that is continues to be there. Okay. Yeah. Sweat was the renal. That was the exception to the rule. Was it?
And this beta 2 induces bronchodilation normally, right?
Yeah, bronchodilation, yes. 2 for the lungs, but bronchodilation, yeah. Beta 2 was for bronchodilation, yes. And the other one we were saying is the adrenergic pathway. Yeah, this one. The sweat glands was, yeah, my M receptor, so that was exception to the rule. So that will remain, yeah. So back to page number, did I say? 321. Okay. Yeah, so beta 2 beta blockers can mark hypoglycemia symptoms. The other thing important here is we avoid non-selective in asthma patients to prevent the beta 2 receptor induced bronchoconstriction. With the beta 2 blocker, if we give a non-selective beta blocker, then we avoid ACE to prevent confusion between drug or asthma-related cough. So these are important points. This one, yeah. Okay. And then primary essential hypertension, pretty much all of them, right? Thiazides, ACE inhibitors, ARBs, dihydropyridine, calcium channel blockers. Okay. So ABCD for heart failure, same ABCD for this also, right? ACE and ARBs, B beta blockers. So the C here is the calcium channel blockers, and ABCD for diabetics, not the diuretics. Actually, yeah, same. Diuretics. So both ABCD for both of these. No, calcium channel we don't give in heart failure. So that's only for diabetes. I'm just trying to see a pattern here. Here we have ACE, ARBs, but ACE are avoided in asthma. Beta, again, beta blockers. C, calcium channel, yes. D, diuretics, yeah. So pretty much ABCD for this page. And for this one, LMN, which is, or new moms love hugs. So nifedipine, methaldopa, labetalol, and hydrolysine. Okay, cool. So next we have our favorite page. Hamna, do you want to try? No, you're better at this than me. Okay, let me see.
Shruti will do better job here. Shruti.
I'm not so great, but I'll pitch in definitely if I know.
No, because I forget about it. Sorry.
I didn't
Okay.
attend this session actually. This when FA was going on.
In the bigger group, okay. Night, I don't think I did either. Okay, let me try, and then we can all pitch in. Okay, so what is happening is we have so this is the cardiomyocyte, cardiac smooth muscle cell. And then we have seen three main things. We have GS, so stimulatory, GI pathway, and GQ pathway. So let's focus on the GS side. Yeah, I wish Shireen was here. I think she's also really good at this. She's not here. Okay, so GS, GI, and GQ. And then we have the NO pathway. All right, so let's see what's going on. So GS pathway, it's G stimulatory. So it's going to stimulate adenylyl cyclase. What does adenylyl cyclase do? It converts ATP to cyclic AMP. Cyclase, so ACE, it removes something. So it's removed a phosphate group. So now it is cyclic AMP. Instead of adenosine triphosphate, it's a cyclic AMP. This AMP is now activating pKa, which is protein kinase A. So these are the downstream effects. When the receptor binds to the substrate, for example, if epinephrine binds to beta 2, it will work via the G protein transmembrane coupled pathway, right? So this is what is happening. By giving epi, which is active on the beta 2, we are causing activation of GS. GS will cause stimulation of adenylyl cyclase. Adenylyl cyclase will activate ATP to CAMP. CAMP will activate protein kinase A. Protein kinase A normally inhibits phospholambin. So this is job of pKa is to inhibit phospholambin, PLB. PLB's job is what? To inhibit the SERCA. So but now pKa is active. So this is inhibiting. Inhibiting the inhibitor is, so now, okay, so normally phospholambin inhibits the SERCA. So by pKa inhibiting this, we're removing this out of the picture. So now the SERCA is free. It's relieved of the thing that is stopping it. So calcium will come in, and there is decrease cytosolic calcium, increase calcium. So SERCA's job is to what? Accumulate all the calcium and collect it. It's a calcium assimilator of sorts. So that is come in, and now we have decreased cytosolic calcium concentration. If we have decreased cytosolic calcium concentration, what happens? We are relaxing. So relaxation means myosin and actin are converted to a myosin P plus actin by MLC kinase. No, actually, no, it should be this side, right? Phosphatase, so myosin and actin are now relaxed. Okay, so I think this is a whole separate pathway. So because there is drop in the calcium and calcium has been sequestered inside the SERCA, that's causing relaxation. So we finished this side. Another thing here to notice, CAMP is now converted back to, it's the cyclic part is converted back to AMP by the enzyme phosphodiesterase. So that's the enzyme here, inhibited by milrinone. And PDE3 inhibitor. So we said milrinone will inhibit the PDE3. If it's inhibiting the PDE3, we're reducing the breakdown of CAMP. So more and more CAMP will go and do its job. So net effect is relaxation.
So Saya, PKA will inhibit phospholamban. So phospholamban will no more inhibit SERCA.
Correct.
So SERCA will keep on accumulating all the cytosolic calcium in it, right?
Exactly. SERCA's job is to what? Sarcoplasmic reticulum. What is the name? Sequestering calcium, right? So it will
sarcoplasmic reticulum, sarcoplasmic endoplasmic reticulum calcium ATPase pump. This is ATPase, I think. SERCA, right?
Yeah, it is ATP bound. It's an active pump. Yeah. So this will sequester all the calcium. So now if we have reduced calcium, what happens? We are relaxed. Always calcium equals contraction. If you have reduced calcium in the cytosol, because where is all the calcium now? Increase, it's stored in the SERCA. So now that's causing relaxation. So this part we have done. What's the drug working here? Milrinone PDE3 inhibitor. So what are the drugs that cause GS stimulation? We have epinephrine, prostaglandins, prostacyclin, phenoldopa, and adenosine. So beta 2 and D1 are GS coupled. Prostaglandins and cyclins also working through GS. You have to remember that. Yeah, I need to make mnemonics for these. And then adenosine. So yeah, adenosine, we know it's a muscle, it's a smooth muscle relaxant. So if you just connect it, then it has to be a GS coupled, it's a pathway. So we have done with this portion. So now coming to this side, what's happening here? We have a GI pathway. So GI is inhibiting adenylyl cyclase. So if it's inhibiting adenylyl cyclase, everything else opposite. So what happens? GI is going to cause contraction. Correct? So if there's no adenylyl, if we're inhibiting adenylyl cyclase, none of these downstream effects are going to happen. So ATP is not going to convert to CAMP. CAMP will not activate PKA. None of this will happen. Cytosolic calcium will continue to float around in the cytosol. Calcium will continue to float around in the cytoplasm. Thereby, that will cause contraction. So GI is going to do the opposite. So GI agonists are epinephrine and norepinephrine, which is alpha-2. And we know alpha-2 stimulation will lead to vasoconstriction. So that makes sense, right? This part is done.
Alpha-2 causes vasoconstriction?
Yeah, I want to catch her right there. Can you go back and think again, please, what you're talking? I think I messed up in my brain. The way you were going is alpha-2 inhibition. Am I wrong?
Alpha-2 will, okay, yeah, I think I might have
alpha-2 vasodilation, I think.
Vasodilate. But then it doesn't match.
No, yeah.
So this is stimulating GI. GI will inhibit, and so none of this relaxation is happening. So
yeah, if it inhibits cyclic AMP, so completely, and that cyclase it's inhibiting. So, don't you think PKA will be activated then? No, I don't know.
I thought adenylyl cyclase job was to convert ATP to CAMP. CAMP activates or activates PKA. So if we don't have adenylyl cyclase, meaning this is like in jail.
Okay.
So how
Okay.
does PK get activated? We don't have that activation, right?
Okay.
Yeah,
PK.
relaxation would happen. You're correct.
Yeah. Yeah. PK relaxation. Okay. Okay. But then alpha 2. Let me go back to the book. Alpha 2 does.
Alpha 2 is like decreased sympathetic. I mean, sympathetic innervation is there, but decreased sympathetic outflow would be happen through the alpha 2.
Okay, it's beta 2, which is for the lungs. So alpha 2 is again, yeah, you're right.
Beta 2 is on the lungs and on the vessel, and beta 2 is responsible for the vasodilatations. Alpha 1 is vasoconstriction, beta 2 is vasodilatation, and even on the vessel there is M3, which we are not using right now here. But yes, M3 is also on the vessels.
Nice.
Actually,
So
the
alpha
point is,
2, we said actually MAT2s, right? So it's going to be inhibited. So we remember
the
that
three.
that part is right. But now, what is it doing in this pathway is the question.
yeah, Saira. So alpha 2 agonism causes vasodilation by increasing nitric oxide pathway, right? But here what happens, yeah, it's true that it causes vasodilation, but here it inhibits cyclic AMP by stimulating GI pathway, right? So decrease cyclic AMP, but in cardiac muscle cells, it leads to more contraction.
She brings another concept here. Yes.
That's actually, I have written it from the previous.
Actually, that makes sense because you know what? GS, she is blocking the adenyl cyclase. So when that is blocked, otherwise cyclic AMP is going to do active relaxation, but this is blocking, so it is going to be contraction.
Yeah, it causes contraction here.
Yeah, that's the way it is.
So then it does make sense what I said, right? So GI agonism in the cardiac smooth muscle cell is causing contraction. Correct?
Yeah. Cardiac
So
is different from the smooth muscles. Yes, yeah.
I'm confused now. Sarah, can you please simplify it? Like because epinephrine has more effect on the beta than the alpha, remember? And like alpha effect on the epinephrine is on the higher dose. Like if you go, let's check the pharmac. Yeah, and
yeah, alpha 1, alpha 2, and beta 1, something. Epinephrine alpha 1, alpha 2, beta 1, beta 2.
Correct. And beta, on the beta, it is more effective than the alpha, right? I mean, correct me if I go wrong.
Not here. It should be pharma.
Yeah, in the pharmac.
But yeah, here. Beta is more than alpha.
Yeah. And if you go down also, you can, yeah, here only it's written, right?
If you go into that diagram, oh, sorry.
Yeah, Faz, you're correct. Like next page is that diagram which we have discussed. And
this one,
yeah.
So it has more effect on beta than alpha. Sorry, go ahead. Not able to, not audible actually.
As your voice is muffled a lot, like.
Sorry, go ahead, Shruti, go ahead.
No, go ahead. Like now it's clear. Go ahead.
Okay, there was remember that diagram that had MAT2 have M1, M3, and what was it? M1 and M3.
Have an M&M.
Yeah, that shows that how GI inhibits adenyl cyclase. It will decrease CAMP. So when it decrease CAMP, then you don't have the pKa will inhibit myosin light chain kinase. That's in GS, right? But in GI, once it inhibits CAMP, now you don't.
Bye. See you tomorrow.
Sorry, let me mute.
Sorry.
Yeah. Sorry, I was looking for have an M&M page. That's my keyboard for that page. You mean this one, right?
Yes, this one. Yep, on the left-hand side, the old book. If you see the old book, it explains it better. Here you go. On the bottom, it shows GI inhibits adrenal cyclase, so the whole process won't go on. Whereas if you go through GS, it increases calcium, but it inhibits the myosin light chain kinase.
So
There's no smooth muscle contraction.
Correct.
In
So
GS.
it means the relaxation, what Sarah has told before, right?
Yes.
Okay.
And basically inhibition of inhibitors, so relaxation. It's the opposite, right? Makes sense. But yeah, it is counterintuitive because we said alpha 2 is decreasing sympathetic outflow, but yeah, it's causing relaxation.
It's
Okay, yeah.
counterintuitive because we give them when the patient is like, in a very serious
Yeah.
condition, right? And
Because
then
it's
that time, yeah, you don't want to vasodilate that time, right? You want the heart to pump, but then in that picture, that big picture, they have given through the alpha 2, but in reality, it is more acting on the beta. So
yeah,
it is
so as I
quite
said, beta more than the alpha property from the other page we saw.
But Hamna was saying something which I did not means like I didn't understand that.
I am saying that alpha 2 agonism, normally it causes vasodilation by increasing nitric oxide, right? But in cardiac muscles, by stimulating GI pathway, it increases cyclic AMP. So if no cyclic AMP, then there will be, if no cyclic AMP, so no PK, right? So no relaxation of the cardiac muscle. So indirectly it causes more contraction of the smooth muscle. So it inhibits the MLCK pathway. It stimulates actually MLCK pathway because cyclic AMP inhibits MLCK. So it inhibits cyclic AMP. So MLCK kinase is not inhibited. So it leads to more contraction.
Yeah, that's what I was saying. Inhibition of inhibition is always contraction. Minus into minus is plus. So yeah, thank you, Amna. Does that make sense, Shruti?
Yeah. Now it is. Thank you, Amna. But please, Sarah, once again, you just means in the diagram, that diagram, no? Yeah, just like, I understood it was very clearly, Hamna said, like explained. Thank you. It's
yeah. Where is my page? Sorry, my good notes is also tired. It's lagging. Okay, here. Hamna, do you want to repeat, please?
Okay. So yeah, GI, normally GS is stimulating adenylate cyclase. So more cyclic AMP, more protein kinase A. So it will inhibit this MLCK pathway, right? MLCK and it leads to relaxation. But GI will inhibit the cyclic AMP, so inhibits PKA. So MLCK kinase is no longer inhibited, so it leads to more and more contraction. In smooth muscles, alpha 2 agonism will lead to increased MLC kinase. So more contraction. It will go into this contraction pathway. Got it? No?
Yeah, I got it. But where I was stuck, that when GI is inhibiting the adenyl cyclase, so there is no camp formation is happening, right? Like no camp is forming. When no camp is forming, then PK would be less, right? So everything would go less. But yeah, you're right.
But there is no PKA2 inhibits this pathway, right?
Correct. Makes
so
sense.
PKA is no there, so there will be no phospholambin inhibition. So no phospholambin will inhibit the SERCA pathway, so the calcium will keep on accumulating in the...
And more contraction would happen.
Yeah.
Thank
Yeah,
you.
but
so
the
much,
simplified
Hamna.
ways, this is not there. So none of this downstream effects are going to happen. So instead of sequestering in the circa, this is going to stay, this calcium is going to stay in the cytosol. And that's increased cytosolic calcium will cause contraction. So that's a simplified version. But yeah, what Hamna said was also nice. So here again, just to cement what she said, because we're inhibiting adenyl cyclase, there's going to be decreased camp. If there's decreased CAMP, there's going to be decreased pKa. If there's decreased pKa, there's no inhibition on PLB. PLB is free to do what it does. It inhibits the SERCA. So if SERCA is inhibited, no sequestering of calcium. Calcium floats around in the cytosol. Increased cytosolic calcium, contraction.
Yes, this is perfect. This is perfect.
Sarah, when we were doing that Pharmac page, no, then we all said that smooth muscle relaxation. Even I have written, and I think you also have written. So
yeah,
correct yours. I'm correcting mine, and I'm
yeah.
really
Actually, that's
terrible.
because I realized yesterday or day before that the older book had an error, and they've corrected it in the errata. This was a plus sign in the old book, and it was wrong. That's a great
Right.
mistake from such a small error.
Right, right. Thank you, Hamza and Dr. Tammy, for correcting.
Thank you so much.
Thank you.
Okay, so G1 agonists. So now it makes sense. Although epinephrine norepinephrine, we think of a life-saving drug, and we think of it as a increasing contractility. Yeah, in a way, yeah. So this is causing increased contraction. How? By alpha-2 and stimulating GI and causing increased calcium. Net effect is increased cytosolic calcium and increasing contraction. So this side we have done. So next, so yeah, what are these? So this drugs we finished. A G1 agonist, we did. Sorry, GI agonist, epi norepi. GS agonist, epi. So epi is working both on both pathways, and so it will kind of find a balance, I think. But then we said beta more than alpha, right?
Then
So
it's
it has a stronger
both
effect.
benefit.
Yeah, so EPIs has stronger effect on the GS. So anyway, so GS agonist is epi, prostaglandins, prostacyclin, phenyldopa, D1 and adenosine. So this is done. And then we also saw the PDE3 inhibitor working on the PDE3, which is breaking down the CAMP. So this pathway is done. So now coming on to this side, we have...
Can I ask a question?
Yeah.
Sorry. You said, actually, Hamna said in a smooth muscle, alpha-2 is working on contraction muscle, right?
Alpha-2 is
Yeah, it causes contraction here. This is a smooth muscle cell, right?
Yeah, it's a smooth muscle cell.
Yeah.
So alpha-2 in smooth muscle causes contraction. That's why it is different.
Okay. Thank you so much.
That's what we were saying. The conclusion was alpha-2 in a cardiac smooth muscle cell causes contraction.
Okay, thank you.
You're welcome. So that's done. So next we're looking at dihydropyridine calcium channel blockers. So we said these, what are the...
Sarah, cardiac, we have skeletal muscles, right? No?
Cardiac muscle is the cardiac muscles, no? Cardiac smooth muscles, no?
Smooth muscles like in the vessels, right? No?
It is, but myocyte is
Myocyte is a skeletal muscle. I'm sorry, I'm confused.
It
So
has
your
its own
question
property.
is cardiac myocyte is what type of cell, right?
Yeah. Is it
Isn't
skeletal
it
or
an individual? It has a different property.
Sure, I'm also confused. Let me...
Wait. No, I think it's...
This is going back to high school.
It's talking about vessels, smooth muscles.
Sorry?
It's talking about vessels, smooth muscles.
Yeah, these are talking about vessels. This is not cardiac muscle.
Okay. So then I misspoke. So I should have said cardiac smooth muscle cells, alpha-2 will cause contraction.
Because if you look at these drugs, sildenafil, prostaglandin, they all work on vessels, right?
Smooth muscle.
This is not cardiac cell. This is
Yeah.
not cardiac. This is the vessels.
There are 3 types of cells: skeletal, smooth, and cardiac is itself a type, which is very different from others.
Yeah, it's coming back from high school memory. So yeah, cardiac muscle is it has, this is one of the 3 types, which is skeletal, the other 2 being skeletal and smooth. So it is a striated type.
Yeah, striated. Sorry.
So yeah. but it's contracts, sorry, it also says cardiac muscle contracts in similar manner to skeletal muscle, some important differences. Anyway, so yeah, that's going off on a tangent, but yeah, basically here we're talking about the cardiac vasculature, so that makes sense. So cardiac smooth muscle cell, so cardiac vasculature smooth muscle cell, I think so, because cardiovascular agent. So it'll work on the heart and the vasculi. So yeah, this is a blood vessel cell, we can say.
Yep.
But then I'm also thinking it's a cardiac cell too, because this L type we saw earlier today, that's present in the voltage gated calcium channel present in the cardiac myocytes, we said, right, somewhere.
It's a mix, I think.
Okay.
Just to explain, they have included all the example in one picture, saying, different receptors they are using here, right? So, yeah.
For the big picture. Okay, cool. All right, so let's see. So what's happening here? We have the L-type voltage-gated calcium channel. Voltage-gated, so it depends on the action potential. So calcium comes in and binds with the calcium calmodulin. And then this calcium calmodulin complex will stimulate the MLC kinase. Kinase, what does it do? It adds a phosphate group. So kinase will add a phosphate group to myosin. So myosin and actin, yeah, on myosin, it's adding a phosphate group. So now we have phosphorylated myosin plus actin. And this is causing contraction. Yeah, contraction, because actin myosin, when it's phosphorylated, has an ATP. If you go back to that contraction coupling process, this is going to cause actin binds to myosin and causes contraction. So that's what downstream effect of calcium via the voltage-gated calcium channel. But now we are blocking these with the help of the dihydropyridine calcium channel blockers. So what are these? Amlodipine, all the dipines. Yeah, all the dipines. Amlodipines, clevidipine, nicardipine, nifedipine, nimlodipine. So if you're blocking this, we're blocking this pathway and we're inhibiting the contraction. We're doing the opposite. No calcium will come in, no binding or no creation of the calcium calmodulin complex, no activation of MLC kinase, no phosphorylation of the myosin and actin, no contraction. So they are going to relax. Does that make sense?
Yep.
Okay, so yeah, membrane depolarizing is what, because they're voltage gated, membrane depolarization is going to activate them. Then here we have GQ. So this part is done. Next we have GQ agonists, GQ coupled pathway. So GQ agonist, again, epinephrine and norepi. So epi is working where beta 2 more than alpha 2, and then also some alpha 1 activity also, right? So epinephrine, norepi, alpha 1, endothelin 1, angiotensin 2, and vasopressin. So these are GQ coupled. What do they do? Yeah, if you remember the steps in the middle, this will be again transmembrane. GQ will phosphorylate or activate the PIP2, that will split into IP3 and DAG. DAG is not shown here. So once it's split and causes the IP3, IP3 will go and activate the sarcoplasmic reticulum. So now this, which is containing full of calcium, is going to release calcium. So if it releases calcium, the complex is formed. Then yeah, downstream effects. So calcium calmodulin complex will stimulate or activate MLC kinase. They add a phosphate group, which is needed for myosin and actin to combine and cause contraction. So on the one side, it's doing contraction. On the other side, it's also releasing Rho kinase, which will inhibit MLC phosphatase. And by inhibiting the phosphatase, it's preventing the breakdown of the phosphorylated form. So inhibiting the breakdown, if we are inhibiting the breakdown, we're increasing this process again. So it has a double effect. It's a double attack, basically. So GQ is increasing the contraction directly. Indirectly, it's also inhibiting the breakdown products. So net effect, contraction, GQ coupled. So what are these drugs? Epi, norepi, endothelin 1, angiotensin 2, vasopressin. Okay, so then on this side, we have the natriuretic pathway. So here what's happening, we have natriuretic peptide. Okay, so natriuretic peptide agonists like ANP, BNP. What do these do? They stimulate the receptor. Receptor is activating guanylate cyclase. So guanylate cyclase is another enzyme. Cyclase, so it's adding a cyclic group to the GTP. So GTP becomes cyclic GMP by the enzyme guanylate cyclase. So once there's more CGMP levels, this will cause stimulation of phosphatase. Phosphatase, so it's going to remove a phosphate group. It's going to remove this phosphate group. So myosin and actin are now separated. If they are separated, that's relaxation. So ANP, BNP are relaxing the vasculature, basically, the smooth muscle. Yeah, that's that. And then this CGMP will break down to GMP. How? By PDE5. So they are similar, parallel, but different things. Here we have ATP, you have GTP. So one more time, GTP is converted to cyclic GMP by guanylate cyclase. Cyclic GMP breaks down to GMP by PDE5, phosphodiesterase. So again, it's removing something. So cyclic GMP becomes GMP. So this is inhibited by the sildenafil drug. So by inhibiting PDE5, what are we causing? Lots of CGMP to remain in this inside the cell. This lots of CMP is going to cause MLC phosphatase activity increase. If it's doing tase activity, it's removing the phosphate. So myosin and actin are separated and relaxation occurs. So we know sildenafil causes smooth muscle relaxation. So that makes sense. ANP, BNP will also cause smooth muscle relaxation. So that makes sense. Right? Then we have nitrates. So nitrates directly and also from the endothelial pathway, we have lots of NO coming in. So nitrates also provide nitric oxide, which is stimulating guanylate cyclase. If guanylate cyclase is there, more cyclic GMP and again relaxation net effect. So that's by nitrates. Then we have L-arginine, which is the precursor of NO. So that's also providing lots of NO. NO stimulates guanylate cyclase and more relaxation net effect. And NO synthase inhibitor is by bacterial lipopolysaccharide. So this produces NO synthase. So it synthase, it's going to synthesize NO. From where? L-arginine. So if you have more NO, again, lots of smooth muscle relaxation. And that's how LPS causes leaky vasculature. So it's causing excessive smooth muscle relaxation, I think. Please correct me if I'm wrong. And that's the mechanism of LPS.
Vasodilation, increased vascular permeability, hypotension, shock.
Yeah. So it makes sense, right? So this is doing it by NO. So lots of vasodilation. Everything is leaky and yeah, massive vasodilation because of, and then yeah, that will lead to shock. So that makes sense. So then now we have some NO diffusing and coming here. Where is it coming from? The endothelial cell. So we have the vascular lumen, and then we have a receptor on the endothelial cell. What are these being stimulated by? Acetylcholine, alpha-2 agonist, bradykinin, cytokines, histamine, serotonin, shear stress. So all these are going to bind to the vascular endothelial receptors. They trigger calcium release inside the endothelial cell. If there is more calcium inside the endothelial cell, this is also stimulating another NO synthase, but this is inside the endothelial cell. So L-arginine is a precursor. In the presence of NO synthase, this is forming NO. Nitric oxide is a gaseous stuff, so it will just diffuse, goes from the endothelial cell into the smooth muscle cell, activates guanylate cyclase, causes net effect relaxation. Vascular relaxation. So this makes sense. Histamine, serotonin, shear stress. So that's causing relaxation. So did we finish everything? So yeah, that's the drugs. And this was on the other page, right, which we did. It's kind of the same thing, basically, just zoomed in. This is the more bigger picture, has more things added on. So net effect, always nitric oxide will cause relaxation, increase calcium contraction. So yeah, acetylcholine, bradykinin, yeah, we saw that here. So actually, this is a better picture. It has everything in one place. but I know.
Does it mean that NO is coming only from the endothelial cells? Because I also see intracellularly there is NO coming from L-arginine. So there are two sources or just one source? That is what is my question.
I think there are two, and because the enzymes have a, what do you call it?
Synthase.
Yeah, NO synthase, which belongs to the endothelial cell, so a subtype, NO synthase, which belongs to a smooth muscle cell. I think it's a subtype, but I'm not 100% sure. I can check.
L-arginine, wherever it is there, it can produce NO. That's all it is.
Exactly.
But it's an
Yeah, because
interesting.
that's the basic precursor for an NO. So that makes sense, right? Okay. And then this was, I think, dirty medicine mnemonic. Go to AC for, yeah, this was AC. I think it was Atlantic City in New Jersey. If people are familiar. So yeah, go to Atlantic City for craps and poker. So so guanylate cyclase will act, no, GS or whatever, either way it activates. Next will be adenylate cyclase, and then will be C for camp, and then for PK, just to remember the order.
So
Yes.
in a nutshell, so alpha-2 agonists work on GI pathway. That's how it increases contraction in the smooth muscles. And it also acts on the, when you go down, acetylcholine.
Oh, yeah, this part.
Yeah, this one, alpha-2 agonist. No, this one. On the right side, acetylcholine alpha-2 agonists. So it causes vasodilation by this pathway, right?
Yeah. So GI, where alpha-2 and GI coupling is causing contraction in the smooth muscle cell and relaxation in the endothelial cell. That's what you said, right?
Yeah, vasodilation. Right?
Vasodilation.
By
Yeah.
increasing nitric oxide pathway. And over there, it increases by inhibiting CAMP. It causes contraction, smooth muscle contraction.
Yes, that's a good conclusion.
Yeah, good point. Good point.
Yes, thank you. So let me just write that down before it slips away. So $322. Okay. Anything else? Hamna, did you want to go over anything else? Or are we good? You said alpha-2 net effect in the...
Yeah, both. Vasoconstriction, vasodilation, both. If it's on the nitric oxide pathway, it causes vasodilation. And if it acts on the cyclic MP by inhibiting cyclic MP pathway, it leads to vasoconstriction. Yeah, very well done, Saira.
No, it was teamwork. I take no credit for this.
No, it's very nice, Saira, really.
You need guts to do this pathway. It's not easy.
Agree.
Thank you.
And Hamna has cleared something which I have been thinking about like since long. I mean, it was a wrong conclusion which I was made because of the last
This one
addition,
was
right?
because of the errata. Yeah. That was, oh my God, it created so much complications. Yeah.
I corrected
Okay.
everything.
Seriously, so mean. as if we're not suffering enough with step one. Anyway, okay, let me speed up so we can finish up and wrap up for the day. Okay, so this should go faster now. So calcium channel, let me clear the hints. I think we're good.
Antiarrhythmics are the major hazardous things.
Yeah, but mnemonic would work. Like there's some.
Yeah, I think there's lots of mnemonics. Okay, so we have calcium channel blockers. What are these? Amlodipine, clevidipine. So all the dipines, dihydropyridines, and act on the vascular smooth muscle from the previous page. And then diltiazem and verapamil, which are non-dihydropyridines acting on the heart. So mechanism, they block the voltage-dependent L-type calcium channels of cardiac and smooth muscle and decrease muscle contractility. So decreasing muscle contractility net effect, as we said. Just to visual memory, so this is inhibiting, none of this is happening, so decrease contraction.
And L-type is present on a smooth muscle and on the heart both. So yeah.
Yeah, this is a good point. So this is on cardiac as well as the smooth muscle. Yeah, nice. So yeah, then we're seeing on the vascular smooth muscle, amlodipine equals nifedipine, but more effect on more than diltiazem and verapamil. In the heart, verapamil more than diltiazem, more than amlodipine, and then these are equal. So these are always together, saath hain, equal. And then here AMLO, then diltiazem ADV.
Dil for dil.
Dil for dil. So, remember? Dil more, okay, nice.
What is that?
Diltiazem acts on the heart.
Yeah. So heart, mill and dil. Okay, nice. I like that actually. Mill and then dip and fed up. Okay. So for remembering the order in the heart, verapamil is stronger, which makes sense, right? These are non-dihydroproteins. So mill and
Mil dil har din. Whatever. Yeah. Mil dil har din. Yeah.
heart.
N. Yeah.
Oh yeah. Then okay, yeah.
Yeah,
Yes,
yeah.
yes.
Mil
Okay,
dil.
okay, nice. Okay, nice. The clinical use dihydroproteins except nimodipine. So what's the use? Dihydroproteins except nimodipine. They use for hypertension, angina, including vasospastic type. They're not phenomenon. So dihydropine mainly dilates arteries. So yeah. So it's useful for hypertension, angina, vasospastic type, Raynaud phenomenon, because they're all arterial stuff. Then we have nimodipine, which is used in subarachnoid hemorrhage, prevents cerebral vasospasm. So nimodipine, subarachnoid hemorrhage, so prevents cerebral vasospasm. Then we have nicardipine, clevidipine. They are used in hypertensive emergency and or emergency. So yeah, so this is nicardipine and clevidipine. And then we have non-dihydropyridines, useful in hypertension, angina, AFib, and flutter. I think the questions usually for the nicardipine, clevidipine for hypertensive urgency, emergency. But I don't know if I've seen a specific question asking.
Nimodipine is also a question for cerebral vasospasm.
Yeah, correct. It comes up in the subarachnoid hemorrhage page. Yeah, this is important. Okay, so then adverse effects, gingival hyperplasia. So we said other than phenytoin, it was calcium channel blockers causing gingival hyperplasia. Dihydropyridine specific side effects are peripheral edema, flushing, and dizziness. Non-dihydropyridine specific side effects are cardiac depression, AV block, and hyperprolactinemia. Verapamil specifically, and constipation. So the reason was verapamil blocks calcium release from vessels in the arcuate nucleus that release dopamine. So by blocking this calcium release, less dopamine means more prolactin, if you remember the endocrine connection. So that's how verapamil is ending up causing more prolactin and hyperprolactinemia. So that makes sense. And constipation, this is tested, most common side effect of non-dihydropyridine calcium channel blockers. Okay, so that's calcium channel blockers. Next, we have hydralazine. What is hydralazine mechanism? Increased cyclic GMP, increases smooth muscle relaxation. AA vasodilates arterioles. The other AA was for mirtazapine. We said AA, so alpha-2 blocker for depression and all that, yada, yada. Okay, so hydralazine mechanism is increased cyclic GMP, smooth muscle relaxation. Hydralazine vasodilates arterioles more than the veins, and afterload reduction. So yeah, this gets tested. Afterload reduction more because it's working more on the arterioles. Clinical use, severe hypertension, particularly acute, heart failure with organic nitrate. Organic nitrate. So along with organic nitrate, we're using hydralazine for heart failure, okay? This was safe to use in pregnancy. We said new moms love hugs. So hugs was for hydralazine. Frequently co-administered with a beta blocker to prevent reflex tachy. This gets tested in like graphs and stuff, right? So it's administered with a beta blocker to prevent the reflex tachy. Adverse effects, compensatory tachycardia. So contraindicated in angina and CAD, which makes sense. So this is contraindicated in angina and coronary artery disease, fluid retention, headache, angina, and drug-induced lupus. This gets tested. Drug-induced lupus with hydralazine. Yep. So co-administer with beta blocker to prevent tachy. Adverse effects, of course, is tachy, so which is why it is contraindicated in angina and CAD, fluid retention, headache, angina, and delay. What's the antibody we see in drug-induced lupus? Anyone? Was it antihistone?
Antihistone.
Antihistone.
Antihistone, right? Yeah, antihistone, yes.
What about
Thank you.
anti-DNA? Anti-DNA also, right? Antihistone is for the drug. You're right, drug. Another one is DNA is the other one. Yeah.
Yeah. So drug-induced was antihistone. Yep. And then anti-mitochondrial was what? I remember my mnemonic, but I don't remember what it was.
The biliary is mitochondria.
Bill, meet my bill. Yes, thank you. Thank you. Okay, so next is hypertensive emergency. We treat with labetalol. This was alpha and beta, clevidipine, phenoldiprem, nicardipine, and nitroprusside. So your hypertensive emergency main drugs are nitroprusside and phenoldiprem. So along with labetalol, which is alpha and beta, clevidipine, dipine, so that will be calcium channel blocker. Phenoldiprem, we said we had D1, somewhere we saw, I think in the previous page. Nicardipine and nitroprusside. So nitroprusside is a short-acting vasodilator. This is super important point. It vasodilates arteries more than veins, and it's short-acting. So it increases cyclic GMP via direct release of NO and can cause cyanide toxicity, because this also is a question. It causes cyanide toxicity. So they gave a very subtle scenario of patient taking nitroprusside for hypertension. And then the rest of the scenario was all like in hemonc, I believe, Palm type situation with cyanide toxicity. And then they asked what's the cause. I think nitroprusside was the answer. But yeah, a couple of questions on that. Sorry? Say again, Hamna, I didn't hear you, not audible.
This is complex 4 of the ETC.
Correct.
This is aerobic respiration, right?
Right, yeah. Cyanide will go and block the complex 4. So nitroprusside is a complex 4 ETC blocker indirectly. And
Draco, right?
Draco, yeah.
What was the name for the complex 4? Anyone remember?
It's synthase, right? ATP synthase was complex 4, no? I don't know. Does it have a special name?
That was 5. Just उसके पहले cytochrome C के बाद वो बीच वाला.
No, I don't
think it's cytochrome C, no?
Cytochrome C के बाद ना, third है cytochrome C.
I think I should just say electron transport chain. Oops, what?
What name are you looking for? It is this is cyanide and carbon monoxide nazide, right?
Complex C.
Complex 4. That's it. Yeah.
Complex 4 ही है.
Cytochrome C bound, yeah.
Yeah.
You said something about it the other day, yeah.
Yeah.
Something that Rahul mentioned. Yes, like complex 2 doesn't do the gradient, it just transfers the electron. That's what he said, yeah. Yep, okay.
Yeah, right.
All right, so back to where we were. Is anyone? Shruti dear? Okay, I found it, I think. Okay, cool. All right, so hydralazine, so short-acting vasodilator, arteries equals veins. So yeah, we spoke about cyanide toxicity and complex 4 inhibitor. Then going to phenoldiprem, this is a dopam, so dopamine D1 receptor agonist, so causes coronary, peripheral, renal, and splanchnic vasodilation, decreases blood pressure, and increases natriuresis. Also used post-operatively and as an antihypertensive. So main use is hypertensive emergency and also post-op. Okay, can cause hypotension, tachycardia, flushing, headache, and nausea. Okay, next we have nitrates, nitroglycerin, isosorbide dinitride, isosorbide mononitride. These vasodilate by increasing NO in vascular smooth muscle, increase in cyclic GMP and smooth muscle relaxation, dilate veins more than arteries, thereby decreasing preload high yield fat. So dilates veins more than arteries. So venodilator, massive venodilator, decreasing preload. Clinical use, angina, acute coronary syndrome, pulmonary edema. Adverse effects is reflex tachy. So we co-treat with beta blockers. Adverse effects, yeah, this can cause methemoglobinemia. So that was a unique side effect, hypertension, flushing, headache, Monday disease. This is a question, right? Monday disease in industrial nitrate exposure, development of tolerance for the vasodilating action during the work week, and loss of tolerance over the weekend, which leads to tachycardia, dizziness, and headache upon re-exposure. So one more time, this is in industrial nitrate exposure, development of tolerance for the vasodilating action during the work week, and sudden drops of levels over the weekend when they are home. So loss of tolerance over the weekend, which causes tachycardia, dizziness, and headache upon re-exposure. So contraindicated in right ventricular infarction, hypertrophic cardiomyopathy, and with concurrent PDE5 inhibitor use. Yeah, this gets tested. You never combine two nitrate type drugs. So yeah, contraindicated in right ventricular infarction. We saw this earlier. Nitrates are contraindicated, hypertrophic cardiomyopathy, and concurrent PDE5 inhibitor use.
Why in right ventricular infarction contraindicated?
Because we are causing venodilation. Already there's no output going, right? Right ventricle
That's RCA problem. Okay.
Yeah. Yep. So by giving nitrates, we're worsening it. So we don't, it's contraindicated. And hokum, again, we're reducing the volume. So empty vessels make more noise. So yep, that's.
It's also because it works on veins more than the arteries, right? So dilates veins more than the arteries. That must be something to do with right ventricular infarction. Yeah.
Yeah. Okay. So next. So yeah, we reviewed calcium channel blockers, hydrolazine, and hypertensive emergency drugs, as well as nitrates. Okay, so next on this page, we have anti-anginal therapy, ranolazine, sacubitril, and then we're going over to lipid-lowering drugs. Okay, so for anti-anginal therapy, the goal is reduction of myocardial oxygen consumption, MVO2, by one or more of the determinants of MVO2. By decreasing one or more of the determinants of myocardial venous oxygen consumption. V is venous. Yeah, MVO2 makes sense. So decrease one or more of the determinants of MVO2, which is either end diastolic volume. So the goal is either end diastolic volume decrease, blood pressure decrease, heart rate decrease, or contractility decrease. So the components and nitrates versus beta blockers. So nitrates versus beta blockers versus nitrates plus beta blockers. So end diastolic volume, nitrates at the end of diastole, so venodilator, so it goes down, makes sense. Beta blocker, no effect, or it can also increase. When we give them together, no effect or decrease. Okay. Blood pressure, venodilation, so it falls, makes sense. Beta blockers decreasing contractility, so it falls, makes sense. Contractility increase, which is a reflex response, which we have seen before. Beta blockers direct inhibition, so contractility goes down. Heart rate increase again, which is a reflex response because we are venodilating. Yeah, increase heart rate. Beta blockers, heart rate is down with the beta. How does it go down?
Direct effect.
Direct effects on B1, beta 1.
Oh, right. Beta 1 works on the heart and the vasculature. Yes. Thank you. So yeah. Yeah. Oh my God. Sorry, had a dumb moment. So yeah, beta blocker. So beta 1 on the heart. So direct effect. Yeah. And then when we give it together, so no effect or decrease. Yeah. And then ejection time decreases nitrates with beta blockers. Ejection time is increased. Yeah. So that's the main purpose. We are increasing the ejection time. Little or no effect. Okay. Then MVO2 decreased with nitrates. Venous oxygen is decreased. Beta blockers. While giving both is super decreased. So basically the tissues are able to utilize the oxygen. So the MVO2 is so the goal is reduction of actually we're reducing the consumption.
MVO2 is actually myocardial oxygen consumption.
Yeah. There's no vein over there. Sorry, my bad again. I'm getting so myocardial oxygen consumption. So that's what we're decreasing. So when we give them both together, it's super low. Yeah, thank you. And then
on the ejection time, Sarah, just one more time, like why? How?
Ejection time. So here we are venodilating. So if you're venodilating, how is the ejection time going down? Ejection time means the time taken for the left ventricle to remove all of its contents. So because the vasodilation, the periphery is now loose and open because we're venodilated, it's easier for this thing to pump out, right? Ejection time. So it's more easy to pump. So it takes its own time to keep pumping out. That's my understanding. I could be wrong.
Less time. Yeah. Okay.
Because heart rate is decreased now. So it feels more time is there for the blood to eject, right?
Yeah, so you've decreased after
Yeah,
loading. It's easier to eject. So you decrease ejection time.
Yeah. It's easier to eject, so it decreases ejection time.
Yeah.
The way I look at it is the preload is less, so blood is not going to the heart, so ejection time is reduced. It's not.
So it's not after. Where does nitrate act? Is it both on veins and arteries?
No, veins more than the arteries.
Veins more than arteries. Okay, then the preload.
The preload is less, so you have ejection time low. Yeah.
Okay, makes sense. Because they are nitrates, the venodilation, so massive pooling in the veins, so less going back to the left atrium, so decreased preload. So decreased volume coming in, so decreased ejection time.
You got it. Yeah.
Nice, thank you. And then with beta blockers, because go ahead.
It decreases contractility, so you would spend more time contracting even for a little blood. I guess. That's what I think.
Nitrates, it is a vasodilator, but it acts more on veins.
Yeah, so that's main effect is on the venous system, but it does have effect on arteries. Yeah, that comes up in that arrow question. I know what you're talking about.
Hydralazine is also acting on both. It's just more on atrials.
Arteries. Okay.
Great.
Gotcha.
Okay. Thank you guys. Okay, so then what are they saying here? Verapamil is similar to beta blockers in its effect. Okay, cool. So then next we have ranolazine. So this mechanism is it inhibits the late phase of inward. So it inhibits the late phase of the inward sodium current by thereby. So one more time.
Okay. Once again, can you clear this for me? Beta blockers, they reduce the contractility, right? When the contraction is less, how is the ejection time increased?
I think that, if you're contracting properly, you can easily get blood out of the left ventricle. But if it's less, then it takes more time to bring out the blood because you need contractility, a good pump to eject quickly.
It's going to take longer. It's going to take longer. Yes, I get your point. Yeah.
Can we relate it to heart rate? Heart rate is down, so ejection time is up.
Yeah. Actually, both, right? Heart rate and contractility, because if you see the formula, stroke volume is equal to heart rate times contractility, right? Or am I mixing things up at this point? So it depends on both the amount of volume injected. So if both are decreasing, the ejection time will take longer for the heart to squeeze things out. Basically, that's what we're saying.
No, I think what she's trying to say in relating it to heart rate, I think I get your point. So when you are bradycardic or when you have low heart rate, it increases the time for diastolic filling. And the longer the diastolic filling time, the longer it will take to also eject. But in tachycardia, they will have less time for diastole. So ejection time will be higher will be lower when you have higher heart rate. So by reverse, I think I may try to explain what you are saying by saying that if the rate is lower, then you have more diastolic time and hence more time to eject the blood.
Diastolic time is more, so longer time to eject.
Yeah.
That was the crux of what you said, right? Yeah, it makes sense.
Yeah,
because
just
the heart rate is less.
too. Yeah, but otherwise, I think I would go with the decreased contractility, which makes it easier for me to understand. But diastolic time can be related to this one with the heart. Yeah.
Okay, yeah, both, if you think about it, does make sense. I think both make sense actually, yeah. But yeah, as you said, easier to remember the ejection time. Okay, cool. Thank you. All right. Thank you, docs. So next we have ranolazine. Mechanism inhibits the late phase of the inward sodium current, thereby reducing the diastolic wall tension. And so reducing wall tension and oxygen consumption. So it does not affect the heart rate or blood pressure. So where do we use this? It's for refractory angina. R for refractory. R for ranolazine, R for refractory angina. Adverse effects: constipation, dizziness, headache, and nausea. So I wrote here, I don't know when I wrote this. So ischemia causes increases late influx of sodium. Yeah, increases the sodium in, I believe, the influx. So sodium overload. Sodium calcium are correlated. So calcium overload. Increased diastolic tension. More calcium, more tension. So by giving ranolazone, we are inhibiting the this late phase of the inward sodium current. Reduction in elevated intercellular calcium levels, reduce tension in the heart wall, reduce oxygen requirement of the muscle. Yeah, I think same thing. I just put it in a flow chart.
Myra, what is the late phase of inward sodium current? In the
So if you remember that thing, let me go back. Was map and PAP
sorry
page.
for that. I'm just
No, that's fine. What's the keyword on that page?
action potential.
Yeah, you have not done the action potentials yet, right? I don't know. I was not there this morning.
No, we finished it.
Haven't? Okay.
So what were we talking about?
Yeah,
The late phase of
sodium,
sodium channels, right? So what
late sodium current, yeah.
Ranolazine, yeah. So we said the late sodium channels. So that will be
Zero.
Yeah. So when they say late phase, remember we said this, I think it's this later phase. Because if you remember, we said in phase 1, inactivated of the voltage gated sodium channels. So when they begin to inactivate, I think these at this point would be the late phase.
Okay.
Am I right? But you said phase, yeah, it's still phase 0, but at the later phase.
At the latter part of phase 0, okay.
Yeah. It makes sense, right? Because if it's ischemia, there's increased influx where at the later phase, sodium overload, calcium overload, increased diastolic tension. Yeah, I believe it's late. I don't know if there's a special channel or anything. If anyone knows, please share. That was L-type, okay.
So it inhibits the late phase of the inward sodium current, thereby reducing diastolic wall tension and oxygen consumption, but it doesn't affect heart rate and BP.
Yep,
Reducing
makes sense.
diastolic wall tension and oxygen consumption.
Makes sense. Agree. Yep.
How, Shruti? Diastolic wall tension, how it reduces?
Because this will correspond to the contraction, right?
Correct. So फिर वो कम नहीं हो जाएगा diastolic wall tension अगर late phase पे if this is working, right? मतलब you only answered it, right? I mean,
Yeah.
what I thought, yeah,
We're inhibiting this inward phase. So we are preventing the increased tension, which means we are reducing the tension. So we're helping out the angina, right? Does that make sense?
Okay. So I guess, so it means that every act of depolarization or contraction increases the wall tension. So by inhibiting it, you are decreasing it. It makes sense to me.
Yep.
So by decreasing depolarization, basically we are decreasing the wall tension, right?
Yeah.
Exactly. Yeah.
Okay.
Yeah, because this is corresponding to the contraction, right?
Yeah,
The ventricular myocyte contraction. So if we're reducing this, we're blocking this phase, we are reducing the contraction, which will help out with the angina.
Yeah.
वो threshold ही नहीं पहुंच रहा है ना, it is not reaching toward that, right? So definitely, yeah.
Gotcha. Thank you.
Thank you.
So thank you so much. Thank you.
Hope that made sense, Bhavna.
Yes. Thank you so much.
Thank you. So back to, ranolazine. So that's what we're blocking, specifically the later phase of the inward sodium current. So reducing wall tension and oxygen consumption does not affect the heart rate or blood pressure. So it's just doing it for the tension. How strongly the myocyte is contracting doesn't affect the rate or the BP. So refractory angina, adverse effects are constipation, dizziness, and headache and nausea. So again, everywhere, not just in the myocyte, some side effects are in the other smooth muscles too, I believe, or other muscles too. So that's why it makes sense, right? Here it's causing constipation, dizziness, headache, and nausea. I think, am I right or am I wrong? No, I think I might be wrong. This might not be related to its mechanism because these are causing reduced tension in the cardiac wall. but here it is causing constipation dyspnea. Yeah, not sure how that does that. Maybe the channels are in the opposite direction in these. Okay, now let me not overthink. Anyway, so ranolazine adverse effects are constipation, dizziness, headache, and nausea. So next we have sacubitril. We saw this in the context of heart failure, HFrEF. So sacubitril, the mechanism is it's a neprilysin inhibitor, prevents degradation of bradykinin, natriuretic peptides, AT2, and substance P. So by preventing the degradation of these substances, the net effect is it's increasing vasodilation and decreasing the extracellular fluid volume. Okay, so use in combination with valsartan, which is an ARB to treat HFrEF, which is the heart failure with reduced ejection fraction. Okay, so adverse effects is hypotension, hyperkalemia, cough. Makes sense because it's increasing bradykinin, so cough, dizziness, and also these hyperkalemia also makes sense because it's via aldo stuff. So anyway, so hypotension, hyperkalemia, cough, and dizziness contraindicated with ACE inhibitors because double effect, so too much bradykinin, which makes sense, right? Okay, so where do we use this? Along with valsartan, which is an ARB to treat HFrEF. That's the main use for sacubitril. Okay, so that's done with the cardiac drugs. We saw anti-anginal therapy, how nitrates work, beta blockers work individually and together. So together, they super decrease the myocardial oxygen consumption, which is our goal in anti-anginal therapy. Ranolazine we saw used in refractory angina and sacubitril for HFrEF. Okay, next we have lipid-lowering agents. This used to be in some other page, right? Okay. I don't know, never mind. Yeah, okay. So lipid-lowering agents, we have statins, we have bile acid resins, ezetimibe, fibrates, niacin, PCSK9 inhibitors, and fish oil and marine omega-3 fatty acids. Used to be in a single page. I think it's messing with my visual memory. Anyway, so here we have statins, all the atorva, lova, prava, rosuva, and simvastatin. Mechanism, we know this. They inhibit HMG-CoA reductase, thereby decreasing the cholesterol synthesis, decreasing intrahepatic cholesterol, increasing the LDL receptor recycling, and increasing LDL catabolism. Decreases mortality in patients with coronary artery disease. Adverse effects, hepatotoxicity. So yeah, we frequently check LFTs in patients who are on statins. Myopathy it can cause, especially when used with fibrates or niacin. So this is questions, right? When combined with fibrates, niacin, supermyopathy. So that's statins. They're decreasing the LDL really low. They increase HDL, and they also have moderate effect on triglyceride. Inhibit CoQ in the ETC. I'm not sure how strong this fact might be from my old books. Okay, next, bile acid resins. These are cholestyramine, cholesevelam, and cholestypol. They also decrease LDL, slightly increase HDL, and slightly increase triglycerides. Actually, slightly increase triglyceride. So the mechanism is they disrupt the enterohepatic bile acid circulation, leading to compensatory increased conversion of cholesterol into bile, so thereby decreasing the intrahepatic levels of cholesterol and inducing an increased LDL receptor recycling of sorts. So one more time, what do the bile acid resins do? They disrupt the enterohepatic bile acid circulation. There's a compensatory increased conversion of cholesterol to bile, decrease intrahepatic cholesterol, increase LDL receptor recycling. So adverse effects are GI upset, decreased absorption of other drugs, and fat-soluble vitamins. I think this is a question, right? Fat-soluble vitamin deficiency, and they correlated that with bile acid resins. Okay, then ezetimibe decreases LDL, variable effect on HDL and TGS.
I think in the ileum, in the ileum bile acids and the vitamin B12 and all these are absorbed.
Can't hear you, Hamna.
You can't hear me?
Now I can, yes.
Okay, I think because in the ileum, B12 and bile acids are necessary for the other fat-soluble vitamins absorption, right? So if bile acids are not absorbed, that leads to decreased absorption of fat-soluble vitamins.
Yeah,
Right?
so you said, yeah, it's still not very audible. So you said bile acid resins are needed for Fat-soluble vitamins.
Bile acids are necessary for the emulsification of fat-soluble vitamins, right?
Yeah, yeah, we saw
So
that.
we don't have bile acids, that leads to fat-soluble vitamins lost. Steatorrhea.
Yeah, correct. Steatorrhea is a side effect, actually. Yep. So that's why G helps it. Yeah. So because we're losing the fat-soluble vitamins, bile acids are needed for emulsification and absorption of fat-soluble vitamins. Yes. Thank you,
The
Hamna.
cholecystectomy can does all this thing, right?
Say again.
Cholecystectomy can does all this thing.
Cholecystectomy will resolve this thing.
Not resolve. I mean, the cause of this reabsorption is steatorrhea and all this thing. In that case, we give the cholesterol and all this thing for the reabsorption.
Correct, for those patients. Yeah. Yeah, makes sense. So ezetimibe, we said decreases LDL. So variable effects on these. This one is preventing cholesterol reabsorption at the small intestinal brush border. So this drug is working on the small intestinal brush border and preventing cholesterol reabsorption. So rarely increases LFTs and diarrhea. Cholesterol reabsorption and decreasing LDL is ezetimibe. Okay, next we have fibrates. So gemfibrozil and fenofibrate. So this one decreases LDL. So this is the question, right? First line for triglyceride or hypertriglyceridemia was fibrates, I think. And this is often tested. The mechanism of action is activates PPAR alpha. PPAR gamma was the
Thioridazines.
Thioridazines, yes, thank you. So that's PPAR gamma and antidiabetics. This is PPAR alpha. So upregulate LPL, increasing triglyceride clearance. And the activation of PPAR alpha also induces in HDL synthesis. So we're also increasing HDL. Adverse effects, myopathy, increased risk with cholesterol statins, cholesterol gallstones. Yeah, this was a mnemonic, right? I think someone had said GEMS. So this GEMS with gemfibrozil, the GEMS are what? Gallstones. Via inhibition of cholesterol 7 alpha hydroxylase. This cholesterol 7 alpha rings a bell, but anyway. Okay, yeah, so that's inhibition. So, okay, fibrates are inhibited.
That's the enzyme needed for bile acid synthesis. Can you hear me?
Yes, I can hear you. Yeah, so that's the enzyme needed for bile acid synthesis, correct. So because it's inhibiting this also, it's causing bile acid stasis, and that can lead to gallstones. Yes, thank you. Yeah, I know, I wish we could take group exam, but anyway, myopathy, increase the risk with statins, cholesterol gallstones. Yeah, so inhibition of cholesterol 7 alpha hydroxylase. Okay, next is niacin. Mechanism is it inhibits lipolysis or hormone. Yeah, we saw this somewhere else too. It inhibits lipolysis by inhibiting HSL. So inhibits lipolysis in adipose tissue, reduces the hepatic VLDL synthesis. And inhibits lipolysis, how? Via hormone-sensitive lipase in adipose tissue specifically, reduces hepatic VLDL synthesis. So it's working on both the adipose tissue and the liver. Okay, so the side effects.
In other words, it stabilizes hormone-sensitive lipase, right?
Yeah, we saw that on UWorld. Yes, it stabilizes the HSL so that HSL can do its job. And this was one that was also stimulated by insulin, right? Stimulates HSL.
Yeah, so insulin basically, inhibits HSL. Insulin stimulates LPL.
Okay, yeah, so it inhibits HSL. Inhibits HSL?
Yeah, insulin inhibits HSL.
Okay, insulin inhibits HSL and stimulates LPL. Okay, stimulates LPL. Okay, nice. So the side effect is flushed face, prostaglandin mediated. This gets tested heavily and decreased by NSAIDs. So yeah, what do we use to pre-treat? Either we decrease NSAIDs or on long-term use, it gets resolved. Also, side effects are hyperglycemia and hyperuricemia with niacin. Okay, then PCSK9 inhibitors. Yeah, we had a question on UWorld. Alirocumab and evolocumab. So they super decrease the LDL. So mainly beneficial for LDL, increase some HDL and decrease TGLs. So how do they do this? They inactivate the LDL receptor degradation. So inactivation of LDL receptor degradation. So now LDL receptor continues to live longer, increased removal of LDL from the bloodstream. So that makes sense. It's mainly working on the LDL. I think, did I take the image? The UWorld had a good image for this PCSK9. Okay, so adverse effects are myalgias, delirium, dementia, other neurocognitive effects, which is so like unique. So PCSK9, myalgias, okay, that's common to many other of these drugs, but delirium and dementia and other neurocognitive effects with PCSK9 inhibitors. Monoclonal antibodies, so maybe some cross reaction, not sure how. Okay, then fish oil and marine omega-3 fatty acids. So increase LDL slightly, increase HDL slightly, and decrease triglycerides at high doses, which is why they are prescribed. Believed to decrease free fatty acid delivery to the liver and decrease the activity of triglyceride synthesizing enzymes. So it's doing two things. One, decreasing free fatty acid delivery to the liver, and also decreasing the activity of triglyceride synthesizing enzymes. So adverse effects are nausea and fish-like taste. Okay, so image, anyone wants to try? Lots going on here.
Yeah, let me try. Yeah.
Go ahead, Nanda. Thank you.
Okay, you can hear me?
Yes, can hear you.
So in the liver, basically, it's the cholesterol synthesis. So from acetyl-CoA, we form HMG-CoA. And from HMG-CoA, with the help of HMG-CoA reductase, we form mevalonate. And from mevalonate, cholesterol is synthesized, right?
Mm-hmm.
And this cholesterol is needed for bile acid synthesis and all these things, right? We need cholesterol for even good purposes, for steroid synthesis. So it's not that a totally bad thing, we need it, right?
Mm-hmm.
HMG-CoA reductase inhibitors, we have statins, all these lovastatin, parvostatin, rosuvastatin, simvastatin, all these things. And we have LDL receptors, which are present on the liver, as well as on the peripheral tissues as well, right? So on the liver, we have LDL receptors and HDL receptors as well. So if you start from the gut, from the intestinal lumen and the enterocytes, so there is a drug called ezetimibe. It inhibits cholesterol absorption.
Yes.
So like we have cholesterol-free fatty acids and bile acids.
Mm-hmm.
So all these are absorbed and form chylomicrons in the enterocyte. And you know that in the via lymphatics, it enters into the bloodstream.
Mm-hmm.
Right? So ezetimibe is the drug that decreases cholesterol absorption in the small bowel. Yeah, prevents cholesterol absorption at the small intestinal brush border. Right? So this
Yes.
one. And then we have bile acid resins, which inhibits bile acid reabsorption, which is cholesterol, cholestyramine, and cholestyramine.
Mm-hmm.
So these two drugs are there. Then chylomicrons via lymphatics goes into the blood, and chylomicrons are packaged into converted into this free fatty acids via LPL, lipoprotein lipase. It's converted into free fatty acids, and then there is a HDL pool and the chylomicron remnants. And chylomicron remnants are taken up by the ApoE receptors. We know that ApoE, basically it's a remnant uptake for everything except LDL, right? If I'm not wrong.
Yeah, I think so.
Okay, so chylomicron remnants are taken up by the liver, and it's converted again there into triglycerides and cholesterol. So triglycerides, it converted into VLDL, and cholesterol is also converted into VLDL. So from the liver, VLDL is produced, and VLDL has B100 receptors on it.
Mm.
Then VLDL goes into the blood, and that VLDL, with the help of this LPL, lipoprotein lipase, is converted into free fatty acids, or it's converted into IDL and then LDL.
Mm.
Right? And then LDL, because it's in the blood, is taken up again by the LDL receptors in the liver.
Yes.
And we have these PCSK9, which normally degrades this LDL receptors. So that's why we give LDL receptor PCSK9 inhibitors with alirocumab and evolocumab. So LDL receptors are not degraded and LDL is scooped up from the blood. Then we have fibrates. So fibrate stimulates this LPL, upregulation, phenofibrate gem fibrosol. And what is the role of LPL? It stimulates, fibrates stimulates basically PPRA alpha, and they stimulates LPL. And by stimulating LPL, it's converted VLDL into free fatty acids. And free fatty acids can go into adipose tissue and store there, or it can undergo lipolysis as well. So the function of fibrate,
muffled. I can't hear you.
Sorry. It upregulates LPL and increase triglyceride clearance. First thing, right? And it also activates PPRA alpha to induce HDL synthesis.
Yeah.
So two things by fibrates. First is LPL, so triglyceride clearance would be good. That's its main function, to decrease the triglycerides levels. And it also increases HDL synthesis via PPRA alpha. And any other drugs?
Nice.
Yeah, it's niacin. Niacin basically decreases VLDL synthesis. If I'm not wrong. Yeah.
Niacin
inhibits lipolysis. So it stimulates hormone-sensitive lipase in the adipose tissue and reduces hepatic VLDL synthesis. So in the adipose tissue, it inhibits lipolysis. So it inhibits HSL basically.
Yeah.
Right?
Inhibits lipolysis. Yeah, inhibits HSL.
Yeah, inhibits lipolysis in the adipose tissue. Yeah, so it's not converted into free fatty acids. And it also reduces VLDL synthesis. Here in the cholesterol to VLDL in the liver.
Yeah.
Yeah, it also inhibits VLDL synthesis in the hepatocytes.
Yeah.
So yeah, these are the functions. So the major things to catch up here, fibrates decreases triglycerides. That's important. I think bile acid resins decreases LDL, increases HDL slightly, and bile acid resins also increases triglycerides slightly. That's something unique to them. Okay.
Nice.
Statins are easy. LDL basically reduces. Statins and PCSK9 inhibitors mainly reduce this LDL levels.
So LDL main attack is statins and the PCSK9.
PCSK9, yeah.
Okay. Awesome. Thank you so much, Hamna.
Not like you, but I tried.
Amazing. Thank you. All right, so we're good with the lipid lowering agents, right? Anything else? Any additions? Okay. So niacin also precipitates gout, right? Because hyperuricemia, I think that was a question somewhere. Okay. So next we have digoxin. Thank you so much, Hamna. So next we have digoxin. What is this? Comes up so many times. So direct inhibition of sodium potassium ATPase, indirectly inhibiting the sodium calcium exchanger, increase intracellular calcium levels, and that will cause a positive inotropy. So increase intracellular calcium levels, positive inotropy, so more contraction. Then stimulates the vagus nerve, decreasing the heart rate. Stimulates the vagus nerve and decreases heart rate. So yeah, digoxin. So we have sodium potassium ATPase. So this is being inhibited. So by inhibiting it, it's indirectly inhibiting the sodium calcium exchanger. This is not going out. Calcium remains inside the cell. Increase intracellular calcium concentration. Increase troponin calcium binding. Increase cardiac contraction. So that's digoxin. So clinical use, where do we use it? We have a heart failure, increased contractility, AFib, decreased conduction at the AV node, and depression of SA node. So heart failure is increased contractility, AFib, decreased conduction at the AV node, and depression of SA node. So adverse effects, we have cholinergic. What are the cholinergic effects? Nausea, vomiting, diarrhea, and digoxin, blurry yellow vision, Van Gogh arrhythmias, okay, and AV block. So it can lead to, So it can lead to Okay, so cholinergic effects, nausea, vomiting, diarrhea, blurry yellow vision, Van Gogh, Van glow. I don't know what they mean by Van. How do you relate this? Glow with digoxin. Anyway, I can't relate to this mnemonic. Yellow vision, okay. Van glow. Okay, yellow is Van Gogh. Okay, something like that. Okay, so arrhythmias and EV blocks. So can lead to hyperkalemia, which will present as invert T waves on EKG, which indicates poor prognosis. So yeah, if they present, it causes hyperkalemia, which indicates poor prognosis. Factors predisposing to toxicity is renal failure, decreased excretion, hypokalemia, permissive. Yeah, this gets tested, right? Hypokalemia, permissive for digoxin binding at potassium binding site on the sodium potassium ATPase. So factors predisposing toxicity, number one is renal failure because of decreased excretion, makes sense. Hypokalemia. If there is hypokalemia, it permits the digoxin to bind more because there's no competition anymore. So that makes sense. So hypokalemia will precipitate digoxin toxicity. Permissive for digoxin binding at the potassium binding site on the sodium potassium ATPase. Third thing is drugs that displace digoxin from tissue binding sites. And then fourth thing is decreased clearance. Verapamil, example, verapamil and amiodarone quinidine, if given together, they'll decrease digoxin clearance. Antidote, we've seen this before, slowly normalize potassium, cardiac pacer, anti-digoxin fab fragments, and magnesium. So antidote is slowly normalize potassium, cardiac pacer, anti-digoxin fab fragments, and magnesium. So,
how it causes, can you explain this diagram, please? Increases intracellular calcium. So what is this TNC?
troponin calcium, right? Troponin C calcium binding.
Okay.
So yeah, normally, so we said pump in, right? Sodium potassium ATPase's work is to put pump potassium in and throw sodium out. So because the sodium goes out, the concentration is increased here. That helps the sodium calcium exchanger to bring back sodium in and throw calcium out. So by inhibiting digoxin at this point, we are indirectly inhibiting this sodium calcium exchanger such that calcium remains inside. If it remains inside, calcium-induced calcium released from the sarcoplasmic reticulum. So super high calcium levels. This calcium will go and bind to troponin. Troponin C calcium binding will lead to contraction.
Yeah, and it xanthopsia basically, and due to decreased sodium potassium ATPase in the retina, because rods and cones are dependent on the potassium.
Thing like that you had mentioned before, but I forgot. Can you say that again, please? Make a note.
Through sodium potassium ATPase inhibition, because rods and cones are dependent on the potassium.
Rods and cones in the retina are
dependent on
these pumps.
Potassium. Yeah, maybe there are some pumps in there.
They're dependent on potassium.
Yeah.
Okay. So by blocking this, it leads to the yellow vision.
Yeah, and with hyperkalemia, we find tall peaked T waves.
So this is wrong then?
Yeah. It's with hypokalemia.
Invert T waves is with hypo. Okay, so this is tall T waves. Okay, thank you. Thank you so much. Tall T waves with hyper. Invert T waves with hypo. Okay. Okay, nice. I corrected that. That should update. So that's done with digoxin. So you said the rods and cones are dependent on this pump. So because that's getting inhibited, it causes yellowish. Okay, so next we have antiarrhythmics. Should we? I got a request that we should stop here, and I kind of agree. What do we all think? So we have antiarrhythmics.
Very difficult, yes.
Yes.
In the morning, we will be fresh.
We do it in the morning.
And guys, if you have any mnemonics for that, kindly very appreciate that. Anyone has better things to understand these things, because these kind of
yeah, it's a challenging topic. Yes.
Done so many times and still keep forgetting.
Yes. For mnemonics for the drugs, you mean to say?
Yeah, for these ones, antiarrhythmics especially.
Oh, don't worry. When we come there, I'll give you mnemonics. There are some good ones.
Yeah, thank you.
Okay.
Yes, I also have noted some. So yeah, we'll do this tomorrow because we're now.
Because
endo is easy.
Endo is not that bad.
No, I think endo is easy,
Yeah,
but
but
when it comes to
much
questions,
better
get
than
them out.
cardio.
Dr. Tammy, you will be available in the morning, right? Tomorrow for the mnemonics. It's very challenging.
I think there are many of us may have it. Yeah, each one. Let me see. You start at 8 o'clock, right?
8 Eastern, yes.
8 Eastern. Okay. Yeah. Can't guarantee, but I want to join. I want to join. So let's see how it goes. Yeah.
Yeah. Yeah, we're not pulling the mnemonics. We got this, guys. It's not so bad. It's just easy.
Yeah. And like one thing came to my mind. Hamna was asking about that drug, right? I mean, you guys have discussed, but in a very lay way, I can just take a minute to talk about it.
Which one?
Ranolin, sorry, ranolazine, correct?
Yeah.
So I'll just talk in regional language and then I translate, right? So usually diastole में क्या होता है, better perfusion होता है, right? Coronary perfusion is better, correct? तो अगर हम मतलब जैसे वो चैनल था, राइट, तो हमने उसका लेट फेज बंद कर दिया, करेक्ट, तो मीन्स हम डीपोलराइजेशन को कम कर रहे हैं, मतलब हम सिस्टोल को रोक रहे हैं. जब आप सिस्टोल को रोक रहे हो मतलब योर धीरे से सिस्टोल करा रहे हो तो डायस्टोल भी कम हो जाता है, करेक्ट. इट्स लाइक when the intensity of the systole is less, the diastole also intensity would be less. उतने कम प्रेशर से डायस्टॉल होगा, मतलब कोरोनरी आर्टरी इतना परफ्यूज कर ही नहीं पाएगी, करेक्ट, मतलब ऑक्सीजन एक्सचेंज इतना होगा ही नहीं, which was the purpose of the angina. Is it okay?
The last part, can you repeat again?
Yeah, thank you so much.
इसलिए क्या
हाँ,
हुआ?
मतलब सारा सिंपल की लाइक आप जोर से सिस्टॉल नहीं करवा रहे हो. आप जब जोर से सिस्टॉल नहीं करा रहे हो तो आपका डायस्टॉल भी फुल फ्लेजड नहीं हो रहा है. आप जब फुल फ्लेजड डायस्टॉल करा नहीं रहे हो तो कोरोनरी परफ्यूजन को आप डिक्रीज कर रहे हो ना, आप ऑक्सीजन कम कर रहे हो, राइट. तो बेसिकली हम यहाँ पे जैसे अगर रोक रहे हैं लेट फेज में, करेक्ट, तो मतलब क्या कर रहे हैं हम, डीपोलराइजेशन कंप्लीटली होने ही नहीं दे रहे. व्हाट इज डीपोलराइजेशन? QRS, करेक्ट. तो हम वो चीज होने ही नहीं दे रहे, कंप्लीट हम सिस्टॉल होने ही नहीं दे रहे. कंप्लीट सिस्टॉल नहीं हो रहा है तो कंप्लीट डायस्टॉल नहीं हो रहा है. कंप्लीट डायस्टॉल नहीं होगा तो कोरोनरी आर्टरी को ऑक्सीजन मिलेगा कैसे, right? So that is the way of saying here that we are reducing the diastolic wall tension and oxygen consumption is also reducing by that. Is it okay?
Yeah, that made sense. Yes, thank you. Yeah.
ठीक है. Okay, do you
Thank you Shruti, thank you so much.
Welcome. Do you want me to translate it, or Saira, you would do it better?
No, you
so in nutshell, you're telling that you're just decreasing the oxygen, myocardial oxygen consumption.
Yeah, so
right?
nutshell, I was saying that I just use the lay words to explain that in the diastolic phase, the coronary perfusion is maximum. So here, when we are blocking it at the late phase, we are some way reducing the force of contraction. Means we are reducing the force of systole. When we are reducing the force of systole, the diastole would be decreased. The force of diastole, what is the force of diastole? The tension of the diastole would decrease. So in that moment, the coronary artery perfusion would also decrease, right? Because we are not letting diastole to happen in their appropriate normal time. We are reducing that time. So that is what I was saying in a very lay way. Is it okay?
But if we are decreasing coronary perfusion?
Yeah. We are not letting the diastole to happen full-fledged. No, we are not letting the diastole to happen. When we are like, it's some simple like a rubber band. When you are stretching it out and then you leave it, it is the same force, right? If like
that's what I got, but then are we reducing wall tension? Yes.
So when you're reducing the diastole, how can you're reducing the wall tension? So okay, so that okay, yeah,
So
you make
yes,
of the phase and the tension.
तो वहां तक I understood and I agreed, but मुझे ये समझ नहीं आया कि if we're reducing diastolic wall tension and we're reducing coronary supply, blood supply, then
we are
that
not
will
limiting
reverse
it
the
time.
angina, na? That's
Suppose 4 seconds ka diastole phase is there and we are making it like happen in the 2 seconds. So definitely the consumption, the cardiac muscle will get a lesser time to get to extract the oxygen from the blood, isn't it?
Okay, so you're talking about ischemia. Mein kya hota hai?
Not in the ischemia. I'm just
no, because if you're reducing coronary perfusion, इसमें तो blood supply to the myocardium will or be worse होएगा ना, तो how
there is
angina?
No. The systole we are decreasing, so that diastole is reducing, and that is making it less reduce oxygen consumption, which is the purpose of the angina, right?
वो उसकी कॉन्ट्रैक्टिलिटी को कम कर देगा ना, हर चीज ही कम कर देगा नहीं? उसका सिस्टोल भी कम हो रहा है, उसका डायस्टोल भी कम हो रहा है, तो ऑक्सीजन कंजम्पशन, जब वो हार्ट कॉन्ट्रैक्ट ही नहीं करेगा प्रॉपर्ली, तो ऑक्सीजन कंजम्पशन तो कम होगा ना?
All right. So first overview, we have class 1 sodium channel blockers, class 1A, 1B, 1C, which are all sodium channel blockers, class 2 beta blockers, class 3, which are potassium channel blockers, class 4 calcium channel, other antiarrhythmics, adenosine and magnesium, and ivabradine and Readathon. So I think the older book had the mnemonic. 1 was double quarter pounder, lettuce and mayo, fries please, or more fries please. 2 was LOL, AIDS, dive or dive, and MAI. Right, having said that, so quickly, double quarter pounder was disopyramide, prokinamide, and quinidine. And feel free to share mnemonics if you have, because this can be a tough topic. All right, so antiarrhythmic sodium channel blockers, class 1. Slow or block conduction, especially in depolarized cells. Decrease the slope of phase 0 depolarization. Increase action at a faster heart rate. This is tested, I think. Decrease slope of phase 0 depolarization and increase action at a faster heart rate. State dependent increase heart rate, so shorter diastole. So state dependent increase in heart rate, shorter diastole. Sodium channels spend less time in the resting state. So drugs dissociate during this state. Less time for drugs to dissociate from receptor. So they work better, I think. Sodium channels spend less time in resting state. Drugs dissociate during this state. So less time for drugs to dissociate from the receptor, okay. Effect most pronounced in 1C more than 1B, 1A more than 1B due to relative binding strength, fast taxi cab. Okay. Okay, so class 1A, we have quinidine, prokinamide, and disopyramide. The queen proclaims disosperimide. Mechanism is moderate sodium channel blockade. So all are sodium channel blockers. So by default, so moderate sodium channel blockade. They increase the AP duration and increase the effective refractory period in the ventricular action potential. They increase QT interval and some potassium channel blocking effects. Okay, give me 1 second. I'm joining in today. Okay, so one more time, what is the mechanism of class 1A drugs? Moderate sodium channel blockade. They increase the AP duration. They increase the effective refractory period in the ventricular action potential. By increasing the effective refractory period, they increase the QT interval, which makes sense, right? Because this corresponds to the QT on the EKG reading. And some potassium channel blocking effects. Clinical use is both atrial and ventricular arrhythmias, especially reentrant and ectopic SVT and VT. So where do we use 1A, atrial and ventricular arrhythmias, especially reentrant and ectopic SVT and VT? Adverse effects, synchronism. So quinine, we know there's synchronism. They can cause synchronism. Headache, tinnitus, and quinidine. We saw this somewhere else. Yeah, with the malaria artesunate drugs, right? They can also cause synchronism. So headache, tinnitus with quinidine, reversible SLE-like syndrome with procainamide, and heart failure with disopyramide. So each of these have side effects. So synchronism, SLE-like syndrome for procainamide, and heart failure for disopyramide. And heart failure. Okay, so thrombocytopenia, torsades due to increase.
Let me interject you once again. Which drug did you say causes synchronism, especially the malaria-causing drug?
Artesunate, right? The artemisinin drugs, so the ones that have quinine.
Yeah. I just want to jog my memory too. Okay, thanks.
No worries. Okay. Yeah, that's why we saw when we did micro that they preserve only for like resistant cases or something we said. Let me just pull it up.
There usually are. There are 3 or 4 drugs. There are 4 drugs, I think, which cause this, especially
synchronism. Yeah, we saw that when we did the systems. Correct. So yeah, so intravenous quinine or artesunate, if life-threatening malaria. So that's, and this causes synchronism. So synchronism we saw in systems. We said yep, we saw it here. So quinidine and quinine and artesunate they didn't mention here, but that's also a quinine-containing drug. So they can present with tinnitus, hearing, vision loss, psychosis, and cognitive impairment. Quinidine, quinine. Okay, so all right. No worries. Okay, so class 1B is next. What are the drugs? Lidocaine, phenytoin, and mexaletine. Lettuce and mayo, please, was a mnemonic, I think. So lidocaine or lidocaine, phenytoin, and mexaletine. I'd buy ladies fine Mexican tacos. Yeah, we may or may not relate to this. So yeah, mechanism. What is the mechanism of 1B is weak sodium channel blockade. So here, moderate sodium channel blockade versus these weak sodium channel blockade. These were increasing epiduration. So versus 1B are decreasing epiduration. So if you see the epiduration has gone down, preferentially affect ischemic or depolarized Purkinje and ventricular tissue. So this comes up in questions. So clinical use, acute ventricular arrhythmias, especially post-MI. So it makes sense, right? Because it's going to be working better in ischemic or depolarized tissues. So it's going to be useful in ventricular arrhythmias, especially which are post-MI, digitalis-induced arrhythmias as well. So 1B, B for best in post-MI. Anaerobic state with accumulate lactic acid and protons. I think I didn't finish those notes. Okay, so adverse effects are CNS stimulation and depression, cardiovascular depression. Seizures because they are lipophilic. So this makes sense from our general biochem. Because they're lipophilic, they're going to go and accumulate in the brain. So that's why they're causing CNS stimulation, depression, and also cardiovascular depression. Okay. So on the curve, we're saying here, slope of phase 0 is increased because of the sodium channel blockade. Phase 3
is it increased or decreased, Ira?
Hi. Increase, right? When you say slope like this, or what was it? Am I wrong?
Yes, you're correct. It's increased. See, look at the dark line, okay? The light line is the control, and it has increased the AP distance, but the 0 phase is reduced. So it moves that side towards the right, my right. That's what it is.
But actually, that's what is confusing, because you say all sodium channel blockers actually decrease the slope. So for this one alone.
Yes, don't you think it decreased? 1 and 3 will decrease, but
no. It means that slope. It makes the curve, actually the slope shorter.
Yeah.
So shorter so that heart rate can be faster,
So yeah, it's
because there is a block. So we need to, already heart rate is very slow. We need to increase the heart rate, right? So that's why we actually, keep the sodium channel open for a few time. For less time, so that it can be faster,
Yeah. Okay. Yes, I misspoke, I think, in a bit ago. Its slope actually is decreased. So because if you measure this in centimeters, or for example, this would be longer.
AP, I was talking about AP. AP, which is increased, but sodium is decreased. Yeah.
Correct. Yes. AP duration is decreased, which is clear. Yes. So we have sodium channel blockade. If you recall from our myocardial action potential, this is a sodium channel. So sodium channel blockade, slope of phase 0 is decreased, and phase 3 is potassium channel blockade. Since it has some potassium channel blockade, it is affecting the phase 3 as well. So class 1A, sodium channel, phase 0, as well as potassium channel. So phase 0 and phase 3 it works on. So for class 1B, we're seeing...
sorry, it technically decreases the slope of phase 0, right?
Yeah, it's decreasing the slope of phase 0.
Okay.
That's what I understood.
And sorry, after this, can you explain the state dependent also, if not a problem?
Let me try. So here it said, so what's the mechanism? Let me repeat this actually. Quinidine, procainamide, disopyramide are the drugs. They have moderate sodium channel blockade, increase the AP duration, and increase the effective refractory period in the ventricular action potential. So they're increasing the QT interval and have some potassium blocking effects. Okay, that was the mechanism. Then we have clinical use, both atrial and ventricular arrhythmias, especially reentrant and ectopic SVT and VT. Adverse effects, we have synchronism. Okay, all that we saw. So 1B, right? You're asking for 1B, this fact?
No, the state dependent above, because it's lower block conduction. Yeah, that one, which you highlighted in blue.
Okay, this one.
Yeah.
Decreased slope of phase 0 depolarization, increase action at a faster heart rate, state dependent, increase heart rate, so shorter diastole. So I think what it means is, if there is a faster heart rate, then these action potentials are coming very close to each other, right? There's not a long ERP going on. There's no refractory period, very short refractory period. So these drugs will go and bind to the sodium channels, which are in a fast state, which are really working a lot, basically. So that's why it says increase action at a faster heart rate, state dependent increase in heart rate, so shorter diastole. So as we said, if there is no refractory period, that's the time for relaxation, right? For the ventricle to relax. So shorter diastole. So state dependent increase in heart rate leads to shorter diastole. Sodium channels spend less time in the resting state. Drugs dissociate during this time. Sodium channels, normally, the sodium channels spend less time in the resting state. They are hard workers, right? So they spend less time in the resting state, and drugs dissociate during this state. So less time for drug to dissociate from the receptor. So it stays bound. So basically, these drugs, like the hard worker, right? So sodium channels working hard because they spend very less time resting. And these drugs, like the hard workers, and there's less time for the drugs to dissociate. So thereby, effect is most pronounced in CAB because of the relative binding strength. So that's a different fact. But I think that's the reason for state. That's the meaning of state dependent increase in heart rate. I don't know if anyone else can please pitch in and verbalize.
The higher the heart rate, more it works better, right?
Yes.
It works. Okay.
The higher the heart rate, the less time in resting.
Okay, let me read my notes, what I have it here. Maybe if it makes more, I think you did a great job. But just to add to it, it says, my note says, 1A drugs work by blocking fast inward sodium channels responsible for phase 0 depolarization, and QT interval is prolonged because these drugs block the potassium channels responsible for phase 3 repolarization and the action potential duration. Does it make any sense? Forget it if it doesn't.
It does make sense. It does make sense. Yeah, thank you, doctor. I think the main thing was she was asking about the state-dependent increase in heart rate, like if we could explain it in simple words.
I think you did great there, because state dependent, because when the heart rate increases, the diastole is shorter because the heart is going to beat faster. So the filling time is reduced. So diastole is reduced. Diastole is the filling time, right? You did well. There's no question there. Yeah.
Okay.
Yeah. Thank you.
Thank you. Okay, so yeah, we just have to remember if there's decreased slope. So all of these drugs, they have a better action at a faster heart rate, which means if the heart is working, just in simple words, if the heart is working fast, if it's tachycardic, sodium channels like this hard workers. Just think of it like that. So state-dependent increase in heart rate. So if there is an increase in heart rate, that means we know there's a less resting time, shorter diastole. So, and if we go into the depth of the heart, what's going on within the myocyte, let's say we focus on one myocyte and zoom in. So these sodium channels, which are responsible for this part, and thereby the QRS. So sodium channels spend less time in the resting state. So when you zoom into the myocyte, what's happening with the ions, sodium channels are spending less time in the resting state. And the resting state is when drugs dissociate. So sodium channels is spending less time in the resting state. There's no time for the sodium channels to now dissociate. So less time for the drug to dissociate. So basically both sodium channels also like to spend less time in resting state. These drugs also like the hard worker. So they are bound together strongly and they work better. So that's why there's increased action and faster heart rate. That's my understanding. Hope that helped. Hope that made sense.
Yeah, thank you. Thank you.
No problem. Okay, so next we have, so we did class 1B. And because they're lipophilic, they cause, it makes sense that they will cause CNS effects, CNS stimulation, depression, and cardiovascular depression. So these drugs will decrease the AP duration. Yeah, this gets tested in questions, right? Slope is decreased in both. Here we are increasing the AP duration. Here there's a decrease in AP duration with class 1B. Okay, so next 1C. Can I have fries, please? So flecainide, propafenone, and also morisazine, I think in some places they mentioned in the older book. I think, so class 1C is flecainide and propafenone. Sorry. So mechanism, strong sodium channel blockade, significantly prolongs ERP in the AV node. So this is working more on the node and the accessory bypass tracts. No effect on ERP, as we're seeing ERP is the same between the bold line and the gray one. So ERP is the same. In Purkinje and ventricular tissue, minimal effect on, this is the AP duration. AP duration, so effective refractory period means the time it is in a resting state. So no effect on the resting state either, refractory period. In the Purkinje and it has two different things depending on this tissue. So ERP in AV node prolongs ERP in the AV node and the accessory bypass tracts. No effect in the ERP in Purkinje and ventricular tissue. So prolongs ERP where? In AV node and accessory bypass. No effect on ERP where? In the Purkinje and ventricular tissue. Minimal effect on the AP duration. So clinical use, we use it in SVTs, including AFib, only as a last resort in refractory VT. Okay, yep. Adverse effects, it's a proarrhythmic, especially post-MI. So 1C is contraindicated, this you've seen before. So 1C is contraindicated in structural and ischemic heart disease. So UWorld highlight was flecainide is a class 1C antiarrhythmic that is typically used to treat supraventricular tachycardias, such as those caused by AFib. Class 1C antiarrhythmics bind to the fast sodium channels responsible for phase 0 depolarization of cardiac myocytes, blocking the inward sodium current. This prolongs the, this was a conflict actually, that's why I put it here. So this prolongs the QRS duration with little effect on total action potential or QT interval duration. So this prolongs the QRS, okay, never mind. This prolongs the QRS duration with little effect on the total action potential or the QT interval duration. Class 1C drugs are the slowest of the class 1 agents to dissociate from the sodium channels and do so primarily during diastole. So yeah, dissociation, D for dissociation, D for diastole, during diastole. So this results in a phenomenon known as use dependence, in which their sodium blocking effects intensify as the heart rate increases due to less time for the medication to dissociate from the receptor. So we saw this in the general fact for all the class 1, but I think it's more pronounced for the flecainide, which is class 1C. So increased action at a faster heart rate, which is the phenomenon known as use dependence, makes it, yeah. One more time, what is use dependence? This is a phenomenon in which sodium blocking effects intensify as the heart rate increases due to less time for the medication to dissociate from the receptor. Okay, so that's class 1C. Okay, so just to overview, class 1 increases AP duration, class 1A increases AP duration, class 1B decreases AP duration. This one, no change. So up, down, no change. Slope of phase 0, all three are decreasing the slope. 1A has additional effect on potassium, so the phase 3 is also affected. Yeah, and then this one has no other effect, so no change in any other phase. Here there is a change in phase 3, but that is because of not sure, it's not mentioned, but probably some potassium effect as well. Oh, this one actually. Okay, so that's 1B, 1A, B, C. So next we have beta blockers, class 2. What are the drugs? Metoprolol, esmolol, propranolol, esmolol, atenolol, timolol, and carvedilol. What is the mechanism? These decrease the SA and AV nodal activity by decreasing CAMP. So mainly in the nodes, decrease calcium currents. So suppress abnormal pacemakers by decreasing the slope of phase 4. So it is decreasing the slope of phase 4. So decreasing the slope. So if this is the slope, it's decreasing the slope. Okay. Kind of more stretched out if you see it that way. So yeah, decreases SA node. So we're seeing the graph itself. Now we've moved to the pacemaker PAP, pacemaker action potential. The decreases SA and AV nodal activity by decreasing cyclic AMP, decreasing calcium currents, suppress abnormal pacemakers by decreasing the slope of phase 4. So this is its main, that's why it's working the most. AV node is particularly sensitive. So there is increased PR interval, and esmolol is very short acting, and esmolol, just memory jog, we said this was the first line for aortic dissection, correct? To decrease the shearing, wall shearing stress. No, what was it? Yeah, wall shearing stress.
It's a more specific one, right? It's a quick acting, more specific one, esmolol. Yeah.
Short acting and
very short acting, very short acting. Yeah. This comes in exam. This is yes.
Yeah, correct. Yeah. So mechanism, one more time, this decreases SA and AV nodal activity by decreasing cyclic AMP and decreasing calcium currents, suppresses abnormal pacemakers, meaning another point of initiation. So that makes sense, right? Suppresses abnormal pacemakers by decreasing the slope of phase 4. So AV node is particularly sensitive. So this will reflect on the EKG as increased PR interval. Okay, then which makes sense because P and R, if we see, was atrial depolarization and up to the start of ventricular. So here, if you're prolonging phase 4, then PR interval will be prolonged. Okay. So AV node is particularly sensitive, so increased PR interval versus these were showing increase QT interval for class 1A. Okay. So this is increasing PR interval, and esmolol is a very short acting one. Okay, clinical use, SVT, ventricular rate control for AFib and A-flutter, and prevents VTAC, ventricular arrhythmia post-MI. So atrial fibrillation and atrial flutter prevent ventricular arrhythmia post-MI. So post-MI was 1B, best for post-MI, as well as B. So the other B is the beta blockers. So they also prevent ventricular arrhythmia post-MI. Then adverse effects are impotence. That's the broad side effect of beta blockers: impotence, exacerbation of COPD and asthma, which makes sense. Cardiovascular effects, bradycardia, a block, heart failure. CNS effects, sedation, sleep alterations, may mask the signs of hypoglycemia. So yeah, this is all high yield. Metoprolol can cause, so specific to metoprolol is it can cause dyslipidemia. Propranolol can exacerbate vasospasm and vasospastic angina. Beta blockers, except the non-selective alpha and beta agonists, which is carvedilol and labetalol, cause unopposed alpha-1 agonism. Yeah, this is high yield fact. We discussed it at some point. So unopposed alpha-1 agonism, if given alone for FeO or for cocaine toxicity, which is unsubstantiated. We saw that was controversial. But anyway, so yeah, giving beta blockers, except the non-selective alpha and beta antagonists like carvedilol and labetalol. So generally, beta blockers cause unopposed alpha-1 agonism if given alone for pheochromocytoma or for cocaine toxicity. Treat beta blocker overdose. This we saw SAG. So the beta blocker overdose is treated with saline, atropine, and glucagon. So yeah, beta 1 in the heart, beta 2 in vascular muscle cell. Yeah, that was the general fact. So yeah, one more time. What are the class 2 beta blockers? Metoprolol, propranolol, esmolol, atenolol, timolol. What is the mechanism? Decrease SA and AV nodal activity by decreasing cyclic AMP and decreasing calcium currents. So suppresses abnormal pacemakers by decreasing the slope of phase 4. AV node is particularly sensitive, so increase in PR interval. Esmolol is the very short acting one. Clinical use, SVT, ventricular rate control for AFib and A-flutter, prevents ventricular arrhythmia post-MI. Adverse effects, impotence, exacerbation of COPD and asthma. Cardiovascular effects, which is bradycardia, AV block, and heart failure. CNS effects, sedation, sleep alterations, may mask the signs of hypoglycemia. Metoprolol can cause dyslipidemia. Propranolol can exacerbate vasospasm and vasospastic angina. Beta blockers, especially the non-selective, except the non-selective. So beta blockers can cause unopposed alpha-1 agonism if given alone for FeO or for cocaine toxicity. Treat beta block overdose with saline, atropine, and glucagon. Yeah, this is just general notes. RMP is the voltage when cell is not electrically excited. And for neuron, resting membrane is -70. This is familiar. For the myocardium, it's -90. Threshold for the neuron is 50 to 55. For the myocardium, is about -70. For AV node was -60. So this also we saw earlier. Okay, so next we have class 3. Potassium channel blockers. So AIDS is a mnemonic.
Can you go back? Excuse me. Can you go back 1 second? Yeah, quickly. Let me write it down. -70, -90. Neuron. This is RMP. Okay.
Oh, sorry. Yeah. Where did it go?
Saira, what was for neurons?
Neurons RMP resting is
-70.
Threshold is 50 to 55. And then I think we should also add for the nodal resting would be -60, close to -60. I think we saw it earlier. Yeah.
Yeah. Thank you so much.
Thank you.
My part of.
All right. So next we have potassium channel blockers. So AIDS is the mnemonic: amiodarone, ibutylide, dofetilide, and sotalol. So quick memory jog. We said very cute AMI or AMI was for the 3 drugs that cause digoxin toxicity, right? They displace and decrease the clearance. Is that the one? Let me see. Before we finish. So that was...
I think you're right. Yesterday we did last drug. That was the last drug. If you go to digoxin pathway.
Yeah.
Here it is. Yeah, here it is. Yeah.
So these are the drugs that cause decreased clearance. So very cute, Amy. Okay. All right, so next we have amiodarone. So this Amy can displace digoxin. So amiodarone, ibutylide, dofetilide, and sotalol. So mechanism, what do? They increase the AP duration, which we're seeing here, increase the effective refractory period, so increase the state, resting state, and therefore increase the QT interval. So clinical use, atrial fibrillation and atrial flutter, B-tachy, specifically amiodarone and sotalol. So adverse effects, sotalol, ibutylide. So sotalol was the, okay, so that's the one that's causing torsades-de-pointes and excessive beta blockade, because it's also a beta blockade, so it makes sense, excessive beta blockade. Ibutylide, also torsades-de-pointes. Amiodarone, we've seen it in other places, in Pulm, I think. So pulmonary fibrosis, hepatotoxicity, hypothyroidism or hyper, same like lithium. We said those two go together always, so hypo or hyper. Amiodarone, yeah, as the name suggests, it's iodine by weight, so it can precipitate hypo, or it can cause hypo or hyperthyroidism. And then it acts as a haptin, so causing corneal deposits, blue-gray skin deposits, resulting in photodermatitis, neurologic effects, constipation, cardiovascular effects, bradycardia, heart block, and heart failure. So all these drugs are kind of slowing the hearts, like beta blocker as well. So if it goes to the other extreme, it's going to cause heart block. Where did we see it here? Yeah, bradycardia, AV block, heart failure. Same thing, bradycardia, heart block, and heart failure. So if you give too much of it, it's going to cause cardiovascular effects. And then amiodarone, why it causes hepatotoxicity should make sense, because this is again a lipophilic drug. So it metabolizes slowly in the liver. And it's excreted in the skin, bile, and lacrimals. So it makes sense that it's lipophilic, so it stays longer. So that's why in the skin, it's causing these blue-gray deposits, which we saw. And in the bile, it's causing, so it is excreted in bile, so it accumulates, so there'll be hepatotoxicity. And in the lacrimals, so it's causing corneal deposits. Where was it? Yeah. Corneal deposits, blue-gray skin deposits, and resulting in photodermatitis. And the hepatotoxicity, it all makes sense because this is also a lipophilic drug. Then UWorld question, amiodarone and other class 3 and class 1A antiarrhythmic agents cause lengthening of the cardiac action potential, which manifests as QT interval prolongation on EKG. So we said QT interval prolongation on EKG. QT prolongation caused by amiodarone, in contrast to other drugs, is associated with a very low risk of torsades-de-pointes. So this was unique. I mean, it was, yeah, all of these drugs cause QT interval, pretty much most of them, but amiodarone has a very low risk of torsades-de-pointes. So that's why I just put it here. Yep, and I was going to say something. Yeah, again, the same thing, right? If they work too much, they cause the torsades-de-pointes. So they're increasing QT. If it's prolonged way too much, that becomes pretty much the pathology of torsades-de-pointes. Okay, so that's class 3, potassium channel, amiodarone, ibutylide, dofetilide, and sotalol. So then here we said, remember to check PFTs, which makes sense. It's going to cause pulmonary fibrosis, LFTs because hepatotoxicity, and thyroid function tests because hypothyroidism. So when using amiodarone, you have to check these. Amiodarone is lipophilic, so and has class 1, 2, 3, and 4 effects. So yeah, this is an important point. It's lipophilic, so we understand the side effects, and has class 1, 2, 3, and 4 effects. So yeah, what is it doing? Its main action is on, so by definition, these are potassium channel blockers. So they're working on the influx of potassium, or IK. Potassium, remember, it goes out of the cell. So if it's going out of the cell, the resting or the membrane potential is going to come back to negative. So that's why we see this massive change. From here, it's going to here. Okay, so that makes sense. Next, we have class 4, which is diltiazem and verapamil. So mechanism, so DV, decreased conduction velocity. So the mechanism is decreased conduction velocity, increasing the effective refractory period, and increasing the PR interval. So just to learn in groups, we said class 1A increases QT. Class 1B is decreasing AP duration. No, I'm talking about EKG changes. So this is increasing QT interval. This is increasing class 2, increasing PR interval. Class 3, increasing QT interval again. And class 4, it's increasing PR. So it's alternative QT, PR, QT, PR. So class 1, 2, 3, 4 in that order. Okay. So mechanism of class 4 is decreases conduction velocity and increases ERP, increasing PR interval. Clinical use, prevention of nodal arrhythmias. Again, we see the graph. This should trigger our memory that this is going to be working in the node. So nodal arrhythmias, SVT, rate control in AFib. Adverse effects, constipation. This is tested. Flushing, edema, cardiovascular effects. Again, if it works too much, it can cause heart failure, AV block. Since this is working the sinus node depression as well. Okay, so that's class 4, DV.
So, Sarah, what's the difference between 2 and 4?
Between 2 and 4, let me see. So this is working on SA and AV node both. Here it is decreasing the slope of phase 4 and it's prolonging repolarization at the AV node. If we compare, this is slow rise of action potential. So mainly this is the slow rise and prolonged repolarization is same for both. So I think here it is decreases the slope of phase 4 is the main thing versus here slow rise of the action potential. So this is more to do with the so if you go back to our action potential, sorry. Can we make a mnemonic for users? I'm not sure why they're all using this. Yes, I agree. We really need mnemonics. This doesn't stick. देख के पढ़ने में अच्छा लगता है first aid and recalling on exams or NBMEs is like zero memory. Okay, where was I? I was gonna look for the normal PAPs. Let me see. I should make a note of that page. No, I think I'm too far on the other side. We're talking about the class 2 versus class 4, correct? So
yes.
Okay, I can add here, well, based on my little knowledge on how to differentiate 2 and 4, I would say that 2 has got just as prolonged. It has got, they both have prolonged repolarization at the AV node. That is accepted. There is a decrease in the slope of phase 4 depolarization in 2, right? And whereas in 4, we say that there is no change in phase 4, but you see slow rise in the action potential that you also already mentioned. That's the way I look at the graph, and I'm telling. And anything else, this is what is standing out for me.
Yeah, I agree. Yes, 100%. So we're saying class 2 are working on the phase 4. So they're working on the funny currents and the T-type calcium channels. So that's what I was trying to recall. So these class beta blockers, their main action is they're reducing cyclic AMP. So by reducing cyclic AMP, I need to find out why exactly, but they're somehow, I believe they should be working. Okay, yeah. They are decreasing calcium currents. That was what we read, right? So they're decreasing calcium currents. So it makes sense that it's working more on the phase 4. So beta blockers are probably working on the T-type calcium currents. So it prolongs the phase 4 versus class 4 are working main on the rise. So they are going to be working on the L type. So I think that is probably the difference. but I need to check my facts. So that makes sense, right? If it's beta blockers are working here. Class 4, which is the diltiazem and verapamil, which are dihydropyridines or non-dihydro. Someone please remind me. Because yesterday when we saw this L-type, they were dihydropyridine sensitive. So
non-dihydropyridine both are in the heart, and the dihydropyridine is the peripheral. That's my take.
Say again, sorry, dihydropyridine.
Non-dihydropyrimidine, that is verapamil and verapamil and diltiazem. They both are in the heart. Whereas the outside is the dihydropyridines and all the deans. They come under peripheral. Like so many deans are there here. I am blanking right now here.
No worries. Yeah. So yeah, I need to check. Maybe there's some difference on that. But the difference is class 2, which is beta blockers, work on the phase 4, and this is working on the rise. I think that's the main difference. So, yep. Okay, thank you. Thank you, Dr.
Thank you. Yeah, if you see the slope, so I think phase 4 slope is more lower in phase 2, right? Class 2.
Class 2, yeah. So this becomes slower. And then class 4, yeah, go ahead, Hamna. I'm just repeating what you said.
No, it's okay. I'm driving. Sorry, I just.
No, it's okay. Driving, please drive safe. Okay, so back to where we were. This pyramid. Actually, let me take a screen hint of this page. Uh-oh. Okay. Okay, so we were on this page talking about class 4 antiarrhythmics. So yeah, diltiazem and verapamil, I'm going to check it later, but so these are working on the rise of the action potential. So mechanism, how do they do this? They decrease, okay, what do? They decrease conduction velocity, increase the effective refractory period, and increase the PR interval, where they use prevention of nodal arrhythmias, which is SVT, rate control in AFib, and adverse effects are constipation, flushing, edema, cardiovascular effects, and heart failure, AV block, sinus depression. So supraventricular tachycardia, right? Supraventricular means above the ventricle. So everything that's coming from the SA node, AV node. So all of these are pretty much working on the SVTs. But yeah, we'll make a list and make a mnemonic. So next we have other antiarrhythmics. What are these? We have adenosine and magnesium. So this increases potassium out of the cells, hyperpolarizing the cell and decreasing the calcium current, influx of calcium, so decreasing AV node conduction. Drugs of choice in diagnosing and terminating certain forms of SVT, very short acting, like approximately 15 seconds. So effects blunted by the theophylline and caffeine. Both are adenosine receptor antagonists. I think we saw that somewhere else. Theophylline and caffeine, both are adenosine receptor antagonists. Receptor antagonists, yeah. Adverse effects include flushing, hypotension, chest pain, and sense of impending doom and bronchospasm. Okay, so chest pain, so yeah, this can, yeah, we saw it somewhere, I believe. So adenosine can precipitate the coronary steal syndrome. And then hypotension, I don't know what I've written. So decreased blood pressure. So blood pressure equals cardiac outputs times TPR. Adenosine will decrease TPR and also decreasing cardiac outputs for super low blood pressure. And if decrease heart rate, it decreases heart rate. So cardiac output is heart rate times stroke volume. Because it's decreasing heart rate, it also decreases cardiac output. So how it decreases cardiac output was this explanation. Hope that makes sense. So adenosine is gonna decrease TPR as well as decreased cardiac output. So by the formula, blood pressure equals cardiac output into TPR. So because it's decreasing both its components, it makes sense that there's decreased blood pressure. So how did the cardiac output go down? It's decreasing heart rate by decreasing AV node conduction. So decreasing heart rate. If it's decreasing heart rate and apply it in the cardiac output formula, so cardiac output is going down. So that all comes together kind of. So yeah, sense of impending doom, bronchospasm, flushing, hypotension, chest pain, sense of impending doom, bronchospasm, all the adverse effects. Then next we have magnesium, effective in torsade du pont and for digoxin toxicity. So yeah, magnesium is a big gun, right? It is used for max sulfurs hypertension in pregnancy, torsade du pont, digoxin toxicity. So yeah, it comes up in its serious cases. Okay, so magnesium. Then we have ivabradine. This prolongs the slow depolarization phase 4 by selectively inhibiting the funny sodium channels. So ivabradine prolongs the slow depolarization phase, so phase 4, which is again this, by selectively inhibiting the funny currents. So if we recall, funny current was working on the phase 4, so it's going to work on these sodium channels specifically. So inhibiting funny sodium channels, IF, funny, and use is in chronic HFrEF, so heart failure with reduced ejection fraction. We said luminous phenomena, visual brightness was a side effect, as well as hypertension and bradycardia. Hypertension over here, okay. And bradycardia for most of these drugs, yeah, heart failure, bradycardia is a side effect. So let's consolidate the uses. Okay. Any other mnemonics? Anyone who likes to add anything?
Usually they ask mechanism of adenosine. That is, I've seen so many NBMEs that question, and even I have taken, so got to know the mechanism. And how does potassium's role, how does this help in the actual disease state? Like, for example, in diabetic patient, diabetic ketoacidosis, here potassium is provided to the patients, right? Suffering from diabetic ketoacidosis because they are grossly hypokalemic. So this will, they're at increased risk for arrhythmia, right? So you just, in that situation, it helps. And for adenosine, usually they ask mechanism. So the way you can put it is, it binds to which receptor, A2A receptor. I think maybe it's there in the last page. If it's not there, maybe I will share my notes. It's not there? Oh,
this one, right? Adenosine, potassium
binds to what receptor? Binds to A2A receptor. There was one of the NBME had this question. And it is in the coronary arteries, actually, and increases the cyclic AMP and raises the potassium, while having a sharp drop in the calcium reuptake, all leading to vascular smooth muscle relaxation. So leads to coronary artery dilation. So this along with lactate are released by skeletal muscles in the exercise. I have seen this also in the questions. Lactate, how does it work? So this is how it is.
You said A2A receptors, doctor?
Yes, A2A receptor in the coronary arteries and increases the cyclic AMP and raises potassium while having a sharp drop in calcium reuptake. So this all leads to vascular smooth muscle relaxation, leading to coronary artery dilation. So this, along with lactate, are released by the skeletal muscles during exercise. So during exercise, they'll ask you what is the mechanism for relaxation is, because adenosine and lactate, they both follow this calcium reuptake. They just, they play a role with cyclic AMP and raises take over. I think I'm repeating again and again. It's the same thing.
No, it makes complete sense. So this is increasing coronary artery dilation. So it explains why it would cause coronary steal syndrome. And cause chest pain. I think I saw this yesterday, so it all comes together. Thank you, doctor.
Exactly. Even coronary steal syndrome can be merged into this bad thing actually.
And then I think we saw this somewhere else too. Adenosine is the one that's increased in peripheral. So that could also be the reason for the hypotension, right? It makes sense because if it's going to be increase in the exercising muscle, it's causing vasodilation and can precipitate hypertension. Yeah, makes sense.
So here is a fundamental thing. There are two things here. Adenosine, the weight, it has A1 receptor, A2 receptor. I think NBME asked us about A2 receptor, but this adenosine has a role in A1 receptor as well. So A2 is in the, where is this guy? Okay, A2 is in the vascular smooth muscle cells, and A1 is in the SA and AV nodes. You got to know these two very clearly. And then in the smooth muscle cell is exactly what I talked about. Like this is like through the A2, when it binds to, then the GS is stimulated and cyclic AMP. You know that pathway, how the smooth muscle relaxation happened. We have been talking past 2 days. And then A1 receptor will be GI inhibitory. That is in the SA and AV nodes. So what does it do is through cyclic AMP, decreases this adenyl cyclase, decreases the cyclic AMP, and then there is decrease in chronotropy as well as donotropy. They all are decreased in the SA and AV node. Whereas in smooth muscle cells, it increases the cyclic AMP, but there is relaxation. So there are two different things happening. We have to know this concept very clear. I have seen multiple NBMEs just throwing us questions on this. Yeah.
Yeah, thank you.
Saira, I'm sorry, can you find this adenosine mechanism and all these things?
Yeah, so adenosine works. Okay, let me go back to the give me a sec. So yeah, to summarize, adenosine is released in exercising muscles. That's an extra fact. What is the mechanism? It's increasing potassium out of the cell. So if potassium goes out, the inside of the cell is negative. So it's super negative.
Hyperpolarization, yeah.
Yeah, so super negative. So it is hyperpolarizing. So we said depolarization is the polarity is lost. Hyper means going too negative. So inside of the cell is too negative. And it's also decreasing calcium. If we recall from our GS pathway, G-coupled pathway, it's decreasing calcium. So decreasing the AV node conduction. So it's drug of choice.
How it decreases calcium?
Because this is the one which is working via GS coupled. So we said that's going to decrease the cytosolic calcium. Remember? So let me pull it up. Let me see.
Okay, yeah. So prostaglandins, prostacyclins, that pathway.
That pathway, right? So net effect downstream is going to decrease cytosolic calcium, and increases the sequestering. Crabs and poker. Okay, yeah. So if you remember adenosine, we discussed this yesterday, it stimulates the GS pathway, stimulating adenyl cyclase, converting ATP to CAMP to PKA. PK will inhibit phospholamban. So what does phospholamban normally do? It inhibits the calcium channel, SERCA. So if you're removing this out of the equation from PKA is inhibiting phospholamban, it's taking it out. Like, get out of here. You're not needed at this point. So now SERCA is free to do what it's supposed to do. It will sequester the calcium out of the cytosol, which is all over here. So if there's calcium floating around, it sequesters all the calcium inside the sarcoplasmic reticulum. So now it's decreasing the cytosolic calcium. So when they say decrease I calcium, I think they mean the cytosolic calcium. So by decreasing the cytosolic calcium, so we said yesterday, no calcium equals contraction, right? By definition, just that's like a rule of thumb. So if you have decreased calcium over here, it's going to cause relaxation. Because there's no calcium to, decrease calcium, relaxation. So that's how GS, adenosine, is causing decreasing cytosolic calcium, thereby leading to relaxation.
Okay, got it. Thank you. Yeah.
But that is only one role of adenosine. Adenosine has another role in SA and AV node. So you have to play both the games. So that's a.
So by this mechanism, it causes vascular smooth muscle relaxation, right? Increasing cyclic AMP.
Yes, she did it very well. Yes.
Yes.
Thank you.
And what about, so in A2A receptors are found where?
So Dr. Tami said A1 is in the SA and AV node. A2 is in the vascular smooth muscle cells.
That's correct. And A1, when it's through the SA and AV nodes, it is through GI inhibitory pathway. Again, cyclic AMP pathway, then there's adrenal cyclase, cyclic AMP goes down. So there is decrease in the chronotropy and dronotropy. Just reverse the story there. So they can ask you a question on any side. You should be able to answer what happens in the nodes and what happens in the smooth muscle cell. They are totally opposite each other. Yeah.
So A2 is working, A1 is GI coupled. A2 is the GS coupled. So just making a note here, A1 is GI coupled, A2 is GS coupled. So it makes sense, it all comes together, right? So A2 is working via GS. It's going to cause relaxation in the smooth muscle. A1 is inhibitory, so it's going to do the opposite. So it's going to, what did we say? In the SANAV node,
isn't it A2 is, Saira, A2 is all inhibitory, GI, alpha 2 is all inhibitories now.
No, I think these are different, right? They're not alpha 2, they are like adenosine receptors. I'm not sure. Let me check my fact.
Okay.
Adenosine receptors are like different from the alpha.
Yeah,
I think.
Okay.
Yeah. Don't mess up with that. But yeah, I get your point. Don't mess up. This is totally
Thank
different.
you, Dr. Temi.
This is totally different. A1 and A2 receptors are behaving differently. And you should also be able to connect coronary steal syndrome in this, which fits in, and caffeine intake also. They put question in different ways, I'm telling you.
Yeah, this comes up, right? And this we should know. If it's adenosine and theophylline and caffeine will do, it's blocking. So adenosine, if it's causing relaxation, caffeine will cause the opposite. So that's why we have tachycardia.
Yeah. So it'll be through your A1 receptor over there. It'll be different. So they have really put both the concepts here. And they asked, they 4 lines, they want us to understand everything. This is terrible.
Thank you so much.
So adenosine receptors, also known as P1 receptors, are a class of purinergic G protein coupled receptors with adenosine as the endogenous ligand. This is Wikipedia. I'll share this. But yeah, this makes sense. There are 4 types, A1, A2A, A2B, and A3. Each is encoded by a different gene, and they're commonly known for their antagonists. Adenosine receptors are commonly known for their antagonists caffeine, theobromine, and theophylline, whose action on the receptor produces the stimulating effects of coffee, tea, and chocolate. Okay, that's a fun fact. Thank you so much, Dr. Tami, and
so
everyone.
Coronary steal syndrome, how would you in coronary steal syndrome?
Let's break it down. Yeah, so if it is causing vascular smooth muscle relaxation, okay, so then remember the image we saw yesterday. Let me put it up. Coronary steal. So yeah, if you remember, if you're causing vasodilation, it's taking blood flow away, right? Because we said they're already, coronary steal with adenosine, these are already maximally dilated to maintain flow. If you're giving adenosine in such a situation, this is going to vasodilate and take the blood flow away such that this side is not getting any blood flow. So arterioles cannot further dilate because they're already maximally dilated. And now this is dilating more because they are active. They're responding to the adenosine. So thereby causing coronary steal. The flow is stolen and it precipitates a ischemic situation.
Okay. So with adenosine, one other drug, right? Dipyridamole or something?
Yeah, Nia, here it is Dipyridamole and regadenoson.
Thank you.
Regadenoson. So they both are A2A adenosine receptor. That's my notes I'm reading. These two are A2A adenosine receptor agonist, and they cause coronary vasodilation for stress test, and they can cause myocardial ischemia, and in the case of coronary steal syndrome. So that answers this one. Didn't get it, huh? Let me read that sentence one more time. Dipyridamole and regadenoson are A2A receptor, adenosine receptor agonist. They cause coronary vasodilation for stress test, and they cause myocardial ischemia in the case of coronary steal syndrome. Steal syndrome, basically there's ischemia as you explained here, right? So that is how it is connected to these two drugs and coronary. In the steal syndrome, this is how these two drugs are causing the phenomena of myocardial ischemia.
Okay, thank you.
Yeah, no problem.
Thank you.
No problem.
Okay, so that was, so both of these, dipyridamole, regadenoson, and this sounds like adene, right? It has adene in the name. So adene, so that's an agonist actually, I think, yeah. Adenosine. Instead of adenosine, it's adenosun. It's sun. Okay. That's that. All right. So adenosine. Oops. Where am I?
So we use it for coronary steal syndrome. Adenosine, we use it for terminating and diagnosing SVTs. Right, and its effect is blunted by theophylline and caffeine, which are adenosine receptor antagonists. And anything else? And it decreases AV node conduction by acting on the A receptors on S and AV node.
One receptors on the SA and AV node, yes. And it's very short acting, it's 15 seconds.
Yeah, and it causes attacks on the A2 receptors, causes coronary vasodilation.
Correct. Yep.
Thank
Okay.
you.
Right. Thank you. So let's summarize the uses and we'll see how it goes. Anyone already has a mnemonic for this uses? Which one is used where? Okay, let's see. So we have class 1A. 1A is being used in atrial and ventricular arrhythmias. Reentrant and ectopic SVT. SVT and LET. Okay. 1B is best post-MI. So acute ventricular arrhythmias.
1 second, can you go back? You said SVT and what?
VT.
VT,
Ectopic SVT and VT for class 1A. Okay. So atrial and ventricular arrhythmias, reentrant and ectopic SVT and VT. So class 1B is ventricular arrhythmias, which is acute ventricular arrhythmias. So post-MI. Post-MI, we said B for class 1B, and B for beta blockers. Okay, so acute ventricular arrhythmias, digitalis-induced arrhythmias. Okay, yeah, that's the main thing. So then 1C use is SVT. And including AFib. And only as a last resort in refractory VT. Okay, so that's 1A, 1B, 1C. What is the pattern pretty much for ventricular arrhythmias? Okay, let me come back to it. Then class 2, these are used in SVT. AFib and flutter. So yeah, this image should trigger us because it's in the AV nodes. This is AFib and A flutter. And VTAC post ventricular arrhythmia post MI, which is the same as 1B. So B, all the B stuff, which is beta blockers, and 1B post MI. So acute ventricular arrhythmia post MI. So that's the same. Okay. And let me test down. Okay. Okay, then we have class 3. Here uses again AFib and flutter. So continuing on, similar to class 2, this is also AFib and flutter. And VTAC. Okay, AFib and flutter. So, and then VTAC. This is the main one, especially amiodarone and sotalol. And then we have class 4. used in, again, SVD. So nodal, again, this image should trigger us the memory of a node, SA and AV node. So nodal arrhythmias and AFib. Okay, and then adenosine, which is the miscellaneous drugs. This is used for, we said, for, no, SVT again, diagnosing and terminating SVT. Magnesium, we said that was the big guns, so that's going to be used in torsa de pointe and digitalis toxicity. And then ivabradine was going to be used in chronic HFrEF. Yeah, it is not going to be used in arrhythmias, but because it's slowing phase 4, that's why it's in this, along with this, these drugs. So ivabradine is a unique one. This is being used in HFrEF. Excuse my handwriting, but so class 1A was atrial and ventricular arrhythmias, reentrant and ectopic SVT and VT. So let's see if there's a pattern. 1B is acute ventricular arrhythmias. So this is atrial and ventricular. This is just speaking about ventricular, acute ventricular, which is post-MI. And digitalis induced arrhythmias, was it? Yeah. Yeah, digitalis induced arrhythmias. So that's DIA. And 1C is for SVT, particularly AFib, and refractory VT. Class 2B, so this is the pattern we've seen, B for B, both are used in post-MI. Again, this is also used in SVT, AFib, and flutter. So the nodal ones, which is class 2 and class 4, so 2 and 4 even numbers, because they work on the nodes, they're going to be using AFib and A-flutter, which makes sense, right? So because they're working on nodes, 2 and 4 are going to be using AFib and flutter, so nodal stuff. And that includes the SVT. Class 3, which was the potassium channel blockers.
The thing I noticed, hang on 1 second. The thing I'm noticing is that there's no flutter in 4, is that correct? There is flutter in 2, both are nodal, 2 and 4. But nodal, fib and flutter is there in 2, but there's no flutter in the case of 4.
You're right. My bad. So 4
that's important because these are in 2 different areas of the heart, right heart and left heart. Yeah.
Correct. Yeah. Thank you for correcting me. So 2 is AFib and flutter. So if we come in order, 2 is AFib and flutter. 3 is also AFib and flutter. 4 drops one thing, so it's only AFib. Plus what we're adding is nodal arrhythmias, particularly SVT. So adenosine is unique. So diagnosis and interruption of or termination of SVT. So this is again SV. So which ones are used in SVT? We have 1A, 1C, 2, and adenosine. Digitalis induced toxicity, we had 2 things. Digitalis induced arrhythmia was 1B, I believe. Yeah, correct. So that is 1B, digitalis induced arrhythmia, and also we're using magnesium. So these are again big guns. And then ivabradine, okay, that's unique, so that's separate. So then atrial and ventricular arrhythmias, we have, so ventricular arrhythmias, 1A, acute ventricular arrhythmias also for 1B. Ventricular tachys, again, 2 things. Let me see it. Yellow, I guess. Ventricular tachy is 1A. Refractory VTAC, we're bringing 1C. Class 3 also. So yeah, this is still confusing, but we need to just learn it in groups and probably make some mnemonics.
Saira, mostly I think they are used in SVTs sort of things.
Yeah, but I think the questions don't ask
the uses
treatment like that, right? So it's just a scenario which we'll be able to pick up. Mostly if their direct recall is probably for post-MI, which works better, which is 1B drugs.
Yeah, post-MI and 1C are contraindicated post-MI. These are.
Yeah, these two they test. 1B for post-MI, 1C for contraindication. So we need to know what are these drug classes so we can pick the right answer. And then these two, they have unique effects. So adenosine
And
is
this,
unique, so they will be
yeah,
tested
so for class 3, amiodarone is important because amiodarone does not cause torsades while others cause torsades. And the side effects of amiodarone are important mostly.
Correct, side effects. So yeah, that's how we'll be tested. So don't worry about knowing the exact things. I think 1B, if you know there's outlines, then it's usually easier to rule out and then go towards the right answer. Okay, hope that helped. Are we good? Any
Yes.
other
And we have UL questions regarding this 1A, 1B, 1C, right? 1C is QRS prolongation and mostly QRS prolongation, but no effect on. We have a question about flecainide.
Yeah, that was the weird question.
Yeah.
I know which one you're talking about.
QRS prolongation, but QT interval is not prolonged. I think something like that. Yeah, and one.
Yeah.
Sorry, go ahead.
No, I was just going to recall that it was alternate, right? 1 and 4 were for increasing PR interval. No, sorry, 2 and 4, or even numbers are increasing PR interval versus the other classes are increasing QT interval. Just jogging that one.
And 1A and 3 are basically increasing QT interval, but all these are increasing QRS.
Yeah, 1A
sodium
and
channel
3.
blockers.
Yeah, if you put that together, 1A and 3 is
if you have this picture in your front of your eyes, like visualization, a guy is pushing from left, a guy is pushing from right. So one is from the left and the right is the right side and the guy. So the peak, if you look, that's the way it is. It's moving one side. Where is that peak? If you go back to the picture, and the third in the middle one will be the one which is crushed in the middle. 1ABC. If you go ABC 1. Go to the picture, yes, summary. It's beautifully, you can put the picture in your mind. See, this guy is pushing, I don't have an arrow. He's pushing this side. The other guy is pushing from the other side. That is the third one. Go to the third one. The picture.
This guy is pushing this side.
This side. And if you go to the third one, go to the 1, 2, 3. Oh, I see. See, he's pushing from the other side. So it's moved
pushing from the
other side. Okay. And the middle guy is in the middle. That's it. If you remember that, you can put all the features easily, like AP and this sodium factor and potassium factor. Everything falls in this concept actually.
Nice, that's a good one. So this is pushing from both sides, so decrease AP duration. Here, this is pushing from here, so it's prolonging AP.
Yeah.
And here it is pushing from this side, so didn't do much to the AP. That's nice.
It reduces.
That's really nice. Thank you.
Thank you.
And then we extrapolate from that, so we know which channels are working and so on and so forth. Okay. And this one is just getting angry and bloating up. So this is potassium, like a pot. So it's like just the potassium channel. So that makes sense. And then this 4 was just a slow rise. Okay. All right. Hope that was decent.